itself, that is starting from intracapsular to today's modern cataract phacoemulsification surgery, along with laser-assisted cataract surgeries. To match with that particular technical and technological advancement in the cataract surgery, it was needed to have the modern lenses, intraocular lenses as well. And I must compliment the trade for making this possible for all of us today. As we know, we have plenty of varieties of intraocular lenses now available to us. And I would like to present a basic, very basic thing today, because when so many lenses are available in the market, it becomes one of the most difficult things for people to choose. As we understand, you have a monofocal lens, we have a multifocal lens, we have toric lenses, we have toric, multifocal and monofocal lenses, we have accommodative lenses as far as the types of lenses are concerned. But along with the type of the lenses, we also have many other considerations, like consideration of asphericity, consideration of the different designs of the lens, consideration of the different materials of the lens, IOL edges, which are also of various types, and various types of haptics which are available. At the end of the day, at the same time, one has to remember that there has to be available diopter power which we need for that particular eye, and the cost involved in that, because there are going to be some constraint with the patient regarding the cost of the total surgical package as well. Obviously, when we look at this particular thing, the first thing would be, how should we analyze which lens is required for this particular patient's this eye? And for that, a detailed workup of A scan along with the axial length, AC depth, lens thickness, effective lens position, etc. is required. But in my practice, one of the most important thing which I first look at is the topographic analysis and the amount of the cylinder. It's also important that not only you notice the cylindrical value, but also find out the meridian. Primarily because if the cylindrical value is more in the vertical meridian, then we can probably compensate also more in the vertical meridian by taking the vertical incision. At the same time, on the topographic evaluation, one can also evaluate the Q value and asphericity. OCT is required in a high-risk patient, and especially when you are using a premium intraocular lenses. Corneal endothelium study in a compromised cornea would always give you a good idea to give a prognostic approach to the patient. Now, first thing, as I said, is the amount of the cylinder. If the cylindrical value is 1.25 or more, then the first decision is that everything else is out. One has to go for a toric lens only. However, if the cylindrical value is 1 or less than 1, then we still can avoid the toric lens by either doing the relaxing incisions or various options which are available at our disposal. But moment we see that the cylindrical value is high, the choice becomes a cylindrical toric lens. Either it could be monofocal toric or a multifocal toric, depending upon the requirement of the patient. Next, we go to the whether patient's requirement is monofocal or multifocal. At this point of time, I would like to clear that the multifocal practice is definitely on the rise. This is primarily because there is improvisation in the quality of the lenses, the glare, halos, the quality of the vision that it provides, all have improved. Also, at the same time, with the stiff competition in the market, the cost of the intraocular lenses, multifocal intraocular lenses, have definitely come down. We have a lot of advancement which we will see in the future presentations in terms of EDOF and other lenses which have come up in the market. However, you need to be very careful when you are taking up a multifocal practice. By elimination, what I normally go for is the need of the patient, whether patient really needs multifocality or not, whether he is a very demanding patient or not, whether he has a lot of driving, night driving to do or not. And last important, very important thing, whether the patient has a willingness to go for the both eye surgeries sequentially in a short time of period. So with that particular thing, we go ahead and counsel the patient for monofocal or multifocal lens. In multifocality, we have now the extended focus lenses, EDOFs. I think I'll skip this particular part because during the presentation, many other speakers are going to talk details about this particular lens. However, accommodative lenses, which in between came up, they probably have a limited use as of now. Somehow or other, this kind of lenses have not really picked up very well, though it gives an excellent distant vision and reasonable amount of the near vision. This is primarily because though it gives about 1.5 to 2 diopter of accommodation for the near vision in the initial phase after the surgery, over a period of time, it further reduces. And also the cost versus benefit ratio becomes relatively less in this kind of practice. The important thing which I would like to now come down to is the asphericity. I think there is a lot of wrong concept with especially the beginners who are coming up as a novice ophthalmologist. And we keep on saying that I have used a negative asphericity lens to neutralize the corneal positive astigmatism, but I don't achieve the result which I should achieve. The patient is not equally happy. This is primarily because you need to be very sure that you do not overcorrect the negative asphericity by the positive asphericity value of the cornea, which is less than the negative asphericity of the lens. These are the various asphericities which we are going to see. For example, if the corneal asphericity is zero point 0.1 plus 0.1, and you choose a lens of negative asphericity of 0.28, then you have left with 0.18 negative asphericity, which is not a good option because it reduces the depth of perception. So what lens you should choose also will depend. The company, various companies giving you various kinds of asphericity, like Technis gives you 2.8, alcohol gives you 0.22. Aspherically neutral lenses are also available in market. And my option or my guideline to the beginner is stick to the aspherically neutral lenses to begin with, because even if the corneal positive asphericity remains, it doesn't matter much, primarily because the positive asphericity increases the depth of focus, and that allows us to have a better quality of vision. Going to the next part of it, the material of a lens, hydrophobic acrylic possibly is the first choice as on today, though there were some evidences of opacification of these lenses, which is probably the story of the past. And nowadays with new modern lenses, the opacification of the lens has come down considerably, giving us additional advantage of reduction in the posterior capsular opacification. The second choice could be hydrophilic acrylic lenses, which are very commonly used now. And some silicone lenses are still being used, but I would like to have a guideline over here that in case if the patient has got any retinal problem, diabetic retinopathy, or he is going to end up with some kind of retinal surgery in future, then it is better to avoid the silicone lenses and go for the hydrophilic lenses. The last but not the least, PMMA still I think is a time-tested lenses, especially when we are looking at the SICS surgery. PMMA lenses would still be the most useful thing. As far as the design of the lens is concerned, 360-degree posterior square edge is always preferable. When we say 360 degrees, it is important to remember that at the junction of the optic haptic, that place also should have the posterior square edge, which is missing in some of the lenses. At the same time, some people came up with the opti-edge anterior surface, which helps to reduce the glare and halo phenomenon. Material and design of the haptic is again an important thing, especially when one ends up into some kind of a complication on the table and one has to implant the lens in the sulcus rather than in the bag. At that point of time, maybe a haptic which is more forgetful, forgiving would be something which is preferred. Tinted haptics have also come up in the market, which helps us to have a better visualization so that we can put up the haptics well within the capsular bag. A plate haptic lens is another important thing which has come up because possibly this has got a better fixation since there are 4-point fixation with the plate haptic lenses and there is less chances of rotation, especially when you are dealing with a toric multifocal lenses. At the end of it, I would just say that counseling is the most important part. The counselor should explain details of what is required for that particular eye of that particular patient. Actually, in our practice, we leave the final decision to the patient, what he wants to choose. But we do counsel them in detail about the benefit, risks involved, and limitation of any lens that we are trying to implant in that patient's eye. Having done that, the package also, the cost also will come into the factor and the patient can then take up a decision that I would like to go for this particular part of the lens. Thank you very much for your kind attention.
It was a wonderful talk, sir.
Sure.
Shall I ask any question?
Sure. If there is a question, please, I would like to go ahead and answer them.
Sir, it is mentioned in the IOL a degree or angle between the haptic and the optic. And how do you decide that angle of haptic and optic? This question I asked for many speakers. Till now, no speaker has answered. Haptic.
In general, we like that the posterior surface of the lens, IOL, touches the capsule very firmly. So if there is a small posterior angulation, then the haptic touches the capsule very, very closely, and then it would probably reduce the chances of posterior capsular opacification. At the same time, if the lens goes little far behind, then the space between the iris and the intraocular lens would certainly be little more, and that would allow the free flow of the aqueous so that the chances of secondary glaucoma or what we call posterior, the capsular syndrome, anterior capsular catch syndrome, that would certainly reduce. So this is my personal choice, but I would not mind going ahead with a zero angulation lenses as well.
Thank you, sir.
I hope that satisfies you.
Yeah, sure.
Next time, don't say that nobody answered that.
I never knew this answer.
Can quote me. You can certainly quote me, no problem.
Sure, you are like Nagpal now.
Thank you, sir. Sandeep, do you have anything to add?
No. Sandeep, you are muted.
Yeah.
So can we go ahead with the second talk of the session? We will take up the other questions as and when it comes to. During discussion part, we can always take up other questions as well related to the every topic. So if you are prepared, I think we can go ahead with the second talk of the day. That is by Dr. Gul Nankani. Gul, you are already, your slides are ready?
Yes, sir. Yes, sir. But you have to stop sharing your screen.
Yeah, I will stop sharing my screen. I have done that. Yeah, Gul, I can see you. So I think one of the most important part as far as the multifocality is concerned is the neuroadaptation, because many patients do find initially a difficulty in getting adjusted to the monofocality that we have given them, especially when the surgery is done in one eye and the second eye is a normal phakic eye. With that particular introduction, may I request Dr. Gul Nankani to proceed with his talk on the neuroadaptation in multifocal IOL.
Thank you, sir. And good morning to everyone out here. At the outset, I would like to thank BOA and MOS for giving me this opportunity to be here this morning. I hope my screen is visible there.
Yeah.
Your screen is visible.
Thank you. It is so common in our cataract practice to see a patient who is not so happy in spite of having a 6/6 N6 vision in each eye. The patient has had an uneventful cataract surgery with the best phaco machine and the best multifocal IOL. The patient has also paid the best price for the surgery. We examine the patient and find a perfectly sitting IOL with a clear visual axis, no dry eyes, no PCO, and a healthy macula. So what is bothering these patients? It could be glare, halos, starburst, rings, symptoms we commonly address as dysphotopsias. And many a times when we ask the patient actually has no symptoms, but just says that I'm not very happy to what I'm seeing. And we try and break our heads to know what exactly is the problem. We need to understand that what we see is actually perceived by our brain. The brain is responsible for our ultimate vision. And for us to have a perfect visual experience, the eye, the brain, and the interconnecting circuitry have to be in order to highlight there is much more than a perfectly done cataract surgery. What happens in a patient with a multifocal IOL? Here, the brain is presented with multiple images from each eye. There is confusion in the brain. There is an intraocular rivalry, and the brain has to make a decision and make a choice which image to focus on from the multiple images that the brain has been projected with. Sometimes there's also been cases of interocular suppression, especially when, as Dr. Yogesha mentioned, that the two surgeries of the two eyes should be done in close dates. What happens in such circumstances is that the dominant one of the eyes, the eye which has been operated first, exhibits a dominant effect on the other eye, and this second eye actually gets into a suppression. And this is something like an amblyopia. And if the gap between the two eyes is long, that we have often seen that one eye actually suppresses the other eye. And this lack of binocular vision in such patients leads to a deficit in stereopsis. Rosa et al. Presented a wonderful study where they did a functional MRI investigation on all these patients who presented with symptoms of dysphotopsias. What they observed was an increased metabolic activity in the frontoparietal lobes of the brain, the cingulate gyrus, and the caudate nucleus. Basically, what it meant to tell us was that there is much more happening in the eye than the visual acuity at the occipital cortex. This is the MRI plate of one of the patients where we see increasing hotspots in the frontoparietal, cingulate, and the caudate nucleus areas of the brain. We all know that the frontoparietal lobe controls the judgment and size, shape, attentive features of the brain. The cingulate gyrus cortex is associated with more cognitive functions like emotions and memory. The caudate nucleus is involved in adaptive behaviors. So just to highlight here that apart from our visual cortex, which is getting activated during the neuroadaptation process, there are other areas of brain which have to be actually working hard for us to adapt to this new phenomena of multifocal lenses. The heartening part of all this is that our brain is neuroplastic, and a brain can be molded at any age by forming new circuitry. So 90% of our patients will eventually neuroadapt. The timeline can be variable, and sometimes it can be as long as 1 or 2 years. But what is really disturbing is that 10% of the patients will never neuroadapt. And these are the patients which are going to give us sleepless nights and even would want to have an IOL explantation. So what can we do when a patient like this comes to our clinic? We have a choice. We either wait for the natural process of neuroadaptation. Like I said, that the time is not in our hands. Some people can get neuroadapted in a month's time, and some may take even a year or two to get adapted. In the interim period, we can give some lubricating or meiotic eye drops, which act more or less like placebos and buying time. Some of these patients can be really bothersome, and they are bothered by what they are seeing, and they bother us, and we may take a decision to explant this lens and replace it with a monofocal lens. Obviously not a great option for any cataract surgeon. Or we have now a new option. Can we train this brain to fast track neuroadaptation? Let's come to some basics of managing a patient who comes with us with these complaints, who's actually 6'6", N6. We have ruled out any pathology in the eye causing for the patient to be unhappy. So the first thing is to always look for any presence of any phorias, because even sometimes a mild phoria, which has been missed in the preoperative diagnosis, can lead to many of these patients not being very happy with what their visual quality is. So I would strongly recommend looking for a presence of any phorias in these patients. Look for any vergence anomalies. We all know that convergence insufficiency has a prevalence of around 20% in the general population. There is a possibility that many of these patients actually have convergence insufficiency, and that actually compromises a lot on their binocular vision functions. They don't have that kind of a depth perception. They don't have a good fusion. They don't have good stereopsis. And that is the real reason in many of these cases where they make them unhappy. Like I also mentioned, that there is a scope for improving the functioning of the brain for neuroadaptation. Let's see how we can do that. There's a lot of research and science which is going on to this in this aspect. David Pinerio from the Alicante University of Spain has been working a lot on this, and he has proposed and developed many games, video games, which take care of fast tracking the neuroadaptation. And this is something which is really very interesting. The games are based on the principle of dichoptic training. Dichoptic training is where two contrast adjusted images are presented to two eyes. The one eye gets an image of contrast which is more than the contrast image of the other eye. Primarily what it does is it helps to develop a good binocular vision in these patients. And there are many games which are built for improving the perceptual and cognitive training of the patient. And such games have been adopted in various other aspects of a human being. They have been adopted for post-stroke patients, for a faster rehabilitation. They've been used in many children with learning disorders. And these perceptual and cognitive training games have really been very helpful. Can we use these games and use them for the benefit of our multifocal patients for a neuroadaptation? Because we all know that even one such unhappy patient disturbs our sleep, and we may have hundreds of patients who are so happy with the multifocal lenses, but one such patient, and we lose our sleep. Because we know that IOL exchange is not really a happy option. What really needs to be done, as Dr. Yogesh mentioned, that the manufacturing companies obviously need to continuously innovate, give us better options of EDOF lenses, accommodative IOLs, so that we have a huge choice here to circumvent the issues arising from the rings of the multifocal lenses. But the other aspect is, can we adopt these games for improving our fast tracking of our neuroadaptation? Obviously, we need more clinical data on this, but I personally have a huge fan of these, and I feel that there is a lot of scope where we will be able to train our brain and actually use these neuroadaptive methods for every patient of ours who undergoes a multifocal IOL, so that they actually adapt to the new system in the brain much faster, and we don't give them a chance to complain. Thank you very much for your kind attention.
Very nice, informative video, sir.
Shall I
Thank you.
ask?
Thank you, Gul.
Yes, sir.
Can I have one or two questions with you?
Sure, sir.
I do understand, I mean, with excellent presentation which you have given, but just in my personal capacity, I wanted to know, did you really have to explant any multifocal lens, exchange it, only because there was no neuroadaptation?
So many of these patients actually do complain of having some weird symptoms, and some of them do complain about glare, but many of them had complained that they're just not able to adjust, and we have not found on the questionnaire any kind of glare, halo, but they feel that their vision is not as what they would have wanted it to be. And personally speaking, I've had very little patients who come back to me for explantation, but I also know that some of my patients have actually gone to other clinics and got the multifocal explanted. And that's been an experience. Also, having spoken to a lot of my colleagues in the West, where patients are far more demanding than what we have in India. And I've had an experience of talking to surgeons like Dan Tran from California. And he says that he has at least 10% of his patients who actually sit out his clinic and go in for and ask for an explantation.
Yeah,
so the incidence is not very high in India, but it is very, very big situation in the West.
Gul, I totally agree that our population is more forgiving than the Western population. I entirely agree with you. One important thing I just wanted to share, maybe Sandeep also and Dr. Katta would agree with me. Rahul, you can also join that the angle alpha and angle kappa. We do not often, go into the detail of it when we are doing a multifocal practice, and that could also be one of the factor. I mean, right in the beginning, if we have taken up a decision that this patient is not fit for multifocality, then possibly the such incidences will be rare. Having said that, Gul, there is important thing which I just wanted to share, that there have been incidences that the patient is extremely happy with the first eye multifocal lens, and unfortunately on the second eye while operating, some complications occur on the table, and we are forced to put a monofocal lens in that eye, and still the patient carries on quite well throughout their life. Of course, he is not 100% happy, but he is still, he is kind of a forgiving patient who would carry on with that kind of a thing. Any panelist has to add anything in that regard? Rahul?
In my practice, I try to counsel the patient in early only, and I don't choose any patient who is very particular of his working style. If he wants 100% for distance and near, I don't encourage him to go for multifocal. If a patient is very forgiving or enjoying type of patient, then I try to put a multifocal.
Good. I think baseline is that a good counseling is the important part.
May I ask a question, sir?
Sure. Go ahead, please.
Say, visual pathway is connected with optic chiasma and occipital cortex. But you have shown responses in the frontal and parietal. How do you coincide with this? Visual pathway is in that way, Okay, please.
So that's exactly what I was trying to point out, that we've always been considering the visual pathway for the best visual experience. But this study with functional MRI clearly showed that there are other areas of the brains which are also trying to adapt to the situation. That was exactly the very fascinating point that came out of that study on by doing functional MRI, where it showed that the brain is not only working at the visual cortex, it is also working in other areas. And these areas have nothing to do with the visual experience. And that's what the whole paper was all about, sir. That we need to look beyond. We need to look beyond. Though we understand that we counsel the patient profile is important. But what is really important is also about the neuroplasticity, an angle which we never look across. We always look at patients, how good the patient is in this compliance. But there is something which is happening beyond that at the level of the brain, which is not in anybody's control.
Uh, Sandeep, are you ready?
I'm ready.
Yeah, good. Sandeep is a very energetic, innovative, and excellent surgeon from Santa Cruz city of Mumbai. He has vast experience in the phacoemulsification and intraocular lenses of various kinds. He has been in this field for maybe more than 25 years. I'm not sure, Sandeep, exactly,
30, more
but
than 30.
more than 30. Okay, for correcting me. I'm sure that his presentation is going to be par excellent. I've heard him on many occasions and I've really enjoyed it. All yours, Sandeep. Please go ahead.
Thank you, Yogesh Bhai, for those kind words. Thank you, BOA. Thank you, MOS. Thank you, Dr. Lahane, Dr. Ragini ma'am, for your exemplary leadership, and to Swapnesh and Preetham, who have worked tirelessly to put up an excellent conference. So after that very cerebral activity from Gul, I come to that thing which causes these problems in the first place. So all of us are desirous of giving our patients the best possible vision. And in today's world, depending upon the optical principles on which these works, there are many such presbyopia correcting IOLs that are available in the market. So there are refractive multifocals, which are essentially bifocals. There are diffractive multifocals. There are accommodative IOLs. There are extended depth of focus IOLs and trifocal IOLs. Now, some of these lenses have fallen into disrepute, mainly because of the unwanted side effects they have. Like, for example, in the refractive multifocals, the photic phenomenon that they cause, the difficulty with reading, the unwanted images, and in accommodative IOLs like crystal lens, which Dr. Yogesh just mentioned, there are genuine issues with performance. So for the rest of the lecture, we are not probably going to talk about these IOLs because they are hardly much in use now. So what are the currently used presbyopia correcting IOLs? They are the diffractive multifocals, again, something which is fading out over a period of time, the extended depth of focus IOLs, and the trifocals. Now, what about diffractive multifocals? Essentially, you must remember the word multifocal to call them is a misnomer. This is because the lens implant companies, when they manufactured bifocals and they called them multifocals. But essentially, all multifocal IOLs are either bifocals or trifocals. So the type that I'm talking of now are essentially bifocals. They split light into two different foci, one for distance and the other for near. They're essentially two types. The full optic diffractive, where the entire optic has got a diffractive zone starting from the center to the periphery, and the apodized diffractive, as suggested by the Restore, where the central 3.6 or the 3.4 millimeter, depending upon the edition, are apodized in such a way that the step heights and widths are different. There are larger step heights in the center, and as you go towards the periphery, they reduce. So as you go to the periphery, less light goes for near, more light goes for distance. However, the drawback with that is that when you are working in a mesopic condition where the light is not very good, these patients have genuine difficulties in reading. And that's why these lenses have fallen into disrepute and we don't use them too much. What are the key considerations about these lenses? One is that the amount of near addition is dependent on the step height, okay, and as well as the width. The greater the near addition, closer the working distance. Greater the addition, wider the split, and larger the halo. Greater the diffractive zone, larger the amount of light lost to unwanted areas or by destructive interference. In case of the full optic diffractive, you begin with a 18% loss of light straight away. And hence these lenses suffer from reduced contrast sensitivity. As opposed to that, the extended depth of focus IOLs are of two types, the diffractive and the non-diffractive. The diffractive are the full optic diffractive like the Technis 2.75, the apodized diffractive such as the Restore 2.5, and the echelon diffractive like the Symphony, which has a near rad of 1.78. We have also newer non-diffractive EDOF lenses coming in the market, the Vivity from Alcon, which I've just recently had some experience with, the Lucidis and the Miniwell. Now let's look at the optical principles of the EDOF lens. In the EDOF lens, in the monofocal lens, as you know, there is a distinct single focus that comes to a focus on the retina. In a multifocal lens, there are two distinct foci. When you're looking at distance, the distance is focused on the retina. The near focus is within the vitreous. What happens in case of EDOF IOLs? Basically, there are two ad paths, one plano, one 1.78. But because these 2 points are very close to each other, what you get is an extended depth of focus because there's an elongated focus, and hence you can see some amount of distance and intermediate very well. Now, the EDOF IOL is best represented by the Symphony, which has got a unique echelon diffraction grating that leads to a low add of 1.78. As I said, it leads to an increased depth of field. It has got some technology to correct the chromatic aberrations. It therefore provides better contrast and less glare and halos as compared to bifocals. However, the most important thing that we have to remember is near vision is often compromised as addition is low. So what do you do to correct this problem with reading? As you know, all Indian patients demand reading. You can have the best explanation given pre-op to the patient, but when the patient does not read post-op, he's unhappy. And therefore, some ways and means were devised to get over this. Like you could do the traditional monovision, you could do a micro monovision, or what we do now is the modified monovision. That means you correct the dominant eye for distance or for minus 0.25, and you correct the non-dominant eye for minus 0.75 or minus 1 diopter. Now, what is the problem with monovision? In monovision, the biggest problem is that it's difficult to predict whether your monovision will work. It's difficult for even an experienced surgeon like me to calculate and customize for each patient. In fact, you must remember that it is very difficult in this geriatric population to even determine which is the dominant eye, especially when there is a significant cataract over there. And in case the non-dominant eye, which is corrected for near, has even a mild pathology, like a small epiretinal membrane, near vision can be severely compromised. And very often these patients will demand and will use readers for reading and other up-close activities, even if initially they have been successful in near vision. So very often you have, at the end of the day, some unhappy patients. Now, what is the modern day lifestyle that we have? You have the digital world today, where intermediate vision needs have increased exponentially. It's difficult to segregate intermediate and near task as both are required almost simultaneously. You must remember that you cannot segregate this. So if you have an EDOF lens which gives you good intermediate, but at the same time he cannot read, he becomes a very unhappy patient. Now, modern day trifocals are based on the principle of diffraction, wherein the incoming light is split into 3 different foci, namely for distance, for intermediate, and near. Now, there are 2 kinds of these lenses. One is what are called as sequential diffraction and non-sequential diffraction. Let's see what it is. In a sequential diffraction, the intermediate focal point, the intermediate focal point of 180 degrees is used to maintain usable near vision at 40 centimeters. You will always find that you have 1 step height, which is for near, which depending upon your add 3 or 3.25 or 3.5 is of a certain height. The intermediate is normally half the height, hence the distance becomes double. So if you have a near vision at 40, you get intermediate vision at 80. If you had 30, you will get at 60. But the problem is 30 is that it is too up close and becomes difficult for the patient to use. Now, if you look at the modern day trifocal, we are now talking in terms of the panoptics, which has been introduced by Alcon. It has a non-sequential diffraction technology. Here, instead of having 2 step heights, you have 3 step heights. These step heights are all of the equal size, so they are non-apodized, equally spaced, equal heights. Of course, the heights vary because there is 1 for distance, the near is the maximum, then you have half of that, which basically gives you a light source at around 80. And then you have a second step, which is of a height of 60, and then one of 120. Now, what happens to the 120? The 120 at 4 feet from the eye, the technology has been devised so that light from this point is directed to distance. So therefore, there is better utilization of light energy, almost 88%, and better contrast sensitivity. Just to explain that the trifocal is essentially a quadrifocal lens. There are foci at 40 centimeters, 60 centimeters, 120, and at distance. The one at 120 centimeters is directed to distance, hence the light increases for distance, giving better contrast. And just to explain to you, this is how it is, and these are the 3 different foci which are seen within the eye. Now, what is the ideal intermediate range? The ideal intermediate range, as determined by the OSHA, which is the Occupational Safety and Health Administration, recommends 60 centimeters for comfortable computer work. 80 centimeters, which is available in some IOLs, is not very practical. because an 80 centimeter is going to be the arm length of a person who's more than 2 meters tall. And Indians are not so tall. So for Indians, a 60 centimeter working distance is good. And if you can give a functional range to your patients between 40 and 80 centimeters, they are able to do most of their tasks, their hobbies, which they are so very fond of. What is the significance of the diffractive zone size? The PanOptix trifocal has got a diffractive zone size of 4.5 millimeters. At 4.5 millimeters, it is not so small that it will cause a problem for reading when mesopic conditions prevail. And at the same time, it's not too large to compromise distance when the person is driving at night. Okay. And light utilization is important because it helps to improve the contrast sensitivity so that your patients, even in their reclining position, can take care. Now, let us see some of the studies that are available as far as these trifocal lenses are concerned. This is one of the most popular studies. This is important for us because this comes from our own country and worked by eminent people like Dr. Vasavada, Dr. Ramurthy, Dr. Prema Padmanabhan, Dr. Jagdish Reddy, Naren Shetty. So what they have shown is that at all ranges of vision, whether it be for distance, for intermediate or near, the PanOptix achieves a visual acuity, a logMAR acuity of 0.8, that is 20, 25 or better. Now you can't ask for better results than that. And if you compare the PanOptix, now there are various studies which are available in the market where they have compared with a mix and match situation. Like for example, they have compared PanOptix in one eye and a Restore 4 and a 3.3 in the other eye. They have found that the binocular uncorrected and corrected for intermediate distances was far better with the PanOptix as compared to the mix and match. And here is another mix and match, which is with the +3 and the +2.5. And here they found that it provides better intermediate and near vision as compared to this combination. If you compare the activity of this lens with the Symphony, which is basically the peer-reviewed lens as far as EDOF IOLs is concerned, that the binocular defocus curve is much better with this because the Symphony basically lacks the near vision, and therefore there is a problem. Not only that, if you ask these patients, the quality of life and the vision FQ25 questionnaire near vision score as well as some score turned out to be significantly better in the PanOptix group. The PanOptix IOL, again, another study, as was the Symphony, provided better near and preferred reading vision activity and a more continuous range of vision as compared to the Symphony IOL. Now, amongst these class of trifocals, if you compare the 4 trifocals that are available today, the PanOptix, the Fine Vision, the AT LISA, and the Ray 1, the last 3 are essentially hydrophilic, though Fine Vision and Ray and AT LISA may say that they are hydrophobic, but they only have a hydrophobic exterior. We prefer a hydrophobic lens because of the various reasons I don't need to go into detail. The best part I find about the PanOptix, it has got a length of 13 millimeters. So it can adapt to a capsular bag of any size, right from a small child to a grown-up adult, from a hyperope to a very large myope, even a normal emetrope with large capsular bag. And you don't have to stick to 11.4, 11 or 12.5. And mind you, some of these lenses can rotate, which can be a problem in astigmatism. If you look at the intermediate to near ratio, in the others, the ratio is 1:2. So while the reading distances are more or less at 40, in the Fine Vision and the Ray 1, the reading distance, the intermediate working distance is about 75 centimeters. In the AT LISA, it is 1.66. And in the PanOptix, it's a comfortable 60 centimeters. If you look at the distribution of light, both the PanOptix and the Ray 1 send nearly 50% of the light to distance, which are the best in class, and hence they provide probably the best contrast sensitivity. Fine Vision and AT LISA provide less light for intermediate, 15 and 20% as compared to 25% for the PanOptix, which makes it good. And if you look at the loss of light, again, the PanOptix and the Ray 1 score as compared to the other two. And here are comparisons within the group itself. The PanOptix lens provides better intermediate vision at 60 centimeters as compared to the Fine Vision. And if you compare it to the AT LISA, the rate of severe and bothersome halos was higher in the hydrophilic group. The percentage of patients reporting never using spectacles for intermediate visions was significantly higher in the PanOptix group. And there are other, but I will not go into details now because of paucity of time. One special precaution that I will always emphasize is that whenever you are doing a PanOptix or any kind of trifocal or any kind of multifocal or presbyopic correcting, you should have excellent biometry. If your biometry is not good, the lens may not be very forgiving. And there are studies to show that. And of course, you have to have an assiduous management of astigmatism. I use the Barrett-Torrey calculator in all these cases. And my threshold, Yogesh Bhai spoke about astigmatic threshold. For him, it was about 1.25 diopters. When I'm doing a multifocal lens, my threshold is very low. Anything more than 0.5, I will go to correct. Now, remember, the toric T2 model is available, so even lower degrees of astigmatism are correctable, and I prefer that to doing an LRI. So the biggest advantage of trifocal lenses provides good, seamless, unaided monocular vision at all distances, whether for distance, intermediate, or rear. Remember, in a EDOF, you have to depend on one eye to give you near vision. Here, each eye will give you near vision. And binocular summation, as Gul just mentioned, enhances further both quantity and quality of vision. You just need to target emetropia. You don't have to do a mix and match. And once you get the hang of it, the results are highly predictable. The glare and halos are not worse as compared to bifocals. And the contrast sensitivity is comparable to EDOF IOLs and certainly better than multifocals. So in this quest for achieving good unaided vision for distance, intermediate, and near with reduced photic phenomenon and reduced visual disturbances, the trifocals, in my opinion, seems to be emerging as a clear winner. Thank you so much.
Excellent presentation, sir.
Thank you, Sandeep. I think one very important point which he also brought out is that the Indian pupil is relatively a smaller pupil.
Yeah.
And hence one has to be very careful because the studies which have been done in abroad, foreign countries, is not possibly applicable. And he aptly pointed out the study which has been brought out by our Indian colleagues who are the leaders in this particular field. Thank you, Sandeep. As usual, it was par excellent and simplified explanation which possibly everyone can understand. Any question from anybody? I think I would request speakers to stick to the time because we are possibly taking a longer time than what is allotted to us. Next speaker is Himanshu Matelia. Is he there?
Yeah, he's there.
Yes.
Himanshu?
Yes, sir. Good morning.
Good morning,
I'm
Himanshu.
right.
Himanshu is a very dynamic surgeon from city of Bangalore. I just would like to share one small thing. Himanshu's father and me were very close to each other, sharing the same perimeter, and we had a lot of conversation on the perimetry in those good old days. So Himanshu, I'm sure you've been doing a lot of great work. We do hear from your side. We request you to go ahead with your talk on sizing the phakic IOLs.
Thank you, sir. I really appreciate.
Go ahead.
Thank you, sir. I really appreciate MOS and BOA for giving me this opportunity, and I'm really enjoying my Sunday morning with wonderful talks which preceded my talk. So I'm going to talk about the sizing of phakic IOL, and I do not have any financial disclosure. Just that the two commonly used phakic IOL in the world currently is ICL and IPCL, and my experience is limited to these two, and hence I'm going to stick to them. However, the principle remains same, and you can apply to the other lenses which you might be using. So when we talk about sizing, the most important part of the lens outcome is basically vault. Now, what do we mean by vault? Well, vault means the back surface of the phakic IOL and the natural lens, the distance between that. The ideal vault measured in micron is somewhere around 250 micron to 750 micron. However, the lenses sometimes can have less than 200 micron vault also. However, please remember the vault can sometimes be dynamic with the pupil changes. Sometimes the vault, what you see on slit lamp, can sometimes be a little different from the person when it goes in bright light. So any vault which is less than 200 micron is not the best lens to keep in the eye. Sometimes with the deep anterior chamber, larger vault can be forgiving, but they can lead to pigment dispersion. So just be aware of that. What are the problems with different vault? As I said, if the vault is very high, there can be potential chance of pigment dispersion, angle closure, or if the vault is low, then there can be touch with the natural lens and you can have early cataractogenesis. and even the toric lenses can have rotational instability. When is the vault reliable? Well, if it depends on the technique which you have used. I normally prefer the hydroimplantation, where I use BSS to implant my lens. So the vault is reliable a little earlier, quite immediately. However, if you use visco, then if the visco is in front of the lens, then vault can be falsely low. If the visco is left behind, partly behind the lens, which can show falsely high vault. So remember, whenever you're using visco, do not jump over to the decision of the vault before 3-4 days, where the complete amount of visco is washed off from the eye. What happens whenever we talk about the outcome? That depends on the parameters which we take for the phakic IOL. Well, the phakic IOL, the most important parameter for the phakic IOL sizing is AC depth and horizontal white to white, apart from the rest of the other parameters which we use. Coming to these two parameters, anterior chamber depth can be measured by any optical devices like A-scan. If you use A-scan, then you have to detect the pachymetry, or more preferably nowadays, we use optical devices like Pentacam, IOL Master, ASOCT, or even the UBM. The cutoff value, safe cutoff value is 3 millimeter, but we'll come to that later on. However, when we talk about anterior chamber depth, it's not just about the AC depth in millimeter. You also look at some other things like angle anomalies, which you might want to see on your gonioscopy, pigment dispersion, pseudo exfoliation, sometime even the cyst in the ciliary body region. Those things would be important. The iris topography is very important when you look at the iris, whether the iris is convex or whether iris is flat or it's concave. It's very important to see. One interesting other component which has recently come up, which is called crystalline lens rise. So on ASOCT, when you join 2 points of the iris which joins, which touches the lens, and the amount of the lens in front of it, it's called crystalline lens rise. Higher the crystalline lens rise, lower the vault, and such kind of patient can sometimes bring you surprises. Coming to the white to white measurement, well, the ideal method told by company to us has been take the patient in OR, ask the patient to lie down, and in supine position using a digital caliper measure the white to white. Please remember, it may not be very practical solution every time taking patient in OR. So many of us use a simulated method on slit lamp with the diffuser on and with a moderate amount of illumination and the magnification. Please remember, whenever we take the white to white measurement, some of the cases can have an indistinct limbus, and such kind of thing can bring some kind of confusion and optical method, and hence the manual measurement is very important. The middle of the limbus from other side of the middle of the limbus is where we measure. The digital calipers are widely available and you do not need to spend huge amount of money. The vernier calipers, what we use, Castroviejo caliper in OR, may not have a very good accuracy because the steps usually is 0.5 and sometimes even 1 millimeter steps, and hence they're not the best thing. Instead, you surely can spend a couple of ₹1,000 for digital caliper. However, I prefer to use double technique where we use two techniques. One, the optical device, and second, which we confirm with the digital caliper. White to white measured with optical device can be OpScan, IOL Master, Pentacam. But please remember, none of these devices actually correlate with each other. This is my own eye, right eye, and taking measurement on 4 different devices, and I have 4 different measurements. There's nothing right and wrong here. You should consistently use one particular device. And what I do is I prefer to take one optical device first in my hand. It's Pentacam. I do not go by the intuitive Pentacam measurement, what it gives. I rather do it myself. I put a horizontal slit, do an image inversion, and with the digital caliper on the Pentacam machine, I measure. Now, this is my baseline. And then I put this baseline on my digital vernier caliper, and then I confirm that. And whatever adjustment I have to do, I do it there. And that's my final measurement, which I take. So basically, cases where optical white to white can be fallacious are like those VKC kind of cases where there is significant pigmentation in the nasal and temporal region, where white to white measurement on these devices can be sometimes faulty. So as I told you, my technique involves something where I go ahead on the Pentacam, do an image inversion, measure it, and take this measurement on my digital caliper, and on slit limb go ahead and confirm that it's fine. Whatever adjustment I do, I have to do it there, and that's exactly how I prefer. When we put the lens on in the ciliary sulcus, and when we take the measurement of white to white, horizontal white to white, there has to be some correlation between them. Well, there are a few studies which showed that horizontal white to white and STS correlation is such that STS is 0.4 millimeter larger than horizontal white to white. Having said that, there are enough studies which showed that the correlation between white to white and STS or sulcus to sulcus is very poor. So not always they both go hand in hand. And that's the reason why you can have surprises, because you take the measurement from white to white and then you decide to put the lens in sulcus, which is a little different. So why can't we measure sulcus? Well, there are some ultrasound biomicroscope UBMs which can actually help you to measure simultaneous sulcus. Please remember, not all the UBMs can allow you simultaneous sulcus, but many of the UBMs do allow you. Some of them can actually give you simulation also, like Quantel here can actually allow you to do a simulation of the lens and the lens vault, which is very interesting thing to do. Now, does it mean that STS is sacrosanct and everybody must buy UBM and that's the best thing? Interestingly, no. The UBM itself has its own interpersonal variability and high variability in different hands. So STS measurement per se is not something which you can always trust upon. And no company is going to tell you to do the measurement based on STS, because that shrinks their market drastically, because that means everybody needs to have some particular types of UBM, and which is not good for the phakical selling companies. So what trick I use is, before I go to that, I'll just give you the simple trick here, that whenever we take a one size lens and put it in an eye which is a larger white to white or larger STS, the vault will be less. Now, if the same lens, if you put in a smaller eye, the vault is going to be high. It's simple, right? I mean, there's no rocket science here. Taking this thing further, if we take, so this, what I have done is I've taken the calculator and I've measured the different white to white and the different lens size. And I'll take the example of ICL first. So if we have, let's take the white to white of 11.70, the calculator is going to tell me to put a lens of 13.2 millimeter, which means the lens is 1.5 millimeter larger than my white to white. Now, the same time, if I had 12.3 millimeter white to white, the calculator would have still told me to put 13.2 millimeter lens. That means my lens is 0.9 millimeter larger only. Where do you think the vault will be high? Of course, the first one, right? Because the lens is much larger than the space available there. Now, the problem is that when you have white to white on the lower side, whether it's ICL or IPCL, in the range where it's going to suggest the same size, your vault is going to be high. And now, if your anterior chamber depth is low, this is a bad combination. So such kind of cases, be aware that you may end up in trouble. So such cases, you might want to take possibly lower size, or just be aware of your higher vault there. Now, let me take an example of now toric IPCL. Now, what if I get a white to white of 11.65? The calculator is going to tell me to put 13 millimeter lens, which is 1.35 millimeter larger. Same time, if my white to white is 11.93, calculator is still going to tell me to put 13 millimeter lens. Now my lens is only 1 millimeter large. Where do you think the vault will be low? Well, in the second part. And how does that matter? Well, remember, my example is toric IPCL. I want rotational stability. If the vault is low, rotationally, this lens actually may not be as stable and it can have rotation. So what I would prefer is that when my calculator tells me when I'm on the lower side of the range, when my calculator tells me to put 13 millimeter lens, instead of 13, I would put 13.25 millimeter lens. So I'm 0.25 millimeter larger than what my calculator tells me. And that means I may have a little larger vault. And how much larger vault? Well, I would have possibly 40 to 60% larger vault. So I might have 100 to 200 micron, 100 to 150 micron vault larger, which is not a great thing. So with all such kind of tricks and repeated measurement in your hand, I'm sure the phakic IOL can become cakewalk. Thank you very much.
Thank you very
Excellent
much,
presentation,
Himanshu.
sir.
Yeah,
Yeah.
sir, Dr. Kudlu here. Yogesh sir, good morning.
Yeah, good morning, Dr. Kudlu. Good
yeah.
morning.
Morning, Himanshu. Good morning to all our esteemed speakers and my friend. There one question to you, Himanshu, especially white to white. People been arguing from mid limbus to mid limbus, but nowadays people even say that you have to take measurement from where the black ends. People always argue on this particular topic. Exactly, black to black means where the black ends till the black ends. What is your personal opinion on that?
So, KP, as I told you, that irrespective of wherever you take measurement, the correlation between your white to white and STS is pretty moderate. Most of the studies have correlation which is moderate to poor. So whatever you take, it's not going to be always accurate. So I really don't think we are getting into a smaller thing where. So the important thing comes when the limbus are elongated. Many cases where you have slanting limbus or elongated limbus, and that's the place where the center part of the limbus they tell you to take. Earlier, when we started, we were told to take clear cornea to clear cornea, black to black, as you told. And then later on, companies decided that, okay, you know what, let's go in between that. But having said that, they also know, and we know, that whatever measurement we take, your outcome is going to be little variable. But at the same time, also have to remember, like if you are talking about ICL, there are only 4 sizes available. So any small such kind of differences is still going to lead you to one particular size only. But the problem is when you are on cusp, when you are, that's where I was talking about those tricks, that when you're on cusp, whether on the lower side or the higher side of the range, that's where the problem starts. So it's not just about one particular thing. It's about the combination of these two things and availability of my AC depth and availability of my, whether I'm dealing with a toric lens or not. That's where I would decide. But I really don't think such kind of thing would matter too much.
Thank you.
Himanshu, just small clarification.
Yes,
when
sir.
we are measuring sulcus to sulcus by UBM,
Yes, sir.
the various configurations of the iris, will that
Yes.
make a difference? Because the
It
magnification factor will change.
Sure, it does make a difference. In fact, I would say UBM. Last week I had a case where the sulcus to sulcus was very different from white to white, and which happens when you use UBM. You come across many times such kind of cases. And obviously, when I'm putting the lens in sulcus, I would go by sulcus to sulcus. And I went with sulcus to sulcus, and patient had such low vault that I had to explant the lens. And when I recalculated it, the lens power, lens size came to something which could have been proper from the white to white. So here it is where the sulcus to sulcus, where my lens sits, that itself was not accurate, because UBM, as you said, UBM per se can have quite significant variability. Even myself, if I measure from the intuitive measurement of UBM, what the machine gives, I get variability there. So UBM per se is not sacrosanct. That also can have problem. We have to be aware of that.
In nutshell, can we convey to the audience that possibly the digital measurement, manual digital measurement is something which is possibly the best as of now?
So, sir, I don't think there is about any best or not best here. It's about what works in your hand. Now, for every patient, you have to send somewhere for the UBM, which may not be very practical, which may not be required even for the company side. So, it's about one particular measurement in your hand, whatever works, and one particular method, what works in your hand. At drop of the hat, if we keep changing the things, which may not be very great idea.
Great. So now we go to the next speaker. And once again, I request to stick to the time because we are possibly taking longer time than what is allotted. Annaga is here.
Yes, sir. Good morning.
Good morning, Annaga. How are you?
Fine, sir. Thank you.
Yeah,
Fine.
Annaga, as we all know, is a dynamic surgeon from Bombay. She is also a member of ARC of All India Ophthalmic Society and has a lot of workload with her own private clinic, Anil Eye Hospital. She is also an excellent speaker, and I'm sure we are going to listen to good talk from Annaga. Thanks, Annaga. Go
Thank
ahead.
you, sir. Thank you. Good morning, everyone. Am I audible, sir?
Yes, yes,
And is
absolutely.
my
And your
slide
slides are
visible?
on.
Yeah,
Yes,
visible.
slides are visible.
Yeah. So thank you, BOA and MOS. Thank you, Lane sir, Ragini ma'am, for giving me an opportunity to speak. Actually, after an excellent talk by Himanshu sir, who has really made my talk even more easier, I would be just sharing my thoughts on this. Some tips and tricks in phakic IOLs, no financial interest. Yes, myopia, the incidence is increasing to the extent that by 2050, nearly 50% of the population is going to be affected by myopia, and all of them interested in refractive corrections are going to come to us. And a lot of them have very high myopia. First thing for the beginners, I would like to say, get out of your comfort zone. A lot of us are comfortable doing LASIK, but when it comes to beyond LASIK, sometimes we get jittery. I know that there could be a learning curve, but because we are already used to using plate haptic IOLs, definitely this learning curve is going to be short for us. But what it requires is perfect planning, meticulous surgery, regular follow-up to look for complications. Now let's start with an example like this. Now, when we have a moderate to very high myopia and a borderline pachy like this, definitely we would think of something beyond LASIK, because these patients would not do well with LASIK and would have very high aberrations that are going to be induced if you stick to LASIK, or would have a residual refractive error. So in this case, when both the eyes had, and there was an ametropia, the eye with the higher refractive error, we went ahead with a phakic IOL and we could get good refractive correction and a good quality of vision also to the patient. Now, the main reasons why we fear phakic IOLs is because we think that there could be an improper outcome because of an improper decision making, whether it is related to patient selection, measurement, lens size, or the implantation technique, finally leading to an unhappy patient. So let's see in the preoperative, intraoperative, and postoperative situations what we can do to overcome these problems. So first and foremost is you have to select your patient well. Refraction is absolutely important. A cycloplegic refraction is mandatory. Remember, the power of the lens that you're going to select is basically dependent on the manifest refraction. So repeat the refraction every time, and also look for any stability in the refraction, because if at all it is unstable, and remember, there could be progressive myopia or there could be nuclear sclerotic changes which is causing the change. So all this becomes very, very important. If you are doing it on a patient of keratoconus, where also phakic IOL is recommended, remember there should be stable refraction and topography scans for at least a year. A central cone, clear central cornea, and values less than 52 will give you better visual outcomes. Now, definitely we know what all we are going to do for a refractive surgery workup, not only LASIK, but also for phakic IOL. Here, what extra you would do, Dr. Himanshu sir has already given us the entire overview. What I would like to add is basically not only glaucoma evaluation, but also retinal evaluation, especially in these very high myopes, is important. And not only pre-surgery, but also tell them that even post-surgery, they need to keep checking their retinas also. Whenever you're doing a biometry, always correlate the axial length with the myopia. If there is a very early nuclear sclerosis, and if there's a high myopia, you would probably missing it. So that is why sometimes you can do a eye trace where dysfunctional lens syndrome can be easily picked up in these patients. Now, as we have discussed already, now what I prefer is taking up the patient in the OT and under the microscope so that the patient is used to it and ask the patient to fixate on the light, and I take it from where the black ends. Now, you should do what works in your hands, but over the so many years, in my experience, this has worked for me. And I usually take 3 readings and calibrate the digital calipers every time. So I switch off, switch on, calibrate, and then take the reading, 3 readings, and then take the average. Now, whatever other automated measurement you're using, like the IOL master or the pentacam or the lens star, remember, they will always overestimate the white to white, and they will give you different readings. So do not compare them directly. There is always going to be a difference. Usually by the rule of thumb is the IOL master is usually around 0.5 millimeters more than the white to white. Now, what is important is whenever you're doing a manual measurement, remember that their increments are higher. So the digital calipers is the best with an increment of 0.1. There is going to be a wide inter-examiner variability. So no matter how busy we are, we need to do it ourselves. I would not really depend on my technician or my optometrist for it. A single observer is important. And whenever you are having a patient with a large arcus, or if there's a pigmentation, I would exclude the pigmentation if any, include the arcus in any, if any. And if when you're comparing both the eyes, they may not necessarily have the same absolute figure. There could be a little different, but you need to correlate and compare. Now, whenever you're doing both digital as well as using automated measurements, remember these automated measurements may be more reliable because they may because there is variability in the examiner variability in the manual measurements. The manual measurements may have lower repeatability, they are more subjective. So ideally what I use is both, and that is why we can correlate and get the best readings. We've already discussed about the UBM, but in my experience also it is more technician dependent, and that is why I would not rely on that. If there is a discrepancy between the white to white and the sulcus to sulcus, I would depend on my white to white and the IOL master reading. Now this ALR has already been mentioned. So greater the lens rise, then greater would be the lens size that we would use so that we get a proper vault. Calculation of the phakic IOL size has already been mentioned, but I would just like to add on one thing. Like for example, let's take this example of, suppose there is a 11.1. So basically the size depends on the ACD as well as the white to white. So if the ACD is less than 3.5 in this case, then you would add approximately 1.1. So that would be 12.2, and round down will be the 12.1. This is for the ICL size. The same white to white 11.1, if the ACD is more than 3.5, they would usually, according to the nomogram, add 1.6, that is 12.7, and that the closest would be 12.6. So basically, if the white to white is the same, remember there could be different lens sizes that are recommended. Always recheck the readings. Usually the company sends you this power calculation. Recheck every parameter that you have given to the company. Recheck and then paste this orientation diagram on the wall of the OR so that you know exactly how to rotate the lens whenever you are having a toric ICL. Know your lens. Now, if you're using an IPCL or if you're using ICL, remember the holes are different. In the ICL, the hole is at the leading right haptic, and the earlier model of the IPCL had a hole on the leading left haptic. Here now you have the newer model, you have the ridge on the leading left haptic and the trailing right haptic. This I would not go into because there is one more talk on this. Now, when it comes to surgery, remember this is the ICL. Use a little visco and a little BSS. You need to just roll on the lens with the silicone tip into the cartridge, and then you hold the cartridge in your left hand, and as you are grasping the tip of the lens, retract the cartridge on your left. Do not pull on the edge of the lens because you can damage it. Now the silicone tipped plunger is then inserted into the injector, and first always load the lens and only then go on to the eye. Here I'm using making first a groove, making a tunnel, and then the 2 side ports, injecting HPMC. There are people who would also inject hyaluronate. It's up to you. And then making a 3.2 millimeter incision. Sometimes I would even extend it a bit. Remember, it should not be a wound assisted insertion because that could cause damage to the wound as well as cause a lens touch. And inject it extremely slowly. Always keep a watch at, now here is the ICL. So the watch on the hole on the right side of the leading haptic, and very, very, very slowly you're going to release and open up the lens. So in the left hand, instead of fixating the globe with a 1 tooth, I would use this lens manipulator and then help to open up the lens. And then tuck each of the foot plates underneath the iris. Remember not to touch the crystalline lens, and very gently then do an irrigation aspiration, holding it at the tip just above the central hole. Keep the irrigation on and then do the stromal hydration. See that the anterior chamber is maintained always. Now here is a case where we are injecting the lens, and then look what happens. Suddenly what happens is the lens has folded on itself and now it's not moving. So now what? So usually in such cases, you just be a little patient, and then with the lens manipulator, you can just nudge the lens very gently and it opens up finally, and then you go on with the case. Now never attempt this. Now this was a case of a flipped lens where the surgeon has in a hurry injected the lens, and then when he sees that the lens has opened up in the upside down direction, he's trying to flip the lens in the anterior chamber. This I would not recommend at all because it can damage the endothelium, touch the lens, and could cause a cataract. So here is the case where I had this problem where the lens got flipped accidentally in the upside down direction. I injected the lens and the lens was folded on itself. I tried to manipulate it and nudge the lens with the lens manipulator very gently, trying to see if it was opening up in the right direction. However, remember that we should not manipulate too much, otherwise it can cause corneal edema on the next day. And then I saw, see, your vision has to be at the hole on the haptic. So here I realized that it was in the upside direction. So I just removed the lens. It's very simple. Just hold it with the McPherson, remove it, reload the lens, and then re-inject it in the right direction, which happened very well. So remember, these are the simple tips. Look for rotation on table when you're removing the speculum also. Sometimes the anterior chamber might suddenly shallow and you need to realign the lens, especially if it's a toric lens. Post-operatively, we have already spoken about the vault. Remember that just because you have a good central vault doesn't mean that there is no mid-peripheral touch. If at all you have a mid-peripheral touch, there could be stagnation of aqueous there because there is a block in the direction of the flow of the aqueous, and that could cause cataract. This is the case where there's a complete separation between the ICL and the crystalline lens. Remember, ICL explantation, the most common reason is improper sizing. Here I had a patient where the pressure was extremely high, even with a normal vault. And here the pressure was almost 50 in spite of maximum medical therapy. So I first decompressed the eye with a 26 number needle. You just open up the incision and make a little slightly larger incision with the lens manipulator. Just very gently remove the trailing haptics, foot plates, and bring it in front of the iris, and then gently with the McPherson, you can just easily remove it and then wash out the ISCO. This was a patient, this is my last case, a 33-year-old patient came back to us with cataract post IPCL. Remember, the only thing I want to say here is when you're doing a biometry, it's an optically clear medium, so you don't need to make any corrections. Here we did a femto for this patient. You remember that there is an IPCL in front of the eye. So first you need to remove the cataract by phaco, then remove the lens so that you don't need to extend the incision, otherwise you could have a leaking wound. So here we removed the IPCL after the phaco, then did the irrigation aspiration, and then put in the lens. And the patient did extremely well post-op. So just to conclude, optimal outcomes you would get with a good preoperative workup. Do not compromise at any point meticulous surgery and post-op monitoring. Counsel the patient. Remember, it is very different from LASIK. Also mention about the risk of complications, put it on paper, reassure them, and have an excellent follow-up. You could also give them options of Indian imported because the cost factor is there. Thank you so much for your kind attention.
Thank you very much, Anaga. I think it was an excellent video and excellent talk. No repetition, I just would like to repeat the statement which she made, which is very important for the beginner. Don't be in a hurry to take the patient in the OT and start working on it. First, load the lens, because by chance, if you break the lens while loading, you have no replacement and you have already opened the eye. You will have to close that particular surgery halfway through. We go to the next speaker now. Dr. Jayan Sarvate will be talking to us on Comparison between ICL
ICL and IPCL. Thank you, BO and MOS, for giving me this opportunity. I just wanted to add one thing that with our lens star or any optical biometer, if we take the white to white, it is always more by about 0.5. So we can manually decrease this with the help of our own judgment, and then do this management of the white to white. So I do not have any financial interest. The phakic IOLs, with the advent of posterior chamber IOLs, anterior chamber and iris fixated IOLs are not favored anymore. Star Vision ICL is there around for more than 20 years now, and our own Indian IPCL and other Indian brands like Appasamy and Bioflex, they are available for last 5 to 6 years. So difference between these two brands, which are usually used routinely, IPCL is a reinforced hybrid acrylic material, and whereas the ICL has got a highly biocompatible collagen and HEMA copolymer. The corneal incision size can be less for IPCL 2.8 millimeters, but it should be usually 3 to 3.2 millimeters for ICL. The power range is different. The widest range is available with IPCL, that is plus 15 to minus 30 diopter sphere, and up to 8 diopter cylinder are available in IPCL, whereas up to minus 18 diopter sphere and up to 6 diopter cylinder are available in ICL. A presbyopic platform of presbyopic IPCL is available as of in IPCL, but ICL it is not available. So it is a highly biocompatible copolymer of ICL. There are some studies which have been done with the quality of vision after Vision ICL by Kamiya Shimizu, and they found that the optical parameters of the eyes undergoing ICL were not significantly different from that of the healthy eye, and optical quality of eyes undergoing ICL is nearly equal to that of normal eye. The differences between the design now. The routinely available ICL V4C model, and now the EVO ICL with a higher, bigger optical size are the models which are available for ICL. And the most important thing is the case aquaport, which was a 360 micron central hole which was present. Then two positioning holes, 2 holes in the haptics for removal of the OVD, and a positioning hole which is there at the right upper and leading haptic. As against IPCL has got a slightly different design. It has got a positioning hole which is there and the left upper side, and now newer one has got a notch also here and here. Whereas in the ICL, the leading right haptic has got a hole. There are 6 haptic pairs for IPCL and 3 on each side, which ensure better rotational stability in the ciliary sulcus. The angled optic haptic junction is designed to prevent excessive vaulting, and it also ensures minimal friction force between the iris and the anterior surface. There are 2 holes of 400 micron on the haptics on each side of the IPCL, as against the central single hole in the ICL. So these are supposed to prevent IOP rise by helping easier removal of OVD. So another feature of IPCL is there are 2 superior positioning holes which are oriented superiorly so that they can be covered by the upper lid. So these holes also ensure continuous aqueous flow from the posterior chamber to anterior chamber. The presbyopic IPCL has got a range from -10 to +6 with the addition of +1.5 to 3.5, and it is predominantly used as a monovision in patients less than 50 years of age, and it can be implanted bilaterally in patients more than 50.
Aryan?
Now, important, as we have already considered that the 2.8 millimeters or greater ACD from endothelium is the prerequisite. It can be slightly adjusted lower to 2.7 for IPCL in some selected cases. Now, I'll just show the difference between loading of ICL and IPCL. This is a slight repetition, but IPCL, the learning curve is less because we have been loading all these years on daily basis, all the IOLs, foldable IOLs in the cartridge. So this is similar to the loading of a foldable IOL, but there is a learning curve because we have to pull the ICL from cartridge to the nozzle. The implantation again doesn't have much of a difference, as it was suggested earlier and shown adequately. We have to be very, very careful and very slow while injecting the ICL or IPCL, so that we know the position of the leading holes while positioning the ICL as well as IPCL. So these things can be noticed, and so we know that it is folded in a proper fashion. So likely difficulties during implantation include entangling and crumpling of IPCL. I have found this for IPCL, but never found this for ICL, especially in the initial stages. IPCL could get crumpled if you don't put some amount of visco in the cartridge. And for that matter, IPCL people also provide you a backup lens all the time. That is a good sort of alternative that you have. Angle closure glaucoma due to oversized lens, and anterior subcapsular cataracts due to undersized lens, and the damage to the optics of the lens with instruments. That is very important. If we want to position the haptics, one should not cover, or one should not traverse the central part, because central optical part is the thinnest part of the lens. So we have to be very careful, otherwise you can damage your optic of the lens with your positioning instrument. And the tear of the periphery of the lens, one can have a situation of removal of the lens. So if it is not removed properly, one can damage the haptic part to some extent while removing this lens. You may have to extend your incision to a certain extent. The ICL sizing has been already discussed very well. So I'll just enumerate. This is the ideal vault ICL, 613. Another patient with a 449 vault, and the stability of vault. This is what I wanted to stress, that after 3 years, after 6 years, and after 13 years. This is my second patient 13 years ago. He came just 1 month back, and I have got his picture of a good vault which is there persisting, and he doesn't have a cataract until now. So this can happen with a higher vault of more than 1 millimeter, crowding of angle, and a low vault can lead to anterior subcapsular cataract. This is one rare complication of a flipped IPCL. So this is sitting just exactly opposite. It is crowding both the angles. So we have to immediately remove this lens, reload, and you can re-implant the lens to get a good outcome. So long-term safety and efficacy with all-vision ICL, there are many papers, and that can be said for IPCL also, though the follow-up is only 5 to 6 years. But all these years, all the studies show that there is a clinically significant cataract in a very low percentage of 0.5 to 1.3% of the cases. Our study also corroborates with the same. So the take-home message is long-term safety and stability of both ICL and IPCL is well established. The Indian brands have a lesser follow-up of about 5 to 6 years. Ease of implantation is more with ICL than IPCL. That is my personal view. And I prefer ICL over IPCL for this reason. Stability of vault of ICL and IPCL is very predictable. The central vault tends to decrease slightly over a period of time, though, so we have to periodically review these people. Long-term complications like chance of glaucoma and clinically significant cataract formations are very low, 0.5% in more than 500 cases in my series. IPCL can be also useful in extreme range of myopia beyond 20 diopters and astigmatism beyond 5 diopters, and IPCL as a treatment for presbyopia also is available. Thank you very much for your kind attention.
Thank you, Dr. Sarvadev. Thank you for excellent presentation. We proceed to the next speaker, Dr. Katta. Most people know him very well. He is one who has been. Can you please switch off your slides, sir, Dr. Sarvadev?
Already I've done that.
Shut down. Then Dr. Katta's slides will come. You have to close your right at the top. You will see the slot for.
Yeah. Are you able to see my slide, sir?
Yes, yes. Go ahead, Dr. Katta,
Yeah,
please.
yeah.
And my request for both the remaining speakers to stick to the time.
Yeah.
We have completed time for our session.
Yeah.
Please, go ahead.
See, why I have selected this, IOL users have given much challenges to retina specialists in viewing and also treating. See, first of all, I would like to offer my bouquet. Please accept this scientific committee, sir. This is the 4th time I am speaking. You see where I have spoken already. No criticism, no financial interest. This is the book being published, and in all languages it is available in the world by Amazon around ₹4,000 rupees. See, this is the 3rd chapter being published in the book in all languages. See, Bernard Matheny in 1946, he was a mechanical engineer. In 47, he was doing a diploma in optics. So suddenly he got the idea. See, Benjamin Franklin, 1784, bifocal by gluing 2 different opticals. See, this is the thing. In 1150 degrees silicon mixture, silicon, sodium, and calcium being fused, then we will prepare. This is the engineering of the optics. Actually, Surat and Bombay is a supplier for whole India. Okay. See, this is the idea of progressive, Newland, and Jupiter. Study, many patients came unhappy. So I myself purchased progressive. I thought, what is unhappy? See, the eye strain images and all, I wanted to habituate. I could not. Finally, after 15 days, I have thrown away bag. This is how long data collection. I did my own study. See, this is the thing. See, when he saw in a bakery, instead of cutting in a rectangular piece, a triangular piece, why can't we cut the glass also? Because he is a mechanical engineer. So afterwards, he did optics. He went to mechanical lab and asked those people whether you are able to cut the glass in this fashion, whatever way I give. So in this way, they said, yes, we can do whatever way you give. See, then he did on 46 people, 5 people excellent, 29 good responses, 2 average, 10 poor responses. See, head can be fixed for certain time. Eye can be moved. See, this is a very important slide. Every degree of band, say I am using distant vision +2, near vision add +3, that means 5. See, every degree of band, 201, 202, like that, 50 degrees. Refraction not at nodal point. At refraction at nodal point, eye movement at center of vitreous. This is very important, sir. These both are not at a single place. That's why more angle of aberration becomes more. See, this is N is a nodal point, H is a center of mobility of the eyeball. See, this is interpupillary distance, centering. This is age. This many users I have studied in 2 years. I have presented. See, these are the materials being manufactured. IOLs. Okay. Yeah. See, digital. See, research, digital micro operation, dim light. So many they did. See, this is very important. SWAM effect. What are the results? See, computer operators, book readers, TV viewers, doctors, especially indirect users, we can't see and focus on a particular fundus point, and we cannot put a laser. This is a very drawback by using multifocals. Drivers, Photoshop, Goldsmith, Tylers, and all. Happy who? Marketing people of all above, politicians all above. What is the SWAM effect? You are able to see. This is the image. See,
your screen is not visible.
Sir?
Your screen is not visible, Katta sir. Your screen is not visible.
Oh, 1 second, sir. Are you able to see now?
No, no.
No, sir.
You are not. You are not able to see now.
No,
Now,
sir.
Now.
Share your screen.
We can see you, sir, but not screen.
Not screen. See, how to do? From the beginning, you didn't see this?
No, sir. We are seeing you only.
Oh, see, sir.
You are talking very nicely, so we are not able to.
That's okay,
focus.
fine, sir. Go ahead. Go ahead because we are running short of time. Dr. Ajay Paul is already there for the
Yeah.
next session. Go ahead, doesn't matter.
Okay, I will give my PowerPoint in that way. I don't know how to regularize
That's
this.
okay, sir. Go ahead,
Yeah.
please.
See, analysis of results, visual gaze direction, which is most important. Eyeball movement can be fixed for longer period. Head movement cannot be fixed for at a cervical level for longer period. That is the problem. Okay, and this is scientific analysis. Angle of upper increases at the point of refraction. Visual gaze bends and passes through various partials of 0.25. That is causing the brain cells do not cope with the accepting digitally changing past images because of old age strain. See, this is very important slide, sir. Very, very important. Cylindrical people and occupational strain, abnormal corneal curvatures, abnormal ocular muscle imbalances, abnormal centering of pupil and lens. These are all the factors important while fixing the thing. So finally, one muscle, second is cornea, third is pupillary position, fourth is fundus will not necessary to see. That means diabetics, hypertension, heart patients, so many systemic diseases where the fundus gets affected. And the youngsters do not do this. With the seniors having 20 to 30% years experience, when you are able to do centering only, taking an example of the profession of the patient, then you select, sir. This conclusion. See, profession is important. Remember, number one, cup angle of the refraction and center of rotation of eyeball different. Second is SWAM effect of the vision. Third is centering and profession. Fourth is other parts of eye and needs of fundus. See, I have communicated this for American Academy of Ophthalmology, and they have gone through this. This has been. Anybody, any comments, please do not hesitate to ask my email, drkatta.sv@gmail.com. And thanks to all my patients who have enlightened me. Thanks to Dr. Nagpal sir for guiding me, all organizers of BOA and MOA, for all audience who enlightened me with their doubts also. Pranam to BOA and MOA.
Thank you, Dr. Katta.
Okay, sir.
And without losing any time, we go to Dr. Krishna Prasad Kudlu. As we all know, he is a member of the Scientific Committee of All India Ophthalmic Society, a proliferative surgeon, a very, very dynamic person. And he will be enlightening us on debunking the hydrophilic versus hydrophobic debate.
Sir, can you hear me?
Yeah, we can hear you. We can see your slides. Please go ahead.
Thank you so much,
And
sir.
sir, the next session people are
I try
waiting.
to finish as early as possible, sir.
Sure, thanks a lot. Thank you.
Financial disclosure for my particular talk, but we should be really thankful to Sir Hedrod Ridley. In the year of 1949, he had actually first implanted the intraocular lens. Then later on, the phacoemulsification has come in the year of 1970. Since then, I think a lot of IOLs has been evolved in terms of optic and material. What should be our aim? Aim to have a better refractive outcomes with minimal incision size and trying to minimize the host cell response. So coming to the evaluation of material, I think we started with glass, then with the PMMA, then we have gone to silicone, then hydrogel comes in the picture. Now we have been implanting hydrophilic acrylic and also hydrophobic acrylic. So my question to you all, whether hydrophilic or hydrophobic, which is superior? Now coming to the one very important point, prevention of post-capsular opacification traditionally has been a prime metric used to determine the success of the intraocular lens implantation. Of course, mass opinion always, we all say that hydrophobic intraocular lenses are better than hydrophilic, even though it's more expensive. And also, most of the hydrophobic IOLs have got glistening effect, do not contribute to visual loss. Of course, square edge IOLs are proprietary of hydrophobic, that's why it's superior. Now, my question is, using a PCO as a prime metric to determine the success of the intraocular lens. I was going through a lot of surfing the literature. Out of 132 studies, only 9 studies really fulfilling the following criteria of randomized control trial, large enough sample size, multicentric trial, and authors with truly no financial interest. So, what are the most common folias that most lenses together in a single category, even among the hydrophobic IOLs, one company of the hydrophobic lens cannot be like other company, like another. And of course, very important, the environment where the IOL is performed, whether IOL is a truncated or round edged. So we got the large sample of RCT, which was published in 2014. So coming to the great PCO debate, of course, as you all know that causes breakdown in the blood aqueous barrier, there is a protein leakage, macrophages migration, and there is a PCO formation. So the source of the PCO is nothing but the equatorial cells of the capsule. But you have to remember, PCO is also a multifactorial. It's also depend upon your surgical technique and also depend upon the IOL material. Of course, dissociation of each factor is almost impossible and difficult to differentiate in your clinical practice. So, most of our study shows that hydrophobic acrylic material has got a lesser PCO than the hydrophilic acrylic. But some of the study shows contrary. So, how do these lenses really prevent PCO? The main property of these lenses is nothing but the tackiness, something producing a sandwich pattern between the IOL and the lens epithelial cells monolayer. So that prevents the migration of the epithelial cells inside. My question to everybody, does this tackiness, this stay forever? So coming to the edge design, optic design, edge profile, haptic material, it's all coming to the picture. Now talking about the square edge on the posterior surface provide a barrier of lens epithelial cells migration by inducing a capsular bend in that area where it is contact with the IOL edge. So what I feel, less angulation, better haptic memory, a more C-looped shape of the haptic, perpendicular incision of the haptic into the optic helped in forming a LEC barrier. So coming to the design. So haptic at different plane. Instead of haptic inserting in the same plane as the optic, breaking up 360-degree edge, the haptic inserts slightly on the intersurface. That means I feel that 3-piece lenses are always better PCO than the other lenses. But in the end, I want to say the most influential factor in prevention of posterior capsular opacification is the edge design. The sharpness of the square edge can vary between the model. So this is very important. Always hydrophobic lenses are still polished in tumbling machines. That makes the optic smooth and round but D-shaped on side. But hydrophilic lenses are lathe cut and drilled in a dry state. This allows you to make a sharp edges. During the hydration process, the material swells increase in volume by 15 to 20%. The bottom line is that the material and the manufacturing process can both influence the sharpness of the edge. So what I want to say, some lenses edges labeled square is not at all a square. The meta-analysis of Chang et al. Concluded that PCO and NDA YAG laser capsulotomy might be influenced by 2 parameters, that is IOL material and the optic edge design. The other factors we often forget about, we need to do a good capsular axis, you need to have a large optic size. If the lens tilts, chances of PCO is very high, inadequate polished capsule. Along with that, even there might be even anti-capsule opacification by causing something like a fibrous metaplasia. So similar to PCO, hydrophobic has got a lesser chance of anti-capsule opacification. Now coming to I will take another 1.5 minutes. Coming to the glistening, Glistening are the condensation of the water within the IOL polymatrix that occur when the intraocular lens is in the aqueous environment, most commonly seen with the hydrophobic intraocular lens, not with the hydrophilic lens. But what people say that visual acuity will not be affected, but definitely there will be reduction in the contrast sensitivity. Let me come to the refractive index. Hydrophobic acrylic always associated with a pseudophakic dysphotopsia than hydrophilic intraocular lens because it is closely mimic biological tissue due to their high water content that ranges between the 18 to 34%. Of course, to ease of implantation, as everybody knows that only hydrophilic lenses are the true MICS lens, you can inject through even through the 1.8 millimeter incision. This is what I used to do hydrophilic lens. Just is from the 909 model from Carl Zeiss, which is toric multifocal. We can do the phaco through around 2 mm incision. You can see the lens and it goes through 2.2 or 2.2 incision without any trouble and very easy to implantation. And because of the property of both hydrophilic and hydrophobic surface on the posterior surface, I could not able to see any PCO. Now coming to the same material about the hybrid material. This is the newest IOL material which has got a property of hydrophobic and hydrophilic. Hygroscopic component that included to produce the desired equilibrium of the water content that reduce the glistening, while hydrophobic surface on the posterior surface that controls the refractive index. So this is the best example of probably the 509 monofocal lens from Carl Zeiss. In conclusion, an intraocular lens is a total package. That is, both its physical characteristics and its material are important how the lens functions in the eye. There are difference which each material category, that is silicon, hydrophobic acrylic, hydrophilic acrylic, and one material will not necessarily act like another in the same category. Despite a long evaluation, no intraocular lens has an all ideal properties. Every material has got its own advantage and disadvantage. Definitely hybrid material hold the promise of combining the best quality of hydrophobic and hydrophilic. We must do a better job of differentiating the effects of physical characteristics of intraocular lens design from effects due to material. Not all hydrophilics or not all hydrophobics are the same. Once again, I thank BOA, Lahane sir, Ragini madam for this wonderful opportunity. Thank you one and all.
Thank you, sir. Thank you, Kudlu. It was a very nice, lovely presentation of the comparison and especially the newer generation where we have a hydrophobic coating on the hydrophilic lenses. With this, we come to an end of this particular session with a very, very big thanks to the team BOA, especially Professor Lane, Ragini Madam, and both Dr. Samant as well as Dr. Savant. We also thank all the speakers of this particular session and all the participants who attended this particular session. Thank you very much, Pritam and Swapnesh, for lovely organization. We had no problem in conducting the session. Slides were going through, everything was smooth. We really thank you for your hard work and we appreciate the teamwork of Bombay Ophthalmic Association. Thanks, everybody. And we hand it over to the new team and we apologize for the delay. The next session will start very soon. Thank you.
Thank you, everyone.
Ajay,
do we have permission to start the next session, sir?
Please go ahead.
Okay, sir. So we are going to miss today the music, the pomp, the charisma of court martial in ophthalmology, but we are very, very grateful to BOA and MOA, Maharashtra Ophthalmological Society, for giving us this opportunity to be here with you. And court martial is court martial. Court martial in ophthalmology is court martial in ophthalmology. So with this, I invite our Chief Judge, Dr. T.P. Lahane sir, and our honorable jury members in alphabetical order, Dr. Ajay Paul, Dr. Athia Agarwal, Dr. Devashish Bhattacharya, Dr. Kamaljeet Singh, Dr. Quresh Maskati, Dr. Rajesh Sinha, Dr. Rajiv Chaudhary, Dr. Praful Mukaddam, Dr. Virendra Agarwal, and Dr. Yogesh Sa. Shall we give all of them a loud clap? Angshu Matalia, what are you doing here? And you're not clapping either.
We are all on the side of the Defense Council already.
Defense Council, your turn has not come. It will come. Be assured. Let me introduce to you the angel of this session, the one and only Dr. Chitra Ramamurthy. And she has promised to be the angel and not speak a word during the court-martial procedure. Accepted, Dr. Chitra?
No way.
Oh, wait, there she is. So without much ado, shall we start off with our presentations? And we have today with us a very, very important galaxy of glamorous surgeons. And these glamorous surgeons are going to show us what court-martial is all about.
Best wishes to everybody. Welcome.
Sir, thank you very much for being with us, sir.
Yes, sir. This was your order, sir.
Sir. Sir, my only plea, sir, today you
Yes.
must hang 3. My plea to hang 3.
No, Dr.
Sir,
Lahani. You just
definitely, sir. But as it is a COVID going on and doctors are doing wonderful work, so I think we should not hang, but we should give them the flowers.
Yes, yes, Dr. Lahani.
रूपक राय, आपका माइक म्यूट करो. रूपक राय.
क्या मैडम ज्वाइन नहीं हो रहे कहीं?
हाँ.
ओ गुड, थैंक्स. चालू हुआ ना अभी तक?
हो गया.
वाईफाई चालू हुआ?
हाँ. मेरा फोन इधर भेज दे.
आपका फोन?
तो वाईफाई चालू कर, मेरा फोन और कंप्यूटर ला.
Somehow I'm not able to share the slides.
क्यों sir? Why? What is the problem?
Share screen is not working somehow, sir.
ऐसा कैसा होगा? अरे साई, नहीं, शेयर स्क्रीन तो वर्क होना चाहिए. Who is monitoring the PEYMAN Hall? IT person?
Yes, doctor.
Yeah, see, I am not able to share my screen. I'm working on the Apple. So
Okay.
it is just showing when I click share screen, it just comes to Dropbox, Microsoft OneDrive, Google Drive, Box, and Microsoft SharePoint. That's what it is coming to. So what do I do now?
Just a second, doctor. I'm looking into doctor. Just a second, please.
Yeah, thank you.
Devashish, welcome.
Thank you, sir.
Welcome, Devashish.
Thank you. Nice seeing everybody here.
Yes.
Sandeep.
Welcome, Debashish.
Dr. I'm Sai here. Can I help you?
Yeah, Sai. See, share screen, and I get a box, I get a window which is basic, advanced, and files. And the basic one says desktop 1, but that has an exclamation on that, and nothing else. Whiteboard, iPhone via iPad, iPhone via...
Doctor, just quit from Zoom, close Zoom, and reopen Zoom, doctor.
Okay, fine. I'll quit Zoom and reopen. Okay, fine.
Okay, as now our advocate has gone, so we are free to talk. Otherwise, it is difficult to talk to him.
But, for those who are tuning in from outside of Mumbai, and are wondering what the blue logo which some of us have got, the TPL for VP 2021, it stands for Total Practical Learning for Value Addition to Practice 2021. So this is the theme for this year's conference, Total Practical Learning for Value Addition to Practice 2021.
Mukadam sir has also joined, sir. Mukadam sir has joined.
Because some people might miss.
Virendra Agrawal sir has also joined. Sir, welcome.
Good morning, sir.
Good morning. Good morning. Good
Thank
morning.
you, sir, for the opportunity. Some derivative of OPL, like
not really. It is just that
overall learning and
total practical learning for value addition to practice. I mean, it just turned out in that particular acronym.
It is a good thing, yes.
Should
On a
ask
lighter note.
Sai, the same thing is coming. I don't know what's wrong here. I logged out of Zoom. I came back to Zoom. I opened the Zoom fresh, and still, I'm not able to do slide share.
Your Mac is not allowing. It's a security setting. You have an alternate machine?
Not here. Okay. So anyway, let us do it this way. So let's go on to the videos, and that can be shared by all our presenters. And let's go ahead with the presentations.
But we cannot see you where you are.
No, sir. I'm here only. We'll go ahead with the presentation, sir. And
you might not get to see Partha's dramatic exclamations and all that. It's fine. He's on the
you will
same
not see my slides, sir, but my drama you will definitely see. So may I request the first presenter to show up the first. May I request Nishant? Nishant, are you there?
I can't see him. Yes, he's there. Nishant is there.
Nishant is there? Okay. Nishant, can you share your video, please?
Yes.
What is happening? Nishant, can you share this?
Yeah. So I think Nishant is sharing the video.
Yes.
Okay, Nishant. So we have this video from you, and to tell you, Nishant is a dynamic young man all the way from Chennai and has come to Mumbai to get court-martialed and to get hanged. Nishant, over to you.
A very good morning to the esteemed guest, judge, jury, and Dr.
And the public prosecutor.
And the public prosecutor. So I start my case. So this is a case of a nuclear sclerosis grade 2, which is actually one which is relatively soft. And we all know this as we are young surgeons, and it becomes the softer nucleus are more harder than the harder nucleus.
Nishant,
So,
can I just pause 1 minute? Can everybody have their videos ready so that we'll go on to each of you and you will be playing your videos from your screen. So have your videos ready. Okay, Nishant, continue, please.
yes, sure, sir. So because it was a very soft nucleus, and we all know that the problem is going to be there with the cracking, I actually prolapsed one half of it to the anterior chamber, and I started doing the carousel technique. So with the carousel technique, with a high vacuum, I was able to take one half. But as we kept going, we realized that no, it was not completely carousel, and I had a little bit of difficulty because the nucleus was not as soft as it was expected. So while I was doing this, it was actually shocking to know that I'm not sure where and when, but yes, there was a small snap sign, and I had a posterior capsular rupture, even when my phaco probe was in the anterior chamber, even when I was doing the emulsification above the iris. So then immediately I realized it, and then what I did was stopped, And yes, not to panic, but the first thing is to keep your phaco probe inside and inject viscoelastic. So that we occlude any vitreous coming. By seeing this, you can actually judge and say that there is not much of any vitreous in the anterior chamber. I always prefer the bimanual cortex aspiration so that I keep the aspiration above the iris and slowly I start, I keep the irrigation above the iris and I slowly start aspirating. So being such a neat process, I'm sure that my public prosecutor might not have much of things to debate about it, but I made sure that even when I came out, even once to change my hands, I injected viscoelastic and I did the other side completely. So when you do like this, you actually realize that there is not much of vitreous disturbance. But no, I remember the last time I was in court martial, I was almost hanged because I did not use triamcinolone. So this time I did not make that mistake. And yes, when you realize that there is not much of vitreous even with the red glow, it is always better and safer you use triamcinolone. Because once you use triamcinolone, you actually realize the amount of vitreous is there not only in the anterior chamber, but it is coming out till the section as well. So I always started doing the pars plana vitrectomy, where I do only one port. I do not do multiple port for the infusion, because for the infusion, I use the side port itself for the infusion and keep my irrigation above the iris and take only the cutter pars plana. And I always keep it in the visual axis so that I don't go under and damage any other part of the posterior segment. The vitrectomy cutter will always be facing upwards. And you can see beautifully how the vitreous is being cut and it goes inside the probe. So once we do all that, I come anteriorly and you can see that the whole triamcinolone is cleared well. So this is where we always know that we need to have a backup lens. Sometimes with the backup, you might not have the same power. So yes, I realized that the anterior capsular margin was intact and my posterior rent was also not extending anywhere else. So I went ahead and injected with a multifocal lens inside the bag. You can see that it is injecting very slowly. The leading haptic goes into the bag. I don't inject the trailing haptic also. I just leave it outside. Make sure that slowly you are able to tuck in it and try not to rotate too much. And the trailing haptic, it is just tucked under the capsular margin. I do have the centration. I do have the Purkinje images, which is showing in the center of the pupil. One last time, even after placing the lens, I go behind and I clear any amount of vitreous, a mild wash in the anterior chamber. And yes, voila, hereby I rest my case. Thank you.
Partha, we are not hearing you.
You're muted.
Partha, you have to unmute.
Yeah. So voila, I take over now from Nishant. So this, Nishant, was a very, very easy lollipop of a case of a soft cataract, and whatever your parameters were absolutely irresponsible and wrong parameters. We could see the surge up and down. With a person who is going to implant a multifocal IOL, you have to be more responsible. You have to be a better surgeon.
Overruled.
The irrigation aspiration in a torn capsule. With irrigation on, why did you not do a dry aspiration? A dry aspiration would have had the vitreous at bay behind the posterior capsule. And you wanted to implant an IOL in the bag. With the posterior capsular rupture that you had, you could easily have converted that posterior rupture into a PCC. And then I would have accepted you for implanting a multifocal with the posterior capsular rupture converted into a PCC.
Overruled.
And
It has to be overruled.
just a minute. Clearing of the anterior chamber with Simcoe. Why? You, Nishant, are guilty. Overruled. Nishant, would you like to
I
say
would like to
something?
intervene something. Can I have a word?
Yes, yes. I think first Nishant should answer. Nishant, you
Yes,
answer.
sir.
You can answer.
Okay, sir. So I saw the edge of the posterior capsular rent, which was not extending. So yes,
You made it extend. You extended it.
Overruled.
Yes.
I think Dr. Lahane.
Chitra, you cannot use words like overruled. That is for the judge and the jury to use.
Yes.
You have to use words like I object.
And the Simcoe at the last is just not a wash. It was just to make sure that no visco in the anterior chamber, sir. More than this, I think I am not allowed to talk. Dr. Chitra madam has told me not to talk more than this.
Okay.
No. It's not that. I would want the permission of the court to
yes.
rule out
defense.
every single thing.
Your defense, Chitra. Your defense.
Now,
yes, for your defense, madam.
These kind of cases can be easily flipped, which is what is being done by even with the best of phaco machines. Have incorporated a flip mode, which is exactly what Nishant was doing. I don't know, Partha, you should come out of the Stone Ages, number one. Now, the other thing is he has used viscoelastic to push the vitreous back. And if you see the ease with which he removed the cortex, if there was a piece vitreous in the AC, he couldn't have teased out the cortex so effectually. So therein, that was enough. You don't have to keep doing your tricot business even before the need arises. So, and then at the point of time when he felt that it cannot be done, why he went past planar. Now, most surgeons, anterior segment surgeons may not do that. He was very intelligent. He realized he has to put a multifocal lens in the bag. So when you go past planar, it is effective cutting of vitreous. So there's not too much vitreous which is getting cut. The PCR will not enlarge. So he was extremely, every single move was so intelligent and well planned. And how he tucked in the IOL, he explained to you, I don't even understand because your laptop was not working. You were not very effective.
Okay.
So I think he was right in every step.
What Chitra said is now I will ask my jury. I will ask Virendra Agrawal sir to talk as a jury.
I think what Nishant has done is really done well because he was knowing the vitreous was not coming. And at the end also he discussed, though the vitreous was not there when he was aspirating, but when he realized that it should be done with the tricot confirmation, he did confirmation. And when he found the vitreous is there, he actually did the right thing of doing posterior approach, and through pars plana he did a very good vitrectomy. I agree with that if you do posterior capsulotomy conversion into a circular one, it will not extend now and later also. So that point is there. But if surgeon feels confident and by his experience, he can implant in the bag lens with centration for multifocal also. I also have experience of doing the same kind. So I think he is not guilty.
Sir, this is Dr. Yogesh Shah.
Honorable jury, I wanted to add a word that PCR was a little too large to be converted into a PCC. Correct. I wanted to add that too.
He made it large. He made it large by his intervention.
Intervention?
Can I come back, sir? Dr. Yogesh Shah here.
Yogesh, yes, in one word.
Yes, in one sentence. Sir, he was very, very calculative and he was very conscious because the moment he noticed that the lens is not rotating right in the beginning, he anticipated that this case needs a proper management and he could succeed and do the proper management and implanted the lens within the bag with possibly very, very minimal enlargement of the PCR, which was initially present. I don't think that much PCR would allow the lens to drop, which has got haptic of 6 millimeter, because it was much smaller than the haptic. And I think this lens would stay in the bag forever.
Okay.
I don't think he's guilty.
Raju?
He's nicely performed the surgery when the PC rent was there, and he kept the chamber inflated. He didn't allow the chamber to collapse so as to increase the. So I think in that situation, he has done the best what he can do.
Thank you,
sir.
Can I just add one thing, Dr. Lahane?
Yes, sir.
That Nishant is well versed with going through pars plana, but not all anterior segment surgeons would have either the means or the equipment on hand when they are doing a simple cataract with multifocal. So I think it would be perfectly all right to have done the conventional vitrectomy, anterior segment vitrectomy as well. But this is just a take-home message for the youngsters who may not have all the gadgets or the experience that Nishant has. That if you go in from the limbal hole itself and do a vitrectomy, of course with the triamcinolone, you would perhaps get similar results.
The challenge is
Debasis.
that this kind of
Debasis.
Sorry, I want to have a word, Dr. Supreme.
Yes. Go ahead.
Judge.
Go ahead. Chitra, go ahead.
Now, in this particular situation, it was a little dicey because his PCR was a little larger. I think the fact that he went past planar, there was less fluid gushing in through the anterior chamber. So the PCR did not extend. That is why he could place a multifocal single piece in the bag. So
all
I
the
think that
gushing
was
in
a
he
big
did
advantage.
anteriorly already.
Acha, Debasis.
Yeah, just a little learning that why did the PCR occur at the first place? I think there was more vacuum than energy. And I think, it is the vacuum that causes the surge and not the energy. And
Yes, as it was soft, I increased the vacuum.
one little learning from this. The second is the pars plana vitrectomy. Because of the pars plana vitrectomy, the PCR would not enlarge because, the vitreous settles down very well. So, I mean, that upthirst is always gone when you are doing a pars plana vitrectomy. I didn't see the video very clearly, but the haptics were probably there was a rexis extension. Was it there, Nishant? I couldn't make it out actually.
No,
Clearly.
sir. No, sir.
Then it was not, because I thought that the haptic probably the open end of the haptic was at the junction of the rexis extension, but that's not a point.
The rexis got a little stretched when he was
Correct.
Okay, I couldn't clearly see it in the video.
As the lens was going on, it just struck the haptic, the rexis, but then it went well within the bag.
So which jury member would support a multifocal in a torn rexis? With the years to come, the multifocality will shift from maybe one eye to the other eye.
It is not a torn rexis.
I just want to add, as he was said, Dr. Debashir was, why did the rent occur? I mean, one has to be very careful when you are doing the carousel technique, when you are taking your phaco tip to the side, and that is when you could have, especially in the soft cataract, where some instability that well. But having said that, I think he escapes the noose of public prosecutor because he did the game changer by going through pars plana. I think in this case, all these steps could have gone either way at any point of time. I mean,
if I may just one second.
I think the pars plana approach was something you chose at the right moment and got the vitreous out, and he could even that longitudinal break which was there from one end to other, you could manage it at that point, and then again, like public prosecutor says,
Ajay, you're my friend. You're my friend.
Yeah, putting a multifocal. Well, I would have thought twice or thrice in that.
Just one second, one photo only, sir. Partha sir, just one photo, just to show you post-operatively day 3 there.
Day 3. I'm talking about day 31 and 3 years down the line, not day 3.
Okay. Mukadam sir.
Don't get too dramatic
Mukadam
now.
sir.
I think Partha should be.
You can,
one minute.
I think you can get a multifocal done, so you'll not need glasses.
I am also in favor of not doing a multifocal in this case. I mean, had I been the surgeon, I would have ventured to do multifocal.
So he's guilty, sir.
But otherwise, the surgery was very well managed. No doubt about that. Except multifocal.
I will prefer that multifocal can be implanted in this condition, because if you are putting in the bag, your effective lens position is almost the same. So you can have a very good result with the multifocal. Might be slight refractive error will be there. Instead of using that big presbyopic lens, you can go ahead with the small refractive error.
Thank you, sir.
So, Supreme Judge, we could hang the public prosecutor for not having managed the case well.
You are not even clad in the official uniform, madam. Where is your coat and gown?
1 minute, both of you. Rajesh?
Yeah, I think most of the things have been already told. So I completely agree with Dr. Chitra that the size of the rent was quite large for it to be converted into a PCC. That is one. A little bit, I would be hesitant in putting a multifocal in such a large PCTR, but it was finally managed very well. And PCTRs can happen with, I mean, all the cataract surgeons have faced this. And if it's managed well, that is the key. So all is well that ends well. So I would say that he should be acquitted.
Kamaljit Singh, sir?
Sir, if you don't have a monofocal, then multifocal is indicated. Otherwise, monofocal is best.
Thank you, sir.
Sandeep?
Sir, I think he managed it very well. He gauged the situation. I'm sure that if he didn't feel confident about putting a multifocal, he would not have put it in. Isn't that right, Nishant? I think you found the situation was absolutely perfect. And
Yes,
you
sir.
probably identified an area where the IOL could be placed. And it was probably the favorable point of entry through which you could go in and set the lens in the back. Maybe that's the
Exactly.
reason you went in for it.
Yes, yes.
I think after hearing all the juries and both the prosecutors, I came to the conclusion that what Nishant did, there was a tear. He definitely identified. He did vitrectomy. Also, he has seen that there should not be vitreous, so he used tricot. He has gone posteriorly. Now, only the thing remains where he should use the multifocal or he should not use the multifocal. Now, see if the multifocal is there and there is a tear and you are putting in the bag, and if you are confident that you have done proper this one, vitrectomy, I think you can go ahead for the multifocal, and I think what he has done is not anything wrong. About the PCCC, his rexis was on one side and it was a larger rexis, so it was not possible to go to the PCCC. So I think he will be awarded for doing a good surgery, and he is not guilty. Thank you.
Thank you very much, sir. But I'm sure the next ones will be guilty, sir. Shall we go on to the next one, sir?
We have to live with hope only.
Yeah.
Thank you. Thank
So-
you, Chitra madam.
What about thanking me, Nishant?
Thank you, sir. Thank you, Lahani, sir. Thank
Lahane,
you.
sir, Honorable Judge, sir, shall we go on to Dr. Priya Desai? Dr.
Yes,
Priya
sir. Yes, sir.
Desai,
Yes, sir.
a
Yes, sir.
confident surgeon for refractive surgery, and we shall see what Dr. Priya has done to this patient of hers.
Am I
Dr. Priya,
audible?
please.
Am I audible, sir?
Yes, yes, very well. Very well.
Share your screen.
Public prosecutor, sir, I'm greeting you before everyone else because I'm so scared. Good morning, Lana, sir, respected jury members, my favorite Chitra ma'am. Thank you for having me here, and I'm going to share my screen. I also have a Mac, so I just hope I don't have the same problem. I'm trying to figure out.
extra.
But I seem to be having the same problem that you were having.
I see. So Priya, shall we go on to the next presenter while you try and sort it out? Priya?
Let me log in from another device and maybe you can have another speaker in the meantime.
Yeah. Priya, what you can also do is speak to Mr. Sai, and maybe Sai will also be able to help.
I'll do that.
So shall we go over
I'll do
to
that.
Dr. Rupak Roy? Dr. Rupak, are you ready? Dr. Rupak, please unmute yourself.
The judge will suspend the court.
Respected judges, member of the jury, am I audible?
Yes, you are.
Respected judges, member of the jury, public prosecutor, sir, and my fair defense counsel, thank you for having me. I'll just share my screen now.
Put some light on your face.
He's going to give us a glimpse of hell.
They call this a brief glimpse of hell. Is my screen visible?
Yes, go ahead.
Yes, Rupak. So this is a case of a 16-year-old boy who presented to us after blunt trauma. And this was the initial OCT, shows full thickness macular hole. And we did a vitrectomy and ILM peeling and C3F8 under general anesthesia. And what followed after this was a saga of complications. The first complication, the biggest complication was that the hole did not close. So we planned a second intervention. We planned to do a ILM transplant. We planned to take ILM from around this area and put it in the hole. So the surgery was simple, just go in inside, do a trypan staining and take out. The surgery is going on very nicely. As you can see, I'm peeling the ILM here. And my goal is to just tuck this in the central hole. So the surgery is almost, this is a 7 minutes real-time surgery, which is going very nicely. And I'm really happy about this surgery now. I hope this tucking will close the hole. And I do a fluid air exchange to settle the flap over the hole. But at this point, I notice that the flap has moved away from the hole. The loose flap has moved away from the hole. So I keep searching for the flap inside the vitreous cavity. I put on the saline again. And as I put on the saline again, I have a real shock. I have a retinal detachment here. I see a large retinal detachment in the nasal part of the retina. You can see the detached retina here. And I see a large break over here. So now I have two options, either just settle this retina and go away, run away, or I try to complete my primary goal of the surgery, that is ILM transplant. So I still try to peel the ILM and do a further more ILM transplant over the area of the hole, which I'm trying to do. And again, I lose my flap. So this is the second time that I've lost my free flap. I'm trying to get the free flap from the vitreous cavity. You can see the retinal detached retina in the background. And somehow I am able, remember this is a phakic case. Always there is a risk of the lens touch when I'm going to the tube periphery. So at last I am able to get hold of the free flap. I am able to settle the flap over the macular hole. And also, thankfully, I am able to settle the retinal the detached nasal retina. You can see this is a central hole, and this is a detached retina with a large break. The retina is well settled now. And I do a laser around it. I put a C3F8 gas. And this is the final OCT, shows the closure of the hole with attached retina. Thank you very much. I rest my case.
Thank you very much, Rupak. So shall I begin my case then? Sir, this is a case with a traumatic full thickness macular hole.
Rupa, could you stop sharing your video?
So this is a case in which there's a full thickness macular hole in a young, and such traumatic full thickness macular holes actually can close in time without intervention. But you, Rupak sir, the big surgeon that you are, but an impatient surgeon as well. So you do your first surgery and it is a failure. Why in the first attempt did you do a surgery? Second surgery. Now, this is a surgical circus that you have created for all of us. So you have the full thickness macular hole, you're losing the flap once, twice, and you have a retina detachment. Everything that you have is a creation of your surgical circus just to show that you are a trapeze artist. So you are guilty. You're guilty of trying to emulate Mr. Bond. Over to you.
Honorable Judge, he needs to be overruled for being so obnoxious to my very gentle defendant. I would have
your
few
gentle
words
defendant
to
can
defend
also
him,
defend.
please. No, he would defend himself. Of course, he would defend, but I am there. I
As
know
the
how to
vitreoretina
fight you.
surgeon.
I know how to fight you. Don't you worry on that. I'll deal with you if the honorable judge allows me.
So far, so good, Chitra. Go ahead.
Yes. So now I think closure in children can be a challenge because they're difficult to maintain that head position, probably. The second time, it is so obvious on OCT, those cystic spaces which are there, which all tell you that spontaneous closure is not possible, and he has actually waited for a month before he has intervened. So having said that, this losing the flap and then getting it back and all that, he actually tried to get a lot of drama to keep my public prosecutor happy. But what we all need to watch in this is he has done the reattached the retina. He has finally placed the flap in its location, and he has had an optimal end result. So how does it matter? What we need to appreciate is, the surgery is a challenge in children, and he has done it so well. And yes, we always need to see the end result and congratulate him.
Thank you very much.
Rupak, I want to know when did the retinal detachment occur? Was it during trauma? Was it during your first surgery? Was it during second surgery?
Sir,
Further going from Quresh, there was a horseshoe tear, as we could see. Was it pre-existing? I mean, before you even started for the first surgery?
No, sir. Before the first surgery, the retina was, there was no tear in the retina. I waited for 1 month for the hole to have a spontaneous closure, but the hole did not close after 1 month. Then only I went ahead with the surgery. During the first surgery, there was no retinal detachment or retinal break. During the second surgery, when I started, there was no retinal detachment, there was no retinal break. When I lost the flap, I started the infusion. The infusion jet went inside and it hit the retina and closed the horseshoe tear and the retinal detachment. It happened intraoperatively.
Iatrogenic trouble by the surgeon.
Why do you have to search for trouble when the problems are sorted out so beautifully? It is a true learning video of the challenges a retina surgeon faces. Public prosecutor,
I think what Chitra says, okay, I will ask my juries. And in my juries, I think I will take the opinion of all. I think I will go to Raju. Raju?
Probably the retinal surgeon now doing, they can justify it more. I will prefer that we should wait for 2-3 months for to doing surgery, especially in the traumatic macular hole.
Okay. Ajay, you want to say anything?
Sir?
No, I think what he has done, I mean, let's not go into how much you have to wait, but then the very fact that he remained in his goal, that his primary aim was, closing the hole in spite of chasing it, in spite of having a break and a retinal detachment, he went ahead with it. I think it's a commendable job. That's what I can see.
Okay. No, we have got the
complications are a part of any surgery. The retinal
we have got the retina surgeon Swamil. Swamil, you tell me.
Sir, I agree with most of the comments. Retinal surgery changes by the second. So the challenges one faces while doing a retina surgery, I mean, you should take that into account. You could have had a whole lot of other complications, but it's important how they are managed. As long as they to let them happen is not in our hands, but as long as they are managed correctly and properly, the kind what we saw in the video, I think it is commendable.
Swapnesh?
Sir, I think as Somil said, that we have to be very vigilant when we are operating even a case of macular hole or ERM, to look out at the periphery if there are any holes, and to manage it on table requires a lot of presence of mind. And he showed that, and he did the case beautifully.
Okay. Okay. Now I want my juries to raise the hand. Those who want that he is not guilty, raise the hand. Not guilty. 1, 2, not guilty. 1, 2, 3, 4, 5, 6, 7, 8. Okay.
Dr. How many has not raised her hand, sir?
How many my juries are against that he is guilty? Jury? Okay. I think what happens, see, I'm not a retina surgeon, but I observe retina on both the sides. It means on one side Pritam is doing, on the other side Saili is doing. And so I always see that what he is saying. I think what Rupak has said is, yes, whenever he was doing that, it has entered inside the jet, and because of that both things has happened. I think this is the complication. If we are creating the complication while doing the cataract surgery, and that we say, yes, this complication can happen. Why not retina surgeon can be also treated like same? Why they should be treated like some differently? And I think the whatever, it may be a cataract where there is a posterior capsule, or it may be a retina. These are thin membranes. And the thin membranes, whenever you are operating, accidents are going to happen. But after that also, important thing is that he managed very well. And I think management after the whatever thing has happened, detachment or also the whole everything he has sealed and did very nice surgery and good result. So I think though both, I think Chitra and Partha, both on the both side, but after that also he has managed very well. So, and my juries are all unanimously said that the Deepak, this Rupak has managed very well. So Rupak Rai is not guilty, and I give him good marks that he has done very good surgery and managed very well complication. Thank you, Rupak. Thank you both of you, and thank you, my juries. And you can go ahead, Partha.
Sir, is Dr. Priya Desai ready? Priya, are you ready there?
Sir, she has communicated that she would be mailing the PPT to Nishant, and Nishant would be playing it from his end. Keep her last.
So we will go to Tushya. Tushya, are you there? Tushya?
Tushya was there all along.
Hello. Hello.
Yes.
Yes. So this is Tushya Om Prakash. He has a legacy of fantastic surgical expertise, and he's one of the best surgeons in the northern part of our country. A young, dynamic Tushya, but Tushya can err, and this is where we bring him to court in court martial, BOA, and MOS.
Thank you so much for such kind words, sir. First of all, I would like to thank Dr. Lahane sir and Ragini ma'am for giving me this opportunity. And good morning to everybody. I will just share my screen.
Next, we'll go to Vaishali. Vaishali can be ready.
Is it shared?
Yes.
Yes.
Yes. Full screen, please.
Yes, sir. So today I'm going to present a case of smile with a suction loss. So if you see, this patient is a 30-year-old patient who came for his refractive surgery and opted for smile. The preoperative refraction in the right eye was minus 1.87 with 0.75 at 135 degree with vision 6/6, and in left eye it was minus 1.5 with 1.5 at 35 degrees with vision 6/6. His preoperative topography was within the normal limits with the thickness of 510. I started with the right eye first. So my parameters for the lenticule was, I took the optical zone 6.3 with a transition zone of 0.10 and minimum thickness of 19 and maximum 60 with a cap diameter of 7.3 and a thickness of 120 micrometer. So starting with the right eye first, I just realized when I started the right eye that the patient was very uncooperative and anxious. So if you see, the most important step is the docking, which should be centralized. He was continuously moving his eye, as you can see. So I had to patiently dock, but then he again moved. So I tried redocking again and applied the suction. As you can see, it was little away from the center, it was not at the pupil center. Started with my lenticule cut laser application, which went on smoothly. Then the lenticule side cut, which also went on smoothly. While I was doing cap side cut, he suddenly moved his eye and there was a suction loss. So the advantage of this machine is that it tells you exactly where it stopped As you can see, the lenticular cut was completed, the side cut was completed, but the cap cut, it was only partially completed, which was 2.86 millimeter. So at this time, I calmed myself down, took 15 minutes of break so that the OBLs should disappear, took the help of Mirocell sponge to flatten out the cornea, to iron out the cornea so that the bubbles disappear, and calm down the patient too. And then again, I started with the right eye surgery. Here, the aim was to, when I'm gonna dock it, it should be at the same point where it was done before. So I started it again, if you can see here, and I realized again he started moving his eye. So again, I had to redock and try to bring it at the same point. With the help of the infrared visualization, I made sure that it was at that point, but still it was not at that point. So then I continued, because he was already so uncooperative, continued with the cap side cut. And if you see here, what exactly happened here is, so normally the outer margin of the cap cut should be equidistant from the lenticle cut, which is supposed to be 1 millimeter. But if you see in this case, on the left-hand side, the outer margin of the cap cut was just outside the lenticle cut. So I continued. I thought that it was a little tricky, but then I thought I'll just continue with the surgery. Made the anterior pocket first, then the posterior pocket. And now with the help of the blunt dissector, I entered the anterior pocket first. And started separating the cap from the lenticule. Did the anterior dissection. As on the left side, there was not much area to maneuver. So I didn't maneuver much on the left side for the anterior dissection. And then went with the posterior dissection. So if you see here, I went on very carefully to that side just to be sure that it gets separated and it is not stuck there. Did the right part. And then dissected the posterior part of the lenticle from the stroma, and luckily I was able to separate it from all its edges and took it out. So coming to the left eye surgery, as I already knew that the patient was very uncooperative, I already had an adrenaline rush. So I started with the docking of the left eye. I was just hoping that he should be cooperative and not moving his eye. I started with the lenticule cut, but now I realize he has started again moving and there were black areas noted. But I continued. And then if you see here, while I was making the cap cut, he had moved so much that the cap cut as well as the side cut came beyond the superior limbus. And there was a suction loss. So what I decided here was, because as there were already few black areas noted during the lenticle cut, plus the cap cut and cap side cut were beyond the superior limbus. So the decision which I took was to postpone his left eye surgery. And there are always backup scientific plans later on where I can do flap LASIK or a trans PRK. So his post-operative day 3 refraction was in the right eye plus 0.25 with -1 at 135 with the vision of 6/9, and in the left eye I couldn't do it, so it was as the same preoperative. So if you see his right eye post-operative topography, It was a slightly decentered ablation, but it was too early to comment because it was just day 3. I've called him after a month, and then I am hoping that his vision would improve. And thank you so much.
Judge sir, shall I please start the trial?
Yes, go ahead. Go ahead.
Thank you, sir. Thank you very much. Sir, my heart goes out to this wonderful, intelligent, tall, handsome young man
Cut out all the drama.
Who is trying to do his best, but he has to know his limitation. This is a patient who is uncooperative. Why did you take him up in the first place? You have proved yourself wrong, and you know that you should not have taken yourself in the first place, and you should be pleading guilty for this. A decentered docking you had. You had the OBL persisting and the second lenticule cut. You had the black spots and everything. Once the right eye was done, you were so foolhardy that you went on to the left eye again. And again, there was no cooperation, but you will not let him go. Lenticule cut and the black spots, but you just went ahead. You even did the
Honorable Judge, he needs to be
finally
He's
you
not
abandoned.
like a refractive surgeon.
Finally, you abandon the left eye, and what you're left with the right eye is a refractive error which you will have to recorrect. Though it is just 3 days, but this refractive error will persist to some extent, and you will have to go ahead for a second refractive surgery.
Overruled, Honorable Judge. I have enough to reason out and argue. Please oblige me.
Chitra, you have to request overruling. Don't take decisions on our behalf.
No, I'm requesting Honorable Judge.
Yes, go ahead. Go ahead.
See, Partha actually did not talk like a refractive surgeon, sadly. I think he's gone too much into cataract surgery. Now, going to this case, he was an apprehensive patient, and that is when very rarely these suction losses can happen. But you all should have all seen how gently he reapplied and did everything. So I do not think the first, let's not go into the residual refraction. The first case was done appropriately and he did it well. Now, as far as the second case goes, yes, I'm sure he would have counseled adequately, but in the second case, the things which could have been done, but what he did finally is not wrong. So let me say that if there is a suction loss and the conjunctiva comes in and the suction thing is complete, he can't redo the docking. So in this kind
Chitra,
of...
1 minute. Sai, can you mute everybody else? There's background noise, please. Sai?
So in this kind of a setting, in this situation, what he was that he cannot rerun the same sitting. So he has gone and planned. I'm sure 1 month beyond, if the refraction is stable, topography is stable, he can do a transepithelial PRK and get done with it. More for the sake of knowledge, what else could have been also done, which is not against him. What could have been done is when he was realizing that there was a suction loss happening, as you could all see the bubbles coming up, if he had actually released his foot pedal control, then that incision cut or the conjunctiva coming on would not have happened. Probably he could have done that incision cut, done it. He could have probably also gone ahead and tried a manual dissection, but he was not sure whether the cap cut itself was complete. So the other chance is to do a circle software and to convert it into a flap. So these possibilities are there, but a brilliant possibility always is to do a PRK after waiting. The other thing, the first day post-op refractive result has absolutely no impact because there has been a rerun of the laser on the same bed. There is an inhomogeneity which has got created. There is some amount of corneal edema. There is some amount of distortion of the corneal lamellae, because of which this refractive result appears. I'm so very sure by a couple of weeks or a month, all this would have disappeared. And after a month, he can go ahead and do a transepithelial PRK. I rest my case, Honorable Judge.
Okay, I will ask the Rajesh. And I request all the juries to switch off their, keep their mic mute. And when I am asking, then you can open it. Otherwise, there is a problem. Yes, go ahead.
Yeah. Actually, it was a difficult scenario, and the patient was very uncooperative. So whatever best he could do, he did. I think I just felt that maybe the first eye wherein we waited for the OBL to disappear. Many times the OBL helps you, guides you to have a proper centration, and so that could have been used to have a better centration. And when a little bit of centration is gone, then that can happen. That can create a very tiny interfaces, which can lead to post-operative astigmatism. But it was a difficult scenario to handle, and the way he handled it coolly, that was commendable, I would say. And the second scenario, again, I agree with what Dr. Chitra was telling. Maybe you could have released the suction pedal a little earlier, and then again, either do a circle or you could recenter based on the OBL. But having said that, I mean, when you're operating on a patient and the patient becoming uncooperative, the best thing I've also felt that what he did was right, that, he waited for the other eye and plan it later. Difficult scenario, there can be a bit of here and there, but I would still say that handled well. So from my side, acquitted.
Okay. I think they, Quresh?
I would, first of all, two things. I congratulate Tushya on completing the job, but I wouldn't have touched the second eye with so much of non-cooperation in the first eye and so much of problem. I would have still have left him alone, because I know that I have to repeat something in the first eye in any case. So when I'm going to do the first eye, I can do the whatever procedure I want in the second eye. The refractive error is not so much. You could do a PRK, you could do a LASIK, you could do everything. Smile is not the only way to skin the cat. Even if a patient agrees to smile, later on after the first eye fiasco, you can always tell him that your eye was not the right one for this smile, and we'll do a PRK or we'll do a LASIK in the other eye. So I would not have touched the second eye. I congratulate him on the outcome, and overall not guilty.
Honorable jury, I think he has managed the first eye well. I think all of us would do a second eye, maybe spend a little more on counseling. This guy would do the same thing if he's taken up after 3 months also. He's just an apprehensive guy, and that suction loss happening so right in the end might not have happened at all. That way, it would be like arguing not to do smile at all.
Okay, Yogesh bhai, bolo. I request all others to mute their mic. Yogesh?
My mic, yes. Sir, complications are known to occur, and we all have faced them. And so far as the complication was there in the first eye, I would definitely say that he did very well. But at the same time, I would agree with Quresh. I would have at least taken it the second eye at a later stage, especially because to expect that this patient on operation table, having known that it has taken a longer time for the surgeon to complete this particular surgery, is not going to be that accommodative or that helpful to the surgeon by keeping his eyes steady. He will definitely be more apprehensive. Doing it after a couple of weeks would not make any difference. Ultimately, he had to do it. So that is the only thing, but otherwise he managed it very well.
Okay, in the Kamaljit?
Sir, I just want to say that since the surgeon was also stressed up because of so much of time that he has taken, as Dr. Yogesh has said. So he could have waited for the other eye and then done the surgery in the other eye later.
Any other jury want to speak?
Dr. Virendra Agrawal does a lot of smile. He
Achha, sir, Agrawal sir.
Yeah.
Agrawal sir.
Thank you, sir. Thank you for giving chance. The smile surgery, many of the times we see that the patient is not cooperative in the first eye. But what I see in many patients, that the second eye actually goes almost smooth. The reason is that in first eye, he was very apprehensive. And when we do counseling, that there was nothing, no pain, there were no other problems. So he agrees. And for second eye, usually most of the patients becomes much more cooperative, and the surgery goes smooth. So that way, trying second eye is not a problem in my opinion. One thing. Second thing, he managed the first eye well. But as Rajesh said, it is right that if you don't remove the OBL, it actually helps you to do a centration again. Second thing, whenever you do a smile and you recap, actually the slot goes into the same area of the concavity of the cornea, and you have the same centration. So doing it early will do much more better centration in the first eye. Second eye, as Dr. Chitra said, that the suction loss was at most at the end. Definitely you can stop it, and sometimes you can't stop. That also is the issue. But in one line, I want to say negligence is to be punished, not the complications. In Consumer Protection Act also, you are liable for your negligence, not for your problems you happen to have in surgery, and you manage well, then it's not a complication.
Okay.
Not a problem, not to be guilty.
Thank you, Agrawal sir. Now I will ask. We are getting late. So now I will ask every jury that he is guilty, or if he is guilty, raise the hand. No. So if he is not guilty, raise the hand. Okay. So I think what Tusha did, that was you can say complication and not a negligence, like Agrawal sir has said. And definitely about the other eye, yes, the patient, if it is not, he is not cooperative, we should, see, take home Moses should be that we should not go for the other eye unless and until that first eye complication has happened. But okay, I think he has managed both. So, and all the juries are on his side. So the Tusha is not guilty, and I appreciate his work, whatever he has done. And I think in this age, when there was a suction loss and all other things, and if he is doing such a wonderful, I think in future he will be the very prolific surgeon, and I wish him best of luck.
Thank you, sir.
Go ahead to the next.
Thank you very much, sir. So we go on to our next surgeon on trial, and that is none other than Dr. Vaishali Vasavada. Vaishali, are you there?
Yes, sir.
Okay. So Dr. Vaishali, again, a lady with a legacy and a lady with a beautiful smile. But let us not get enamored by this beautiful smile, but because what she has to show needs to be judged in this court of law. Over to you, Vaishali.
Thank you, sir. Thank you, Lahane sir, Maskati sir, Partha sir, Chitra madam, and all honorable jury members. And I'm really, really hoping that everybody is kind to me, especially this being a virtual platform. But what I want to show, and I'll start sharing my screen, is that things can go wrong. And it is not about, like Virendra sir said, it is not a problem if you create a problem. It is a problem if you didn't manage it well. And so this is my case. And this is about how I started off with a small pupil and a white cataract, as you will see. This man has a bilateral advanced angle closure glaucoma. One eye optic atrophy, this is the only seeing eye. And you can see that the pupil is not very large, not dilating well. So I prefer to use iris hooks here. And I'm doing all the right things, using a heavy viscoelastic, aspirating the fluid because it's a dense white cataract. And I'm using micro forceps, not even made the main incision yet. But you can see that the rhexis is already starting to go to the periphery. Now, before I could do anything, this split. But I'm not giving up. I have to think of alternative ways. So I start from the other end, and to my bad luck, it broke off even on that side. But so that doesn't mean I don't do the right thing. I still use my micro scissors and a combination of heavy viscoelastic, complete the rest of the capsulotomy. Now I'm using appropriate parameters, as in I'm not going to use very high flow rate, only 16 flow rate, lower bottle height, but obviously high vacuum because this is a dense cataract. I keep injecting viscoelastic to prevent shallowing and also to protect the corneal endothelium in this eye. And you can see that I'm being very slow, step by step, making small pieces which can be removed without causing any further damage to the endothelium. And at this point, I would like to acknowledge Dr. Rohit Om Prakash sir, because he has taught us how to make out whether or not the split rhexis margin is fluttering or not, which gives us an idea of what to expect in terms of your posterior capsule. So you can see here that the anterior capsule split, which you can see is pretty stable. So I'm not worried about a posterior capsule rupture. You can also see that I am confining my removal in the very center, and I'm not trying to keep moving my phaco probe so that further damage or shallowing does not occur. Now I could salvage this case. The very hard cataract was removed without any conversion or anything. Again, I'm using both hands, 2 ports and micro forceps to enlarge this capsular opening because I don't want to jeopardize this during IOL implantation, and I could do that. Yes, I do acknowledge that there are 2 large areas of split. So I also understand now that even if I did convert the rest of it to a rexis, if I put a lens in the back, the story is finished. But what is going to happen later? This lens is going to come up. It's a shallow chamber. It's an angle closure glaucoma only eye. And it will cause optic capture. It will cause synechiae and all other problems. So now I cannot just give up on this eye. So what I'm going to do and what I'm doing, if you can see here, is I'm creating a posterior capsulorhexis. I want the lens to be away from the iris and yet very stable. So I'm creating a posterior capsulorhexis so that I can now go in and put in a 3-piece foldable lens. I will not use a 1-piece lens because I don't want any kind of those thick haptics rubbing around. I use a 3-piece foldable IOL. I put it in the capsular bag, but now if I just left it like this, it can easily come out through these split rexes. So I will remove all the viscoelastic and then capture the lens. That means push the optic behind the posterior capsular rexes. This way I could achieve 2 things. One, obviously it's a very stable lens. It's not going to move at all, no capture, nothing. Second, very importantly, because it's an angle closure glaucoma, this lens is much far behind from the iris tissue, and so there will be a lot of space. So I could, although I created a complication, I acknowledge that, but then I didn't shy away from managing it, and I did what was best in the patient's interest and in my interest. Thank you.
Thank you very much, Dr. Vaishali. And now over to the trial. So the trial, the first question might seem a little impertinent, but you have to answer me there. Do you go to the gym every day, Dr. Vaishali? Yes or no?
No, not every day.
Okay. So now we have this case. We have this case as a rexis which has run out in 2 places. It's a one-eyed patient. A rexis turned out in 2 places. And here we are, our deft surgeon attempts a PCC. Yes, she is an experienced surgeon. But what if this PCC had run out as well? She would have lost the whole bag, and the possibility and the probability in such a case is definitely there. So the lost bag, and it would have been a mess. She did not lose the bag, but this is not a message that she should be giving out to every individual who does these cases for our patients. So that is the reason I asked, do you go to the gym every day?
Objection,
You are
Your
guilty
Honor.
of showing off your muscles, madam.
Objection,
you,
Your
madam.
Honor. The Honorable Judge, I think I need to intervene.
Yes,
Public
go ahead.
prosecutor is getting very obnoxious. Most importantly, what we need to watch is, this is a very shallow anterior chamber and a floppy iris because the patient has on anti-prostate drugs, so she has used retractors. The rexes run off in an intermittent cataract cannot be called as a crime. It could happen. More because it was a very shallow eye, it could have got triggered off because the pressures are higher. Now, the other thing is she has tried to round off the rexes. We all saw how fantastically she regulated her phaco parameters in dealing with the operation in a very shallow eye, protecting the endothelium. And the most intelligent move was doing a PCC is as challenging as an anterior rexis. And she has converted to PCC and optic capture. This is a learning video for all of us. We do not put a lens in a rexis gone eye and with a shallow eye and with the challenges which come in the post-operative period and the glaucoma and all these issues. PCC, where she has locked the IOL, it is well away from the endothelium, the anterior chamber has not shallowed, there is no optic capture, she has had no problems. The only argument you could ask, if you really want to argue, was when you had a rexis extension, couldn't you have converted it to a SICS and done it, if at all you want to ask that question? For that, she has an answer that it is an eye with a glaucoma. So she wanted to spare the conjunctiva and continue the phaco. So Partha, this was the most intelligent move in every step of the way. I think you need to be hanged. What has happened to our...
My compliments to Vaishali. I think the PCC was done brilliantly, and to put the lens far away from the cornea and far away from the shallow AC was a great idea. So I see nothing wrong in any step of the with such an intumescent cataract with a shallow AC, the anterior axis running off is, I think, would have happened in 90% of the cases of any surgeon even touching the anterior capsule. So again, managed well.
I think Dr. Swapnesh has something to tell. Dr. Saumil.
Yeah, I'm not a part of the
Lahane is on a call. Maybe Dr. Swapnesh, you could talk.
Dr. Rajiv, sir.
Hello.
Can I have a comment?
Raju. Yes, Swapnesh, you can also.
Sir, so that Rexis runoff, I feel when you have a shallow AC like this, if you fill in Helon, it is a space maintainer. It is not a space maker. If you want more space inside the AC for the capsule to go down, for me, the solution that has worked being a VR surgeon is to make a single port in the pars plana and decompress a little bit of vitreous. That way, the whole lens diaphragm goes down. It's a major game changer, I feel. We wouldn't have had this Rexis runoff at all.
Yes,
Okay,
I agree.
Raju.
Yes, I agree with the Somil that in cases of that shallow chamber and the intumescent cataract, you can try that pars plana vitrectomy to lower down the pressure, and then Rexis runoff will be less. But this was the one-eyed patient. Probably she might not use this. Otherwise, it is one of the good option. Otherwise, she has done the very well surgery. The lens was well captured, and excellent surgery.
Devashi, sir.
No, I will. 1 minute. Devasis.
Just a point to the public prosecutor. You said about the posterior capsular axis. I agree fully with Guresh. It's a very intelligent move, and also with Chitra, because here the bag was full of lens, right? So once she has emulsified the entire nucleus, there is lot of space. So you don't have the upthrust and the risk of doing a PCC. In fact, it is easier to do a PCC, and that she has done an optic capture. It's a wonderful step. So I cannot support your argument, public prosecutor.
Okay. Now Kamalji, sir.
Yes, sir. Sir, I just wanted to say whether AC maintainer could have been used in this case, number one. Number two, whether the peripheral iridectomy was done or not.
Okay. Yogesh, sir.
Sir, I think she managed the entire case very well. But before we learned, vitrectomy through pars plana as an anterior segment surgeon, in such cases, in good old days, we used to use mannitol preoperatively. This is one thing which would probably help in maintaining the Rexis in a manageable way. We used to try mannitol intravenously just 10 minutes or 15 minutes before the surgery. This is something which I would like to add over here.
Agrawal, sir.
Thank you, sir. I think she has done a good job. She must be complimented for taking the complications smoothly. And extension of Rexis is common, we know. And we also know just by having extension, we need not to abandon the phaco. Initially in a teaching period or initially in the practice, you may require to abandon the phaco if there is a Rexis extension. But until you know the Rexis is really going behind, and if you lower down the parameters as she did, I think phaco is a good job. And definitely a good message that you can keep the IOL away from the cornea and maintaining the antechamber at the end of the surgery. I agree with Dr. Kamalji, sir, that the PI should have been done as a second safety measure.
Okay. Thank you, sir. Mukadam, sir.
Yes, I totally agree. She did a very fine job. And additional, as suggested, peripheral iridectomy would have also been.
I think all the juries. You want to say anything, Ajay?
No, I think everything was done. I mean, any lesser mortal would have just put the lens in the sulcus and come out of it. But then doing that posterior capsular exit, the size is so important because you're going to, capture a 6 mm optic. So getting that right size, I don't know whether you have done anything. It should be around, I suppose, at least around 4 mm or 3.54 mm to put that lens down in the posterior capsule and behind the posterior capsule and capturing. I think that's what the challenge was in that. Anything you visually.
Okay. KK sir has joined. KK sir, you want to add or anything?
Naiji, I thought it was a beautifully done case. I was watching right from the beginning, and she managed a really difficult case very well. Vaishali,
just one point I want to add, which I mean, most of the people have said that very nicely in PCC and everything. So it was definitely very well managed. One point that I noted was, again, I would like to compliment her because she enlarged the anterior opening as well, the anterior axis. Because what happens when you're putting the multi-piece lens and the anterior opening is a little small, it will have a tendency to, further extend the ripped area. So that was something which was which was a point which was, it was a good thing and good thinking, and of course, managed very well.
Sandeep?
Hello. Yeah, I think, Vaishali should be complimented. I think it's all in the genes, so beautifully managed. And I was just going to make the point which Rajesh said about extending that anterior capsule. One thing I wanted to comment, because somebody mentioned about the pars plana vitrectomy before, and I have done it in a lot of cases. But correct me if I'm wrong, there was a lot of intralenticular pressure also, no? Vaishali? Was it an intumescent cataract?
Yes, intumescent cataract.
Yeah, so in that case, I don't know whether that would work. A UBM before surgery could show whether, the posterior chamber needed to be entered. But otherwise, I think you managed it. Just hats off to you. As Chitra said, this was a learning video for all of us. Thank you so much for presenting.
Okay, I think all the juries, I want to ask you, those who are on the side of she is not guilty, please raise the hand. Not guilty? Okay. Okay, thank you. I think all are with the not guilty side. And Vaishali, I think you have managed very well. The tear has happened. The manital or posterior, the vitrectomy, all other things, yes, these are the options. But when you have managed by your own and you have done very well surgery, so I appreciate your surgery. And this is, I think, all the people who are in the learning phase who want to learn few more things, I think Vaishali, this video will definitely guide them.
Yes,
So though the Partha wants that somebody should be hanged, but for that he should bring such client. And I want to request him, whenever you are now going, all over the police are also not getting successful in the court of law. And the same thing is happening with you. So here also she is not guilty. And I request Partha next time he should study more. And whenever the case is registered, he should register properly. Thank you. Thank you very much. Go ahead next.
Thank you, sir. So we go to our next very glamorous surgeon, again, a young, dynamic person, none other than Dr. Somil Seth, and he's going to show a challenge in vitreoretina surgery. Somil, over to you.
Yeah, can you see my screen now?
Yes, yes. Somil.
Yeah, so I will be talking about a surgery. Actually, it is not a complication, but the case itself is so complicated that it has no known treatment. So we all know that central retinal artery occlusion has no known treatment, and I'm doing a vitrectomy for the same. So to give a background of the case, it is actually a 75-year-old female, central retinal artery occlusion, as you can see from the cherry red spot, with PL and PR inaccurate vision. You can see two atheromatous plaques in the two branches of the arteries in the optic disc. So when I begin the surgery, any vitrectomy begins with a PVD induction, which I did because you need that to approach the retina. Stain the ileum. Now, you don't really require to peel the ileum. The reason why I did it is because if I was not successful in doing anything to those emboli there, at least I would have achieved improved oxygenation by way of removing the ileum barrier so that at least the macula can get oxygenation directly from the vitreous. So ileum peeling happened uneventfully. I also tried to peel the ileum around the disc, because that is where majority of my interventions are going to happen. Now just note the plaques over here. My first maneuver would be creating a low pressure inside the vitreous, because the arterial pressure itself is good enough to draw the embolus out. So it is working by negative suction. I close the port, infusion port, and I create a negative suction. You can see the discoloration here, and you can also see the choroidal knuckle over here, which clearly means the eye was under hypotony, but the arterial pressure was not enough. So I tried the next maneuver, which is deangulation. What I did is a curved artery, a curved vessel. I tried to make it straight just by pulling with a forceps and see what has happened.
Yeah, khatam bhi ho gaya. Ekdam
Embolus,
time pe 12 o'clock dot.
embolus is
Give it to the
traveling
next
all
session.
along. More importantly, please note that there is circulation immediately established behind the embolus. Now, this has not been done before anywhere. I'm trying to show this video again under high magnification. See, just teasing of the vessel, deangulating it a little bit, and you see this embolus traveling right through. It's like opening up a dam, and you see the gush of water right there. Very similar. You see this under high
But what were you
magnification.
talking? That's important.
The
What were you
embolus
talking?
going
That's
through, and you
important.
see the perfusion
Means
right
it was
here
not
in the artery.
apna
1 minute.
discussion nahi na.
Sai, can you
Voting time.
can you mute everybody, please? Sai, can you mute everybody?
Swapnesh, can you mute yourself?
Somil, carry on.
Yeah, sorry. So now what I try to do is, because atheromatous plaques are still there and they're going out piecemeal, I tease, and you see these two emboli going in the superior vessel. Again, I'm showing it under high mag. This atheroma, you just tease the adventitia of the vessel directly, and you see the plaque breaking again and two pieces going in the superior arteries. So this was a second maneuver. My third maneuver was actually milking it with a forceps. It's like, you're trying to push the emboli all along the vessel. And this is how I did it. So if the embolus, I try to peel the, there the embolus is getting dislodged, and I'm trying to actually milk it with my forceps, so as to make it go distally. And if it goes distally, you see over here very clearly, at least a proximal circulation with the collaterals is there enough to perfuse the macula. Now you see the cigar-shaped embolus, it is getting lodged at the fork, and it won't go further because the embolus is too big. But at least I've established proximal circulation. Anyway, I'm not much concerned with this area. It is inferonasal retina, not really coming into the macula. So if you see final restoration of circulation, in fact, it was established the moment the embolus was displaced distally. And you laser all the suspicious areas as what you would do in every VIA surgery. Thank you. Actually, drastic situations call for drastic measures. Because this surgery had no other solution, this is what we resorted to. The patient actually improved in vision from PLPR to 618. So with that, I rest my case and over to the judge and the jury. Thank you.
Before the judge and the jury, I come in. So Somil has presented a case which has left each one of us nearly speechless. But let me give you the facts. It was a phenomenal surgery done. It was something that many of us have not seen before. The outcome was brilliant. But this was a 75-year-old lady with a CRAO, and she presented within 24 hours. So did Somil try the conventional methods before, for example, the digital massage, the paracentesis, the IV mannitol, and possibly this could have had the same outcome without going into a surgical drama. But he wanted circus, and he wanted a surgical circus also. And PVD-induced retinal traction, the choroidal detachment possibility, the breaks possibility, all these things in a 75-year-old. But at the end, I think there was another thing that was in his mind, and that was money, money, money. He is guilty. Over to you, Somil.
I don't know how, Partha, this was a particular case, Honorable Judge, which just all of us should have stood up in our seats and given him a tribute of that kind, because I don't think any of us would have seen such wonderful videos shown by such a young guy at that. So Partha, this is no way of searching for problems when they are not there. Maybe you and I would not attempt to do these surgeries, but a gutsy guy like Somil who has surgical skills is the right person to do it. and a vision of 618 improvement. He has shown us how beautifully the ILM has to be peeled in the peripapilar area, why not, why it should be done, and how he has brought down, created a hypotony. He taught us so many things in the course of the surgery that if not us, any other young, brilliant surgeon who's watching this would know this is how it has to be done. And we don't talk of some ridiculous conservative measures which never succeeds. Of course, he had that golden period of the patient coming to him within 48 hours, which has to be kept in mind. Kudos to you, Swapnil.
Thank you, Chitra madam, for supporting me. Partha sir, I would like to highlight one thing. I have tried those measures. Those measures are non-invasive, and it is a given that those measures will be tried before resorting to surgery. In fact, I consider my surgery an extreme form of digital massage, because you're massaging right at the artery itself. And I saw those clots right there. Many of the times you don't see a clot, they are behind the artery and you can't do anything, but here you can do. Sir, I would just like to say, sir, this massage technique that is there, I don't feel it is documented. It's like massage, it's like Baba Ramdev, sir. Next time you'll say do yoga. Third thing you'll say use coronal for it. So a disease that has no solution and a patient who is just PL, is she going to go worse? Definitely not. You definitely can try something.
Okay, I think the Swapnesh is there. Swapnesh, tell me.
Yes, sir. No, it's a wonderful surgical video, but I think it's a superb outcome. We may not get the same outcome in every case. I think in this case, there was a fibrotic plaque over the optic nerve head, which was also an important thing, and which might be one which was blocking the clots. Secondly, is the timing of the surgery important? And there have been such cases presented even by Dr. Nishikant Bodse with successful outcomes. But the percentage, Saumil can tell, if it is attempted in 10 cases, how many cases it would be successful. And finally, it is important to under-promise the patient, not to promise the patient that the vision is going to improve, and treat this as a last attempt. Swapnesh, I've done 14 cases. Only 3 cases have benefited. So you're right there. And the young audience who's actually watching this should take that message home, that most of the times it does not work. But do we have anything better? And you have PL vision. So, I mean, it makes no sense if you just leave it alone.
I think the Kuresh, you want to say something?
Yeah, I just wanted to add that I think what Saumil pointed out, the positive factors going for him in this case, that he could see the clots, he could see that it was not a clot which was behind the disc. So there are some pointers that he's giving as take-home messages as to which cases of CRAO this should be tried and in which case it should not be tried. So that way, you can't blindly do it in every CRAO. He's not advocating it, and I think that should be the take-home message.
I think the any other jury want to say comment anything? All the jury, I want that
he needs a standing ovation, sir.
Yes.
Wonderful idea.
It means all my juries on the same side. That see the CRAO, when it is a CRAO, we certify that patient is not going to see. Patient is blind. And when patient is blind, to go and do the surgical approach, okay, it may be a band or it may be something. The removal of the clot by massaging, I think that was a heroic job that he did. Out of 14 cases, 3 were successful. I'm happy because I also operate the blind cases to come to me. And out of 100 cases, we get near about 8 to 9 cases get the vision. The reasons are not CRAO, but so many type of reasons are there, but we operate blind cases. So I think what you did is very good, and success in 3 cases is also good. You should be appreciated, and I think we must garland you for the successfulness. You are not at all guilty, but we appreciate your work. Can go for the next, sir.
Thank you very much. Thank you, sir. Thank you, Lahane sir. So we go for the next of our surgeons on trial, and that is Dr. Ritika Sachdev. Again, someone with a huge legacy, with a huge standing. And here she is to present something that I do think that she's guilty of. Ritika, please.
Thank you, sir. I'm hoping this plays. Is my screen visible?
Yes.
Okay, great. I'd like to thank Dr. Lahane sir, Dr. Ragini madam, Swapnesh for this kind invitation. I'd be talking about a very simple thing that we've all started using last year, which is the practice of teleophthalmology. So the pandemic and the ensuing lockdown that came in brought into spotlight a lot of technological innovations, one of which was teleconsultation, which got a full and acceptance from the patients. Seeing the growing demand at Century Site, we launched our own teleconsult platform and saw a surge in the number.
Ritika,
bring
can
down
you
the
cut off the
volume and
music?
start again.
The music, yeah.
Yes, sir.
It's interfering with your voice. So
We
can you
can't
cut
hear
it down
Oh, okay.
and start again, please?
Start again.
Am I audible now, sir?
Yeah.
Am I audible, sir?
Yes.
You can be louder.
We launched our own teleconsult platform and saw a surge in the number of cases. And with that, there was a lot of excitement and hype that came in with teleophthalmology. I'm going to look back over a few cases to really realize that newer possibilities also bring newer challenges. Red eye was 20 to 25% of the cases that came to us for teleconsult, and I'm going over the story of 2 red eyes. This is a patient who was operated by me 5 to 6 years ago, 2 intact segments for keratoconus, had associated allergic conjunctivitis, thick segments were placed. This patient reaches out to us during the lockdown, the previous lockdown, with extreme irritation and redness. The photographs seem to be unremarkable, but the congestion is definitely there. And we decide that possibly this is just an allergic conjunctivitis and treat him like that. 10 days later, we get a call, the symptoms are much worse. And 2 weeks later, he comes to us. And what we see is possibly there was an epithelial breakdown that the teleconsult could not pick up. And now we're dealing with a full-blown stromal melt. The extent of the stromal melt is significant, and the intact segment is nearly exposed. The melt has happened in the mid segment of the intacts. And because it is easy to access the intact segment through the proximal or distal end, we now need to access it, engage it through the hole that lies at either end. What I'm trying to do is enter through the original incision, but I soon realized that it's a fibrosed cross-linked channel. So now I'm going to make a deroofing stab incision, a T-shaped incision over the proximal end. This will give me access of the small hole that is there at the end. Once I'm able to access this, I use a Sinskey instrument to apply significant pressure and wheel it out and pull it out with consistent force, similar to pushing it in. Now this is a pulling out maneuver that we cartwheel the intact segment out. Fortunately, the cornea is a rather resilient tissue, and once the intact segment is out, the reepithelialization does happen. We have removed the segment, and we've managed that to stop the cycle of stromal lysis here and prevent secondary infection. But the original teleconsult gave us a false sense that this may have been just a simple allergic conjunctivitis, and a full eye exam at that time possibly would have allowed us to handle the epithelium better. But this unfortunately progressed to a full stromal melt. And this is the post-operative photograph. The epithelium heals. Fortunately, we see in many of these cases, the topographic improvement continues to persist. We've had 3 intact segment melt during the lockdown. This is another one. Now, moving on to another red eye, this patient had a history of uveitis, was being treated with us, but also had a corneal opacity. She called us for a teleconsult, but being a 59-year-old lady, was not able to share any significant photographs. And as per the present guidelines, giving steroid was a gray area. In follow-up still can be given, but we wanted to be very secure. So we said that you must come in. The patient could not come in due to the lockdown. And because she was a uveitis patient, decided to self-medicate her with steroids, which had helped her so far. And then the patient came 2 weeks later with a fungal keratitis, because possibly the opacity and the infection either got enhanced or was originally a fungal keratitis. We had to glue her immediately, but the 2 weeks of steroid and not receiving treatment had done their damage, and the fungal keratitis continued to persist, and now she doesn't have any useful vision. So all in all, though we were quick to latch on to the technology of teleconsult, and it's a beautiful technological interface, the most important interface in ophthalmology remains the human interface and a discerning eye examination. Thank you.
Thank you very much, Dr. Ritika. And so we come to a set of questions that we have for you, and the trial begins with your case 1. The epithelial breakdown or melt that was missed as a diagnosis, and ultimately the segment was explanted. Who is responsible for this miss? My first question. And the second case, this patient of yours was not followed up for nearly 14 days, and knowing that she needed to be treated, disastrous consequences, and were the teleconsultations charged for these patients? Let us remember, teleconsultations are regulated by the government, and these 2 cases are gross negligence on the person who was doing the
Objection, Your Honor.
Guilty.
Honorary Supreme Judge, I think I need to intervene here. Each of us should look into the such thought-provoking thoughts which Ritika has brought out. This is a time when all of us are going gaga about video consultation and cheating ourselves that we could treat our patients. So what she has let us know that video consultation is actually only a screening device, and it is actually more of a hype in many of these dangerous moments. Both those situations she could not have seen with a patient somewhere far away in a rural place or anywhere with the photographs which they show. We all know a mild epithelial defect in an overlying and intact which is going to go for a stromal melt will not be noticed at all. The only thing she must have done is stress to those patients to come back at their earliest, but it was a life and death issue. People couldn't have come. And she has actually in this video taught us that the problem with video consultation is there is only this much we can do. And we would have to accept the problems which had come, and she has dealt the first case beautifully, and she couldn't have done anything better for the second case. I think hats off to Ritika for bringing out a very sensitive issue in this court-martial. I think Partha is too stunned to talk.
Lahane sir, can we have the jury on the subject, sir?
Yes,
Yogesh,
I
sir.
think
Yes, sir. Kamaljeet, sir, go ahead,
it's a
please.
very nice presentation, but many a time I think that this telemedicine is a big problem. Number one, in the peripheral areas, we have this problem of net connectivity. Secondly, we don't get good photographs. So many a time we may miss, although the management was good, but still the patient had poor vision in the
To the jury, I want you to ask your conscience one important question. Was she right or was she wrong? That's it.
I'll just like to
I would like to say something over here that, you know, when I have also done a lot of teleconsultation and on WhatsApp and all that. What happens that when you ask the patient to send a photograph, mostly he sends the photograph of the face with little bit of eye, partly with the eyeball covered with the lid and all those things. And it becomes very difficult to judge. And basically you decide the treatment or give the treatment based on his previous illness or whatever. I mean, based on some symptoms, and there are few patients who are sensible enough who give you a large, you know, magnified image, which gives you an idea that probably it's a keratitis, probably it's something wherein I should not use this and that. So it's very difficult to say. There's a lot of gray area in this because it depends heavily on the patient. It depends heavily on what technology the patient is using to send you the photograph, how good is that photograph. So I think it's a very pertinent point that Ritika has raised, that, you know, teleconsultation is not something about which we should be very much hyped in cases of ophthalmology. Teleconsultation is good.
That is, yes.
Subjects like endocrinology or psychiatry, etc. But for ophthalmology, a proper examination is a must.
One thing I say that if the patient is under your care, then you can give him some suggestion.
Yes.
And if the patient can get good photographs, he can show the ophthalmologist then and there. What is the point of a teleconsultation? Unnecessarily, he'll be confused. Because
Yes,
if you can get a good slit lamp photograph, a good fundus photograph, why not to show the consultant there in your surrounding areas?
Dr. Yogesh, sir.
Sir, you made a point about whether the patient was charged or not. I think it's very clearly mentioned that you can always charge in the teleconsultation. However, I do agree that we have to make it a point to to inform the patient that teleconsultation has its own limitation. We cannot be 100% sure, and it cannot be compared with a physical examination of the patient. Recently, just last week, I had a patient who just came up with a history which would be very similar to mucormycosis, having severe pain, nose block, black surrounding the eye, and things like that. She sent me the photographs also. Nothing was very clear, as Rajesh was saying. It wasn't very clear. But when I insisted that she should come down for the further checkup, and when I intervened into the questioning, she said that I have a pain somewhere over here near my hair. And where I noticed over there, it was something which gave me a hint that this could be herpes zoster. It looks like a early pre-eruptive pain. So I think you cannot compare the physical examination with the teleconsultation. It has its own limitation, but it has its own advantage, at least in the current status.
Absolutely.
Mind you, you can be taken to the courts for a teleconsultation.
So I wanted to bring these cases simply because we followed all the rules and had the consent. And hence this thing. And teleconsult even on WhatsApp or audio today is legally binding. So it was just to bring forward that it is something that we should all be aware of.
Yes.
And at the end of every teleconsult, we advise that that this is only a provisional advice, as the patient is unable to visit the hospital, and we recommend a visit at the earliest.
So you should be very careful in doing this teleconsultation.
Shall we have a quick raise of hands if anybody finds her not guilty? Raise of hands for not guilty.
She's not guilty.
Okay. Unanimous. So let us go on to our next presenter, and that is Dr. Priya Desai. Priya, are you there?
I'm there, sir. I'm just going to share my screen before. Can you see my screen, sir?
Yes, Priya. Yes.
Okay, so I'm hoping it works. Okay, so this video is about cross-linking corneas. Cross-linking is a routine procedure which we are all doing in our OPDs, but the real challenge that corneal surgeons are facing is cross-linking in thin corneas less than 400, and we've been scratching our brains to look for all sorts of different techniques to cross-link these corneas, and this is one of the techniques that I have found personally very useful, and the video is otherwise self-explanatory. I'll just run the video, sir.
Priya, it's not very audible. Priya, can you just pause? I would suggest that you speak while the video is running. Have the video on mute.
Okay, let me just do that, sir. Okay, am I audible, sir?
Yes, yes.
Okay, so basically, we're going to talk about keratoconus. So we all know that keratoconus is an ectatic disorder of the cornea, and we have been trying several techniques to treat keratoconus, and clinically, every patient presents to us at different stages, and by far we've realized that one of the most easy to do procedure with the most promising results is CXL or cross-linking. And the treatments available are the conservative and the surgical treatments, the conservative being the contact lens, scleral contact lens, the glasses, and now we have even moved on to treatments like DLK for severe cases. So why CXL? Because CXL is a surface procedure. It has had very good long-term results. CXL is basically a procedure in which the cornea is soaked with riboflavin and there is exposure of UVA. In the presence of oxygen, it has been noticed that the cross-link, the covalent bonds increase and the corneal stiffness increases, hence reversing the procedure of reversing keratoconus. So here is the real problem, less than 400 microns, because that is our normal limit. I'm going to pause here for a second. Riboflavin itself has an effect that it is going to protect our endothelium, but that is only if our cornea is more than 400 microns. So what do we do for corneas which are less than 400 microns? There have been several techniques that we have tried, from hypoosmolar to epi-island CXL to doing a epi-on CXL. We have tried several techniques, and if you can see that all these techniques have their limitations, and we're still working on the long-term results of these techniques. So here is a highlight of all the techniques that we've tried. I'm going to pause here for a second. The hypoosmolar, the epi-island, the contact lens associated cross-linking, the visco-CXL, and the transepithelial. So what I'm going to talk here is the lenticle-assisted CXL that I have been doing. And I'm going to show you the procedure. So basically what we do here is that this lenticule that we're using in SMILE is anyways of no use to us. So doing a SMILE, when you're doing a SMILE technique, you're taking this lenticule off, and this is the lenticule that we have used to augment our cornea to make it more than 400 microns, so we can do our CXL and protect our endothelium as well. So what was done is the SMILE surgery was planned on the same day as the CXL, and as you can see that we've put a lenticule on top of the cornea after epithelial debridement. So here the standardization that we have made is that we have taken 100 microns cornea with an 8.5 diameter size. So after epithelial debridement, we apply the lenticule over the cornea. And once we have placed, now the very important thing that we need to remember that the thickest point of the lenticule should coincide with the thinnest point of the cornea. And once the lenticule is placed over the cornea, a pachymetry is done to check whether we have reached above 400 microns to go ahead and continue our treatment. So if you can see in this particular case, I reached 428. So I was now secure that I could go ahead and do my CXL procedure. There have been a lot of protocols of doing CXL procedure. The protocol here that I have used is the conventional residence protocol, which is 3 milliwatts for 30 seconds. And if you can see, this is the first post-operative day. There is minimal haze on the anterior segment exam. And the most important sign is the demarcation line on the OCT, which is seen very well in this particular case, if you can see here. And this is the sequential topographies that we have done. As you can see, the cornea has stabilized over the time, and the endothelium was also protected. We also did a specular to see whether the endothelium was okay, and we had very satisfying results. So we still have a long way to go, and we need a long-term follow-up for these. And for cross-linking less than 400 microns of cornea is still evolving day by day. We are coming out with new techniques, but until we don't come up with a very promising technique, I think this is probably one of the technique that is going to be very promising in the future. Thank you, sir.
Thank you very much, Dr. Priya. And now we come to the trial. So the trial, Dr. Priya, is very, very simple. So hardly any pre-op data that you showed, actual thinning. Could it be a steep cornea? That's a question to you that I must ask. But for the procedure that you have done, 2015, this procedure was first reported. There's only one reference in the PubMed. It's not a popular procedure. And you, Dr. Priya, is taking a risk on this eye. You are guilty. Yes, Dr. Priya.
Objection, Your Honor. Can I put in my word? Our Supreme Judge is not here. Can I take?
So I will take over, maybe.
You as a judge.
Go ahead.
No,
Go ahead.
I have been asked to replace Dr. Lahane.
Go ahead, please.
I think
right,
what I would like to suggest here is using a SMILE lenticule is something so physiological, the diffusion properties and the fact that it will conform to the globe. You need to thicken it. If contact lenses can be used.
How many have you done, Chitra?
It's not a question of how many have been done. And I haven't gone through the literature, but what I'm trying to say, we need to accept something which is coming new and not. Of course, we would argue. Then I am
2015, not
arguing
new.
against a person who argues without a cause at all. Here, I know a smile lenticule can be used to augment the corneal thickness, and you can do it. And you know of other procedures which are being done. Yeah. And the other thing is this hypoosmolar cross-linking also is nothing so titrated and so effective. We are never too sure whether how optimal the results are. When you go on to thin corneas, the results are suboptimal. And I don't think all those figures and flattening and topography she's shown should be an indicator. It's just that if smile as a machine is not available all over, that people are using smile lenticules and doing it. I think Ritika would be the right person to answer to.
You don't have a smile machine and you don't do this procedure. Yet
of course, I have a smile machine. Of course, I do the procedure. I wanted Ritika
have you done
to
this
talk.
procedure? Have you done this procedure, madam?
Yes, of course.
Really?
Yes.
What about you, Partha?
No, I have not done this procedure at all. I don't believe in it. Ritika?
We had reasonable results, but I think with adaptive fluence now going to be accepted, fortunately, we don't have to resort to all these different modalities, and adaptive fluence will be the future. But the time where we are using this, we don't have adaptive fluence, and we're still giving these are normally, young children or advanced cases. We're still giving them a chance. And later, 5 years from now or 10 years from now, when we have a better modality, perhaps we can even repeat it with adaptive fluence. And we've seen deep demarcation lines, more than 250 microns in most of these cases. So
okay, we are running short of time, so we
Yes.
should finish.
I think let us finish. Let me thank every one of you, all our
Partha, you
jury
should
members.
take a photograph, Partha, with all of us together.
Okay.
Yeah.
So
Thank you, sir.
Somebody
Thank
should
you, everyone.
thank you very much. Thank you, everyone. And here is the photograph. Let's all keep smiling. Thank you.
Thank you. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you very much, Partha, for a wonderful.
Thank you, Partha. As
Thank you,
usual,
sir.
it's
Thank you.
Another
Thank you.
And he's not guilty. He is not guilty.
not guilty. Yes.
Thank you, sir.
Okay.
Okay,
Thank
sir.
you very
Bye.
much. Bye bye.
Bye. Bye. Bye, everyone.
So, bye, Partha, sir. Bye, ma'am.
Bye, bye.
See you again for court martial.
Sure.
See you. See
Bye,
you. See
Partha
you.
sir. Bye, Chitra madam.
Bye.
Partha, better luck next time.
And Somil, hats off to you.
With Lahane, sir, I can never
you,
have
ma'am.
good luck.
Sir, Partha, my best
Dr.
wishes for the
Partha,
next time.
you have done a great workup, and both of you have done wonderful. I am replacing Dr. Lahane, so I congratulate both of you and the speakers also. Thank you so
very
much.
Thank you, sir.
Thank you.
Thank you.
Bye. खत्म हो गया चलो
Please, Keki Mehta, sir, is there?
I'm here.
Yeah. Sir, I think we should start our session now.
Absolutely.
So I welcome you all for this exciting session. And with so many stalwarts on the same platform, I'm sure it will be a great academic feast to everyone. With me, chairing the session is none other than Padma Shri Dr. Keki Mehta, sir, co-chairman Dr. Ramamurthy, sir, convener Dr. Aditya Kelkar, co-convener Dr. Siddharth Chauhan, and I'm Dr. Shirish Thorat moderating the session. So let us move to the first talk directly. May I call upon Dr. Ramamurthy, sir, for his presentation on maximizing outcome with toric IOLs.
I won't interrupt the session, but I must say this. Sincere apologies for the delay. Mehta sir, Ramamurthy sir, Sri Ganesh sir, Sirish, Siddharth bhai, Sonu Goyal, Ashwin, Mehta sir, Kurian sir, Ladi sir, everybody, sincere apologies. But there is no session till 2:15 after that. I'm sorry for wasting, for the time delay, but please continue your session the way it is, because after this, there is nothing in this hall till 2:15. Thank you so much. Mehta sir, sincere apologies once again.
Not at all up. I enjoyed the previous one. It was marvelous.
Yes. Still we try to maintain our time, madam. So, Dr. Ramamurthy needs no introduction. Sir, please. He's a past president of AIOS, chairman scientific committee AIOS, and past president Tamil Nadu Association. Sir, please.
Thank you, Dr. Shreesh, and thank you, BOA, Dr. Lahane, Dr. Ragini, and all the friends over there. Uh, Unfortunately, the second year we are meeting virtually, but still, I think we'll make the best out of it. The topic given to me is maximizing outcomes with toric intraocular lenses. I think this slide has been oft repeated in many ways, where almost 20% of our patients who present for cataract surgery have more than 1.5 diopters of toricity, but then less than 5% of them actually end up getting toric intraocular lenses. The range is anything between 0 to 80%. And whenever you leave cylindrical power uncorrected, it not only reduces the unaided visual acuity, but it also causes a significant drop in image quality. And this becomes even more important when you're dealing with multifocal intraocular lenses, where it is absolutely essential that we take care of whatever pre-existent corneal toricity is there. So there is several options to deal with corneal toricity: laser arcuate keratotomy, limbal relaxing incision, opposite clear corneal incision, incision on steep axis. But any of these things done on the cornea is something like a radial keratotomy, where the results are not much or not predictable, and whatever little you get also regresses over time. So maybe for your mental satisfaction, you can try some of these for small degrees of astigmatism. But if you need some definitive treatment for pre-existing corneal astigmatism, there's nothing better than toric intraocular lenses. As far as this procedure itself is concerned, this is not for irregular astigmatism, where like in corneal scars, in keratoconus, in post iatrogenic keratoconus. But where it works best is in where there's orthogonal astigmatism, that is the steep and flat axes are at 90 degrees to each other. And it's regular astigmatism, and it's not irregular astigmatism, which has been brought about largely by aberrations, higher order aberrations in the cornea. Having said that, there have been several instances of keratoconus as well as iatrogenic keratoconus, where subsequently stabilization of the cone, either because of the aging of the patient or subsequent to collagen cross-linking, we had gone ahead and implanted toric intraocular lenses, provided these cones are well-centered, so as to debulk the amount of astigmatism these patients have to deal with. As we all know, refractive astigmatism is just indicative of the amount of astigmatism that we need to deal with. And lenticular astigmatism is does not really matter because this lens is out. Just to demonstrate this point, you see over here, this is the internal aberrations and this is the total aberrations. And this would make you feel that there is a significant astigmatism. The patient has been wearing glasses about 1.5 diopters right through the life. But as you can see over here, the cornea is pristine. There's hardly any astigmatism, as you can see in this curvature map. So when the lens comes out, this is going to completely disappear. So obviously this patient, though has been wearing astigmatism in his glasses throughout his lifetime, does not need any toric intraocular lenses. On the other hand, a situation like this, where the toricity internally on the lens and in the cornea almost balance out each other, so that centrally there's hardly any astigmatism. But this corneal astigmatism is going to get manifest when the lens comes out. So obviously this patient is a candidate for a toric intraocular lens. So suffice it to say that do not go by lenticular by the refractive astigmatism, but measure the corneal astigmatism. There are three aspects which have undergone a sea change as far as our understanding is concerned in the last 5 to 6 years. There's the concept of posterior corneal astigmatism, surgically induced astigmatism, and toricity ratio. It was Doc Koch in his 2012 innovative lecture brought this concept to the outside world, where now we understand that the posterior corneal astigmatism, which is most often against the rule astigmatism, enhances the amount of astigmatism if it is against the rule on the surface of the cornea by about 0.5 diopters, and reduces the anterior corneal astigmatism by about 0.3 diopters on an average if it's with the rule astigmatism on the surface of the cornea. The initial nomograms came out incorporating this concept, but we have much better ways of dealing with it, and I would allude to it shortly. Another important aspect that we need to deal with is over the lifetime of the patient, the corneal astigmatism tends to shift from with the rule astigmatism to against the rule astigmatism. by about 3/8 of a diopter for every decade of the lifetime of the patient. And that's the reason most often in our LASIK patients who are much younger, we have with the rule astigmatism, while in our cataract patients is most often against the rule astigmatism. The implication of this is when you have younger patients presenting to cataract surgery, so there are some of us who are doing clear lens extraction, obviously we would go easy on correcting with the rule astigmatism. But it's against the rule astigmatism, especially in an elderly patient, even though you might be doing temporal clear corneal incision, you have to go ahead and address this against the rule astigmatism significantly. Another important aspect is the toricity ratio, which takes into consideration the effective lens position of these toric intraocular lenses. Conventional wisdom has been that every 1.5 diopters of intraocular lens toricity corrects about 1 diopter on the corneal plane. But again, depending upon the location of these lenses in highly hyperopic short eyes, the ratio is much less, while in myopic eyes is much more. And this table again illustrates this. As you can see, in a 20 millimeter short eye with a 38 diopter flat cornea, you just require 1.29 diopters in the lens to correct about 1 diopter on the corneal surface. But on the other hand, when it's a long eye with a steep cornea, you need as much as 1.86 diopters. So you need to remember this, and the current formula incorporate this. The other important aspect is this surgically induced astigmatism. For a long time, I was incorporating 0.47 diopters as the astigmatism induced by my 2.2 millimeter temporal clear corneal incision, because that's what the Warren Hill formula told me. But today we understand that it's the centroid value which is important, because astigmatism on the cornea has both a direction and magnitude which tend to neutralize each other. And for my 2.4 millimeter temporal clear corneal incision, I just add a value of 0.1 diopter. And if in case you are using a 2.8 diopter millimeters, it's just about 0.2 millimeters. This further tightens out the kind of results that you have. In case you do not have access to advanced biometers, I feel the way to go about when you're dealing with toric intraocular lenses is the Barrett toric calculator. Each and every one of our patients, when they are ready for cataract surgery, the first examination we do is a Barrett toric calculator, not the universal 2, because we find that quite a few of them, even though might be having small degrees of astigmatism all along, are going to benefit from toric intraocular lenses, and our entire counseling is based upon that. In case the patient has had previous refractive surgery and is maybe a candidate for a toric intraocular lens, is a Barrett 2K toric formula that we use. This is available to you at no cost at the APA-ACRS and the ACRS website. And this is actually a drop-down menu that you are seeing over here. And this is something we use even in our centers where we do not have advanced optical biometers. But nowadays, these Barrett formula is incorporated in Oil Master 700, Lensa, the Varion, the Topcon, and of course, as I already mentioned, and these couple of websites. So I believe that instead of confusing with multiple formula, which have their own advantages, if you want one go-to formula as far as your toric and intraocular lenses is concerned, it would be the Barrett toric calculator. It has also been shown by studies that when you are looking at results of less than 0.5 diopters residual astigmatism subsequent to toric intraocular lens, the Barrett algorithm scores much better over some of the other recently available algorithm, and that's the reason to adopt it. Why is it so? It's because the Barrett toric calculator incorporates posterior corneal astigmatism, the effect of against the rule drift that I alluded to that occurs with age, targets about 0.25 diopters of with the rule astigmatism, takes into consideration the axil length and intraocular lens spherical power, the AC depth also, incorporating the toricity ratio. Centroid value of induced astigmatism is what is fed in. And in case you are using different machines for your corneal surface, then K index is also variable. And nowadays, we of course have the capability of the total keratometry, where using the Swepsos OCT, you are able to measure the posterior corneal surface and because of the thickness of the cornea that's incorporated, so that you can directly get a readout as far as the anterior corneal curvature and the posterior corneal curvature is concerned. That's why you have the Barrett TK Universal 2, the Barrett TK toric formula, and even the Barrett toric TK formula. But essentially, this may be of limited use when you're dealing with regular eyes, but it comes to eyes which have already undergone refractive surgery and the Gulfstrand ratio has been changed, maybe resorting to the Barrett TK toric would be a good idea. As far as marking itself is concerned, there are different options that are available to us. But my preferred modality today is to go ahead and do a digital marking. But of course, when I was using this was my conventional way of marking. Just before the surgery, make the patient lean against the wall of the operation theater using a bubble marker and with the light pointing at the level of the patient's eye. Go ahead and do this. I was getting reasonably good results. But today, it's you have the Callisto, and then you have the we use the Verion regularly. Is the image registration. It's not only the location of the incisions. Today, of course, it's a temporal clear corneal incision all along. And I used to usually keep my side posts about 60 degrees away from my side post central incision. In this case, which is a slightly older video, I'm making my initial incision as 30 degrees because that was what was being recommended. But as you all know, today it's no longer the case. And it's not just the location of the intraocular lens, but even getting an absolutely well-centered rexus. And you can see me polishing the rim of the anterior capsule, which I do in these cases, so that there is no reduced incidence of capsular phimosis. That's a toric intraocular lens being slipped in. Usually what you want is to rotate these lenses only in the clockwise direction. And it's extremely important that the viscoelastics is completely removed both in front of the lens as well as from the back of the lens. And subsequent the positioning of these lenses, at the end of the surgery, you tap down the lens onto the posterior surface. To finally, just a brief summary, what are the tips to maximize outcomes? Multiple measurements of K readings, and in case they don't line up, then maybe you have to go ahead and recheck them. And nowadays you have a special Barrett formula where you can put 3 readings from 3 different instruments and get a median value. And consider the refractive cylinder, but do not be guided by that. Ensure the ocular surface is premium, because unless it's pristine, you would get wrong readings. Use the Barrett toric calculator. The SIA for your 2.4 millimeters temporal clear corneal incision is 0.1. Undercorrect with the rule astigmatism, overcorrect against the rule astigmatism, but it's not necessary if you're using the Barrett toric calculator because it's already compensated for it. My final slide, during surgery, kindly make a little longer incision though, so that your anterior chamber is quite stable. Avoid overinflating because that will make the lens shift in its position. Ensure complete viscoelastic removal. Nudge the intraocular lens onto the PC at the end of the surgery. Slightly smaller rexus so that there is regular overlap. Ensure good positioning of the lens once even after the speculum is off. And rest and patch for about 2 hours, because it's been well proven that whatever toric intraocular lens rotation occurs, most often occurs in the first 1 hour after surgery. So avoiding excessive movement of the patients, and normally we do not patch our patients after topical anesthesia cataract surgery, but the toric intraocular lenses for the past 6 months, I've been patching them and removing them in about 2 hours time before sending these patients off. Finally, if residual astigmatism is there, then we rotate these lenses about 2 weeks later. If you rotate them too early, then there is a tendency for them to come back into inappropriate position. So 2 weeks is a good time, even if it's a hydrophobic acrylic lens that you have implanted. I use the Barrett RX formula for this, and I do not introduce any viscoelastic, but just going with an irrigation cannula and under balanced salt solution, just reposition the lens into its correct position. Thank you so much for your kind attention.
Thank you very much, Ramamurthy sir. Particularly the rest and patch for 2 hours is a very informative and much needed tip for many of us. We'll take up the question at last. Now I'll call upon our next speaker. A big name in cataract and refractive surgery is none other than Dr. Sri Ganesh. His topic will be newer techniques of scleral fixation IOL, modified 4 flanks technique.
Good afternoon, everybody. And I would like to thank Professor Lahane and Dr. Ragini and team of BOA for inviting me. And I would be talking about my experience with the modified 4-flange technique for scleral fixation. As all of you all know, scleral fixation there are various techniques, but most of them are time consuming. And let me just share my screen.
Thank you, Dr. Ramamurthy Bhaiya. Thank you, Dr. Sri Ganesh Bhaiya, for being with us. Thank you so much.
Thank you.
And joining today,
Thank
all
you.
of you, in spite of the lockdowns, in spite of so much work and running huge hospitals, thank you so much.
So let me go on to the technique. Basically, the 4-flange technique was described by Canabrava, and I kind of modified this technique to preload the needle with the proline, and I will be showing you the technique, a couple of cases. And as I describe it, this was a case which came to me with a subluxated IUL, and with this technique, you have to use 6-proline. So here you have to create here I'm creating a scleral tunnel. So I reflect the conjunctiva, and then after cautery, I make a 6 millimeter scleral tunnel.
So we can't see the video.
You can't see the video?
No, sir.
No, sir. So we could see your computer screen, but not the video.
Can you see it now?
We can see the
only screen.
Main PP.
No, no.
No,
The
sir.
video is not seen. It's only the slide is seen.
Oh, I don't know what the problem is, because okay, let me just recheck if I can do.
So instead of sharing the PPT, can you share the whole desktop screen?
Yeah, this is the. Can you see the desktop screen now?
Yes, sir.
Okay. Can you see the
Yes, sir. Please.
video now? Is it playing? Okay, I'll play it like this.
No, video. Yes.
Yes, it's playing. Okay. So this is the 6-0. We use a 6-proline in this case, and you can see this is the case where I have actually. This was a subluxated IUL. A patient came with a lot of glare and diplopia, and so I reflected the conjunctiva, and I'm making a 6 millimeter scleral tunnel here. First, we need to expand this lens before putting in the secondary IUL scleral fixation. So once I create the tunnel, now I'm going to remove this lens. Probably there was a PCR. I don't know what the problem was, but I held the lens. This is a PMMA lens. And once I remove it, I find that it is an anterior chamber lens. An anterior chamber lens which has been put in the posterior chamber, and so it was not stable. Probably there was a PCR, and the surgeon put this lens, instead of putting it into the anterior chamber, he put it into the sulcus, or he was trying to put it into the sulcus. Anyway, it was not centered. So this is the IUL that was removed. So following this, you'll have to do a vitrectomy and clear the vitreous. So you can see it's actually a Kelman multiflex lens. You can use triamcinolone, or here I'm just doing anterior vitrectomy and clearing the vitreous from the pupillary area and just below the pupillary area. And once the vitrectomy is done, then you have to just mark diametrically opposite points, 0, 180, about 1.7 millimeters from the limbus. This is where you're going to introduce the needle. I take a 27 or a 30 gauge needle, and I thread this 6-O-Prolene, a piece of 6-O-Prolene through the front of the needle. So this technique is very easy and even residents can do it. It's much easier than the other techniques. Then you just pass in the needle through the sclera, transconjunctiva, transcleral, and then you pull out the proline through the main incision. Similarly, on the other side, again, the pre-threaded proline is pulled out through the needle and brought out through the main incision. After that, you use a scleral fixated IOL with an eyelet. You pass the needle from anterior to posterior on both sides, and then you use a cautery to flange the proline. So once you flange it, you get a kind of a knob there, and then it is stable. The proline does not come out. And then you can insert this IOL through the incision and just put it below the iris. So these lenses with eyelets, sometimes the haptics are more fragile and tend to break. So I like to dial it in instead of rather just pushing the trailing haptic in. So you can see that's with the dialer, I'm inserting the lens, dialing it under the iris. So once you do that, then also you'll have to see that the proline does not get intertwined or crossed. You just pull on both sides of the proline and you can see that the lens centers beautifully. You hold the proline, cut it about 3 millimeters, and then you will have to cauterize it. You will have to flange it so that the flange is quite tight and there is no play. Again, the other side also, similarly, the proline is flanged. You hold it up, and then once this is done, then all you have to do is bury the flange subconjunctivally. So you can pull up the conjunctiva and just bury it under the conjunctiva. The flange is very smooth and rounded, so this does not cause any erosion or extrusion. And that's basically the end of the procedure. You can just close the tunnel with a little hydration, and the wound is holding well. If required, you can apply a suture, but in this case, it's holding well. So you can see that the IOL is very well centered. The actual procedure takes only about 15 minutes, and it's quite easy to do when compared with the other techniques. So this is the first day post-op picture. You can see the flanges, and the lens is well centered. So I'll just show you another video of another case. This was a patient with aphakia who had come for a secondary IOL implantation. You have other techniques also like the iris claw, but in this case, it's a scleral fixation. And many times when you want to do a combined procedure along with VR surgeries where you want to put air or silicone oil, then the iris claw doesn't work very well because it's pushed anteriorly. So here we just make a scleral tunnel, regular 6 millimeter scleral tunnel. And then, of course, you put in viscoelastic and do a vitrectomy. This is the threading of the proline. I'm doing the vitrectomy. And once you do the vitrectomy, then you pass the needle with the proline, pre-threaded proline, 1.7 millimeters away from the limbus at 0 and 180 degrees. Pull out the proline through the main incision. And similarly on the other side, you repeat the same procedure. Pass the 30 gauge needle. I'm using a 30 gauge needle here. But sometimes you may not be able to freely pass the 6-O-Prolene in a 30 gauge, so you can use a 27 gauge needle also from BD. So once you have the suture out, then again you can use any scleral fixated IOL with eyelet. These lenses are available even from most of the Indian companies. You have to pass the thread from superior to inferior, above to below. This is very important. The direction in which you pass the proline, and then once you have adequate proline, then you can use this low temperature cautery to cauterize the. You don't actually touch the proline, but because of the heat, it kind of forms a flange. You'll have to ensure that the flange does not come out of the eyelet. See, I'm just checking here. And then you go on to the other side. Again, pass it from above, below. And then you can flange it similarly. The advantage of this technique is that unlike M&A, you do not get decentration, you don't get tilt because you are passing the needle directly. Then you can just insert the lens under the iris. And I just dial the trailing haptic under. So you don't have to be afraid that you lose the lens because it's quite secure. You just have to pull on the threads and then the lens comes up. So hold the proline threads on either side, and you can just, as you can see, as you pull it up, the lens centers beautifully. So you get a perfect centration, and then you hold the proline, pull it taut, and then I like to hold it, pull it and then hold it near the conjunctiva now, and then cut it 3 millimeters away. And then you can use the cautery to flange it. And see that it is tight, there is no play. Okay, similarly, the same thing on the other side. This is actually a very simple technique, very easy to do. And we have been doing it from now nearly 3 years, more than 50 cases. And the results have been very satisfying in terms of visual outcome, centration. And so far, we have not had any extrusions or erosion of the suture. And unlike the 10 or 9 proline, because this is 6 proline, it does not degrade that easily. So it should remain for a very long time. Because with 10 or 9 proline, after about 8 or 10 years, suture can give way because of degradation. But 6O is fairly thick, so you don't expect it to degrade. So this is burying the flange subconjunctively. You can just pull up the conjunctiva and then push the flange under the conjunctiva. And you just wash out the viscoelastic. And that's basically the end of the surgery. A little bit of a strand there, vitreous strand, which I remove with the protector. So this is the technique, the 4-flange technique, which is the new technique for scleral fixation. And of course, you need a larger incision because this is a PMMA lens. We have also come up with a foldable IOL, which we are trying, but we have some challenges, and hopefully in the future, we'll have a foldable IOL for this procedure. Thank you very much for your attention.
Thank you, sir. Very wonderful technique. Every time we hear from you, there is something new every time. Thank you, sir.
Thank you.
Now may I call upon our next speaker, Dr. Sonu Goyal, who will be speaking on choosing the correct IOL for keratoconus.
Dr. Sirish, can I interrupt his topic? No, there was a miscommunication. So his topic is actually on subluxated lenses.
Okay.
This was yes. So I'm sorry for that. And subluxation management, that is Dr. Sonu Goyal, sir.
Yes.
Thank you very much. At the outset, I'd like to thank Professor Dr. Lahane Congratulations, sir, in advance. Dr. Ragini Parikh, ma'am, Swapnesh, and respected judges. I'd like to, am I audible?
Yes, yes, sir.
My
Yes, sir,
screen
you are
is
audible.
So I'd like to extend what Sri Ganesh had beautifully explained, wonderful surgery. So there is always a problem with the 9O and 10O proteins that they get over a period of time degraded. So we have to find an alternate where we have over a period of decade the lens remaining there in the eye and not getting repeated subluxation. So let me take you to the subluxation management. Clinical evaluation is important. A proper history of trauma, the onset, the visual symptoms, and definitely age, because young usually means metabolic, where the adult usually we find Marfan's and other syndromes. So examination in the upright and the supine position, because a lot of times when we take the patient in the OR, we fail to find where the lens has gone because the lens has been dangling in the upright position, but the moment the patient lies down, it falls off. UBM is essential in all these patients to assess the degree of zonular compromise. Lens capsular trauma gives quite an indication of traumatic insult to the eye. The lens density is important because this would then guide us to the amount of the zonular support that we are planning and phacoemulsification being carried out. Vitreous in the anterior chamber, the intraocular pressure, a specular and a retinal evaluation being part of the routine evaluation. So the ophthalmic examination basically is divided into classifying this subluxation into mild, moderate, severe. So I would take the patient on the slit lamp, full dilatation, and if the lens edge uncovers 0 to 25%, they are classified as mildly subluxated. 25 to 50% would give you a moderate, and more than 50% uncovering means a severe degree of subluxation. The degree of zonular loss has to be assessed, and the zonular status gives us a degree of the phacodonasis. We can assess by the degree of phacodonasis. Now, localized, if there is a locular loss, it could be a focal trauma, or there could be a congenital defect. And if it is extensive, it indicates a marfanoid or a pseudoexfoliation. Now, what is important, I would like to emphasize here, a dilated examination, we should always analyze the lens edge. If the lens edge is flat, that means the rest of the zonular fibers must be quite healthy and could be a non-progressive illness. And if it's a rounded, that means the adjacent zonules might not be very healthy. So the patient might require a 2-point fixation, or you might think of doing an Emmett segment in these patients. The choice of capsular support basically depends upon the degree of zonular lysis. It depends upon the extent, whether it is a progressive or a static, and what is the strength of the retained zonules. So the the armamentarium includes a capsular tension ring or a Cioni CTR, the Emmett segments, and a lot of new devices that have come into the market, like the ASI anchor device, the Yagachaki hook, the capsular hooks. So for me, if it's a 3 to 4 clock hour of zonular lysis, I will just do away with the capsular tension ring. If it's between 4 to 8 clock hours of complete zonular lysis, either a Cioni 1L or a combination of a Cioni CTR or a CTS, a capsular tension segment with a capsular tension ring would be warranted. If it's more than an 8 clock hour of zonular lysis, either a combination of a capsular tension ring with 2 capsular tension segments or a Cioni CTR with 2L or a Cioni CTR with a capsular tension segment. So the suture material here is important. What over the period we have been using is the 9O or a 10O polypropylene. And the biggest problem with this is that it hydrolyzes over a period of years. So we have seen patients coming back to us over a period of 5-7 years where the lens has got again subluxated. So addressing this problem, we find that the CV8 or the Gore-Tex is a great tool. It's a polytetrafluoroethylene CV8, and you can procure with your pediatric cardiac surgeons who regularly use this suture material. The biggest problem with this is that it doesn't have a needle. So the 26 gauge needle comes to an arm where you thread it reversely. I'll show you, run through your video, and how we can manage these patients. So this subluxated, if you see, I go in 2 side ports, push in, do a limited anterior vitrectomy. I would always stain with triamcinolone to assess the vitreous. A good capsular axis, centralized. The hooks gives me a support, phacoemulsification with low parameters. And the bag always has to be distended with a good viscoelastic. I would thread in a capsular tension ring so that the vectorial forces are divided, shift the capsular hooks 90 degrees apart, do a good irrigation aspiration, and have a clear bag with a capsular tension ring. I would make a Hoffman pocket, and then this is the Ahmed segment. Now watch, this is the Gore-Tex threaded reversely onto a 26 gauge needle, and this is the Ahmed segment where one loop is being made. This is pushed inside the bag, and now what is to be required is the two arms of this thread has to be externalized. So this 26 gauge needle now acts as a loop. Watch, I have made a loop. I thread one of the arms of the Ahmed segment inside this, and then gradually with the loop, I externalize. So the one thread of the Ahmed segment is out. The second remains. I again pass this 26 gauge needle, make a loop, and then thread, and then externalize. So this 26 gauge needle is helping me to externalize the two arms which are being threaded from the Ahmed segment. So once this is externalized, the Ahmed segment sits inside the bag. Through the Hoffman pocket, I withdraw the 8 Gore-Tex, trim the sutures, and then just check the centralized position of the bag. I would always push in a 3-piece just in case if I lose the bag, I can always convert it into a glued or the Yamane technique. Now the bag is central, the lens sits there. I check with the Lumera 3 Perkins images, and then I tie this Gore-Tex, trim, and then bury it under the Hoffman pocket. And this is what a centralized lens bag complex with a NATO Gore-Tex, and I'm pretty sure this is going to work for the rest of the life of the patient without any risk of getting hydrolyzed over a period of time. And this is the day one picture where the lens bag complex is quite stable, centralized, and visually quite acceptable. A newer device is the Ahmed ASI anchor, which of late we've been using, and it's like a paper clip. So if you see the slit lamp image of this patient, subluxated lens, rhexis is tricky in these patients. So I would always do a triamcinolone, do a limited anterior vitrectomy, push in a viscoelastic, and yes, make an initial nick, make a little opening, and gradually draw the lens so that I can get a centralized opening of the bag. It's an aspirable lens, so I quickly aspirate, always distend the lens, push in a capsular tension ring so that the vectorial forces are divided 360 degrees. And this is the ASI anchor device. The 8 Gore-Tex is threaded, and now I'm trying to make a loop with this 26 gauge needle. Almost similar procedure. The two threads have to be externalized through the Hoffman pocket. So here I am able to externalize. The lens goes in, and just watch this device. It's a beautiful paper clip kind of a device. Just watch while I stretch it. The whole lens bag complex is drawn as if a paper hook, and I achieve a centralized lens bag complex. Underneath the Hoffman goes the suture buried, and this is the day one picture, a centralized lens bag complex, and I believe a good job for the rest of the life. Thank you so much.
Thank you so much, Dr. Sonu Bhaiya. I know I pulled you away from your COVID meeting and forced you to come and talk today. Thank you so much. Thank you so much for being here.
Thank you for the opportunity. I'm really grateful to you.
Very wonderful videos. Now, next speaker is Dr. Kiki Mehta, sir, who will be speaking on multifocal dual IOLs in the children. KK Mehta sir, please share your slides.
Mehta sir has been Dr. Lahane sir's and my mentor to whole of BOA for it to grow the way it has, and being there and being the chief patron and advisor. But you know, he's so young at heart, we cannot call him a patron because he's still working during the COVID times all day, operating, seeing patients when so many people shut down their clinics, and such an inspiration for all of us, Mehta sir.
Yes, madam. Actually, words fall short beside him, madam.
Very correct, Sirish. Very correct. It's been so nice to have such stalwarts in this session, people whom we can look up to, people who are teaching us new techniques and techniques which are safe for the patient.
Yes, absolutely. Thank you.
Is my slides moving okay?
Sir, we are seeing the slide sort of view, sir. You have so please make it the slideshow, sir.
Okay. 1 second. I'll stop sharing and I'll just do it again. 1 second. I've got Ragini, I have your slide on top. Okay, sorry.
Anybody from Neurotech there?
Just a second. Okay. New slide show. All right. Okay. Have we got it now?
No, sir. It's not coming. Mr. Shahid? Yes, sir.
आ गया?
आ गया, sir. We need to go to slideshow. Sir, it's not coming, but just go to slideshow.
Manjula Didi, good afternoon.
Okay.
Yes, sir.
Yeah, multiple slides are there.
So now, yes, sir.
Okay.
Yes, sir. Sir, can you? Yes, sir. You have to just choose the first slide and then go to slideshow.
First slide is on.
So we can see the slide sorter view. We can see all the slides in the slide sorter. So you can click on the first slide and then go to the slideshow, sir.
Yes. Upper left, sir. Extreme left.
Upper left. Upper left.
The first slide, sir. Yes.
All right.
Yes, sir. Yes, sir. Yes, sir.
Thank you. Sorry for the trouble. I'm going to talk to you on something a little interesting, something I've been working for a number of years, which is multifocal dual IOL in children below the age of 18 months. Normally, people are hesitant even to think of doing implants in this. I only hope that after you hear me today, you will take it up as a regular routine. It's challenging surgery doing pediatric cataract surgery. But you have to consider most important that the critical period of visual maturation is complete in 3 to 4 months' time. Up to the age of 8 months, the visual apparatus goes on developing, and the ability to see near and distance is important for the child to develop. The problems of stimulation, deprivation, and myopia are very real. Children have shown improved stereopsis provided you do it at an early age. A number of references confirm that the stereopsis develops when the procedure is done at an early age. So waiting till the age of 5 and 6 and 7 doesn't really work. You need to do your implants at an early stage. Multiple proofs have shown it. Next important thing is you need to do, if it is all possible, you need to do a femoral laser surgery, not for any other reason, but you get a perfectly sized rhexis. And I would turn around and say that these lenses, implanting lenses in a multifocal in a child is extremely beneficial to the child. Physical ocular characteristics are important because in the first year, I wanted to notice the sag, the IOL power and the sag length that is here and here. You notice that the age at 6 months, the power is 31, while in 1 year it drops down to 21. Now the question is, if you implant the child at the age of 6 months, what are you going to have at 2 years? You're going to have 8 diopters, 10 diopters. Now we need to do the calculation. Below the age of 2 years, we do biometry undercorrect by 20%, and we use the Hofferty formula, which seems to give us excellent results. The American Academy has also worked out the same system, and as you will notice right on top, at below 2 months of age is almost 9 diopters. At the end of 1.5 years, it works out to be almost 6. So there's a gross variance. So how do you manage these patients? And this is the reason why people have not been doing this children. You have options. The option is to place the full power IOL in a baby and replace it with the lower part at the age of 18 months, which means 2 surgeries. Or you replace it with the partially powered IOL, calculating at 2 years. The third option is to piggyback. But piggybacking a normal lens leads to problems because you tend to have difficulties with what we call as a red rock syndrome. So though it is the easiest way to do it, it's easy to calculate, the big problems are, and this is the references confirming that it can be done. Wilson is one of the pioneers in this use of piggyback in children. The problem is this interface debris. If we can get rid of this problem, then life becomes much more comfortable. So the answer is very simple. You use a permanent lens, which you would calculate at the age of say 15 or 18, this will be the lens. And use a removable IOL. To be a removable IOL, you need to have a pure HEMA material. Why? Because HEMA induces no adhesions and can be removed easily. Also, HEMA can be cryo-extracted. You make the HEMA lens in the shape of an inverted dome so it can be bagged easily. I'll show you the details a little later on. This is the material we've been working on. It's a Vogue material. It's a German material. And the lens is made for us. It has a very high saline uptake. Important thing is to notice the ash content is very low, indicating a high purity material. And it is made for us by the care group. It's a 9.5 millimeters in diameter, 5 millimeter optics, with the optic on the external convex side with a base curve of 6.8. There's a bevel on the external aspects. Can be easily folded and inserted via a standard incision, no problems. So the criteria for selection is under anesthesia, we measure the corneal curvature, extrapolate to puberty, place the anticipated IOL power, either as a Rayner multifocal lens is what we are using, or utilize an Acrisoft lens. And the ideal surgery, of course, is to aim for a -1. We expect an average of 6 to 7 diopter myopic shift from surgery done at 3 to 5 months. So you have to do the calculations accurately. And then when the anticipated IOL refraction is reached, you remove the IOL. To give an example, if a baby placed IOL at 3 months, 31 diopters, 23 diopters as a Rayner multifocal, and 6 diopters as a HEMA lens, which after correcting 20% will reach -4 at the age of 24 months. So we use a rule of 4 as a variation of 4 diopters from emetropia, rarely induces significant embolization. Our technique, we use general anesthesia with intratracheal intubation. This is a positive pressure intubation system. The tube doesn't go down the throat, it just stays in the mouth. It's a high viscoelastic in the anterior chamber. Ideal is viscoed. I prefer to use a catalyst phaco system because it gives me the perfect rhexis in children. Let me show you the procedure. You'll understand how it works. It is freezing, but I'll run it by hand. That'll be easier. Now, what we basically do is you put him under the catalyst, and then we loop him at the side, and we inject a bit of solution. And under the catalyst, you can manage to do it comfortably. This is the child being done under the catalyst, moving down the line as you see here. And you can notice the small little lens, which is typical of children, and running down again down the line. Ultimately, you take the child under the operating microscope. Under the operating microscope, you simply have to aspirate it. Phaco power is not really required. One of the advantages of doing it by a catalyst is simply that you get a perfect rhexis. You lose a rhexis in a child, and that's the end of the procedure. You can't do anything after that. So all we need to do is to suck it out. Here we use negative pressure sucking. That means fluid goes in on one side. There is no suction applied. It is just left open. The fluid comes out by itself. Once it is done, then we implant in the lens. Now, how do we insert a double lens? That is what I want to show you today. You insert first. This first is the restore, which is the Acrysoft lens you put in. Regular, normal technique, nothing extraordinary, no great shows about it. Lens goes in comfortably and sits in. Remember that the eye is small. The only two lenses we have found which fit, one is the restore and one is the Rayner multifocal lens. Both fit perfectly. So once your lens goes in and is then centered inside the eye, then the second lens is inserted. In the second lens, what we need to now do is again very simple. We put this one back into proper position, and then you take your second lens. Second lens, you put it into the injector, and you inject it into the eye. As you notice, it just folds and comes out. Now here it is not placed under the bag, it's placed on top of the bag. And as you see, the lens opens out comfortably. Once it opens out completely, you place it so that the edges of the lens go, so it lies anterior to the anterior rhexis. This is not put inside the bag. The second lens is then centered into place. It's just looped in. There's absolutely no reaction whatsoever. And using this particular HEMA lens, you don't get the red rock syndrome at all, which is great. Subsequent removal is simple. You can go in with a capsule forceps, just hold on the surface of the lens and remove it, and it comes out. So it's a great method and it works great. Let me show you some statistics. These are the unilateral 47 cases which we have done over a period of time in basically below the age of 18 years. As you notice, the implantation starts from 2 months to 15 months, which is what we have done and followed them up. We have now been almost, I would say, about 9.5 years down. We're waiting for 10 years before we publish this thing. And these are the age at which we explanted. When you find that the number comes to the appropriate power, you can get rid of it. Now, residual emetropia. Now, this is the only thing I'm not very proud about, is that it shows that my calculations still need to be improved over a period of time. When we started doing these implants, my calculations were a little rough. Now they've become a little more accurate, so I'm getting less residual powers left over. Complications in these cases, really nothing. Low-grade iritis, a little shallow anterior chamber, a little hyphema once in a while, but really nothing to bother about. So at the last 4 months, 4 years later, the power decreases and the best corrected visual acuity improves significantly. In a number of cases, you can follow up. And the big problem, of course, is just that in all these sort of cases, patients are skeptical about surgery. The worst is, I tell them everything and then they go to my friend across the street who says, hi, you're putting implants in a child and that also a baby, something very wrong, and they run away. So the problem is too many opinions waste precious time, and the patient's concept about surgery is no idea. And the partial and unilateral cataracts are not detected for a long time. So very often you tend to get these a little later when amblyopia tends to supervene. Thus, in summary, I'd like to state multifocality in infants is not an option, it's a necessity. The concept of multiple IOL with phased removal is a concept which is feasible, giving the best hope for controlling deprivation amblyopia in infants. At a later stage, even if a little number is left over, you can always manage to control it. But once amblyopia supervenes, then life is no longer interesting. So I would consider that everyone should now consider doing these implants as a regular routine. Thank you for listening to me.
Thank you very much, KK sir, for a very absolutely thrilling and thought-provoking. Just one question for you. What is the contraindication, rather which patient you don't want to subject to this procedure?
Where there's any problems with the pupil, adhesions are there, pupil is irregular, in cases in which you do not have perfect glow and which the retina is not perfect, we don't do it. Why? Not that it can't be done, but the patient will be unhappy with the results and then will blame me that you did a new novel procedure and my child doesn't see.
Yes. Thank you, sir.
Thank you.
I would like to invite our next speaker, a young dynamic fellow, Dr. Ashwin Agrawal, a Chief Clinical Officer of Agrawal Group of Institutes. And his topic, and he is speaking on the topic, a single piece IOL, refixing with the glued IOL with SFT. Over to you, Ashwin, sir.
Thank you so much.
Ashwin, congratulations for the beautiful, superb conference that you did yesterday and the great things that you keep doing. You are a dynamic superstar.
Thank you so much. And thank you so much for inviting me. First of all, I have to thank Dr. Ragini and Dr. Lahane and whole of BOA. Actually, they've been so supportive and so supportive to all ophthalmologists across India. I mean, it's been unreal. One of the best societies I've come across recently, at least. I'm going to share my screen. Hope you guys can see my screen.
Yes, Ashwin, it's visible.
Perfect. So my topic today is the same lens, refixing the same lens. I think one of the challenges that we face in these kind of situations is a subluxated single piece lens with the vision of 360 because it's dislocated, it's tilted. So there's an astigmatism component. There's so many other issues that could be, the bag is completely weak and probably unstable. In these scenarios, how do you actually look at it where you don't manipulate or you don't cause too much trauma to the eye and yet you get a really good result? Probably the lens is not that damaged, it's just dislocated or subluxated in its own way. So in these scenarios, what I started to do a long time back was refixing this with a glued intraocular lens, and for the same I'm making these partial thickness scleral flaps for the glued IOL. I've also placed my trocar AC maintainer. I'm not going in the posterior, so all anterior segment surgeons, watch out, this is really beneficial. AC maintainer is fixed, and the most important in these cases are to visualize. So first have a look at what is below the iris. Is the iris attached to any capsule? Is the lens, can you see the lens? If you can see the haptics, are the haptics not damaged or any of that sort? If you see this, I've made only 2 small paracentesis incisions and 2 small sclerotomies under the flap. And now I'm using a bimanual technique to kind of reach the tip of the haptic. Once I see the tip, I go through my sclerotomy and I have now externalized that haptic on one side. Once I've done that, I don't know the visibility of the second side. So I don't know where that second haptic is. And by pulling or yanking on it, it will not help me. Instead, it might break that intraocular lens, since we all know that these lenses, these rigid lenses, are very brittle in its own way. So what I'm doing now is to remove all the bag component and have a better visualization of whatever I'm doing. This whole surgery is based completely on visualization, and that's something that I think is a takeaway. And watch this here. This is a desmaze that's coming out. So I have another issue that's provoking me. So now I have to go below that desmaze. The whole desmaze in this case was coming off for some reason, and probably it was due already before. But here is the tricky situation. I have to go under the desmaze, which is tilting off, but predominantly I'm also doing a bimanual technique to kind of see the haptic tip of the other end while not breaking this this intraocular lens. Once both the haptics are out, I'm pretty well surfaced in terms of removing all my iris hooks, which are helping me in my visualization. And now I've placed my, now I'm going to place my, first I'm going to ensure that there is no vitreous or iris that is prolapsing in the old wound. I'm trying to remove any adhesion, place an air bubble so that Descemet's goes back and sits in place while I'm doing the rest of the procedures. That is basically tucking that haptic into a Gabor-Chariot's tunnel. Now, once I've tucked that into Gabor-Chariot's tunnel, I replace the air bubble. But while replacing, or before that, I first see with the air bubble test, I noticed that the optic on the inferior side was popping out. So I'm doing a single pass fourth row. Mind you, all this is while there is already a Descemet detachment in this case. So I have to be very, very careful while doing any of these procedures. But at the end of the day, you will be faced with challenges like this in complex and complicated cases. And we must be very, very sure of ourselves in terms of what we're doing and how we manipulate tissue in these cases. I have managed to do a single pass fourth row. I've placed an air bubble in place and completely closed this case with some glue under the flaps and conjunctiva. This is day one post-op of the same patient, and I did see the patient about 15-20 days. This is a very, very recent case of mine in April, so we just saw the case recently, and it was doing exceptionally well, even though you had a Descemet's detachment. Going back now to another case, and I'll go very quickly on this one, is another case of complete capsular phimosis as well as dislocation anteriorly while one haptic was in the posterior segment. The same procedure follows. I do a flap. I first make my scleral flaps. I make my sclerotomies, and I've also placed a trocar AC maintainer. Using my sclerotomies, I am first going to do a anterior vitrectomy, and I've also made my 2 paracentesis incisions as I showed you in the case before. Once I've been able to do an anterior vitrectomy and remove all the vitreous that was there in the anterior chamber, as well as remove any bag remnants that are there. So this is very important. You must remove the bag remnants around the haptic, not around the optic in this cases so much so, but around the haptic. Removing the bag remnant is very important if you want to get a good grab. While doing that, you're also doing an anterior vitrectomy. So it's a combination of bag removal, with anterior vitrectomy, and any cortical removal. So those 3 combinations work in tandem, and one device that is a vitrectomy cutter works really well in these cases. Now what I'm doing is I have externalized one haptic, and since my assistant was a new one, I placed a kind of iris hook tire or a silicone sponge in this case to kind of make sure that that haptic does not go back inside or does not retrace inside. This is taught to us by George Baiko from Canada, and very, very good surgeon. And basically now, once both my haptics are externalized, I am not worried too much about that bag remnant right now. I will get worried after this. First, I want to tuck all my my haptics in place. Once I've seen that the haptics are tucked in place, I'm now removing all the bag remnants with a vitrectomy, and I can just pull away some of these remnants with forceps itself. It's more than enough. You really don't need to cut so much as to pull. Once that is done, recheck if any of the haptics are not in place, and ensure that the optic edge of that IOL does not come above. If it does come above, please go ahead and do a single pass fourth row in that, on that side, because that really prevents any optic capture or IOL tilt post-operatively. In interest of time, I'm not going to show this, and I'm going to move ahead. So this is 2 single pass fourth row pupilloplasties that I'm doing here to ensure that the optic of that lens stays behind the iris, which is where I intended it to stay. And now I'm placing some glue under the flaps and conjunctiva, and this is pretty much the end of the case for me. Happy, and this is the post-operative look and feel of the same patient. Thank you very much.
Thank you very much, Dr. Ashwin sir. Those were very impressive video
Absolutely.
surgeries as usual. Now we can move. May I now May I now call upon Dr. V.C. Mehta sir to deliver his talk on iris fixated IOL. He is very well known prolific surgeon of Maharashtra. He has vast experience of more than 30 years in the field of cataract and LASIK. Over to you, sir.
Thank you, Sirish. Am I audible?
Yes, sir. Good afternoon,
Oh,
sir.
good afternoon, Ragini. How are you? Thank you very much for inviting me for this
Thank you,
meet.
sir. Sorry for the
Yeah.
delay in the session, but thank you.
No, no,
So
that's okay.
I remember going to sir's clinic when he was operating my grandmother and I was doing my MS. And I remember watching his Rexes and being completely awed by it. And I still remember his surgery and learned from it. Thank you so much, sir.
Thank you, Ragini. Good old days. Okay, is this thing visible?
No, sir.
You are visible.
Sure. Oh, you don't want to see me. You want to see my videos, eh?
Both, sir.
Okay. Is it now visible?
No, sir.
Not yet?
Yes.
Now?
Yes, sir. Yes.
Okay. So we always have a situation where we lose the zonules and the capsule and everything, and we need to then put in an IOL. And you have seen multiple presentations of scleral fixated IOL. But today I'm going to give you one more kind of an alternative, which you can always try it out, and which I have been using it for quite a long time with a good kind of results. That's an iris fixated IOL. So we all know that we get into a situation where the zonules and the capsules and everything go away. And some of the examples from my practice, this is a case where the lens capsular bag complex all dislocated, and we got it out, and then we have to put in an iris claw lens. This is a second indication where the nucleus drop happened during the phacoemulsification. So our VR surgeon gets the nucleus material, and then we need to assess the scenario and try to put in a lens, whatever is possible. This is another scenario where the lens got dislocated into the vitreous. You have to remove the lens and then put in a lens where there are no support for the either of the capsule or the zonules. So, and on a bad day, if you in a case like this, you are doing a phaco and you lose zonules significantly, and the nucleus, the whole nucleus is almost sinking into the vitreous. We need to salvage it, prevent it from going back into the vitreous, and you bring it up into the anterior chamber, extend the incision, and bring the nucleus out. In all these scenarios, we need to then put in a lens of my choice, is that is the iris claw lens or iris fixated lens. Before we attempt to do that, we need to do a good vitrectomy. Now, this is very, very important, because any strands of vitreous left behind is going to create problem in future. So there you go, by manual vitrectomy, do an extremely good vitrectomy. At the end of it, see to it that no strands are remaining, especially in the side ports of the main incision. And if you constrict the pupil at the end of the vitrectomy, which also helps in scleral iris claw lens fixation, you will know that there are any strands of vitreous or no. Now we go into the fixation of the iris claw lens. Two side port incisions, main incision, viscoelastic. This is a case where the silicone oil has been removed. Capsular bag also is not there, and we are putting an iris claw IUL. So pick up an IUL, we always put in some amount of viscoelastic, push in the lens into the anterior chamber, position it exactly where you want it after the enclavation. So before the enclavation, position the lens nicely, hold the optics with forceps, and just pull up a knuckle of iris and put it through the iris claw. Now, holding the lens is very important, and putting your side port or the enclavation needle before you hold the lens is important, because you don't want to struggle after with the second instrument. If you have taken a corneal incision like this, you will have to close it and then wash out all the viscoelastic from in front and from behind, so that there is no chance of IOP rise in the early postoperative period. If you do not want a corneal sutures, you can always take in a corneoscleral tunnel, and it can be a sutureless cataract surgery. Retrofixation is another good way of putting this lens. So again, the same thing, put in a lens and align it where you want to, and here holding the lens with a good forceps is very, very important, and just closing one part of the wound so that the leakage is not much and the chamber is maintained. Once you do that, you hold the lens with a good forceps, tuck the haptic on one side, and with just a small dip, where you can actually see where the claw is or the edges are there, and there you just tuck it, the knuckle of iris into the claw, and it just stays there. It is so fast, it is so easy, and it is so quick. Important again is to see that you are not left with any vitreous strands. As you can see here, if you are left with a vitreous strand, it is better to put in a vitrector and remove or cut the vitreous band. Again, cleaning doing it with closing it with the suture is mandatory if you have taken a corneal incisions. Just to wind up, this is one more case of the posterior fixated iris claw IOL, and you can see how easy it is to enclave the iris into the IOL claw, and it doesn't take really a much long time. It's less messy and it's very easy for the surgeon. The learning curve is very, very small, although it may look very difficult whether enclavation is there done or no. But having done significant number of cases, it becomes very easy. Thank you for your kind attention, and I hope that some of you will pick up the iris claw in absence of the capsular support as a lens of choice for putting the IOL. Thank you.
Thank you very
Thank you,
much.
sir. Definitely, it can be a good choice to correct surgical aphakia. Thank you, sir. Now we can move on to the next topic. May I now call upon Dr. Matthew Kurian, sir, who's going to talk on incorporating toric IOLs in practice. He's very well known for high volume cataract and refractive surgery. He's a key researcher with many publications and presentation in various national and international conferences. So over to you, sir.
Thank you. So first of all, I would like to thank BOA and the MOS, Dr. Lahane and Ragini Madam for this invitation. I'd talk about incorporating toric IOLs into my practice. I have no financial interest to declare. So I really don't understand why we are having this discussion, for the simple reason that when we are doing spectacles, phakic lenses, surgeries, or contact lenses, we never consider correcting only the spherical error without incorporating the cylinder. So why then should, for cataract surgery, the spherical or aspheric lens be the standard of care? So suitable patients, like Dr. Ramurthy had discussed earlier today, are those with regular orthogonal astigmatism, and in my practice, the offer is given for individuals with more than 1.25 for regular spherical lenses, and for multifocals, it is 0.5 diopters. Measurement is the key, and accurate measurement is very important. Optical biometer of any model, any company is adequate, and this will be the primary measurement for both keratometry as well as the axis. Now, it is desirable to have additional measurements. Secondary instruments could be the old manual keratometer, or it could be a topographer. And if you have three, it is desirable to take the 2 out of 3 at least which coincide with each other. And this will ensure that there is a reasonable accuracy in in the outcomes that we have. Why do we need to do multiple measurements? Because not all machines are same, and so the results that we get from different machines will be slightly different. The typical old style manual keratometer measures the central 2.6 millimeters. The IOL Master 500 measures only one zone, and the 3-zone keratometry of the IOL Master 700 measures up to 11 millimeters also. When it comes to the lens star, 2 rings of 16 points are measured at 1.6 and 2.3 millimeters. And in the T-cone, the attachment to the lens star, we get the Placido, which is a central 6 millimeter topography is getting. Then if we use something like the Pentacam, central 9 millimeters at least, or the machine default 12 millimeters will be there. So because of this different areas that are being measured, the magnitude as well as the axis will vary. But what we need to do is ensure that at least 2 out of 3 are coinciding, and that will ensure that we pick up, avoid the individuals with irregular astigmatism. Other errors that creep into measurement is when the patient position is not correct. Here the head is tilted back a little bit. Here it is tilted sideways. And these can cause a difference in half a diopter in magnitude and between 5 to 60 degrees in axis of the measurement. Before we even consider a toric IOL implant for any individual, we must make sure that the ocular surface is perfect, there is no dry eye, and there is no other health issues on the corneal ocular surface. The skills that are involved with regard to toric IOL have been highlighted multiple times for many years, and I will touch that very briefly. The IOL marking and the surgical steps. Surgical steps, essentially, we want to have no complications during the surgery. The rexes should be overlapping the IOL once it is fully implanted, and there should be adequate dilatation till the end of surgery. So that has to be, the intraoperative manipulations have to be very delicate to maintain the pupil well-centered, well dilated. Preoperative marking, my preferred method is to use the slit lamp and measure the reference mark 0 to 180 degrees. And this is with the individual seated. Preferred technique is the slit lamp. The intraoperative marking, multiple more expensive methods are available, but a simple marking on a dry ocular surface. This is very critical. Dry ocular surface, you will get a very thin and narrow mark instead of getting a thick smudged area. The target astigmatism, there is a mean with the rule to against the rule drift of about 0.3 diopters per decade. So a small with the rule astigmatism is desired as the residual astigmatism. So in pre-existing astigmatism, which is with the rule, I avoid flipping and attempt to retain a with the rule astigmatism. Where there is a pre-existing astigmatism is against the rule, I do not mind flipping and getting a with the rule post-operative astigmatism. I feel that the greatest challenge for most individual is all this mathematics that goes into toric IOLs and the graphical representation of these vectors. So I'll just take a few slides to simplify it. Okay. It is actually something that we are doing regularly when we are doing spectacle prescriptions. 0 to 180 on the spectacle prescription, the other degrees on top, and obviously inferiorly are the continuation of 180 to 360. In order to avoid this doubling of the numbers, the double angle plot is used. Here, the superior area is with the rule and nasal and temporal becomes against the rule. So when we double the angle, the 0, 180, everything is doubled, and the against the rule all comes towards the right hand side of the plot, with the rule comes to the left hand side of the plot. So that takes care of the axis portion of the representation of the vector. But what about the power? So if we consider that this particular circle is, let us say, 1 diopter, A concentric circle inside, which is half the size, would be 0.5 diopter, and a larger circle on the outside would be correspondingly 1.5 diopters. So this takes care of the power also. So the clinical application is that at the end of surgery, we see this nice clusters over here in the center. That is fantastic. That's what we want to do. We need to congratulate ourselves if we achieve this one. A small cluster at maybe 0.5 diopters with the rule is also very well accepted and will result in very happy patients. Against the rule, cluster is good, but it is not the most desirable of the outcomes. However, if our post-operative outcomes are individuals which are scattered like this all over the place, it means that our measurement, surgical technique, and choice of lens needs to be reconsidered. Everything in the process needs to be reconsidered. So here is a set of my patients where the preoperative corneal astigmatism is widely scattered. The mean is about 0.7, with mean absolute cylinder power is 2 diopters, and it is scattered all over the place. And post-operative, after toric IOL implantations, the post-operative refractive astigmatism, the centroid is at 0.1, the mean absolute is 0.18. So less than a quarter diopter is what we are able to achieve. And this is in 48 eyes where we have implanted a Technis toric lens. So the outcomes can be extremely satisfying in these individuals. Posterior corneal astigmatism is something that is again causing some amount of confusion for a few individuals, but it is also very simple. There is in individuals with the rule astigmatism, the posterior corneal astigmatism typically reduces the magnitude of the anterior astigmatism, whereas in against the rule, it typically increases. So when we put the data into the formula, the majority we find that there will be a small alteration in the IOL power selected. So with the rule astigmatism eyes, the toric lens model is typically less by 1 step in about half the eyes and less by 2 steps in about another quarter of the eyes. So almost 75% of eyes are affected in pre-existing with the rule astigmatism patients where PCA is considered. In toric lenses, where there is a pre-existing against the rule, there is a 1 step increase in the power to try and flip the axis from against the rule to with the rule. So there is a greater diopteric model that is selected in these eyes. So all this can be a barrier to uptake of toric lenses for most individuals. Lot of differences in calculators are there. But I think as Dr. Ramamurthy mentioned earlier today, the Barrett toric lens is the one, toric calculators is the one-stop solution which will eliminate all these confusions. So once we enter the data into the Barrett toric, it will give the layout of where the lens should be, what your astigmatism is, depending on where your incision and the size of the incision. It will give you the sphere and cylinder model and the expected target refraction with that lens implanted in place. And in the rare occasion that we do have some amount of residual astigmatism, the Barrett outcome analysis formula also helps us to take a decision on where to and how to rotate it. So we don't really require very expensive equipment like the Verion or the Aura and things like that to create a satisfied patient. And from a practice perspective, it's a fantastic growth opportunity for all of us. Thank you for your patience.
Thank you, Dr. Matthew Kurian, sir. Thank you so much for being with us today. Thank you so much.
Thank you, madam.
Thank you, sir. Thank you so much, sir, for being with us here today. Thank you, sir.
So our last speaker is Dr. Jivan Lani, sir. We'll be speaking on vertical glued IOL.
Last but not the least, he is my senior from Mumbai. He's a pure Mumbaiite now, Pune ka, but I will always say that he is Mumbai ka hi. And he has been the scientific chairman, the president of MOS, and a great brother and family to me. Thank you, Ladi sir, and sorry for the delay. Once again, apologies.
And he has used most of the laser machines in India.
Yeah, ma'am. Thanks a lot. Thank you.
Yes,
Thank you. I would like to thank at the beginning Bombay Ophthalmic Association office bearers, Dr. Tipilahane, Dr. Ragini, Dr. Parishit, Dr. Shirish Sudat, and all the dignitaries. So this is vertical glued IOL under topical and subclinical anesthesia and can be done through small people also. The horizontal fixation of scleral fixation or glued IOL was classically described by the Agarwals in 2010. And we did our first case in 2010, November. It was published in IGO in 2013. The advantages over the horizontal fixations are vertical white to white is less than horizontal. So you get more haptic length available for tucking. IOL is more stable, which is very vital in myopic patients. Scleral flaps are covered and flattened by the eyelids. That's why there is a less tail film instability. There is no foreign body sensation. There is less congestion. Induced astigmatism due to the vertical incision is avoided as we are going horizontally. Against astigmatism is very common in cataract reduced. Temporal approach is more common in cataract surgery, so same wound can be opened again. In under topical septenal variable also, it is very good for pterigem patients or squint surgery where they have a scar horizontally, and there is no need of eye patch for this surgery. Can you see the video, Dr. Shirish?
Yes, sir.
Okay, this is the intracapsular aphakia. Anesthesia is 0.05 proparacaine and subtenal 1% preservative free lignocaine. So this is a cortisone of conjunctiva superior nasally. We take a nick onto the conjunctiva and tenons, and we inject 1% preservative free lignocaine. Axis marking is done at 12 and 6 o'clock. So I'm sitting temporarily now. And conjunctiva is cut with a scleral flaps of 2.5 by 2.5 millimeter at 12 o'clock and at 6 o'clock. At 12 o'clock, which is scarred, so let's in this area because the tissues are scarred. Keep your crescent blade as horizontal as possible, so it will not going to be perforating the sclera to expose the uveal tissue. The same thing is done at 6 o'clock. Now that's a virgin area, so the dissection is better than a superior area. Don't use too much of a cautery. Just enough to cauterize the blood vessels. Take the dissection up to the 4 o'clock for the right eye, this is it. For left eye, you can put at 7 o'clock. Now you take a clear corneal temporal incision. Vitrectomy can be done from 6 o'clock or 12 o'clock, whichever is convenient. When you're passing the blade, go horizontally, vertically down first and then make it horizontal. So the base of the iris and the ciliary body is not damaged. In this case, we are doing vitrectomy from 6 o'clock port, which was easier. We prefer to put hydrophobic acrylic 3-piece lens because the optic-haptic junction is better and tighter. And then we exercise the haptics. When we are doing this, see to it that your forceps is opening inside properly. Hold one tip of the haptic, pull it up, take it out. And in all cases, we try to retain this by using a sponge which is used for iris retractors. The second haptic is taken. Now we create a track at the edge of the dissection. Haptics more concentric with the limbus. Remove the antechamber maintainer. Hydrate the wound. dry the flap areas, put a fibrin glue, seal the flaps with the conjunctiva and the flap both together. You can see that IL is well positioned and you can see full extraocular movement because this patient is done under topical and subtenon, and patient can go home without a patch. This is immediately post-op. You can see that there are extraocular movements are there, bit of a congestion. The patient can see immediately. Now this patient is having basically subluxated IL and the bag both into the anterior chamber. As you can see here, there is an IL and the bag is here, which I will show you during the surgery. Surgery, we came to know that this is Si30 silicon lens 3-piece. This is the IL. So in this patient, we have not taken any main wound. We have taken 2 side port incisions and the lens is flipped and fixed by using a glue. As you can see, we gave a subtenon, 1% lignocaine. We are going to flip the IL into the anterior chamber completely. So you can see the chamber. The challenge in this case that the pupil is not dilated. If you dilate the pupil, so the challenge is that you have to travel from here and pick up the haptic. So this is haptic is picked up now. As you can see, there is no main wound. Everything is manipulated through 2 side port incisions. So first haptic is taken out. This is the second haptic which is taken, which is fixed. The secured sponge is taken out.
Hello, Larissa. Larissa, we lost your connection. Larissa,
I think it was a very good. I was listening you, Jivan. So a very good presentation, and thank you. The first session, all these I think Nikhil and all others. This series.
Yes, sir. Yes. I really thank you all the speaker from my bottom of heart.
Yes, sir.
And,
Rakshit, thank you. Amay, thank you. Pakare Sahib, can thank you. Matthew sir is there.
They are joining and they thank you for waiting. Thank
Yes,
you,
yes,
Dr.
thank-
Siddharth,
Sri
Dr.
Ganesh,
Sirish,
Sri Ganesh,
Dr.
thank you,
KK
Sri
Mehta, sir.
Ganesh. Thank you very
Thank you,
much.
Sri Ganesh.
Thank you, sir. Thank you. Thank you very much.
Thank you. Thank you. Chandrasekhar, thank you. Siddharth, thank you. Matthew sir, thank you very much.
Thank you, sir.
Thank you, sir. Nipur Bhatt is there. Thank you. Sandeep, thank you. Thank you very much. It was a very good session. I was listening, but on that side and this side, but I heard few of them speaking. Thank you very much.
Thank you.
Thank you, sir.
You can continue your discussion, no problem.
Good afternoon, Bhatti sir.
Good afternoon.
Hello, can you hear me?
Yes, we can hear you.
Yeah. Dr. Bhatti sir, with your permission, shall we start the session?
Yes, I think we should. We're already 5 minutes.
Okay. Okay. First, I would like to welcome all the panelists, speakers, and delegates for the BOA MOS Summer Focus Symposium. This is the post-lunch session, that is the FACO 6 at PEYMAN Hall. Now, coming to our panelists, I would like to introduce first our chairman for the session, Dr. S.S. Bhatti sir from Mumbai. past president of BOA with a vast experience of practice and teaching. The co-chairman, Dr. Chandrasekhar Vavikar sir, director of Vavikar sir Institute, Thane. Convener, Dr. K.D. Pathare sir, senior ophthalmologist of Bid. Co-convener, Dr. Praveen Patil, VR surgeon practicing at Sri Venkatesh Eye Institute, Latur. And moderator, myself, Dr. Rakshit Galia. Welcome all.
Thank you, Rakshit. You have been working very hard in this BOA program. And it's really something. You have been such a lovely running partner. And Swapnesh for roping you in. Good afternoon, Bhatti sir. Good afternoon, Vavi. Bhatti sir is still my teacher in JJ today. Vavi was the first one to hold my hand and teach me cataract surgery. Good afternoon, everybody. Good afternoon.
Good afternoon.
Sakhare sir, his family
good
from
afternoon,
Bid,
madam.
Praveen. Thank you, everybody. Thank you so much.
I would request all the speakers to kindly stick to the allotted time of 8 minutes. Now over to you, Dr. Praveen.
Our first speaker today is Dr. Rakshit Galia. He is director at Krisha Eye Hospital, Nalasopara, Palghar. His talk is on CME after cataract surgery. So I think you can start, Rakshit. Please share your screen.
You can see my screen? Yes. At the outset, I would like to thank Dr. Lahane sir, Dr. Ragini madam, Dr. Preetham sir, Dr. Swapnesh, the entire team of BOA and MOS for giving me this opportunity. My talk for today is cystoid macular edema after cataract surgery. Cystoid macular edema is the most important post-operative complication of cataract surgery, first described by Irwin in 1953. Compromises the result of a cataract surgery, can occur even after uneventful cataract surgery, but the incidence rapidly increases after complicated cataract surgery. Now coming to the incidence, the overall incidence in Indian patients coming to the clinical CME is of 2% and the angiographic CME is 20%. Incidence with diabetes, it is seen in 47% of eyes without pre-existing DR and 55% in eyes with pre-existing DR. Now coming to the pathophysiology, any surgical irritations causes the disruption of the normal blood retinal barrier, leakage from the perifoveal retinal capillaries, accumulation of fluid in intracellular spaces of retina, and subsequent development of CME. Basically, inflammation due to surgical manipulation is the major cause of CME. Now, as you can see in this picture, there is accumulate of transudate in the outer plexiform layer and the inner nuclear layer of the retina, which creates cystic spaces which join to form large pockets of fluid. Now, coming to the classification of CME, basically classified between angiographic CME and clinical CME. Angiographic CME defined as the presence of fluorescein leakage detected on FFA, and clinically there is decreased vision and diagnosed by biomicroscopic examination. Angiographic CME is more common than the clinical CME, and angiographic CME is mostly asymptomatic. Coming to the onset, there are basically 4 types. The acute onset, which appears within 4 months of surgery. Late onset occurs after more than 4 months post-operatively. Chronic CME, which lasts for more than 6 months, and the recurrent type. Now coming to the clinical presentation, symptoms in the form of a decrease in visual acuity, loss of contrast sensitivity and color vision, metamorphopsia, and signs which is clinically significant foveal edema with retinal thickening more than 300 microns, subclinical foveal edema with less than 300 microns, and vitritis and optic nerve head swelling. Signs and symptoms of clinically significant CME develop within 4 to 12 weeks after surgery and peak approximately 4 to 6 weeks after surgery. Now, identifying the risk factors for CME is crucial for prevention and adequate treatment. The risk factors are divided basically into the systemic diseases, pre-existing ocular conditions, intraoperative complications. Now, the risk factors of diabetes, which promotes the development of CME even in the absence of diabetic retinopathy. There is increased risk of post-surgical complication associated with poor visual outcomes. Systemic hypertension increases the incidence of CME. Furthermore, it is a risk factor for retinal vein occlusion, which itself promotes development of CME. Risk factors in the form of retinal vein occlusions, vitreoretinal interface changes such as the ERM, glaucoma, uveitis, intraoperative complications in the sum of a PCR, vitreous loss, trauma to the iris, intraocular lens dislocation, incarcinated vitreous in the incisions, etc. Now coming to the diagnosis of CME, clinically there is retinal thickening and loss of the foveal depression. These findings are best observed using a fundus contact lens and a red-free light. In severe or chronic cases, optic disc swelling with or without a lamellar hole may be seen. Splinter images may also be seen. Now, imaging techniques, there are various imaging techniques which can be used in the form of a color fundus photograph, fluorescein angiography, the OCT, functional testing, autofluorescence, and retinal thickness analyzer. Amongst these, the OCT is widely used in detecting CME. Now, in this photograph, as you can see in the color photograph, there is an intraretinal cyst seen in the honeycomb pattern. In the fundus fluorescein angiography, the early phase shows capillary dilatation and early leakage. And in the late phase, there is the classic petaloid pattern or the expansile dot appearance. Now coming to the OCT, it allows high resolution cross-sectional imaging of the macula, can be used to quantify macular thickening. It basically reveals foveal depression, retinal thickening, and cystic hyporeflective areas within the macula. As you can see in this image, there is a retinal thickening which shows in the form of color-coded high colors in the form of yellow, red, and white. And in the below picture, the cross-sectional area shows hyporeflective areas. Now coming to the management of CME, prophylaxis is the most important step in the prevention. It should be a traumatic surgery, medical therapy, and surgical therapy. Now prophylactic treatment is a useful and important approach in the prevention of CME. Topical steroids and NSAIDs are the main line of treatment in the prevention of post-operative CME. Prophylaxis must be considered especially for patients with high risk factors including diabetes, uveitis, venous retinal occlusions, intraoperative complications, extracapsular cataract extraction, or cases where phacoemulsification was not successful, or patients who take drugs for glaucoma. Now, majority of the post-operative CME resolves spontaneously with vision returning to normal. In cases where there is no spontaneous resolution, topical NSAIDs are the first line of treatment. Topical administration is thought to have better ocular penetration than systemic routes, and side effects are less. Topical or systemic NSAID inhibits cyclogenase enzymes that decrease the production of prostaglandins. Pharmacolytic vitrolysis agent in the form of chondroitinase, dispase, etc. induce a posterior vitreous detachment to relieve CME from vitromacular action. Now coming to the corticosteroids, topical corticosteroids are the main line of treatment for post-operative CME. Periocular corticosteroids have been shown to be effective for pseudophakic CME refractive to topical treatment. Intravitreal steroids in the form of triamcinolone is also used, but one of the major limitations of intravitreal steroids is the transient effect that requires repeated injections. Sustained drug delivery systems have been developed to address this limitation of repeated use of intravitreal steroids. Ozudex is an injectable biodegradable intravitreal DDS that provides sustained release of preservative-free dexamethasone, a potent steroid. Now, the oral carbonic anhydrase have been considered in refractive pseudophakic CME. They are thought to improve the pumping action of the retinal pigment epithelium to decrease intraretinal fluid. They alter the polarity of the ionic transport system in the RPE, moving fluid away from the intracellular spaces. Anti-VEGF agents acts by decreasing vascular permeability from disrupted endothelial cells. Marked reduction in retinal thickness and fluid accumulation has been noted in various studies with a significant improvement in visual acuity with minimum side effects. Now coming to the surgical management, ND-YAG laser can release vitreous incarceration in cataract incision wounds that complicate pseudophakic CME. Pars plana vitrectomy can help to relieve macular edema due to tractional or non-tractional components, especially when refractive to medical therapy. Tractional components are addressed by releasing the posterior hyaloid in VMT or conducting an internal limiting membrane peel of an ERM. Pars plana vitrectomy for non-tractional components are basically having inconclusive data on improvement in visual acuity in CME. Hence, to summarize, despite new cataract surgery techniques, management of CME still remains a therapeutic challenge. Inhibiting the inflammatory cascade is a core strategy for CME risk reduction. Topical NSAIDs and corticosteroids are first line of modalities. Since CME can lead to permanent structural damage in the retina, risk reduction strategies may be more effective than treatment. Thank you.
Thank you, Dr. Rakshit. That was a nice talk. Bhatti sir, shall we take the questions at the end or in between the talks? Bhatti sir, are you there?
I think we should take questions in the end, Dr. Patil.
Okay.
You know, we invariably land up exhausting the entire time. And
Yes, sure. So our next talk is by Dr. Vivek Kothawade sir. He's practicing at Gangapur Road, Nasik, and he's having experience of more than 25 years in this field. His talk is on interpretation of pentacam and oculizer. So, Kothawade sir, please share your screen.
Sir, your screen is visible. Make it full screen.
Yeah, am I audible?
Yes, you're audible, sir.
Yeah, thank you. At the outset, I would like to thank Dr. Dahane sir, Dr. Ragini ma'am, and Dr. Preetham for giving me this chance to talk. I'm going to talk on interpretation of oculizer or pentacam. Basically, it's a tomography or elevation-based system which gives you information of the anterior as well as the posterior surface of the cornea. And it's less accurate though in corneal haze and scars, but it is TFM independent. The limitations of topography or curvature-based system is that curvature is analogous to measuring a spectacle lens power, which though accurate tells you nothing about the shape of the lens, as multiple lenses or shapes can give you the same power, or the same lens can give you multiple powers. So curvatures do have limitations. If you tilt a Placido's disc or you tilt the eye, the effect is same as you get in a high-angle kappa, where the normal curvature may appear abnormal. So the need for elevation, where you use shine flow photography with two cameras, one centrally located and the other one which rotates 180 degrees. This is one of the shine flow images. And the settings which you follow the standard international scale to compare the maps of other machines and same patient repeat exams. This is the chord map that you get. You confirm the name of the patient, the date of birth of the patient, then you confirm the quality standards. If it is okay, then you go further to interpret it. You get the K1, K2, the K-mean, the astigmatism, the minimum radius of curvature, the radius of curvature at 9 millimeters periphery of the cornea, the Q value for the anterior as well as the posterior surface of cornea. Then these are the Pecki values that you get at different points, but you also need to know the different overlays used by the machine. The plus sign denotes the pupil center, the white circle, the apex of the cornea, the black circle, the thinnest point, and the white diamond is the K-max. So these are the overlays used. Then we come to the X and Y coordinates, which are shown here. The X coordinate of the pupil center is very important. It gives you a rough idea about angle kappa, which is not directly measured by the machine, but it gives the distance between the 2 points, that is the center of the pupil and the apex of the cornea, also known as chord mu. If it is greater than 400 microns, then you may need to shift your ablation profile, or you don't put a multifocal in that case. Then you come look at the Y coordinate of the thinnest location. If it is displaced more than 700 microns, then it is an indication for ectasia. Then you also get a corneal volume, and many studies have shown a reduction in the corneal volume in ectatic disorders. You get a chamber volume. If it is less than 100, then you suspect angle closure glaucoma. You get anterior chamber depth from the epithelium as well as from the endothelium. Then you get a keratometric power deviation supposed to be less than a diopter. If it is greater than 1.5, then it is abnormal. You get an angle measurement, then the pupil diameter, the mesopic pupil diameter, and the lens thickness if the pupil is dilated. Then we come to the tangential and the sagittal curvature maps. Most of the times we use the sagittal because tangential are too noisy to interpret. These are different patterns that you get on the curvature maps. If you have an inferior steepening of more than 1.5 or a skewed radial axis of greater than 21 degrees, then it's a red flag for ectasia. Coming to the elevation maps, how do we measure the elevation? What should be the reference surface and which reference surface is the best? If you want to measure the height of a mountain or a city, you consider mean sea level as the reference. So if suppose you measure the height of the city of Mumbai, Nasik, and Mount Everest from mean sea level in meters, this is what you get, and you can easily interpret that Mount Everest is the highest. But if the same three places are measured from the center of the earth in kilometers, then it is difficult for us to interpret which one is which vertical bar is taller, though there is nothing wrong in measuring from center of the earth. Similarly, you have different reference surfaces for cornea, the best fit sphere, the best fit ellipse, and toric ellipsoid. Smaller the reference surface, the steeper it is, larger the reference surface, the flatter it is. The same cornea looks different if the BFS changes. If we use larger BFS, more corneas will appear ectatic and it will be difficult to screen. Though changing a reference surface does not affect the accuracy, sensitivity, or specificity. So all reference surfaces are correct, but for easy understanding, 8 mm BFS is used for quick visual interpretation. So here with BFS, the cone stands out much more prominently than a toric ellipse. So this is a normal and a keratoconus map. In high astigmatism, you get elevation in the periphery of the cornea, but it's not a true ectasia. Like here, you get it in the center. These are the cutoffs which are used for anti-elevation map with a 8 mm BFS. Anything greater than 12 microns is supposed to be ectatic disease. These are the cutoffs for the posterior elevation. Then you get a pachymetry map where the gradual increase in the corneal thickness from center towards periphery in healthy eyes is used as a criteria to detect ectasia. So you get a corneal thickness spatial profile where you use 22 concentric circles 0.4 millimeters apart with thinnest point being the center of it. Basically, you get a graph with 3 dotted lines. The above and the below line signifies the 95% confidence intervals, and the patient data, which is in the red line, should fall within it. If it goes like this with a quick slope or a S shape, then you suspect ectatic disease. If the dip is before 6 millimeters, it is more significant. If the dip is after 6 millimeters, it is less important. You also get a pachymetric progression index. It has to be less than 1.2. Then you get a standard elevation map, an exclusion map, and a difference map. The standard elevation map uses a standard BFS. An exclusion map uses enhanced BFS. So why is the need for enhanced BFS? Let us look at this example. If the height of the cone increases, the height of the BFS also increases. But if you exclude the central 3 to 4 millimeters of the ectatic area, the height of the BFS reduces and it becomes more flatter, thereby increasing the distance between the highest point of the cone and highest point of the BFS. So it makes us easy, the enhanced BFS significantly increases the chance of detecting a subclinical ectatic disease. So this is a standard BFS, this is an enhanced BFS. The standard one not picking up anything, but with the enhanced BFS, you pick it much earlier. Then you get D values for the front surface, the back surface, the pachymetric progression, the thinnest point and the thinnest point displacement, and the overall bad D or the big D. If the big D is more than 1.6, it is shown in yellow. If it is more than 2.6, it is shown in red. You can make an age adjustment for the bad D. Then you get Ambrosio relational thickness, which is the thinnest packet divided by the progression index. It is normally it's more than 400. But a final clinical decision before refractive surgery is not should not depend on the individual red or yellow shown by the machine, but the complete history of the patient, the age, the refraction, the ablation depth, also the other eye. If you want to detect a post-LASIK ectasia, the anterior surface and the pachy, which are altered by the previous surgery, are not of any help, but use the posterior corneal elevation for it. Then we come to the Holaday report, which gives the curvature maps, the relative pachymetry, and here the elevation maps. But for the elevation, the best fit toric ellipsoid is the reference surface and not the best fit sphere. You also get the EKR values from 1 to 7 millimeters and the corneal histogram, which shows you the power distribution. Now, the EKR values given here in the upper panel, they are used for IOL power calculation. The EKR basically gives you the total corneal power considering the front as well as the back surface of the cornea. And use the EKR at 4.5 millimeters because majority of the population undergoing cataract surgery had a mesopic pupil size of 4.5 millimeter in whatever studies that Dr. Holaday did. But you may choose a different EKR according to the pupil size of your patient. Then you get a Q value according to which you can decide which aspheric IOL you want to implant. You also get a spherical abrasion, which becomes more positive with myopic ablation, and on the negative side with hyperopic ablation. Then you get a root mean square of high order abrasions. If it is greater than 0.66 microns, then you don't put a multifocal IOL. You also get a red eye ratio back is to front, which normally is 82.2%, but post myopic surgery, it goes to below 80%. Then you get estimated pre-refractive SIM K in the Holaday map, which is used for IOL calculation by double K method. Pre and post-op K help in sizing the eye beta and calculate the effective lens position. If you're implanting a toric IOL, you also look at the semi-meridian lines here, which are quite regular here, but in this map with keratoconus, they are just haywire. Then you get the EKR distribution map where the normal distribution is within 1 to 2 diopters, but a post-LASIK patient is distributed over 3 to 4 diopters, whereas post-RK patient is just all over the place, more than 10 diopters. So these are things that you see in the Holaday report, but you can also use oculizer for ICL surgery, for ECD confirmation and post-op measurement of the ICL vault. You can also use it in cataract, as you already seen this. You get the corneal densitometry also, the lens densitometry and the corneal densitometry also, which is higher in the periphery and lower in the center. And just yesterday evening, I saw this study where they use the corneal densitometry for monitoring the amiodarone therapy. So we have a gadget which gives us a lot of information at our disposal, and how to use it, it is up to us. Thank you so much.
Thank you, Dr. Kotawade sir, for the excellent talk. Please stop sharing your screen. I would now like to invite our next speaker, Dr. Siddharth Mehta, Director of Mehta Eye Clinic, Mumbai, for his talk on managing intraoperative floppy iris syndrome.
Yes, good afternoon, everyone. And I'd like to thank the organizers for inviting me and making me a part of this conference. I'm going to talk about how we can manage a case of IFIS. A small pupil is always a challenge for any cataract surgeon, and it requires excellent intraoperative decision making for a successful outcome. It becomes even more challenging if the iris is floppy, like in this one, and it starts prolapsing from the incision. You know that you are dealing with the IFIS. It is very important that you deal with it in a better manner, because it has a potential to derail the cataract surgery, especially when it comes as a surprise. Now, IFIS was first described by Dr. Chang and Dr. Campbell way back in 2005, and they found that there was association of IFIS with the drug tamsulosin, which is mainly used for the benign prostate hypertrophy. And what this drug mainly does was it caused the atrophy of the dilator muscles muscles of the iris, and that led to the poor dilatation of the pupil, and also intraoperatively a triad of events, that is the fluttering and billowing of the iris prolapse, and progressive meiosis. Now, if you look at the typical case of IFIS, now it usually starts like a routine case. Pupil is actually good enough to do the rexes, but during hydrodissection, this is what happens: the iris pops out, and this is always the first sign of iris and things to follow. You now have to use more of visco to push this back and maneuver it and to maintain the dilatation. But during phaco, there is a progressive meiosis, and you tend to lose the red reflex. Now, the red reflex is so important to give you that depth and also to give you that good visibility. So at every step, the things start becoming more and more difficult. The iris starts prolapsing, and now you have to use more of your instrumentation, and you tend to damage the iris, and this iris now becomes extremely floppy. Now, when with this floppy iris, you go ahead with the phaco, there is constant risk of catching that iris and causing more and more damage. And not just the iris, it is now possible to catch the posterior capsule and cause a rent, which is what happened in this case. And we had to do the vitrectomy and implant the IOL in the sulcus after stretching the pupil. So as a consequences of these, mainly the iris, there is a lot of trauma to the iris. The iris can easily bleed and can prolapse. And because of this meiosis, you can not really see the lens material, the capsule. So there's a lot of difficulty in removing the lens particle. And like you saw in the last case, there is always a risk of the posterior capsular rent. And another major problem is now you have to implant that IOL, and placing, and to ensure that placement of the IOL becomes very important. And more so when it's a toric IOL, that you need to align those marks along the desired axis, because these marks are right at the periphery. And if your pupil is less than 5 millimeters, it becomes extremely difficult. So managing of the IFIS, it's very important that you identify it well and identify it pre-operatively. You ask the patient of any treatment. You look at on the slit lamp about the dilatation and the pattern of the pupil. However, in spite of everything, it can easily come as a surprise. So safer way to go ahead during the surgery is to use the pupil expanders like the iris hooks. And the more popular ones now are the Malujan ring, the B-hex, or the Gupta ring. Now, secondly, you also have to rely on the surgical skills and the technique, because, use the low parameters phaco, low vacuum, low flow rate. This will minimize the turbulence in the eye. But But to be honest, today these pupil expanders are so easily available. They are in fact, you have cheaper option. They're easy to use, they're extremely effective. That yeah, it makes more sense to use them rather than being heroic and relying only on the surgical techniques if things are not going your way. So also, I cannot emphasize more on the use of the cohesive viscoelastics like the Hilon GV and the viscoadaptives like Hilon 5, where the role of the HPMC sometimes becomes very difficult. It may not serve the purpose. So this is one of the case I wanted to share. I suspected it could be a case of IFIS. So I started a little more cautiously. The first point here was I wanted to make sure that I have a long tunnel, longer incision. And I tried off with the use of intracameral adrenaline and the cohesive viscoelastic to increase the dilatation. The dilatation was good enough so that I could perform a desirable rhexis. So that made it very easy. But as I was going through, I easily realized that pupil is not staying the way it is, and there is some more meiosis. So before I did the hydro dissection, I wanted to make sure I'm a little careful and not do a very aggressive or excessive one. But even then, when I did the hydro and tapped the nucleus in the center, I could see that the pupil is coming down. So without having any more thoughts, I knew that this is going to give me trouble if I carry on. So I decided to use the pupil expanding device. That's the Malaysian ring. So here I'm putting the viscoelastic to create space between the lens and the iris. This Malaysian ring is very easy to use. It comes with the injector, and when you push it in, you try and make sure that the nasal scroll and at least one of the side scroll gets engaged with the iris, and then it becomes easier to engage the remaining two. The big advantage once you have that in place is the stability that you experience. Everything becomes much more easier. You feel more in control, and there's no fear of pupil coming down. So as you can see, I could very well manage this case with my routine parameters, and even because the visibility was so good that I could go in and take out all the cortex that was there, and finally I could implant the lens very well in it. Now when the time came to remove this Malaysian ring, it's important that you remove the visco underneath the lens. Once you are done with the visco, just add some amount of visco above the iris, so that, and you disengage just the subincisional scroll. You need not remove the remaining three, because once the same injector can be used, and once you engage that, the remaining three comes out very easily. But just be very gentle and be more in control. And as you can see, it came out very easily. Now there are other types of rings also. The other ring that I used was the Gupta ring, extremely effective, like the Malikan ring. The advantage here is you don't really have to use the injector. It goes through the same incision, and it actually gives a uh, wider dilatation of the pupil and a better view. The only thing is not as strong, or it doesn't have uh, the rigidity as the Malaysian ring, but it definitely does the purpose. And here you can see through the same incision, without any special instrument, you can remove the ring also. In my last case, this is what I wanted to show, is that everything looked very nice. The pupil had a good dilatation. I didn't suspect any IFIS in this case. So went ahead with the routine phaco. I could easily do the rhexis that I wanted, and pupil maintained. But as I was doing the hydro, there was something that I noticed, that the pupil was definitely coming down. I became a little more alert, and I knew the back of the mind, this could be the case of iris. As you can see the iris pattern also, that this pupil may not remain the way it is. I still did not use any pupil expanding devices like the Malagin ring, which I normally use. I went ahead, but here I relied more on my surgical parameters. I tried to bring down my parameters. In fact, I even took off my side instrument to prevent that extra leakage, so as to maintain that stability of the chamber. But I was progressively finding it difficult. I could manage and remove almost 3/4 of the nucleus without any problem. Uh, but the last piece, I was struggling with it, and I decided, even at this late stage, it is better again not to be heroic and do more damage. I decided to put a Malagin ring even when I just had the last piece. So the best part about the ring is that it can be used at any stage. So once you get a hang of it, these are extremely good devices, and they give and they help you to ensure a safer surgery. And this is what happened. So all in all, it's a good combination of a good viscoelastic and a low parameter phaco. And I cannot emphasize more the use of the pupil expanding devices in controlling and in managing the IFIS. IFIS has always been is always a surprise. So make sure you have one of these pupil expanding devices. All have their own advantages, disadvantages, but have it in your OT and ready, because you may need it anytime. Yes. Thank you so much.
Thank you, Dr. Siddharth Mehta, for the wonderful talk on IFIS. Nice practical tips to manage it. Please stop sharing your screen. Yes. Any questions from the panelists? We shall move forward for the next talk. Okay, we'll move forward. I would now like to invite our next speaker, Dr. Nupur Vijay Bhatt. She's a young ophthalmologist practicing as a cataract refractive surgeon at Ashish Eye Hospital, Mumbai. Her talk is on intracameral moxifloxacin prophylaxis, our practical way.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Lahane sir, Ragini madam, Swapnesh sir, Preetham sir, and the entire BOA-MOS committee for giving me this opportunity today. I hope my slides are visible.
Yes, they are visible. Continue, please.
Okay. So my topic today is intracameral moxifloxacin prophylaxis, our practical way. We have no financial interest in any of the products mentioned. So there is enough published evidence that has shown us a reduction in endophthalmitis with the use of intracameral moxifloxacin. Prominent studies from the Arvind Eye Hospital groups have shown a reduction of almost 3.5 folds in their rate of infection. So we're all aware that moxifloxacin, being a broad spectrum antibiotic giving us a wider range of coverage, its bactericidal efficacy is concentration dependent, and we can achieve high aqueous concentrations by injecting an intracameral injection. So the advised dose of 0.5 mg per 0.1 ml, the intracameral dose, is known to exceed the minimum inhibitory concentration of most susceptible bacteria. The commercially available preparation in our country is Oromox, which is routinely used by majority of us, wherein you use 0.1 cc of this solution, and which is directly injected in the eye in the anterior chamber at the end of the surgery. However, the dilemma that we faced in spite of using this advocated dose was that around 4 to 6 weeks after an uneventful cataract surgery, we had patients that we labeled as post-operative rednesses, say around 3 to 4 cases out of 100 operated in a week, would present with mild amount of redness and pain and signs which vary from mild to moderate anterior segment inflammation. However, they all resolved with intensive topical medication. After some brainstorming and ruling out all possible other etiologies of this, we realized that a mild infective etiology could be a cause of this inflammatory presentation. So we reevaluated our surgical protocols, and we realized that even after ensuring optimal sterilization of equipment, using fresh autoclave disposable cannulas so that we avoid using any cannulas, as cannulas can be a source of infection. To avoid minimal use of viscoelastic, we started injecting IOLs under fluid, and we spend an extra minute to thoroughly clean under the IOL. And conclude the surgery with intracameral antibiotics. So this got us to two aspects to consider. That were we adequately administering the advised dose, and how much of that was being retained in the anterior chamber at the end. So yes, we faced difficulty in drawing an exact 0.1 cc without an interfering air bubble. There was certainly some loss of this fluid at the incision site, some in the syringe. And so eventually we weren't sure of how much concentration of the antibiotic was actually being retained in the anterior chamber. And the second aspect being the capsular bag, as we all know, forms a sequestrum for a lot of indolent pathogens. These could be responsible for chronic late onset endophthalmitis. So we, as a solution to tackle both these problems, what we decided to do was we decided to make a diluted preparation of moxifloxacin. So we used Mahaflox self-preserved drops, which are available in a 5 ml bottle, where each ml contains 5 milligram of moxifloxacin. So we used 2 cc of this solution with 8 cc of BSS or Ringer's lactate in a 10 ml syringe to give us a diluted concentration of 1:5. So 1 ml of the solution was equivalent to 1 milligram of moxifloxacin. Now, our method of administration was such that we used around 1.5 to 2 cc of this solution, and which was at the end of the surgery injected under the IOL. Then the AC was reformed using this solution to ensure adequate pressurization, and eventually the ports were hydrated with the same solution to ensure a watertight closure. So our eventual aim was to replace majority of the AC volume with this diluted solution. So our practical experience was that we found it a lot more easier to replace the anterior chamber volume with a diluted antibiotic solution rather than trying to inject an accurate 0.1 cc. Aliquots of this solution could be injected under the IOL within the capsular bag, and diluting the antibiotic made it more physiological, so to reduce the potential toxicity to all the other intraocular structures. So in our clinical experience of around 15,000 eyes operated using this method, there was a significant reduction in our instances of post-operative infection without any adverse effects in a cost-effective manner. So the important pointers to take home is an appropriate preparation of the periocular skin and conjunctival sac with povidone iodine, ensuring appropriate sterilization of all surgical equipments, regular quality checks of irrigating fluids, viscoelastic devices, and an appropriate use of intracameral antibiotics are the key factors in preventing post-operative infections. We'd like to acknowledge Dr. Jagdeep Kakadia for introducing us to this technique. Thank you all for your patient listening and your time.
Thank you, Dr. Nupur, for the wonderful talk. Any questions from the panelists? Okay, we will move forward. Our next speaker is Dr. Karishma Wadia. She is the director of Jehan Eye Clinic, Mumbai, and she will be talking on counseling an unhappy multifocal IOL patient. Over to you, Dr. Karishma.
Good afternoon, everyone. Are my slides visible?
Yes, they are visible.
All right. So nowadays, even our patients walk into our clinics asking us for freedom from glasses after their cataract surgery. But very often we land up with an unhappy multifocal patient. Now, this is my beginning slide, but I'm going to be talking about a few case-based examples. The first thing that you do if you have an unhappy multifocal patient, whether it is your own or whether it is somebody who is unhappy with another person's surgery and then walks into your clinic for a second opinion, first thing you need to do is analyze your data. Make sure that you have done a thorough workup, or the previous or the operating surgeon has gone through a set of investigations, which I'm going to be talking about. Look for uncorrected astigmatism. There is a role of posterior corneal astigmatism also in this, which sometimes pops up after the surgery and may give you a refractive surprise. Something very important is check whether your IOL is in the bag. We often assume that our IOL has gone into the bag, but if you dilate such a patient and see, very often one haptic will be maybe in the sulcus, causing an IOL tilt, which gives rise to an unexplained astigmatism, which may be reducing your patient's visual acuity. Look for any dry eye. This can greatly compromise in the patient's satisfaction quotient. And last but not the least, if you have nothing else, tell the patient about neuroadaptation and tell him we have to wait for at least 3 to 6 months. That's the last armamentarium tool that you have in your armamentarium. So let's go on to some case-based examples where a 62-year-old male who is retired, likes to play chess, and has hazy vision since 6 months, and clinically he has immature senile cataracts. He underwent an uneventful right eye cataract surgery with a multifocal IOL, but is extremely unhappy with his vision and complains of significant glare and halos. Now, if we see his pre-op file, his vision before the surgery was a plus 3.5 with a plus 0.75 cylinder, correcting only to 618 and N18. Apart from the fact that he had a routine immature cataract, everything else was normal. Uneventful surgery with a well-centered multifocal IOL. So what exactly went wrong when his unaided vision is still 6.9 N8? So when we try to see what went wrong, you do, first of all, like I mentioned, a corneal topography. Now, in the corneal topography itself, you will get, apart from the fact whether there is regular or irregular astigmatism, it tells you your angle kappa. In a multifocal IOL, we would try to keep 5 degrees as our cutoff, because usually patients with this high angle kappa are going to be unhappy. This angle kappa is the angle between your pupillary axis and your visual axis. And what happens in a patient of multifocal IOL, if you have a large angle kappa, then the fovea-centric ray may hit one of the edges of the ring. That ray hitting the edge of the ring causes the light to split, causes the colored halos, and causes the discomfort in the patient's vision. So if you have a patient with high angle kappa, you need to have diagnosed this before your surgery and counseled your patient accordingly. Does this mean that if you have a high angle kappa, you're going to reject the patient for multifocal? Maybe not, but if you would have explained this to the patient pre-operatively, it would save you a lot of your anxiety post-operatively. Because the IOL tends to center on the IOL bag and not over the visual axis, so you can always have this happening. So if you have a large angle kappa, you need to watch out for this. So axis of the eye is very important if you are planning a multifocal IOL. A second case is a 71-year-old lady, again, both eyes immature cataract, underwent left eye cataract surgery with multifocal IOL. She's come to me for a second opinion. Her post-operative vision is 6/18 only, and she has a residual refraction of -1 with -1 at 90. So what exactly went wrong? If you see her K value, she's just on her paper documented K value says 44.4 and 45. So it doesn't seem too much significant. But when I did a corneal topography, we saw that she had a significantly irregular cornea. Okay, almost like an ectatic cornea with high irregularity in the 3 mm as well as 5 mm zone. Now, if the irregularity is high in the central zone, that's of paramount importance to us, because that's what's again going to affect our visual quality. You also need to look at the pupil diameter. This patient had a pupil diameter of 5 millimeters. So she's going to be all the more uncomfortable with all that scattering of light happening to her. Why? Because apart from her already existing corneal aberrations, the image to the right is showing her internal aberrations. Putting in a multifocal IOL is going to increase her internal aberrations. So in the end, you've landed up with a soup because you have only increased her overall aberration. So this is something that again you need to watch out for. Trying to emphasize on the importance of doing a corneal topography before your surgery. Again, is it mandatory? Is it compulsory? No, 90% of your cases, or maybe even 95% of your cases, you will get away without any problem. But it's that 5% patients which are going to come back to you and eat your brain and make your life miserable, which you want to prevent. So again, topography, is this important to me? I would suggest yes. If you are planning a multifocal or any premium IOL where you are charging so much to the patient, it is important to have done a good preoperative workup. So mainly you would want to look at your topography, your pupil size, and you can even do an OCT macula to ensure there's nothing subclinically in the macula going on. Case 3 is a very interesting case because this happens to be one of my own relatives. This is a 64-year-old male who underwent right eye multifocal surgery. It was a bifocal IOL with an addition of 4. And he enters and says, I can't read anything, and complain of a little irritation. He has got all his scans done. So you can see the preoperative topography, right eye and left eye, absolutely fine and bang on. But on clinical examination, he has MGD. All right. If you do an aberrometry, you see that the point spread function is a little distorted. So like I was telling you about the importance of dry eye evaluation as well in such patients, cataract surgery may worsen your dry eye. So to begin with, we give him just plain and simple dry eye treatment, lid hygiene, hot fomentation, a topical lid ointment, and mainly a good lubricating eye drop. You can even go for preservative-free eye drops. If you see On the left is before MGD treatment and on the right is after MGD treatment. Basically, the point spread function significantly reduces, meaning that the lubricants are going to make a good tear film quality, contributing to good visual outcome of such a patient, which is what has been achieved just by plain and simple MGD treatment. The optical quality of the patient significantly improves. Concluding that, associated dry eyes can compromise post-operative visual quality, which is why you need to give lubricants in the post-operative phase. I give it routinely for 3 months. But it's not over. The patient still says, I can't read. But when I see the file, the optometrist has examined and written near vision N6. But the patient says, I can't read. So then I take him back into the optometrist cabin and ask him, what are you talking about? Because we just checked it and you read everything. He says, yeah, I read everything because your person was holding it here, but I hold my newspaper here. Now that's very important, why you should be giving an adequate chair time to your patient before the surgery to find out what are his visual needs. So this particular patient was holding or likes to hold the object of interest at an arm's distance away, and he has been implanted with a bifocal IOL of an addition 4. So even though his vision is N6 at this distance, he's not happy about it because he does not want to hold that object at that particular distance. So it's important to know what your patient's needs are, what is he looking at, and accordingly maybe implant. Like for example, in this case, maybe implanting an IOL with a lower addition, say a 2.5 or a 2.75 would make him much more comfortable. So I think that counseling your multifocal patient begins before surgery. It's very important to give adequate chair time, have realistic expectations, explain to them that they might require glasses after surgery. It's always under promise and over deliver is what will make your patient happy. A thorough preoperative good optical biometry, OCT macula, dry eye evaluation, post-op lubricants for all patients in general, post-cataract surgery. And if you still have a surprise, this is a trick or rather a suggestion that Dr. Sandeep Nagvekar gave to me, that look at your post-op IOL position if you tend to make a larger rhexis. I was having a random result in just 3 or 4 patients out of my total set of patients, and he was kind enough to draw my attention to the fact that if you tend to have a larger than regular rhexis, the IOL gets pushed forward eventually and maybe touching the rhexis margin, or maybe pushed even beyond that, because of which again you get an unexplained refractive surprise and you are left wondering what went wrong. So when you dilate these patients, you often will get an answer to your question. And last but not the least, neuroadaptation does have a huge role. After a few months, the patients do adapt to their vision. So adequate chair time and good counseling will avoid all these disasters. Thank you very much.
Thank you, Dr. Karishma, for the excellent talk on multifocal IOLs. Many of us do face such patients, and nice practical tips to manage these patients. Now, moving forward, I would like to now invite our next speaker, Dr. Bhagashri Deshmukh, practicing at Deshmukh Eye Hospital in Amravati, and the talk is on phakic IOLs, getting the size right.
A very good afternoon to everyone. So coming to my talk.
We are not able to see your screen.
You don't? Just give me a second.
Yes. Yeah, now it is visible.
Okay. So is it okay now?
Yes, it's visible.
Okay. So coming to my topic, phakic IOLs, getting the size right. Phakic lenses is such a wonderful technology for high myo. And from a surgeon's perspective, there's absolutely no extra investment. Surgically, it's not a very demanding procedure. Once you know which hole on the lens goes where, any cataract surgeon can do it. And plus, it's reversible. So what seems to be the challenge then? One of the most important challenges in phakic lenses is that you select the right size of the lens for good outcome. And a good outcome for phakic lens essentially means a good walt. So what is the walt? It is the distance from posterior surface of the phakic lens to the anterior surface of the crystalline lens. An optimum walt should be 250 to 750 microns. In other words, For those who do not have OCT, it is compared with the thickness of cornea on slit lamp, and a good vault should be 1.5 thickness of the cornea. And with newer generation lenses with a hole in the center, the tolerance for vault has widened further from 200 to 1000 microns with regular post-op follow-up. And if you select a larger size lens, it will lead to a higher vault. As you can see in this picture, the iris is almost touching the endothelium, even though there are two PIs in place. And this can lead to endothelial cell damage, pigment dispersion, and angle closure. On the contrary, if you select a size smaller than optimum, it will give a low vault. And as you can see here, the lens is almost sitting on the posterior capsule. And this can lead to cataract. Furthermore, such lenses can rotate in the sulcus, which is a suboptimal outcome, especially in cases of toric lenses. So to achieve a good vault, pre-op workup is very important. And most important of all the pre-op parameters needed are the white to white and anterior chamber depth. Please note that it should be internal anterior chamber depth, that is from corneal endothelium to the anterior capsule of the crystalline lens, and it not to be confused with external anterior chamber depth, which extends from corneal epithelium to lens. So obviously it includes the corneal thickness as well. The cutoff value for anterior chamber depth for phakic lenses is 3 mm, but many experienced surgeons can dabble till 2.8 mm. Coming to the most important part, the white to white. Ideally, we should be measuring sulcus to sulcus because that's where the phakic lens goes. Only way to measure the sulcus to sulcus is wide angle UBM. However, it is operator dependent and has less predictability and repeatability. So we use two surrogate markers. The first one is white to white. It's an external marker, so easy to measure, and hence it's the most widely used one. The second popular marker is angle to angle, which is measured on anterior segment OCT. Recent studies have shown that it has higher reproducibility than white to white and correlates better with sulcus to sulcus than white to white. So how to measure white to white? It's a good idea to use multiple instruments and then correlate the readings rather than testing just one modality. The optical biometer always overestimates by around 500 micron and should not be relied upon independently. So personally, what I do is I take the reading given by Pentacam and input them in digital caliper and then fine-tune the reading under the microscope. It is very important to be consistent and stick to one fixed method and ask only one person to perform it for you. So having said this, I'll just take you through a couple of cases of sizing surprises. First case is of 23-year-old male. His refraction was around minus 13.5 diopter sphere with minus 3 cylinder at 45 degree in right eye and minus 10 diopter sphere with minus 1.5 cylinder at 125 in left. Her anterior chamber depth was around 3 mm. White to white on digital caliper was 11.4. And it is correlating well with the Pentacam reading. As expected, the lens star showed a slight overestimation. So everything looks in sync here, and we advise the patient to go for toric IPCL. And when we input data in IPCL calculator, it provides us with sheet of suggested lens implants. And this here is the IPCL sheet for this patient. It advises us to implant IPCL 125, which means it is 12.5 millimeter. So we chose 12.75 after discussion with product application specialist because it was a toric lens and taking a slight bigger lens makes its rotation in the posterior chamber during surgery a bit difficult. The great thing about this lens is that it has custom toricity inbuilt. So it does not need intraoperative rotation. We have to implant it 180 degree. And in addition, a larger lens fits snugly in the sulcus and gives us better post-operative rotational stability. So on post-op day 1, the vault was almost 1000 microns. IOP was okay. We waited for 1 week and repeated the vault, and it went down to 850. So don't believe in the wall sizing on the first post-op day. There are so many things going on in antechamber in the initial few days. So now on the 7th day, the vault is still a bit higher, but not in the dangerous zone. So for the second eye, we reordered one size smaller lens. IPCL comes in 13 sizes in steps of 0.25 from 11 to 14 millimeter, and usually one size lower lens decreases the vault by 100 to 150 microns. We implanted 12.5 mm and we hit the sweet spot with 725. The patient is doing excellent post-operatively, and he has even gained a couple of lines in vision. To the case 2, this is a 20-year-old lady with -8 and -5 diopter sphere in right and left eye respectively, and she had steep corneas, and these were her readings. We were pretty sure that this patient will do good with IPCLs, and we selected 12 mm model. And to our surprise, the first post-op day, the vault was merely 100 microns. And we have learned to never take decision based on first day vault. So on 7th day, the vault was 350 microns. And what had happened here is that we use pilocarpine in this patient, and during pilocarpine, the whole pilocarpine basically pushes the whole iris and lens down. It takes a few days for its effect to wear off. So patient gained excellent unaided vision after the surgery. And so to conclude, with time, the phakic lenses are getting better in predictability. And even if you stick to all pre-op protocols, vault-related surprises are not uncommon, can be dealt with. And last but not the least, the post-operative result of one eye helps to predict for the fellow eye, which is, I think, is very important. And I think this is my last slide. Thanks for patient listening.
Thank you, Dr. Bhagreshi, for your talk on phakic IOLs. Indeed, sizing does matter in these cases. Now moving to our next speaker. Ma'am, can you stop sharing, please?
Yeah, yes, I'm trying. A second.
Our next speaker is Dr. Amaya Kulkarni, practicing at Dr. Anil Kulkarni Eye Hospital, Miraj, as a phaco-refractive surgeon. His talk is on tips and tricks for posterior polar cataract. And there's a button of stop sharing. Press escape, madam, once. Yes.
Yes, I got it.
Dr. Amaya, please start sharing your screen.
My screen visible or my slide
Yes,
visible?
it is visible, and you're audible also.
Thank you. At the outset, I would like to thank Dr. T.P. Lane, Dr. Ragini Madam, Dr. Swapnesh Sawant, and of course our moderator, Dr. Rakshit, for giving me this opportunity. Today, I'm going to talk on posterior polar cataract, and specifically the problem that I had with these kind of surgeries that I have solved. And I would like to have the opinion of the esteemed panelists on how I do and what I do. So why posterior polar cataract is important? Because in the posterior polar cataract, there is strong adherence of the opacity to the weak posterior capsule. There's 26% likelihood of defective posterior capsule pre-operative. And there's a 40%, these are 40% more prone for intraoperative PC rent. Now, as they say that the surgery in a posterior polar cataract does not start when you take the patient to the OT. Actually, your surgery starts in your OPD itself. And counseling the patient before surgery in a posterior polar cataract, chair time, the doctor's chair time rather than an optometrist or your counselor is important, wherein you have to explain to the patient the possibility of a PCR, the possibility of a nucleus drop, need for a VR intervention, long operative time, and delayed visual recovery. Long operative time is essential because invariably the patient has heard stories about his relatives who got operated with you in 10 minutes or 5 minutes. You take a longer time, the patient becomes more apprehensive on table, thinking something is wrong. something is not going right in my surgery. And of course, delayed visual recovery, because if you end up operating for long, you'll have certain amount of corneal edema, which you need to explain to the patient beforehand. Now let's see why posterior polar cataract is so different. When you talk about good phacoemulsification, we talk about thorough hydrodissection, we talk about rotating the nucleus, we talk about chopping and lateral separation. What happens in a posterior polar cataract? You can't do the same things that you're supposed to do in a good phaco surgery. So what do? Let's see. When you start, a complete CCC is absolutely essential. Once you do the CCC, what I'm doing here is hydrodelineation. This hydrodelineation has to be done just paracentral, and do not force the fluid in, because you want the fluid to find its own cleavage plane around the central portion of the nucleus. Because once the central portion of the nucleus is out of the way, all you need to do is then go to the posterior plate. Now here is what I do differently. As Vajpayee et al. Had described, you really don't need to crack the nucleus in the bag itself, because those forces that you apply while cracking the nucleus can crack open your posterior capsule. So here I am partially flipping the nucleus. This is done with a manual blunt chopper. This is a long chopper. This is generally 1.5 mm chopper that I use. As you can see, it is partially flipped. Once this is partially flipped, you can then go on to divide the nucleus pretty safely, because whatever forces you're applying are not being transmitted to the bag and to the posterior capsule. And then you can safely do your phacoemulsification. You can see all my parameters are very, very low, and voila, it's done. The nucleus is out of the way. While taking out the cortex, it is absolutely essential that you go from outside in. Now, the difficulty here is because you've not done hydrodissection, you will have some problems while doing cortex removal. And you can see you're supposed to touch the central portion the last. Once you do that, once it comes out, this is how beautifully you can do. This technique becomes very predictable. Now we go on to the next case that I want to show you. This is because in the first case, the nucleus was very small. So it was much easier to do the partial flipping of the nucleus. There will be times when you will be faced with a much larger nucleus. You can see the nucleus in this particular case is much larger to the one that was in the first case. So here I am. Here I decide against flipping it, and you'll see it's a partial prolapse of the nucleus. It is just above the iris plane. The first case is better because the nucleus still remains in the iris plane. Here it is just above, one pole is just above the iris plane. And once you have this, you can then go ahead with your chopping. You can do your vertical chopping, you can do your horizontal chopping in this particular position without any fear of it being transmitted to the posterior capsule. Once the nucleus is free, you can do all the maneuvers that you do in a normal cataract surgery. Another point that I want to make is it is essential that we ensure there is the AC stability, because any sudden shallowing of the AC will give rise to PC tears, which has to be avoided at all costs. Another thing you will see here, I'm not at any point rotating the nucleus at all, because rotational movements of the nucleus will again give rise to intraoperative PC tears. This is the last piece. Again, it was taken out without rotation. Bring it to the center, and then you can chop it, emulsify it as beam fit. Once that is done, you can see how the posterior polar cataract is then exposed. Then you can do the irrigation and aspiration, and it's done. So in conclusion, what is important in posterior polar cataracts is you do hydrodelineation, remove the nucleus first without disruption of the posterior polar cataract, peel the cortical material from outside in, leaving central posterior polar component last, and gently remove the posterior polar cataract attachments to the posterior capsule. Thank you.
Nice, excellent talk, Dr. Amaya. I think so proper counseling and proper surgical technique modification is the key in such cases. Thank you for sharing your tips on PPC. We'll move now to the last speaker of this session. Speaker is Dr. Neha Dholakia Madam. She is an eminent ophthalmologist practicing at Dholakia Eye Clinic in Nana Chowk, Mumbai. She has an overall experience of more than 30 years in this field. She is going to speak on new ring-free extended depth of focus IOLs. Over to you, madam. Ma'am, your screen is seen, but you are not audible.
Yeah, am I audible now?
Yes, ma'am, you're audible now.
Okay, thank you.
Yeah, you're quite audible now.
Okay, so basically this is talking about cataract and presbyopia correction beyond the rings. I'm not able to go to my next slide. Okay. So I have been using multifocals since when they came out with Restore with +4 and +3 and +2.5 and Symphony and Panoptics and everything, because I'm a big 80% of my practice is multifocal or EDOF. And I was still in search for a lens which would, sort of make me happy. So something that would give me a bigger range of vision where I didn't have to exclude any patient. Halos and glare were my biggest scare or what I was wary of. Good contrast and faster neuroadaptation. So if we were to just take simple specs, and if you see a bifocal, what a specs looks like, you have two distinct points of foci, the distance and the near, that was equivalent to our old multifocals. Then came the trifocals, which is equivalent to specs you used to get like trifocal glasses before the progressives came out. And now you get progressive spectacles, and this is what the Mini-Well is like. It doesn't have any specific foci, but it has a continuous range of foci. So it is a pure EDOF. You get hybrid EDOFs, but they also have a diffractive platform. Therefore, if you just see this lens when I'm implanting it, the picture on the right is a lens where I had managed to break one of the haptics. It was my 30th case. I have done 75 implantations till now. In the 30th case, I got a little confident, so I didn't check in the cartridge. And if you see the after 1 week post-op also, despite me breaking a haptic, the lens is beautifully centered without any tilt and didn't give me any cylindrical number post-op. The cartridge of this, the loading is very, very simple. Also, when you see this lens, it looks like a monofocal lens. So when as a surgeon, you're implanting it, the confidence level is amazing. Every time I used to put a multifocal or an EDOF lens with rings, I used to think, will the patient see as well? Isn't this cutting off some amount of light? While when you implant this lens, it gives you the confidence of a monofocal lens. In fact, post-operatively, if your patient were to go to some other doctor and see on the slit lamp, you would find that they may mistaken it for a monofocal. The opening of the lens is really smooth as the material is 50% hydrophobic and 50% hydrophilic. So it's a very, very soft lens. The two haptic, the bunny ears, you have to just tap in and it's done. So it's a really, really beautiful lens. Here I'm implanting a toric lens. If we see at the end of any surgery, this is what any lens with ring looks like. And you can see the three Purkinje images, the first, the third, and the fourth, which is inverted. And at the end, we want to align the visual axis with the center of the lens. Here also, you are able to align the visual axis with the center of the lens because there are zones and you can still see three Purkinje images here. So aligning it is not a problem at all, but it is a very clean lens without any rings and no disturbance so-called. And this is the reason why it doesn't have any halos or glare. So we know all this old lifestyle, just reading glasses, and new lifestyle requiring more intermediate vision, night driving, etc. Now, if you see in evolution of diagnostics, we have moved from the contact A-scan right up to image guided. However, in the IOLs, we move from monofocal to maybe toric and then bifocal, trifocal, and EDOF. But all these are based on the diffractive platform. The problem with the diffractive platform is all these lenses are superb, by the way. But the only problem is there are gaps in between the foci. There are halos and glare, which we are afraid of asking the patient a direct question like that. The neuroadaptation takes some time and it cannot be offered to some patients like ARMD or glaucoma or diabetic patients. Here, the technology is a wavefront engineering technology. And if you see in the central, spherical aberration is inducted in the central pupil. And if you see this, the central 2 millimeter zone is giving you very good near to intermediate. The next zone gives you good intermediate to distance. And the outer zone is nothing but an aspheric monofocal, which gives you excellent nighttime and distance vision. If you see the defocus curve, the blue line is the mini well. It's a continuous curve. There are no dips in the vision, and we are getting very, very good vision throughout. This is the most important point I would like to point out. When you see the light transmission of any other ring lens, it will be 85, maximum 88%. However, in a monofocal, it is almost 95%. You can do this test on your own at your own clinic. Go to an OCT machine, see an implanted lens. Any lens which has rings will give me a light transmission while I'm doing it, a strength, signal strength of around 4 or 5 on 10. However, if I do this in a monofocal or a mini well, I'm getting a signal strength of 6 or 7, which itself shows that light is not getting cut off at the plane of the lens. Therefore, the contrast sensitivity is comparable to a monofocal. This is Dr. Offart's slide from Heidelberg University, Germany, where the patients, 45 patients were tested for the contrast. Let's listen to it. How many of y'all have the confidence to ask the patient about halos, contrast, and glare? Just see this video, and she has been operated. Let's listen to her.
Hi, Sangeeta ji.
Hi.
So, when did you get your cataract operated?
It's 3 months back.
3 months ago. And we have put a mini well for you.
Yes.
And how do you find your vision?
Yeah, it's excellent. Means I can see very clearly. And thanks to you, that lens are really nice, and I can see.
You can see. And are you able to read your mobile?
Yes. I'm enjoying now.
Okay. And do you get any halos or glare at night from cars or anything? Nothing. And what about if the light is a little dim? Is there any loss of contrast?
No, nothing.
No complaints.
No complaint.
Okay.
Because I walk sometimes in the night in the hall, I switch off light and go in bed. So I'm very comfortably walking. Not previously, I used to get little difficult to walk and all that, but now easily I can walk and all that. Yes.
And you practice yoga?
Yes.
And now you're happy to do it without glasses?
Yeah, without glasses, I can see my students, I can guide them very clearly, and I can do asanas also.
Okay, so you're happy all in all?
Yes, very happy. Thank you so much.
Okay, bye.
She's currently conducting classes on Zoom through yoga. So intermediate is very good, mobile is very good. The biggest thing is no halos, glare, or loss of contrast. Though the company says it's very less halo, glare, or loss of contrast, I have not had a single patient in 75 patients who have complained of any of these three. So if anyone is hesitating putting a multifocal or an EDOF due to these fears that postoperatively the patient will complain, you can be quite reassured from my side that there is no halo, glare, or loss of contrast because there are no rings. So my take-home message will be all our new age relationships today, people want no strings attached relationships. The new age IOL surgeons will want no rings attached. And I personally feel in the next 1 or 2 years, all the leading companies will come out with lenses which do not have rings. The cost may be higher, but they will definitely come out because this is the only way to go. Thank you so much.
Thank you, Dr. Neha Dholake, ma'am, for a wonderful talk on the mini well lens. Ma'am, I wanted to know what was the longest follow-up for such patients?
Longest follow-up, first case I put before the lockdown in December. So 2019 December.
Okay. And as such, no complaints of such patients?
No. Up till now, as I said, I love using multifocals and I have used lots and lots. And I said 80% of my practice is multifocal. Of course, patient counseling is required, post-operative cylindrical. You must try to keep below 0.5. I quickly use a toric if it is more than half, especially if it is against the rule. And counseling that in 3 months' time, you will all be fine. So have that patience. But in the long run, you will thank me for having put a lens. The main thing which I felt was when, as a surgeon, if you implant this lens, you are absolutely fearless of the rings. It is such a crystal clear lens. You will feel you are putting a monofocal. So that was the thing that convinced me. And this OCT thing that I'm saying, it's really, really worth trying. Just implant one lens and just see the OCT signal strength when you're doing the OCT. Even the pictures that you, even the pictures that you get of the retina are very clear. Sorry.
Dr. Neha, did you find any pupil dependency of the near vision?
Not really, sir. I have now up to 4.5 pupil I have gone, and some 1 or 2 patients were quite myopic pupil of 2.2, 2.3. I took the courage and implanted the lens. They have not complained. I have been directly asking patients about halos glare. This is committing suicide, actually, wherein you ask the patient, do you see? So if they don't see also, they start looking out. But I'm so confident to ask this question.
I see Dr. R.C. Shah is here. Can I ask him, what about the new lens that he is promoting, and he has good experience about it? Could you tell us a bit about that? How is that similar or different to a EDOF lens?
We have a autofocus lens. There is a presentation after this session. We're going to tell everything about. The only difference between the Neha's lens is our lens is that we have 7.2 millimeter lens. This is probably the largest lens in the world.
Correct.
I think she has also put 1 or 2 lenses of ours.
Yes.
What our idea was to promote this lens to convert all the monofocal into varifocalities. Dr. Neha's lens is very good. There is only one thing which I want to ask her. How many patients do you really see any negative dysphotopsia? Because the lens is small. This is 6 millimeter, and most of the time you must be placing vertically.
I generally place the lens in a very funny way. I'll tell you one thing which I was doing right from the time of IQ. Whatever is the steeper axis, I place the lens along that side. Because sometimes even in an IQ or in any lens, if you see and magnify the central zone, you may see micro lines which have occurred due to the injector. And I have noticed, I don't have a pentacam, but I have noticed that you end up getting a minus cylinder in that axis. So whichever is the steeper axis, if just like how you were to implant a toric, if you implant all your monofocals also like that, you will end up reducing your cylindrical post-op.
Any patients complaining of negative dysphotopsia?
No, luckily no.
Dr. Bhatti, you put this lens, I think, on Saturday. My lens.
Yes, but I don't have any follow-up on that yet.
That is okay, but could you implant it safely and properly in a small 2.4, 2.8 millimeter?
Yes, it went through very easily. Very easily.
I will be telling everything on my talk after this session. So, Dr. Bhatti, your question will be answered. That time I did not waste the time just now in this session. We have designed the lens thinking everything. It took about 2 years to design that lens. And we have taken care of every negative factors of the previous lenses.
Any other questions from the panelists? Dr. Vavikar, sir.
Very good presentation, Dr. Neha.
Thank you, sir.
Very nice. Very nice that you are studying in so much of detail. And it's always nice that there is some kind of a researcher or scientist hidden in you. Very nice. You're talking about those small grooves which are formed because of injection while injecting the IQ. I could easily correlate what you're talking. So that's a very good.
So now what I do is, anyway, we do topography for all the patients. And even if nothing, at least on the A scan, one can always come to know which is the steeper axis. Just start in putting all the lenses on the steeper axis, not vertical, not horizontal, just the steeper axis. And literally post-operatively, especially in any EDOF, I think one of the biggest reasons for a good outcome is having your cylindrical power less than half.
Absolutely.
The moment you get that, and of course, then it's just neuroadaptation, which takes 1.5 to 3 months. And if you've got that well centered, all lenses, whether it is panoptics or anything, everything will do very well.
Neha, you just said that you implant all the lenses along the steeper axis.
Yes, sir.
No, you mean the steeper axis or the steeper power meridian?
The steeper corneal topography axis.
That means, in other words, the flatter axis or the
No, the steeper axis, sir. The steeper axis.
No, the axis would be at 90 degrees to the power, no?
So let's say if it is with the rule, I would implant the lens at 90 degrees.
if it's with the rule, you'd implant the lens at 90 degrees. Okay, so along the steep, that means the loops along the steeper power.
Yes, just as if it was a toric lens.
Toric lens.
Steeper meridian rather.
Yeah, steeper meridian.
Steeper meridian, correct. That's right.
Because if you say axis, the axis would be exactly 90 degrees opposite of that.
What happened once, in fact, my father-in-law was operated around 10 years ago, and he had a minus 0.75 cylinder at 70 degrees. And when I did his keratometry, topography, it was 44, 44. So I was wondering, where has this cylinder come from? When I dilated his pupil and saw a picture of that under the slit lamp, exactly at that 70 degrees was that crack in the lens or that fold in the lens.
But normally these folds are having a good memory, I think.
Yes.
Should disappear.
If you just start seeing some of your post-ops and just dilate them and take a good image on your OCT machine, you will start seeing these folds and you will start correlating the axis post-op and the cylindrical numbers. We take so much care in surgically induced astigmatism, which generally recovers back to almost zero with all such good surgeons. But we don't take care about the lens.
That means the lens does not have a good memory to retain its original power.
No.
Dr. Vavikar?
No, it has a good memory. RC, if you see these grooves and folds, all these things you will see in the first 1 month post-op, but if you see 1 year or 2 years down the line, you will see that there is nothing left.
Yes, I would agree. Lots of them don't have anything left, but some, like, for example, the example of my father, after 5 years also, he has that same line I can see. Yeah.
Do you have a difference between hydrophilic?
Can I add one thing, Ramesh, Neha?
Yes.
Mohan Rajan here. Hi.
Yes, sir. Everybody knows you.
No, I just want, because I have seen this commonly with Acrisoft lenses.
Yes.
If you never hold the optic of the lens, especially with an Acrisoft lenses,
yes,
the mark may stay there. In fact, in the next session, I'm going to talk about IOL acrobatics, and one of them is an Acrisoft lens, wherein there is a mark right in the center.
Correct.
The patient complained of polyopia, and she sued me. Yeah, and she went to another doctor, and he said they put a cracked lens in your eye. So,
another point, if it's a power more than 24 diopters, I don't like using the D cartridge. Extend the incision a little and let the lens go in nicely. Sometimes if in that central 2-3 millimeter zone, especially in a EDOF or a multifocal lens, if the crack is bad, you may completely lose the near vision for which the patient has paid you so much, and it will work just like a monofocal lens. You will need to give a plus 2.5 or 3 addition. And this has happened with me. Luckily, it was my mother's very good friend, so she understood it, but you have to be very careful, especially if the patient is a hypermetrop.
Absolutely. Do you find any difference in this phenomena between hydrophilic and hydrophobic material?
You're asking me?
Both of you.
No, hydrophobic, I find it more common.
Neha?
Yes, hydrophobic.
Hydrophobic.
Do not have so much of a problem like this.
See, hydrophobic lenses are a little stiffer.
I have not seen this with Envista at all, or even the thickness for that matter, mainly with Acrisoft.
So in you refer to one case, did that damage done by the forceps disappear or was still there?
Some of them don't disappear, that's the problem. If it's slightly off the visual axis, it doesn't matter. But if it's right in the center in the visual axis, that may scatter the light.
In fact, if you see, Dr. Sri Ganesh uses that as in the toric lenses in a small pupil to keep the axis properly in toric lenses. That one which you see the line in between when you fold it, that particular portion he uses for aligning the toric lenses in a small pupil.
Any other questions from the panelists? Dr. Pakare sir, for any talk?
I want to ask one question to Neha madam.
Yes.
If patient has already operated with EDF in first eye, can he go for a second eye with this mini veil?
Definitely. But the only thing is, sometimes in the billing, we don't want to complicate things for the patient. He may ask, why didn't you put this first? So I generally, during these 75 lenses, which I did during this last 1.5 years of lockdown, All the patients who had a panoptics in the other eye, a symphony in the other eye, I have stuck to the same thing.
Okay.
This is an advantage of all the ringless lenses where you can put in other eye.
Absolutely, absolutely.
Lenses you can put in any eye you want.
I think slowly, I think Vivity will also come out, which is without a ring, but the near is not 100%. And also the price will be double than this. And this is an imported lens made in Italy. Sometimes patients want to see that sticker. And I've had a very good experience. There's no financial interest at all. I wish there was, but there isn't any. And but I'm just happy with the lens. And tomorrow, if a better lens comes out, I would definitely shift to that. I'm not stuck or married to any lens. I've used lots and lots of Alcon and lots of Symphony also.
You can use our lens and become a partner with us.
Yeah, I know.
Yeah, I don't mind, Ramesh.
Yeah, you can. I will send you the.
I need some money now.
No, it doesn't require money. It requires only 50,000 rupees to become a partner.
Yeah, I will do that.
Okay.
Dr. Neha, I'm Dr. Vinod Arora.
Yes, doctor.
Just one question. You'll prefer the EDOF in a dominant eye if you're doing a mix and match?
So this is a very good point. Currently, what I'm doing, see in Symphony, I used to have to keep a difference of 0.75 because the near would not come very good. And in this, I'm having to keep a difference of around minus 0.3 myopia. That gives me a very, very good near. So I go with the first eye near, where I choose the first minus reading. And I go only by Barrett formula. That is spot on. I've done all the permutation combination of SRKT to everything. I go with that. Barrett has worked very well with this particular lens. And the second eye, after a week, I ask the patient, if they're very happy with their near, they can see their mobile really well. I give them that choice that, do you want the second eye also to be seeing so well? Are you okay with that little minus half for distance or minus half cylinder or whatever it is? Half the patients tell me, doctor, please keep the second eye exactly how you have done this. I'm really okay with that little distance number. And some who, I had a lady, a Marwadi lady, a very surprised, very modern lady. She loved playing table tennis. She's saying, Neha, please make the other eye so that I can see distance well. Then you go bang on emetropia. The defocus curve covers around 3.5. And very shortly in the next 2 months, Minivel is going to come out with a Minivel Proxa, which is going to have a defocus curve, which is extending little onto the such that you can get reading distances at 33 centimeter distance, sorry. So a blend of both those will work very, very well. Till that comes out, I have used all these with just a minus 0.3 or minus 0.5 maximum and getting very good near and good distance.
Any other questions? Okay, I would like to thank all the panelists and speakers of this session. And Dr. Bhatti sir, with your permission, shall we end our session?
Yes, I think we can end it now because the next speakers already seem to be there.
Okay, sir. So we'll move on to the next session. Over to you, Dr. Ruchik.
Thank you, everybody.
Thank you very much, everyone.
Thank you, everyone.
Thank you.
Thanks a lot. All the best.
I'm not too sure if all the speakers have joined in though.
Ruchit,
Is
can
Dr. Rajesh Sinha there?
Ruchit?
Yes, sir. Tell me.
No, I just want to know whether I can go second or third because I have the OPL at 4:30 in Kansky Hall.
No issue, sir. Looks like the first speaker, Dr. Rajesh Sinha, has not yet logged in. Probably we can change the sequence of this thing for you.
Shall I go in first?
Oh, yes.
No issues. Yes, definitely, sir.
Okay.
Because Dr. Rajesh Sinha is not logged in, I think it's
my topic is also a little different, not the one which is mentioned because Sujata is talking on that malpositioned IOLs. I'll talk on IOL acrobatics. Okay. I will just talk about it. Yes. Shall I share my screen?
Please.
Yes, sir.
Dr. Mohan Rajan is a prolific surgeon. He keeps on doing acrobatics and gym. He goes to gym every day and is a wonderful surgeon, and he has got a great sense of humor. So you listen to him, you will love him.
And sir, all the best for a 56th OPL win. You already won 55, which is a world record. So you'd wish you add to it.
Thank you very much. Let me thank Dr. Lahane, Dr. Ragini, and Sapnesh and Preetham and the entire BOA and MOS for this wonderful opportunity. I'm going to talk to you about some IOL acrobatics complications which are related to the IOL, which is very, very common. The only thing is we don't report it because we are a little complex in the end of surgery. These are IOL cracks which can occur. You can see here, this is a multifocal lens wherein it cracked. You can see the array lenses which cracked. Obviously, these lenses have to come out. And this is again another haptic which has come out. And these are all used to be very common because the cartridges were not suitable for the lens. This is the first MI60 lens, which became the MI30 lens. Only half the lens came out. Yeah, and these are all because of tight cartridges. Initially, when the MI60 lenses came, the Bosch and Lomb didn't have the proper injector as well. And this is the Krista lens, and this guy came all the way from Coimbatore at that time in 2009. I was the largest user of Krista lens, and you can see that about 10 people were watching the TV outside my operation theater, and you can see this Krista lens. Only the Krista came. You can see the lens is completely broken, and yeah. So obviously this lens has to come out. You can see this lens, the Krista lens completely broke, and we had to replace this lens as well. This is what I was talking about in the previous session, Ramesh, because the staff, the sister in the OT, when they load the lenses, if you catch with the McPherson, this is an Acrysoft lens, right in the center. I should have actually noticed this on the table and explanted this lens, but obviously I didn't notice this on the table. And this patient had a crack. It's not actually a crack. It is a line which is there. It's an impression because of the thing. So no forceps should touch any part of the optic. That is, whether it's a monofocal or a multifocal, it doesn't matter. But make sure that you catch only the haptic while you're loading the lenses as well. This patient became very, very upset, and she had polyopia, and she had a lot of glare, and she was not able to sing. And she went to another doctor, and that guy told that lady that you got two cracks actually. There's one crack on the lens. The another crack is the surgeon who operated on you. So she became very furious, and she sued me. But obviously, she didn't win the case. There's another patient can see there's a preloaded lenses. You have to be very careful because all the companies are now coming with the preloaded lenses. You can see here, the preloaded lenses is the Lucia lens made by the Zeiss, and only the optic came, and the company guy was telling me, sir, that the world's first apparent surface optics, sir, only the optic came. Whereas the haptics came later. You can see here on the right side, you can see this haptics came later. The two haptics. So obviously this lens had to be explanted as well. Again, another patient who had a preloaded supraphobe lens. You can see here. See, what happens is the preloaded lens, you do not know what exactly is happening inside. And sometimes you can see there is a beautiful, I call this the donut lens, right in the center, you can see here. And one of my postgraduates is asking this, what is this hole in the center, sir? I said, this is a pinhole lens, wherein through the pinhole, only thing is there's a very large pinhole. Pinhole, the patient will be able to see better. So again, is another patient, you can see is a Zeiss trifocal lens. It's nothing to do with the lenses. Probably something to do with the cartridge. The cartridge is a little tight. Probably you have to make sure that this thing. You can see here, these are the trifocal lenses. 3 zones you can see here. The zone for the distance, the zone for intermediate, the zone for near. All the 3 cracks were there.
One you can call it ready to explant lens.
This is another patient. You can see this is a push type lens. You can see here. You have to be very, very careful in pushing these lenses because sometimes it can come out with the great force, open the posterior capsules. You can see the lens dancing the vitreous cavity as well. There's one of my pediatric ophthalmology consultants who did a beautiful posterior capsular excess. This is a little older video, and that is the reason for the quality of the video being a little thing. The lens had other plans. You can see here, there's a hydrophilic lens. You can see here the lens somersaulted inside. Suddenly it came with the somersaulted, and by the time she could pull the lens, she went through the posterior capsular excess into the vitreous cavity, and we had to do a pars plana vitrectomy and remove the lens as well. Again, the supraphobe lenses, I use the Alcon injector. Don't use one lens for another injector. This is a mistake. Again, coming with the jerk, and see the whole lens is ruptured the PC and it's dropping into the vitreous. Obviously, I had to do an anterior assisted levitation of the lens and take it out. Again, I have another patient with the refractive multifocal lenses made by the Appasamy long time back in 2003. With the capsular phimosis, the lens started folding inside the eye. And it was because of that, there was a posterior shift of the lens and hyperopic surprise. And I had to do a YAG laser. And obviously, after the YAG laser, you can see on the right side, the patient had this thing. Z syndrome, not uncommon with the crystal lens, wherein it can suddenly move forward and turn to one side, and this can produce irregular astigmatism and also a myopic shift as well. This again, when you do wound assisted lenses, the docking of the lenses, you have to make sure the lenses, the AC is fully tight or inflated. Otherwise, if you try to push this lens, so once you get the lens out, very difficult to pull the lens out or push the lens inside. If you push the lens inside, suddenly you can go with the jerk. Always go posterior to the incision and try to open up the wound and try to remove the lens outside and probably put another lens. This is again very common with the access of lenses, the shifting haptics. And there's another patient you can see here, again a preloaded lenses. I think it's a supraphobe lens. You can see this is a lens which is coming out, and see the silicon, the cartridge also coming out along with I call this the blue whale. And you can see it's very difficult because it's so slippery, this silicon one, and he had great difficulty in removing it from the anterior chamber as well. So again, this is another problem. Again, it's a Lucia lens. You can see here, the haptic got stuck to the posterior surface of the optic. So difficult to remove this, the addition between the optic, the haptic and the posterior surface of the optic. So we had to do a lot of irrigation, spent almost 10 minutes to do this thing because it's very difficult to go underneath and try to pull the haptic. It got so much stuck into the posterior surface, and at last it came off with this thing. And these are 3 IOLs, which I called this Pandora's box. This patient was referred to me for removal of AC IOL and vitrectomy. And this is the first IOL, the anterior chamber IOL, which I removed. Then you can see the plate haptic lenses. You don't have to go to it's a virtual trade itself here because there's no physical conference this time. So a virtual trade, every company is there. You can see the Alcon single piece, the PMMA lenses is there, and all the 3 lenses. And this patient underwent, apart from this patient had a piece of nucleus also inside the eye and also a CTR. So the take-home messages are very, very simple. Load the IOL yourself. Use the time-tested injector systems. Check the compatibility between the IOL and the injector. Beware of preloaded IOLs. Do not be complacent. Normally, at the end of surgery, you are a little complacent. Your concentration is not there because you might have done a hard cataract or a small pupil or a patient with a zonular dialysis. You must have had a very tough surgery. So you are not concentrating when you are putting the lenses, and you have to be a little more, attentive and make sure that you are not complacent at the end of the surgery. So this is the take-home message. Thank you very much, BOA, for the wonderful opportunity.
Dr. Mohan, you have such a large collection of these kind of IOLs being implanted there. So why don't you have another set of instrument like Sinskey hook or from the side port, so that if it goes inside, then you can control the movement by the Sinskey hook. You can simply put optic, and at the optic and haptic junction, you can put the Sinskey hook and can solve the problem sometimes.
Absolutely.
But these are wonderful videos, very, very...
No, these are all because over a period of time we learn how at the end of the surgery, everybody is a little complacent. You don't concentrate as much.
I know it's not one-day complication.
Yes, at that time it will occur, and without your knowledge, especially when you have...
Yes, it's a decades experience that you have, and I've been seeing these.
These are good teaching videos. Good teaching videos.
Yeah, very nice.
Thank you so much. Thank you so much.
Dr. Mohan Rajan, I have one suggestion, if you don't mind.
Yes.
Especially these Appasamy lenses. Now, if you first of all put it into the saline, the whole cartridge system, and put a methyl cellulose on the posterior loop. Normally, these loops getting stuck to the haptic does not occur. That is my personal suggestion.
That is not a Appasamy lens.
Most of the time, it is a Appasamy
nice Lucia lens. Zeiss Glusia lens, Apasami have not had this problem. Zeiss Glusia lens, the lens with the hole in the center is Apasami.
Methyl cellulose usually helps you in this.
Yeah, possibility. Yes. We have. And another thing is, what I have learned is, when you are injecting the lens, if the cartridge is a little tight, don't, for heaven's sake, don't inject the lens. Come out and probably take another lens or use some other injector.
This is a problem with...
No, you are likely to have some crack, or the haptic will fracture, or the optic will fracture. That's what has happened. So this I never realized. After some time, after seeing complications, retrospectively we analyze all these things.
One more thing I do, Dr. Rajan, is that when I fold it between the flyer, then what I do is that with the help of a fine instrument, I push the lens within this cartridge.
Yes.
So if it goes smoothly, then it will never do this. Otherwise, we have all experienced these kind of complications.
You put in the nozzle. Yeah.
This is what is
put in the nozzle. I use a very fine McPherson or this iris repositor to push it into the nozzle, and then it becomes very nice.
Yes, sir.
Something like the forceps that Alcon people
especially when you are using a little thicker lenses, are hyperopic, like 28, 30, 32
No,
dab.
they are very thick lenses. Yes.
You have to be a little careful, sir.
Yes.
And with a little tight, don't try to go ahead with the implantation. Just come out and find out what exactly is wrong.
And even if you implant these lenses in a tight situation, then it has lots of folds on the lens, on the optic.
That is what we are talking about, no? That's
Yes,
good.
yes. Thank you. Thank you so
Thank you
much,
very much.
Dr. Mohan. Thank you.
Since Dr. Rajesh Sinha has not yet logged in, so can we have Dr. R.C. Shah with his lecture? Dr. R.C. Shah requires no introduction. He is an excellent anterior segment cataract and refractive surgeon. He teaches at Pramukh Swami Eye Hospital also and has a lot of innovations to his name, like Omni Glow, Methylene Blue, and some of his special IOLs, something like he is going to talk about today, unique autofocus IOL. Over to you, sir.
Yes, sir. Can you see my screen?
Yes.
Okay.
Yes.
Yes, sir, we can.
We have a financial interest in this product. We all three of us have a financial interest in this company called Milli Optics Intraocular Lenses. Milli Optic is formed to help our fellow ophthalmologists to become a shareholder and become a partner of this company and get the world-class products at affordable price. We are all three a promoter of this company. The autofocus which I'm going to talk about is we have taken about 2 years to design this lens, and we have implanted 5,000 lenses so far. Myself and Dr. Kakadia has implanted nearly 2,000 lenses of this. The longest follow-up we have is about 2 years. The design is done in such a way that it looks monofocal in outlook, but functionally it is a progressive lens. The principle of this lens is a gradient refractive index from center to the periphery. There are micro refractive radial progressive zones which cannot be seen. It has asphericity which is neutral. It is the largest lens in the world, probably 7.2. It is 7.2 millimeter by 6 millimeter, static and fixed in the back. So it is more or less an autofocus lens. There are no rings which are there in diffractive multifocal lenses. There are no halos, no glares, no exhibitions. The A constant optical is 118.7 for hydrophobic and 117.8 for hydrophilic lens. Contrast sensitivity is very good. Reading speed is an excellent. This is the biggest plus point of this lens. It can read 200 letters per minute. No relations with angle kappa and angle alpha. Any patients with healthy macula, you can fit this lens with fairly good results. There is nothing like neuroadaptation with these lenses. It is instant. It can be implanted in monocular cataract as well as the one who has done previously monofocal IOLs. Even if there is a significant corneal astigmatism, we can implant this lens. We do not have a toric lenses so far in this on Please platform. They may need a minus cylinder or plus cylinder for distance, but will mostly not require for bifocal or progressive spectacles. In diabetic with healthy macula, you can implant this lens very easily. and there is no diffraction of green laser if they need PRP in future. It does not cause blurring of retinal image for any retinal procedure, any laser procedure on retina. PCO rate is very low, as this is one lens which has got double square edge on the posterior surface and a single square edge on the anterior surface. This is the result which is we have seen in last 2,000 patients. I'm not going to give you the detail of the statistics. The most important thing which we found is the kitchen platform, the staircase steps, and below the furniture vision, which probably is the new concept which we have thought in this lens. It has got a double square edge. You can see this one and the second one, which is just inside the outer edge. It is autofocus for all. We have come out with three varieties. Actually, there are three varieties, and hydrophilic lenses are not yet out. It is whatever I said, that it is UV and deep purple blocking material, a real square edge, preloaded. It has got a special dual injector, which I will show you now. This is the one. This particular injector is manufactured from, it is imported, but we are on the verge of making this injector system at 1/100th cost of what we are importing today. The protocol of this injector is already ready in India. This is a screwing mechanism in which you can deliver the lens. The same lens you can deliver with pushing the lens instead of screwing the lens. So it's a dual system of injecting the lens. You open the flange and push the lens. This is the implantation in the eye. It has got 7.2 millimeter horizontally and 6 millimeter vertically. You can see this lens is so large from one end to the other end. The idea of increasing the size of this lens to negate the negative dysphotopsia. This is a PMMA lens which will be used on the same, the principle is the same, but this will be more useful for a lot of surgeons who are doing SICS. It has got an L loop instead of C or J loop, so that the contact area of the loop and the rexis, and the bag is almost 6 millimeter as compared to the conventional loop, which is about a 1 millimeter. So the stability of this lens is very good. There is no negative or positive for dysphotopsia in this lens. The conclusion of this lens is that it is a diffractive ring multifocal IOL, will be phased out over a period of next few years. All other readout IOL requires micro mono vision adjustment. Autofocus at present appears to be a fairly ideal choice of varifocality. About 5,000 IOLs has been implanted so far with very good satisfied patients and doctors. It is free from negative dysphotopsia because it's a 7.2 millimeter IOL placed horizontally. It is free from positive dysphotopsia like halos and starburst, as it does not have any diffractive rings. It does not reduce contrast, as it does not have diffractive rings. It reduces that is the only small negative factor of this lens is that the pupil size is less than 2 millimeter. The distance vision is less, and you might have to. Thank you so much. We have this is a company which is owned by our own ophthalmologist. We have about 70 owners at present, and we are going to send the offer letter to all of you. We are expected to declare 100% dividend this year, ending March 22. So whatever money the previous all other doctors were paid probably will be returned in terms of dividend, because we have put some amount of money into stock exchange and we have made a good profit in that. So we want to make this company for all of us, so that you become the member, you become the owner, you become the shareholder, and we are expecting all these to bring more products which will be about 1/5 or 1/10 of the cost of what is available in the market. This lens also has been designed in such a way to replace the monofocal lenses for all of us in the full range of hydrophobic, hydrophilic, and PMA. All three lenses will be available at different costs so that everybody can afford this lens to have a varifocality in their patients. Thank you so much.
Very nice presentation, a great idea, Dr. Shah. And what is the cost of this lens?
This hydrophobic lenses, if you buy 10 lenses, you get 2 free. So it effectively becomes 8,000 rupees now. But once our injector we start manufacturing our own injector, probably we might be able to sell it at 6,000 rupees. The hydrophilic lenses probably is around 4,000 to 5,000 or maybe less. Hydrophilic lenses have not been given to anybody. Only myself and Dr. Kakadia has already tried that. Once this pandemic is over, we will launch the hydrophilic lens also. The PMMA lens should be around 2,500 rupees only, so that we can cover the full range of doctors who are doing because SICs in rural India as well as even in the cities. So we want to cater those people at an affordable cost, so we can convert all the monofocal IOLs into a varifocality variety. So all our patients, and the next target is we have one more improvement has been done, which is under the trial. Once that occurs, we'll replace the previous one and have a wonderful, extremely good varifocal lens.
That's nice.
So you can get a Make in India award.
This is the whole purpose that, you know, let me tell you one thing, that we are paying so much of money, 30,000 lenses, 50,000 lenses per lens. And the actual cost is not even 200 to 300 rupees, considering the research part is over. Because I am in manufacturing, I have seen everything for years together. And with the experience of me and Dr. Kakadia, we have decided that we will give the lenses to all of us at a very affordable cost. And whatever number of lenses that you use, you become a partner and share the profit.
Yes. That's a great idea.
That is a brilliant idea.
Excellent concept, sir.
Arsi, can I
Brilliant
have,
idea.
Yes. Is there any problem in rotating these lenses because the size is quite big?
Nice, yeah, that's one thing I want to ask.
Yes. What happens, you have made 2 holes in the extreme periphery. You can dial these lenses through this hole. And the same holes can also be used to remove the viscoelastic under the haptic. So dialing is not a problem. You can very easily do the dialing very well. In the beginning, we did not have the hole. But once we got the feedback from the people who used this, we had put 2 dialing holes on the opposite to each other. At the haptic junctions, more towards the haptic, not towards more to the optic.
I think it can be a good lens for toric platform.
Yes,
I would say because the rotational stability is very, very high.
It's very high. I have done only one PCO with YAG laser in my personal 1,000 lenses so far in 2 years.
Excellent.
Got a double square edge. It's not a single square edge. It has got a double square edge posterior and surface square edge on the anterior side.
How are you able to get the double square edge? I don't understand.
If you, I think you should leave it to us.
Great secret.
I can when I meet.
Sir, apply for a copyright for that double square edge.
It's on both the sides.
No, it's not on the both.
Anteriorly.
It's a very square edge on the posterior surface. Not
only
one.
posterior.
So
Excellent concept.
There are 2 edges, sir. There.
2 edge, posterior surface, there are 2 square edges.
Okay.
Interior surface also there is 1 square edge.
Okay.
Something like that. And the square edge is 360 degree. It's not optic-haptic junction has got the same square edge. Normally what happens in all the proliferation cells occurs from the optic-haptic junction. Here the square edge is done in such a way that it is 360 degree square edge.
That's nice.
Only thing is that enough efforts because of this COVID problem and the factory where we are producing these lenses had a lot of problem with COVID. The last 3 months, they have somebody else positive, negative, and then the owner and somebody else and something or the other is going on for last 3 months. So we are held up to bring certain changes. We are planning to do that. And I think we are almost reached the final stage now.
Thank you so much.
Amazing. RC, fantastic.
Can we have Dr. Rajesh Sinha next?
That is 1 minute. There are few products which are to come. We are coming out with the phaco emulsification with these epochs, the highest quality at about 7 to 8 lakh rupees for all of us. We are getting a femto cataract system, probably in up less than 20 lakh rupees. C3R machine is approximately 70,000 rupees. All these things are on pipeline, but because of this pandemic, we are held up with the materials and other things to design and then implement it. So it will take about 1 or 2 years so that all of us, including the newcomers will be able to afford high quality products at the low cost.
So we must all become shareholder immediately.
Brilliant, sir. Brilliant.
The Omni
All the
Glow,
best to you for that, sir.
the Omni Glow, which was designed by Dr. Kakadia, we have installed 450 microscopes.
Okay, wonderful.
Good evening, everybody. Good afternoon. Good evening,
very-
Kamal sir, Purendra Bhaiya, RC sir.
Namaskar. Very good evening.
Namaste.
Thank you. Namaste.
Thank you. Thank you. Thank you. वो
It's so
बहन का
nice.
राइट करके मैं आपको कोविड के काम से thank you everybody for being here. Hi, Amai.
Really, it's a nice opportunity to interact with everyone. Dr. Vinod,
Finally,
Dr. Shah.
So finally, we are meeting everybody. At least this reunion is there. Hello, good evening, Sujata ma'am.
Yeah.
Good evening, Rajesh Bhaiya.
It has been made by you.
Good evening, Vinod Bhaiya.
Reunion and this meeting has been, credit goes to you.
So to everybody, it was Preetham's dream of these 4 Sundays, Swapnesh's hard work, Sumit, huge teams, RC sir and all our mentors, guides. And it cannot be possible for all of us, whether RC sir and us, if all of you do not come, then there would be no meeting if you all do not come.
No.
When
How
when you call, everybody has to come in any case.
Yeah.
You know,
The way you invite,
Zabardasti.
Who can refuse?
no one can refuse you because the way you invite is such a brilliant, such a beautiful way, and we respect everything.
And
All
after a
our
long
regards
time,
to
we are
sir.
having this day-long conference now, so it's wonderful.
Sir is very much there. I'll just see he's very much here.
He's
Yes,
in
thank
the
you.
other session.
Yeah.
Actually, I
must
was
be
in the other
busy.
session actually. So sir was in that session.
In 2 years' time, we have grown old. We have
Sir, Kamaljeet Singh sir and RC sir, sorry to interrupt, but
It's
okay.
Thank you so much for joining us.
Thank you.
Shall we go to the next presentation?
Yeah.
Dr. Rajesh Sinha.
You ready?
Yeah.
Okay.
Ruchik is also here. Ruchik is the treasurer of BOA and MOS and an integral part. So Ruchik should be thanked for all the support all this technical support that we have.
Yes.
Thank you.
So I thank BOA, MOS, and Ragini ma'am, and Ruchik, and Rane sir, everyone who have made this thing possible. And during this pandemic where there was so much of negative feeling going all around, it's a wonderful opportunity to talk to each other and meet each other. And in this session, I would like to present on malpositioned and decentered IOLs. So the basic aim of IOL implantation is to have the center of the IOL coinciding with the visual axis. And if it doesn't happen, the IOL is decentered. And if the IOL is decentered, there can be various problems. Now, these problems depend on the severity of the decentration. Like it can cause astigmatism, it can cause poor quality of vision, it can cause prismatic effect. If further, there is decentration, then there can be dual zone aphakic and pseudophakic. If it's more decentration, then the whole eye becomes aphakic. And there can be complications related to mechanical effect of IOL decentration. Like the visual acuity definitely does get affected. But then because of the IOL decentration and associated features like vitreous coming into anterior chamber, etc., there can be glaucoma, there can be corneal decompensation, and all these things have to be managed apart from recentering the IOL, which is the main aim of management. So I'll just show a couple of case scenarios. The basic idea is to recenter the IOL with minimal manipulation. So in this particular case, you can see there is a damage to the capsule in this area, but this whole thing is well centered. And it is, as you can see here, it's an earlier, rigid PMA lens with the hole with the dialing hole, etc. So it's a 13 millimeter lens. So if we can recenter it and put the haptic, both the haptics on the capsule, then it will remain in position in majority of the cases. And that was the basic idea of just redialing it, and the patient did well in the post-op period. So that is the minimal manipulation that one can do. But sometimes what happens that if you have a worse scenario, like a traumatic repaired corneal perforation with cataract surgery done, there was a zonal dehiscence here, there was a posterior capsule damaged here. So this there was a lens that was placed in the sulcus, but it was always getting decentered. As you can see here, you can see the reflection now. It was getting decentered. Now, then there was only two options in this scenario, that either you fix the lens by doing a scleral fixation or put an ACIOL or whatever, or there is another option which is very much there actually. The patient's condition itself helped. It was a margin which was central area was clear, and there was a large open area in the capsule, and so this opening in the capsule was utilized to do the optic capture of the IOL, and it remained rock solid in its position. So sometimes these small little maneuvers, they do help in recentering the IOL. Now, this is a case wherein an IOL surgery was done and the patient suffered trauma, and then this is a single piece foldable IOL placed in the bag, and the haptic with the bag came over the iris because of the trauma. And now in this particular case, because of the zonal adhesions of about 90 to 100 degrees, and since it was a one-time damage, not a progressive condition, but a traumatic zonal adhesions, so if we can support it with an endocapsular ring, it may remain in position. And as you can see here that the endocapsular ring moves in this direction, it pulls the bag posteriorly behind the iris, and along with that, the haptic also, IOL also went behind. So it just plays a damage of about 90 to 100 degrees of zonules because of trauma, which is a one-time damage, not a progressive condition. It can remain in position. And with us, so the basic idea is that we have to recenter it with a minimal manipulation. But in this particular case, as you can see here, the IOL is in the bag, but it's quite a lot subluxated on one side. So this part has to be fixed. So we planned a lasso suture in this around the haptic, and a 9-O-proline suture needle was used in this. A groove was created at from 2 millimeter at the 2 millimeter point behind the limbus up to 1.5 millimeter. A paracentesis was done on the opposite side, and a 9-O-proline suture needle is introduced going behind the haptic and piercing the capsule, coming up over the optic, and then it is docked into a 26 gauge needle and exteriorized. Now, this patient had an asteroid hallosis. Now, it was good for the patient to have asteroid hallosis, because in such cases, it is always preferable that whenever you do any maneuver, you should inject a little bit of tricot, because no manipulation should be done if there is vitreous above the IOL, because once you are pulling the IOL, there will be a pull on the vitreous. So that should be avoided. But this vitreous was already stained because of asteroid hallosis. So whenever vitreous came into anterior chamber, it was removed. As you can see here, in this particular situation again, so the needle has been taken out, but IOL has not been pulled. Vitrectomy was done, and now the IOL will be pulled. So the loop around the haptic will pull the IOL and bring it in position. And then you pass a single knot, see the titration. You have to be careful in not tying very tight knots, otherwise it will pull it on one side. Now, another scenario that I would like to show is, this is a case wherein an inverted IOL is placed. There is no capsule. I don't know how this lens was stuck because of the uveal tissue, or somewhere it was stuck. This patient was referred to us with UGH syndrome because of that. So it was intrascleral haptic fixation was planned. The IOL was reversed in a proper direction. One haptic was taken out so that the IOL doesn't fall posteriorly, and then a groove and the flap was created here on one side and on the other side as well. So one haptic was exteriorized, and the second haptic was also exteriorized, and the haptics were tucked into the intrascleral groove placed in position, and fibrin glue was used to stick the conjunctiva in its position. So the patient did not have UGH. Later on, the patient did not have much reaction after that, and it went on very well. Now, some patients can have glaucoma. As I said, that some patients can have glaucoma, some patients can have endothelial decompensation because of that. So just a small clip regarding endothelial decompensation. If you have an endothelial decompensation, then you have to do endothelial keratoplasty for that. So an ultra-thin DSEK is being planned in this case. And then this IOL, which is touching the endothelium on one side, causing decompensation, will be removed. So sclera is marked at 1.5 and 3 millimeter positions. And then a lamellar scleral flap is created and a groove adjacent to it. Epithelium is being debrided in order to have better visibility. And then this paracentesis is done, and then the Desmase scoring will be done now. Yes, it is being done. And once the Desmase scoring is done, then the IOL is out. Okay. The IOL is being taken out, and then multi-piece IOL is introduced, and the haptics are exteriorized on both sides. And then these are tucked, and once the haptics are tucked, then the donor lenticule is placed in position, and it is introduced into anterior chamber, and air is injected. So in conclusion, I would like to say that a decentered or malpositioned IOL has a huge spectrum of presentation, and there cannot be a definite rule that you have to follow or you have to do it. Surgeons have their own ways of handling it. They modify a described pattern or a described method. The basic idea is to have a well-centered IOL and also to manage associated complications. And since these cases can have their own issues, so a good patient counseling is very essential in order to have a good outcome. So thank you very much once again for your patient listening, and I'm okay for any questions.
Thank you so much, Dr. Rajesh Sinha. It's a wonderful presentation, very nice videos, and you have made this complicated issue such in a simple way that we can learn a lot from this, and one can all of us can develop a little bit of your own technique. Like in many cases, we would like to, here in Allahabad, we implant a posterior iris claw lens in those cases where you have to explant the lens, which takes very little time. And it's a wonderful presentation. And lasso suture, I was always thinking how to apply it. So you have wonderfully demonstrated that. So thank you so much for your presentation, Dr. Rajesh.
Thank you, sir.
And with the, any question? Yeah.
Shall I?
Yeah, Punend, you may present your.
Thank you, sir. Thank you. I will share my screen. At the outset, I would like to thank MOS for giving me this opportunity. Am I audible?
Yeah.
Thank you.
Yes,
I will be sharing my experience of NRD IOLs. I don't have any financial interest in this. And pigmented iris diaphragm plays a vital role. It increases depth of focus, decreases chromatic and spherical aberrations. This is very, very important. And patients, they come to us with a partial or total aniridia, and it is a cosmetic blemish, as well as there is a decreased visual function like glare, photophobia, photopic retinal image that appears from the margin of IOL, and need to wear dark glasses all day while indoor doing near or computer work, and they develop headaches at the end of the day. Various options are available, like we can do tattooing, which is a temporary procedure, colored contact lens, which is again not a permanent procedure. We have to remove it every day. Foldable iris implants, they are available, but they are quite expensive. We can do iridoplasty if we have sufficient enough iris tissue available. And lastly, we can do an NRD IOL, which is the topic of the day. Colored posterior chamber scleral fixed NRD IOL. The indications are traumatic cataract with partial or total iris loss, which are commonly seen, or in cases of congenital aniridia, when there is large iris coloboma, in cases of herpetic iris atrophy, surgical iris loss or ocular albinism. And very first case is a child of 15 years old, developed a penetrating injury to right eye by a stick. Vision was hand movement, a full thickness paracentral corneal tear with traumatic cataract and total iris loss was observed. On ultrasound, it was found to be normal. A corneal tear repair with cataract extraction was done. And 2 months later, we planned a secondary IOL, which was NRD IOL, which was fixed to the sclera because they are. So this is the scar which you can see, which is present, and there is a total iris loss, only that this rim of iris is present here. We have to make a section which is large enough, almost 10 millimeter size, and at 2 places, 180-degree apart, we make a scleral tunnel. As you can see here, I don't make flaps, and I am using it either horizontally or vertically. We are placing the lens, and this is the lens, as you can see, with a eyelet in the haptic, and a proline suture is passed railroad technique, and the 2 ends are tied to the IOL. And this is a pigmented lens, and this pigmentation doesn't disappear over the period of time, and they don't produce any reaction also. The suture is tied to the sclera, which is around 2 millimeter away from the limbus on either side. So it remains away from the angle of the anterior chamber, and chances of rubbing of the iris stump or chances of damage to the angle of the anterior chamber is not there. So this is how the patient appears in the immediate post-operative period of a case of traumatic aniridia. We put 3 sutures or 5 sutures in the scleral tunnel as per the need, and which will be removed after a month or 6 weeks post-operative period. And we can use AC maintainer to place this IOL. As far as possible, we use very little amount of viscoelastic to save the cornea. So this is the post-operative picture of the same patient, improving to 6/9 visual acuity. Another case, 26 years old male, had a road traffic accident. Corneal tear repair was done. Patient developed uncontrolled intraocular pressure, secondary glaucoma. In this particular case, we planned a Ahmed glaucoma valve along with the NRD IOL. And post-operative at 6 months, with the patient improved to 6/24 with a well-corrected intraocular pressure. So this was a tri-radiate kind of a corneal tear. So we could save the eye involving the central cornea. And this is the AGV which is being placed here. A pre-placed suture for the AGV is placed at 9 millimeter away. Valve is primed and pushed behind, and a pre-placed suture is tied around the Ahmed glaucoma valve, adult Ahmed glaucoma valve. Tube is cut, and it is now placed inside the subconjunctival space. Then we make a scleral tunnel, which is almost 9.5 to 10 millimeter size, because the optic of this lens is 9.5 millimeter. And the haptics are very, very delicate. So we have to be very careful that it doesn't break during injection. So we make a roomy scleral tunnel. So this scleral tunnel is made at 6 o'clock, and our primary large scleral tunnel is at 12 o'clock. And by railroad technique, the suture is traversed from one side to other. The suture is passed, pulled out. The stump of the iris, which was present preoperatively, to avoid any secondary iritis, with this we have cut it, and This lens, the two cut ends of the proline sutures are tied to the sclera. Lens is pushed inside. AC maintainer will maintain the intraocular pressure and the anterior chamber. And corneal scleral tunnel is sutured. Then the lens is fixed to the sclera and the knots are buried in the scleral tunnel. The Hammett glaucoma valve is the tube is shunt tube is pushed inside, and a corneal graft, which is glycerin preserved, which cannot be used for optical or therapeutic purpose, is used to cover the tube to avoid any damage to the conjunctiva in the post-operative period, because there is chance of extrusion of the tube because of the thin conjunctiva. So this way we manage the, we planned a triple procedure with the therapeutic DSEC also, but it was not required. And with this only, the stump was cut, and this is the preoperative picture of the same patient. This is the Hammett glaucoma valve, and patient improved to 6/18 vision. Another case of similar type, but I will. Sometimes when our we have a sufficient amount of iris tissue available, and this was a temporal area where the patient had a traumatic corneal tear at the limbus, which was repaired. After 2 months, the patient came to us with the fibrosed anterior capsule and a hypermature cataract. The intralenticular pressure was high, so with the help of the microforceps, we did so the capsular access, successful capsular access was made, and the phaco aspiration of the lens was done, and then we used aniridia segments. In such cases, because of the temporal opening in the iris, these patients tend to develop photophobia and problem glare and photophobia and problem in reading. So to avoid such thing, we used in this particular case 2 aniridia rings. The hydrophobic acrylic lens is placed after placing the first ring, and this aniridia ring, they complement each other. The gap in the previous ring is filled by the another ring which is passed from the opposite direction, and it should be inside the bag, and they complement each other, and they cover the make a central dark area which reduces the glare and halo, and which reduces the light which goes inside. To conclude, aniridia IOL or aniridia ring segments restore quality of vision with less glare issues. It provides visual and aesthetic rehabilitation both. A proper case selection is important consideration. Preoperative proper case workup is important, and not all cases are suitable for this. Post-operative course depends on the intraoperative manipulation which we have performed. And secondary glaucoma is still a concern, although we didn't develop or we didn't face with such kind of glaucoma, maybe because we were away from the root of iris and the angle of the anterior chamber, and there was no vitreous around the lens. Thank you.
Very nice presentation to Narendra again. So it's a wonderful presentation and some very good cases. Dr. Rajesh, do you have any comment to make?
Yes, sir. Actually, I wanted to say that because I have a reasonable experience of these lenses. What I have felt that whatever Dr. Purendra showed, all were traumatic aniridia. And I also prefer using aniridic IOLs in traumatic aniridia. I'm a little hesitant in primary aniridia because of the stem cell deficiency and all that. So in those cases, these aniridic rings are very good. The last video that you showed was very good option, because I don't want to make a 9mm incision in such cases. The problem of glaucoma is there in only if it's there, only if there are pigment release, which has happened earlier in some of the brands, that there was some pigment release and that resulted in post-operative glaucoma. But in I won't go into details because of the brands and all that. But there are certain brands which don't release pigments, and that way, in those cases, I'm yet to see a case of glaucoma. But yes, I think in primary aniridia, I will prefer doing rings rather than aniridic IOLs.
Absolutely, because to do a phacoemulsification and put a ring is better option, safer option. And in primary aniridia, I have done couple of cases with rings only because of the large size. It is so we do it only when there is subluxation or the absence of the posterior capsule, or when there is grossly dislocated or subluxated lens with aniridia, then only we can think of this. Thank you, Dr. Rajesh, for sharing your experience in this.
1 minute. Is it a black PMMA or it's a pigmented lens?
It's a pigmented lens. From this is from IOC, IOCare.
That is why I'm asking you. As far as I know, it was a black PMMA. We need to find out from the company whether it's a black PMMA or it is a pigmented lens.
I think it is. It's a pigmented lens. Black PMMA, and what is the difference between the two? What do you mean to? I am not able to.
The material itself is black, and there is a central one which is a different material. That is what I.
No. This is, I think, the paint is what I feel is that it is not totally pigmented.
I know the
surface
central portion is clear.
Yeah, central portion is clear.
The second thing is there is one more thing. Can I add one thing? Dr. Ravijit Singh's brother has made a very nice iris claw segment for this aniridia segment.
That's
a 3 or 4 size, and he fixes onto the edges of the iris, gap portion of the iris, and that is wonderful. I have seen that.
Yes, that is Kiranjit does that.
Yes,
that's the coloboma side of things.
Coloboma.
Yes.
Now that is good. And sometimes we get aniridia rings also, in which one segment is there, which is broad enough, and it covers the aniridia part of the lens. So that has to be fixed inside the bag. That also is available.
Aniridia, it is really useful, particularly if you have, in one direction, in one meridian, if there is iris damage, then the segments are on opposite side and they are fixed like that. You put it in the bag, so you have these segments covering up for the iris in the same meridian. So it works very well.
Dr. Daljit Singh used to put the color intraocular lenses, anterior chamber iris claw lens, or
yes,
he used to put these color lenses to reduce the photophobia in albinism patients. And it was coming from Holland, and the manufacturing was such that the whole lens in the center was pigmented, over which the PMMA plastic sheet was impregnated, so that no pigment is released from that lens. I'm talking of some 25 years back.
I think that is very brilliant idea.
It's a brilliant idea.
Yeah.
That is how the IOCare lenses also are. There is that brownish black pigmented circle which is within the PMMA. So it's not on the surface of the PMA, but it's within the PMA.
That is exactly what I wanted to tell.
Similar to how your scleral shells are made.
Yeah.
So this is the reason why it doesn't, the pigments don't release, because it is embedded inside.
Yes.
We're running short of time also.
Thank you.
Can I have Dr. Kamaljeet Singh?
Yes, I am there. Am I visible?
Yes, sir.
Very well.
Your screen is not.
Thank you so much. So it's a very, very old topic of refractive lens exchange. The history dates back to 1708 when it was described first. But then it was perhaps not a good technique of cataract surgery or extracapsular cataract surgery. So this was a failure most of the time, and many of us saw lots of retinal detachment in these myopic patients. So there are several evolution has taken place. There are so many techniques available to the patient these days, starting from the PRK to the LASIK to SMILE. And in the year 218, I found
So we can't see your slides.
You cannot see.
Your screen is not visible.
Oh,
Screen sharing has to be done.
How to go back then?
So you can share your screen.
Okay. Ensure.
Somebody from Neurotech, are you there? Could you just help out?
Can it be seen now?
No, sir. No, sir.
No, sir.
It's
So
not showing.
you stop sharing, and then I mean it's not being shared. You open the presentation, then click the share screen, sir.
Okay.
There's a green arrow.
Button. Green
Yeah,
button in the bottom. Just click that. Then
Open the PowerPoint first.
that is opened.
That was open, but I don't know what mistake I'm doing.
No, you just open the presentation first, sir.
Presentation.
Don't make it full screen. Just open it.
Ruchit, can we go for the next presentation?
Yeah, I'm coming in.
Okay.
Yes, share the screen. Blue understand.
Yeah.
Yes, sir. Yes, sir.
You can see
your
your
screen sharing has started. Now you can open the presentation there.
So
yes, sir. Maximize it.
So this was the title page there in the Cataract and Refractive Surgery Today magazine, and in the year 2018, and they said that is the lens surgery, the new LASIK. Why it is so? Because these days what we are seeing is that the lens-based surgery has become very, very important, and the advantage is that the cornea does not get affected, and you have a very good technique of phacoemulsification, and therefore the surgery is so easy that you can easily implant these lenses. So what are the indications? Usually in a myopic patient, if the patient is more than 50 years, then we plan refractive lens exchange. But it's good for hypermetropic patients because there you cannot put a phakic IOL in those patients. So in a hyperopia, if the patient has got 3 diopter for distance, and at the age of 50 years, 2 adapter is added for near thing, then it becomes a problem to the patient, and therefore we have to think of doing, if the patient wants glass-free life, you can easily do an refractive lens exchange, and it gives a permanent option. You don't need to do phakic IOL in these cases. So, and in these cases of hypermetropia, you have crowded angles, so there are chances of having glaucoma. So therefore, this becomes a very good technique for these patients. So if you have this thing, a hyperopic patient, and as I was discussing, you can do this, or if the patient is myopic. So at the age of 50 years, he says that, Leo says that, why should I do a phakic IOL and corneal surgery? So it's better to do a refractive lens exchange, and this will help this patient. The problem in hyperopia is that if you do other techniques, then you get a total higher order optical aberrations are there, and therefore RLE becomes very, very useful technique. And the complications like retinal detachment and CME is lower than in myopia. They say that the chances of detachment increase in myopic patients, and CME also occurs in these myopic patients. So it's much less in hypermetropia, so it can be easily implanted. So what we have to do is that we have to exactly do a proper biometry. Several formulas are available to do good biometry for hyperopic and myopic patients. And so therefore, refractive lens exchange is easier. If the LASIK has already been done and then you have to do a cataract surgery, then it becomes difficult to do a good IOL biometry. And so the indications basically are myopia of more than 8 diopters, hypermetropia of usually 5 diopters. And in those cases, I have tried in high anisometropia in myopic patients, also in younger patients, I have tried and I have found that it works very well. And so therefore, this can be used as an alternative to LASIK and LASIK in these conditions. So this was my first case wherein he was a 37-year-old male. He had quite a large myopia, about minus 12.5 diopters, and he was having right divergent squint also. So in this case, the other eye was having 6.6. So this was my first case. I tried doing this, and despite having such squint in this patient, we did a refractive lens exchange, and to my surprise, the vision was 6.9. So this encouraged me a lot, and I did lots of surgeries in younger patients between 30 and 40 years old. And a special mention has to be made in anisometropia, where you can do, in a poor patient, you can do refractive lens exchange easily, because patients cannot afford a phakic IOL in these patients. So the contraindications are very young patients, and if the axial length is more than 29 millimeters, and if there is history of detachment in the other eye, then you should not perform this surgery. Then pre-operative work is essential. SRK-T formula is used for high hypermetropia, and Hoffer-Q is used for high hypermetropia, and SRK-T for myopia. So these are the formulas that I have been using since long, and I'm very much satisfied. These days, several new formulas have come, and you can use them also. And for me, the target post-operative refraction, because we are implanting monofocal IOL, the post-operative refraction is around -1 diopter, so that the patient does not have much problem for near also. So we have implanted lots of monofocal IOL in these patients. And when the multifocal was required, then we have add plus 2.5 for intermediate vision, and add +4 for those who like to read while lying down. So elderly patients, we can use this lens, and patient gets sharp vision. So biometries, these things are essential. And in myopic patients, we have to do, because the lenses are usually very soft, and what we do is that we make a slightly large capsular axis, and tell the patient that there are chances of 20% chances of enhancing by LASIK if sometimes there is some error in the calculation, so that may be there. And the technique is very simple, and what we have to do is simply, this is a refractive lens exchange done by me about 10 years back in a young patient. And I always use capsular access forceps. And what I do is that, since I am a person who is doing lots of SICS also, so what we do is that we simply do phacoaspiration by prolapsing this nucleus and epinucleus into the anterior chamber, and can finish off the surgery very easily. So this is the normal technique that we are used to doing without any problems, and the complications are much less. The incision is so small that it will not cause much of the turbulence in the anterior chamber, and therefore the chances of detachment is not there. So we do a biomanual this thing, and you see, just prolapse the nucleus out of the bag and aspirate it. It becomes easier, so there is not too much of turbulence in the anterior chamber, because the turbulence might create detachment. So a smaller incision and phaco technique is very, very useful in these affairs. In chronic angle closer glaucoma also, this is a very useful technique, doing refractive lens exchange. And they say how much the IOP is reduced by doing this in glaucoma. It's about 20% reduction in IOP. So you can do this, and this avoids the lifelong risk of bleb, which may not be required if you have done a cataract surgery in a patient who has got it. I don't have much experience of this angle closer glaucoma, but other experience I have. The complications, as I already enumerated, are RD and cystoid macular edema and posterior capsular opacification. And so it has been said that the detachment chances increase if the axial length is much and patients are younger. But if the intraoperative rupture of posterior capsule is there, then only the chances of detachment increase, as this study suggests that this whole thing was done. And it was found that the incidence is almost the same whether you do a IUL or not. And the rate remains about 1.5 to 2% in most of the studies. The controversy was because in the initial few years when the surgery was done, the detachment was around 8%. So that was the problem in this study also. In by Paulin et al, it was 8%. But in many others, there is 0%, and so little detachment is there. In my cases, my experience of 25 to 30 cases, we have found that the detachment incidences, only one patient I had detachment after 5 years. So if you continue doing good indirect ophthalmoscopy and laser photocoagulation, then the chances of detachment are not there. Now the other question and the is asked by the people is the post RLE PCO. So with these good lenses and the technique that is there, you may require YAG laser capsulotomy. But if you have a condition like this where you have ethnic pearls, you don't need to do YAG laser, and you can simply peel these ethnic pearls off, and the posterior capsule will remain there, and you will not have much problem of doing YAG laser and having more incidence of retinal detachment is not there. And therefore you can have the two segments in the two chambers, the anterior chamber and posterior segment. Both the segments would be there, and therefore the chances of detachment are not there. This we have been doing for almost now 10 years, and the results are good, and the chances of detachment can be reduced in this way. In a fibrotic PCO, yes, it becomes problem. Then you have to do YAG laser, and you must do a smaller capsulotomy in these myopic patients if it is required. So refractive lens exchange is a very good option, and one can do if the patient is slightly elderly. In young patients where you have anisometropia, in hypermetropic patients, you can easily do this surgery. And in myopic patients, you have to do a good indirect ophthalmoscopy and check the retina, and then you can do this surgery. Thank you so much.
Thank you for a great talk, sir. Any questions for sir?
Share कैसे है?
So stop share, same button. Done. Any questions for sir?
So any questions?
I think
with all the refractive surgeons sitting there, I am talking about refractive lens exchange. So you must be surprised.
RLE is definitely the last option for refractive surgeons, sir.
Yeah.
It's definitely the last option, but it is still a viable option. And because there are many patients who even can't afford any of the refractive procedures. They are poor, having -18 diopter of myopia, -16 diopter, -15, 16. They want to get rid of glasses, but they cannot afford anything. I mean, that is definitely an option. Then apart from that, you showed one unilateral
Yes.
case with
Yeah.
So,
I have a series of 10 patients of such kind. There is right divergent squint, and we do surgery and the vision improves. I don't know. I'm working in strabismus, but I was so much surprised to see this, because they say that in myopic patients, the vision usually improves. They have good fixation for near, so maybe that is the reason that the vision improves.
that is very true, sir. And -15 diopter of myopia will cause magnification and all sorts of things.
Yeah.
So, I mean, it's really helpful for the patient. Patient is happy. So,
I have an appeal to be made. Hello?
Yeah, please.
Yeah.
We request all the delegates who are attending this conference to vote for Dr. Lahane for Vice Presidents in the forthcoming AIOS elections.
Definitely, sir.
Very nice appeal, and we are always there.
Thank you.
Rajesh will not comment on
Thank you. No, but Dr. Tawaljit, I really appreciate the way you have said, and for a country like India, our country where the cost of refractive procedures are high and affordability is less.
And the chances of detachment are not there.
It's not available. Availability is also not there at all places.
And one-time surgery, you don't need to remove the IOL, the phakic IOL, and then do cataract surgery later.
But I think I will restrict this option for the last, as Dr. Rajesh has said. And secondly, I will restrict it to hypermetropic cases.
In elderly patient, why would you put a 50 years old patient? Why would you put a phakic IOL?
I think there are 2 or 3 clear indications. One is high hyperopia. Second is presbyopic hyperopia. And even in presbyopic myopic cases, we can think of it, but not younger than that.
Not younger.
Patient, yes.
Yeah, in myopic patients, it will be I will not prefer to do it. I will never prefer to do it in myopic patient. That is my observation.
There are so many articles coming in the press and the journals that this is a very good option now.
And
so, not in younger patient. I don't say that you do in 20 years.
Patients.
Thirdly, lens has to be put there. Even the power is 0. That helps to prevent PCO.
Yes, that
so
will
lens
prevent
has to be
PCO.
placed there. That's for sure.
Yes.
Kawaljeet, what is the lens of your choice?
Actually, in the initial few years when the lenses were costly, I used to put a hydrophilic lens, but now I am putting just the hydrophobic monofocal lens and make the patient, I try for a monovision if the bilateral surgery is to be done.
Dr.
360 degrees square edge.
And I go ahead without any problem in a patient who is anisometropic.
Dr. Rajesh, will you go for 3-piece or a single-piece lens in these cases?
See, the thing is, it depends on the availability. Somebody who is having minus 15, 16 diopter of myopia and you are doing a lens extraction, or minus 20 diopter of myopia and you are doing a lens extraction, then the power that is available is mostly in the focal series, actually. Not multifocal.
Hydrophobic, yeah.
Hydrophobic acrylic multi-piece.
Multi-piece. That's what you asked, no? Multi-piece or single piece?
And in some cases, you need to put a CTR also to stabilize the bag. In a large.
You asked multi-piece or single piece or multifocal, monofocal?
I use, I don't know what the question
is. I just slipped out of my mind the question.
You asked whether it's multi-piece or single piece.
Yeah, multi-piece.
No, yeah. So is available. That's all.
It depends on availability. High powers, high myopes.
You can't.
In those cases, you have multi-piece available. So you put multi-piece.
One point.
I think Dr. Shah wanted to say because the overall size of the bag is larger, so single piece lenses, they are unstable. I think Dr. Shah means to
raise this issue. Put a CTR also in these cases.
PCO is also much less with 3-piece, I think.
Yeah, that's right. So absolutely right.
The size is a little bigger, so that can stretch the capsule also.
Yeah.
Now we go to the next speaker.
Sir, there is one question. Can we take that?
Yeah, please do that.
Yeah, the question is refractive lens exchange an option in ophthalmos, or must one wait for cataract to develop as the chance of surgical complication is high in ophthalmos?
Absolutely. I will take it last.
Yeah.
If unless until the cataract is there.
So first do a sclerectomy or whatever.
Yeah, that is where you have a chance of choroidal hemorrhage in these cases in anophthalmos. So you have to do a pars plana, this thing, and then you can go ahead.
Okay, now we go to the next presenter.
Dr. Vinod Arora.
Vinod Arora.
Okay, he has already started sharing.
Yeah, good.
Go ahead, sir.
I just want to share that. Today's topic is toric IOL tips and tricks. It's basically for the beginners, not for very experienced. They know all the tricks, but I'll share a few tips. So astigmatism is quite common in cataract patients. So more than 1/3 of the cataract patients are suitable candidates for the toric IOL. If you bring down this limit to 0.5, I think it may be more than 50%. So toric IOL has to be put in these patients. So astigmatism can be managed. Astigmatism can be managed by steep axis surgery. We had a very good discussion in the previous session. Then astigmatism keratometry or LRI can be done, which can be combined or can be done after the procedure, which causes reduction in astigmatism. And laser refractive surgery and toric IOL done to eliminate the astigmatism. So these early, say, steep meridian astigmatism keratotomy or LRI, they reduces the amount of astigmatism and are quite helpful. These two things can be used is to totally eliminate the astigmatism. In toric surgery, precision is the key. So any alignment causes gradual reduction in the effect. If we reach at 30%, the effect is almost lost. And sometime it has been placed on the 90-degree because there is a confusion. In the previous session also, we had some confusion whether it's the axis or the meridian or something. So if you're not clear, and sometimes for the initial surgeons, it has happened, and the effect may be doubled in these cases. So managing ocular surface, I think, is the most important aspect of toric IOL implantation. This is the most important. An unhealthy surface will lead to surprises, will not get a proper reading, and will end up in surprises. We should utilize all our basic or advanced equipment to get the precise information for perfect planning. There should be accurate alignment, and IOL chosen should have good rotational stability. That's again very important. So for preoperative workup, precise orientation of the astigmatism correcting intraocular lens. On the axis of plus cylinder, that's very important. It has to be placed on the axis of plus cylinder, essential for maximum effect. Many of the present methods for determining the correct axis are time consuming and often fail to place the marks in the optimum position for accurate alignment. So these are some exclusions, like we have to exclude and do the proper case selection. Counseling is again very, very important. Then prior use of contact lens has to be discontinued. For soft contact lens, we discontinued for 1 week. For GP lenses, we have to discontinue at least for 4 weeks before doing biometry. And special care should be given to dry eye. If it's there, we have to manage it first. Then we have to prevent the CME. The rest of the things are same as we do in cataract surgery. There's some relative exclusion, especially for beginners. Don't do it in irregular astigmatism. In post-refractive surgery, it's not recommended for beginners. Corneal edema, if there is a corneal dystrophies, and surgical complication are there. Suppose there is a pupillary damage, there is a PCR, vitreous loss is there is general instability. These are not good candidates for toric IOL implantation. Proper power calculation, proper keratometry is essential. The manual keratometry is very, very accurate. It should be calibrated properly time to time. Automated keratometry is more popular because it's easy to do. Topography helps to give a wider picture and accurate estimation of the axis. The posterior corneal surface has astigmatism against the rule we have to keep in mind. And with the modern machines like IOL 700, this has been incorporated. But still, if you are using older machines, we have to adjust this thing. If it's with the rule group, then we have to overcorrect by 0.5 diopter. If it's against the rule, then we have to mean undercorrect by 0.3 diopter. These are rough estimates, but it's quite helpful. There should be regular calibration with phantom eye. This is very important. Every instrument, whatever you use using, there should be proper calibration. Sometimes we leave it over opticians or optometrists, and they keep on doing. We don't care about these things, but this has to be calibrated from time to time. At least 3 readings should be taken, and average is used for calculation. It should be done before applanation tonometry. So nothing should be placed on the cornea before we are going to do optical biometry or anything. So we have to make sure about it. We should ask blinking before reading, because especially patients don't blink once they are watching on that our optical biometer. So we ask them to blink 3 or 4 times, then take a reading. Critical approach to automated measurement should be there. We should make sure that these are confirming different readings. I would say if we're getting different reading, they should confirm it. Sometimes what happens, preoperative calculations, the moment we talk about preoperative calculations, we come across with many diagnostic equipments available in our clinic. And we are not very sure which instrument to consider as the best equipment. So how to proceed? So if we are getting different, if we are getting different readings, we have to rule out whether the machines are properly calibrated. And very important, if the head tilt is there, it's very, very common. We are busy in our machines, but we don't look for the basics. And if there is a dryness, we have to rule it out. If there's a dryness, we have to manage it first. Then there may be microsquint also. And poor vision may be due to dense cataract. There may be macular pathology and eccentric fixation. So all these things has to be ruled out if we are getting a different readings. Then these are the optical biometers, very, very good, very, very accurate. It makes the life very easy. IOL Master 700 is with total keratotomy. We can have the keratotomy from the inside also. That's a very, very accurate. It utilizes swept source OCT. And we have Barrett TK Universal and Barrett TK toric formula incorporated in it. At present, SRK1 and SRK2 formulas are obsolete now. So for a surgeon who's going to start toric surgery, calculating SIA, that is surgically induced astigmatism, is very, very important. We have to remember that no incision is truly astigmatically neutral, whether you make it in temporal, whether you make it on the axis, but it causes some effect, maybe less on temporal side. There's a beautiful site called drhill.com. This is a site where you can download the form and do your initial 25 or 50 cases, fill all the details. And it's better not to change your surgical techniques. You keep on making incision on the same site. Suppose you're making on 90 or 110, you keep on making on that site only. So you'll come to know what is surgically induced astigmatism. This is your special A constant. So you have to adjust in every case. Then these are the forms available. I will say these are the calculators you can very easily get online or offline also. This is Hoya. It's an offline one. You can easily fill it. And you can have the option of overcorrecting, undercorrection, whatever you want, you can adjust here. Then almost all the companies which provide toric lenses have their own calculator. You can use them, or simply on a smartphone, you can have iToric app. That's again very helpful. These are the various forms available once you go online. You can get a proper planning of your IOL. It's freely available. You can use any lens, but you can get these things very free. And you can easily see where your lens has to be placed. You can see the proper direction. It will suggest you the type of lens which should be done. We have to remember that the corneal astigmatism and the lens astigmatism are different things. Where we are putting a lens, the plane is different. So we have to follow these instructions and not our keratometry reading only. So question comes, how to mark in this? There are two methods. One are the basics ones, which requires marking on the cornea. The seconds are the without marking, we can do that one. Those are called the digital ones. So these are placed on the limbus 2 or 3 locations and 90-degree apart. Normally we do at 3, 6 or 9 o'clock marking. Marking is always done in sitting position with head states. Never do it in lying position to avoid the cyclotorsion. These are various types of markers, not very popular now. This uses a bubble mark. This is a gravity based. So many times that these manual marking are bubble and pendulum is not so precise as we want. This is attachment which can be placed on the slit lamp and you can mark on the cornea directly without touching anything. And this is normally what we do. Slit lamp is a very good option. We just can directly mark or we can place it on 90 or 180 axis. There is a calibrated mark on it. The patient has to close the other eye. That's important. You have to fix with that eye. Sometimes it's not there. We have to close one eye. So we see a bright corneal light reflex. We have to use a fine marker. That's again very important. Thick markers are giving a smudge that causes a lot of problem. If you got a smudge, then you can use a needle. That's a 20 syringe of insulin syringe or anything. You can mark with that one. So that will be there even if the things are washed. So we place on nasal side, then we do it on temporal side. And if you get 2 or 3 marks, that's very common initially, then you can use a needle that's giving you permanent mark. Then head position is very, very important. Often we neglect it. You have to take a help of your assistant or staff also. That the patient keeps at his position state. If patient keeps as tilted, that's everything is going haywire. Whatever the equipments you use, whatever the instrument you use, you're not going to get a proper reading. So these are the basic simple things which are very, very important. Now this is the placement of axis. It's not on the Purkinje images. So that's not a proper thing. Then it should be aligned like this. It should be proper on the Purkinje image. That should be the center. That is show you are in the right position. But what happens with slit lamp? Sometimes it may not be totally horizontal. I mean, say your plane of stool or table, whatever you're using, may not be perfectly horizontal. So you have to verify it, whether whatever you're doing, suppose you're putting it at 180 degree, it's not or there. There is a beautiful instrument. This is a gravity driven. It's from Joda company. You can attach it to slit lamp and you can just verify whether your marking with a slit lamp is pop or not, or if there is some problem is there. So you can verify.
Sir, we are running late. Could we summarize?
Okay, sir. Okay, sir. Or if it's not rare, you can simply use a smartphone. There's a marking on it. I'll just come to that one. This is the intraoperative marking. Then toric planning, I'll not go because this will be covered in the next talk. So this is a smartphone, very, very good. You can use it and it's as good as any digital marker is there. You can place axis and mark. You can analyze the post-operative result also and see whether it's properly aligned or not. This is again by a TriCam by Graham Barrett. Then these are intraoperative marking system. So IOL alignment, we have to leave it little short of final adjustment. Then we have to remove the OVD and we do the final alignment. It's better to do a viscoless. That's a hydroimplantation. There are less chances of rotation and less chances of IOP there. This is the Ganesh mark is there. Sometimes what happens during surgery, the people constitutes and you find it difficult to see the marks and it's become very difficult to align the lens. But if you place a mark on the lens, that mark remains there during the surgery and you can very well align even in the smaller pupil. Eye test, I'll not cover it. Then rotational stability is very, very important. And we have to be very sure if there is any rotation, it will cause decrease in the effect. So post-operatively, the toric analyzer can determine the amount of IOL rotation if it's required and the expected residual reflection. We can see with this one whether there is any need for rotation or not. So I'll not cover because it's being covered in the next talk also. So Ultima is a prefix. You have to place it only on 180 degree axis. The cylindrical is provided by the company. And post-operative surprises. If there is eye rotation, you have to rotate after 1 week. The reason being, because by that time, some fibrosis is there. And if you rotate, the lens will stay where you want to have it. The other options, if you got surprises, then you have to change the IOL, or you can do piggyback IOL, or you can correct it with laser vision correction. To sum up, toric provides great rotational stability and optimization with accurate reflective results. It's now a premium lens, but standard of care, it's not a premium lens, but it's the standard of care in cataract astigmatism patients. Taking care of ocular surface is at most important for good results. Toric IOL provides unique spectacle independence and quality of the life, leading to more patient satisfaction. We should all incorporate toric IOL in our practice. Thank you. Thank you very much.
Thank you very much, sir. Do we have Dr. Nagendra Prasad logged in? I can't see his name in the participants. Fine. Dr. Sujata Mohan, madam, are you ready with the presentation?
I'm ready, sir. I've been ready.
You can share the screen, madam.
Okay, yes, I can share my screen. Okay. Are you able to see my screen?
No, madam.
No?
Now it is. Yes, now we can. Go ahead.
Okay. Thank you, and thank you, BOA, and thank you, Dr. Ragini, for giving me this opportunity. My topic is on dislocated IOLs and fixation techniques. At the beginning, I would like to confess, this presentation is very similar to Dr. Rajesh Sinha's, and his is definitely far better than mine. So I'm just going to demonstrate 3 cases which we had a dislocated IOL in which we fixated the lens without opening the eye. So it's an ab-interno technique of using 2 approaches. So the first was a case of a 70-year-old male who had a phaco foldable done 15 years back. He had 6/6 vision. There was no history of trauma, but he complained of oscillopsia or shaking vision for the past 6 months, and he also had pseudoexfoliation. Here you can see the video showing how it's a multi-piece lens, and you can see how the lens is shaking as he's moving the eye, and that was disturbing him. So we decided to go in and plan a glued IOL that is fixating the same IOL and prepare the eye to receive the glued IOL. A posterior infusion line was inserted. And Chariot's pockets were created, and a sclerotomy was done under the flap. And you can see using a second instrument, I'm lifting up the lens very easily and I'm placing it on top of the iris. So the whole bag was so weak. I tried to remove the bag using a cystitome in the beginning, but I was not able to remove the bag. It's important that we remove all the lens material all around the lens. So I used a retractor to remove as much of the posterior capsule as possible so that the lens will get freed and I can glue the, exteriorize the haptic. Once I could do that, you can see that one haptic I was able to hold on to it at the tip and I exteriorized it. All the time holding on to the lens so that it doesn't fall down. And the second haptic, once we've exteriorized it, the second haptic using a handshake technique, I held on to the tip of the second haptic and that was also exteriorized. And after that was done, both the haptics were tucked into the Chariot's pockets. The remnant of the capsule which was there, I had to do a vitrectomy. There was absolutely no vitreous at all in this case. And the case was complete without any complications. And we just had to make 2 side ports and the lens was glued into position. And the post-operatively, next day the patient had, you can see the lens is in position and you can see a very nice centered IOL and absolutely no movement of the intraocular lens. And he regained his 6/6 vision, but without the oscillopsy that he was complaining about. So the next case is again a 75-year-old female who had a male who had drop in vision, which was worsening over a 2 months period. And on examination, he had a dislocated IOL back complex, as you can see here. This is a hydrophobic lens, and because of the pseudo exfoliation, probably the whole IOL bag and complex had just shifted down a little bit, and that was definitely compromising his vision. So I decided to go for the Hoffman's pockets. Just a little bit of explanation for those people who are not aware of what are Hoffman's pockets. In Hoffman's pockets, we create a limbal incision and make a scleral pocket above the conjunctiva and sclera. The scleral pocket is about 1/3 the thickness of sclera, say about 300 to, for anywhere between 300 to 500 microns. And once this creation of scleral pockets is done, which is about 3 to 4 millimeters, a 26 or a 27 gauge needle is inserted through the roof of the Hoffman's pockets, through the conjunctiva and sclera, and enters the eye, and through a paracentis which has already been made, a 10-0 polypropylene suture is introduced, and it is looped around the one portion of it goes under the haptic, and it's docked onto the 27 gauge needle. The other portion goes over it, so it forms something like a lasso around the haptic. And you can see that both the loops are out now. Once both the loops have been out, what we can do is, now that there is a traction and the lens is pulled towards the sclera, you can retrieve both the ends of the sutures and you can suture it. This is the same thing is done on the other side. So before you suture it, tie it down, it's important that you center the lens properly and you don't put too much of tightening on one side. So there's just a small video to demonstrate our case. So I'm creating Hoffman's pockets. The only problem with Hoffman's pockets, sometimes it can bleed quite badly. I'm using a crescent knife to create the pocket, which is about 3 to 4 millimeters. And it's always better to check, once you've done the pocket, it's always better to check how much of the pocket is the length and width of the pocket, making 2 side port incisions as well. And you can see that the 10-0 polypropylene is passed through that and docked onto the 26 gauge needle. First one going above the below and the second one going above the intraocular lens haptic. And as it is pulled down, you can see that the lens is moving so much. It's already so much loose in the anterior chamber. And now the sutures are retrieved from under the Hoffman's pockets. This can be done even later. You can always do the other side and also we can retrieve it later. And then the same procedure is done, repeated on this side. You can see now more clearly that the 27 gauge needle has gone under the haptic and the 10-0 polypropylene is threaded into it, it's docked into it and pulled out. And see, once more it's entering, now it's on top of the haptic. So it's the 10-0 polypropylene is now looped around the haptic. And this is retrieved from the pockets and center the lens very well, and then you can suture, you can tie the knots. It's a very simple procedure, and it can be done for multi-piece, for single-piece lenses, hydrophobic lenses, and has excellent results. So this is again third case where there you can see the dislocated IOL. I think it happened in the primary surgery itself, and over a period of time, a period of 2-3 years, it is dislocated. And now I'm retrieving it from on top of the iris. I think one portion of it was kept on top of the iris and looped into the PI, which sometimes some of the surgeons do to avoid putting another lens, and making a sclerotomy under the flap, doing a little bit of vitrectomy to remove all the capsular components, and catching hold of it's quite similar to the first one. And using a handshake technique, you present the other haptic, which is again exteriorized. The first one I did a posterior infusion. This one is an anterior segment anterior IAC infusion. You need an infusion. Without the infusion, you can't do a glued IOL. And it's tucked into the chariot's pockets. And the case is over. So this is just a few of the cases that we had, which are managed ab interno with totally different approach. And all patients regain their 6x6 vision without any complications. So summarizing, dislocated IOLs can be managed by different techniques. Using the same IOL is the best option. What I found was the hydrophilic IOLs cannot be fixated in the same way that we showed, because they have a very flexible haptic, and also this some of the hydrophilic IOLs made by the Indian group is actually folds when you try to do it, so it cannot be fixated. It has to be explanted, and you have to probably put in another IOL. Thank you.
Thank you very much for the nice and concise lecture, madam. Any questions from the audience? Otherwise, we can call this session over.
There is one question for Dr. Kamaljeet, sir, from the audience. Dr. Kamaljeet, sir.
Thank you, Sujata ma'am.
Thank you, ma'am. Thank you,
Thank you, everyone. Actually, I am busy in 2 sessions simultaneously.
Okay, sir.
So there is one SICS, the other one is FECO in Goa. And today we had 4 sessions of SICS. We should be so proud of SICS plus FECO, of course. There are a lot many sessions. So thank you so much, ma'am, Dr. Ragni and Dr. Lahane, Dr. Rajesh, Dr. Dinesh, Dr. Vinod, Dr. Shah, Dr. Sujata, Dr. Yogesh, and Dr. Punen, and Dr. Prashant, and Dr. of course. So thank you so much for this.
Thank you, sir. Thank you, everybody. Kamaljeet Singh, sir. Sujata Mohan, madam. RC, sir. Thank you, Purendra Bhaiya, Vinod Arora, sir. Thank you so much, sir. Thank you. Thank you, Rajesh Bhaiya.
Thanks, Ragini. One appeal.
Thank you, everyone.
Excellent presentations. All the delegates who are attending this conference, we request on behalf of BOA to vote Dr. Lahane for Vice President.
Yes.
Yeah.
Thank you. Thank you, definitely.
Thank you so much. Yes, we are one big family. Thank you so much. Thank you so much. Thank you so much, everybody. Thank you.
Thank you, everyone.
Thank you, Purendra Bhaiya, Vinod Bhaiya.
Thank you.
Waiting to
Have a
come
safe
back.
time.
Waiting to come back to Gwalior, Dehradun. Now it's been too long.
Yes. Absolutely. Absolutely. It's been long, and waiting to come to Bombay as well for the physical BOA.
Yes, sir. BOA. Yes. So Mumbai and everywhere. Thank you, Rajesh Bhaiya.
Thank you. Thank you for the opportunity. It was a wonderful get together and reunion for all of us.
Yes. No, you should never say that it's an opportunity. We are one family of ophthalmologists all over India, and we are all working. You all came in spite of the heavy schedule for the betterment of science, and you've been working so hard in AIOS, and you have a very big, brighter future in AIOS too, Rajesh Bhaiya. And we are all together, and thank you so much.
Dr. Rajesh, you have saved more or earned more? Dr. Rajesh, you are treasurer. You have saved more or earned more?
We are trying to save for the society as much as possible, but this year I don't think we will be getting too much. But yes, we will be spending also less because the conference is going to be virtual. So I guess the saving will be reasonable.
Sir, he's positive, his balance is positive. No problem.
The society is richer now.
Yes, very positive.
Thank you. All the best. Thank you.
Thank you so
There
much.
is time for Dr. Amey Kulkarni to take over.
We can leave the meeting till we meet again.
Yes, yes.
Thank you.
Excellent
Dr.
session.
Amey, you can take over.
Yeah. Good evening, everybody. I welcome you all to the next session that is going to be on practice management. We have heavyweights here. Good evening, Ragini ma'am. It's wonderful to have you here.
Sir, good evening, Amay. Good evening, Yogesh sir, Taswala sir.
Good evening, Ragini.
Good evening, Ragini.
Good evening, good evening. Good evening, Nana Sahib. Good evening,
madam.
Prashant Bhaiya.
Good evening, ma'am. Good evening.
Good evening, Dr. Bajaj sir. Good evening.
Good evening, ma'am. Evening, ma'am.
Good evening. So let's.
Good evening, all of you.
Hi, Pankaj. Pankaj is an integral part of BOA MOS. He is the treasurer.
Pankaj bhai is everywhere. Good. Pankaj bhai, Ragini and Lahane sir.
Sir, you are everywhere. You are our vice president.
Yeah.
Yes.
Yeah.
And since long he is everywhere.
So, Amay, we'll start the session. As the chairperson, I welcome all my co-panelists and all the esteemed speakers for the practice management session. I am sure it's going to be with all the stalwarts around. We are going to have a very rich scientific dialogue on all this. And I hand over the same. First of all, I would like to thank Professor Ragini, Professor Lahane, Dr. Preetham Samant, Dr. Swapnesh Samant, Dr. Parikshit Gopte, Dr. Sirish, the BOA and TMMOS for having this wonderful session and for making us chairman and co-panelists. Over to you, Amay, to start the lecture.
Thank you, sir. Welcome all. We'll start straight away. We'll start with Dr. Ashish Bajaj, who is a anterior segment surgeon, head quality assurance at the Sadguru Netra Chikitsalaya Chitrapur. He'll be talking on battling COVID the Sadguru way. Over to you, sir.
Good evening. I'll just be starting screen sharing. Is my screen visible now?
Yeah. Yeah, it's visible.
Yeah,
sir.
just yeah.
So, am I audible?
Yes, sir.
Yes, sir.
Please go ahead.
So, good evening to all. At the outset, I'd like to thank BOA and MOS and Ragini ma'am for giving me a chance to speak on this forum. So, I'll be just sharing the experiences at the Sadguru, how we are battling COVID and how we have battled COVID in the past 15 months or so. So, I'll just be going through the background of an organization and how the challenges we faced and how we have been handling the first and second waves and what lessons we have learned from this. So as an organization, we are situated in rural Madhya Pradesh. Apart from eye and healthcare, we also work for women empowerment and rural upliftment. And also we undertake a lot of social activities, which we realized are all the more important in this COVID pandemic. On the eye care front, we are one of the world's largest rural eye care providers. Having state-of-the-art infrastructure, we are also a postgraduate institute. We cater to approximately 300,000 patients a year and perform about 1.2 lakh surgeries annually. What were the challenges we faced? As we look at the timeline, COVID-19 was declared as a pandemic by WHO on March 11, 2020. And lockdown in India was initiated on March 22, 2020. So at this point, we realized that we are going to have some challenges in the form of being in a rural and remote area. We are going to have supply chain issues. We are a 275-year campus, almost like a mini township, and with 1,600 plus employees, containing the infection would be the first and foremost priority. So main concerns or area of focus were health and well-being of our staff, safety and education of our patients, and the most important was procuring the protective equipment as well as sanitizers, masks, and the medications. So handling the first wave, early March before the lockdown, our first priority was to procure all the PPE, sanitizers, masks, And as the pandemic progressed, we also were in the process of procuring all the medicines which were required. And as the clarity on the virus became more, that what all medications might work, we were already in the process. We realized that the personal protective equipment is going to be a game changer in the management of the virus and the pandemic. So we were already manufacturing our own drapes. So we upgraded this facility and started manufacturing in-house PPE, packing as well as sterilizing it. And also we started manufacturing masks and all the gowns which were required for usage within the hospital and the organization. Late March, as the pandemic set in and the lockdown was announced, we also had a mini lockdown sort of in our organization, because considering the size of our organization, it was imperative to decrease human traffic. So we only cater to emergency services, build a protocol on the basis of fever, on whom we are going to see and whom we are not going to see. And also we came up with a fever clinic on the premises. And late April to May 2020, as the government allowed us to open up the OPD services, the first and foremost priority was preparation. First, we made up COVID guidelines within the organization, taking inputs from the various organizations who had already shared the knowledge regarding the virus. Secondly was the facility preparedness. We took the triage and the registration separately, made temporary hand washing facilities, and also put screen guards wherever our employees were there on the registration counters. Of course, thermal screening continued to be done at the main gate of the organization. There were revised SOPs and guidelines as far as procedures and triage was concerned. And this, I am sure all organizations must have gone through that. Also, the disinfection and PPE protocols were revised. We divide the hospital into 3 areas: the high risk, moderate risk, and low risk, and accordingly devised our protocols and the PPE protocols depending upon where the staff was working. Once the OPD services resumed, they were the ones highlighted in red were the key areas. A separate entry and exit was made. We had staggered duty rosters to avoid exposure to all the doctors or the staff. No mask, no consultation policy, 1 attended, 1 patient policy, and an open door policy. At that time, there was a lot of work around the virus spreading through the surfaces. So we also took up comprehensive fumigation of the facility at the end of the day. These were the few of the innovations we had at that time. We converted old refrigerators into UV chambers. We made our dispensers of sanitizers. We even designed an in-house isolation OPD where there was a screen between the patient and the ophthalmologist to minimize cross-spread of the infection. In the optical shop also, there was a number of changes we brought about, but the 2 most key ones were a paperless prescription, because at that time there were a lot of concerns regarding the virus spreading through paper, and also a 3-tray system for frame cleaning. Once the OPD services resumed, there was also elective surgeries which resumed at the end of June or July. Again, there were certain changes which we had to make. We preferred daycare surgery, changed the outlook of our wards, increased the gap between the beds in the general ward, prevented the private sharing of rooms, and also changed the PPE attire for our staff as well as what the patients should be wearing. So you can see in this case how in this photograph or slide, how in pre-COVID era the PPE was and how it was in the post-COVID, and how the patient attire it changed altogether. We also made a separate PPE kit doffing area to prevent contamination at other areas. Once the unlocking continued, we also realized that sustenance of vision centers was important, and also unnecessary patient visit to the hospital had to be curtailed. So we also decided to open up the vision centers, replicating what we had done in the base hospital to the vision centers. We have close to around 60 vision centers spread across Uttar Pradesh and Madhya Pradesh. This would also help us in following up of the cataract surgery patients, and patients with minor refractive errors and minor ailments could go to the vision center rather than coming to the base hospital. At the same time around, we also adopted new technology, and telemedicine connection with the vision centers was initiated. It's still in the process, but as COVID-19 is here to stay, so it will help us in curtailing unnecessary hospital visits, and the patients and the staff both can be safe. Once the unlocking continued, so community ophthalmology and outreach is our hallmark. We undertake about 4,000 eye camps annually in Uttar Pradesh and Madhya Pradesh. So there were a lot of restrictions from the government, which were understandable. So we took up 2 innovations, that we took up community ophthalmology patients through the vision centers and door-to-door screening with full precautions. The patient was given a travel allowance to come to and fro from the hospital. And this is how the underserved people, they were not left out during the pandemic as well. Although we could see that we got a lot of mature and hypermature cataracts and advanced cases as far as glaucoma and retinal disorders were concerned. Beyond October 2020, again, the high volume OPD and surgeries were a challenge. So we shifted our free OPD complex to a larger complex. Rest of the OT protocols remained the same. We decreased our lunch break, increased the working hours, and patients would be called in batches to the operating theaters. Now, coming October, November 20, we made an isolation center and quarantine center for the staff, especially those who are with families, so that the families could be safe if any staff members are infected. And also the rapid antigen test started at Sadhguru campus. So it was actually an advantage, especially the longer surgeries like retina and oculoplasty, the patients would undergo a rapid antigen test as well. And the wait was finally over with so much talk around the vaccine in January 2021. The vaccination center was inaugurated at the Sadhguru campus. Until now, we have been able to cover close to 90% of our employees here with the COVID-19 vaccine. As the second wave came up, all the protocols remained the same. As per government instructions, we had to make a 35-bed COVID isolation centers, out of which 10-bed was oxygen supported, and a 45-bed COVID isolation for the poor and needy people was also made free of charge. This was only for the mild to moderate cases. Staff training and patient training continued as such. So this is a pictures of the COVID isolation center, which had a testing of RAT facility, oxygen support, and various other facilities as well as COVID treatment at level 1 and 2 were concerned. Now, Sadhguru always remains in the forefront as far as social activities and sharing and caring is concerned. So on the capacity building front, we have 6 Menti hospitals. So we trained them on the protocols of COVID-19. As a part of Orbis, we also helped them formulate the guidelines for comprehensive management of eye hospitals around India. Humanitarian work is also at the forefront of the Sadhguru philosophy. So we've been delivering, we have started an Annapurna van, which has delivered close to 1.32 lakh food packets, out of which these are grocery items as well as ready-made food for the poor and needy people. And being a religious place, groceries are also delivered to the sadhus around the area. Service to society also remains a key as far as our organization is concerned. We have started a COVID Arogyam van, which goes in an area around 20 kilometers around the hospital, screens people, anybody with COVID symptoms, rapid antigen is done and he is advised home isolation and then followed up telephonically. Even provision of medicine kits is given to them for the management of mild cases of COVID. Employee welfare remains at the forefront. Regular counseling and training sessions are done. So as a part of the lockdown, so employees don't have to move forth from the organization, and essential groceries and vegetables are available within the campus. And our organization was one of the organizations where there were no salary cuts during the pandemic. Everyone received the full salary. PG residents and training again, because these are one area where the residents might feel a bit low. So having state-of-the-art wet lab, we continued on whatever little resources like artificial eyes we had to continue the training for residents. Even online classes were continued. Staff training and counseling I've already discussed. We have a hospital announcement system for the staff as well as patients, always guiding them and telling them what COVID-19 is. And also a lot of IC material is on display and online classes are regularly conducted to allay the anxiety of the workforce in the institute. During this time also, we had another milestone. We have an eye for quality. We were able to get full NABH accreditation by a virtual inspection through the NABH. This was another achievement for us. As the third wave involves, there are a lot of challenges, but we have 2 more important things in this. We have upgradation of our COVID isolation center with oxygen
I request you to sum up, sir.
Yes, sir. So the key message here is that in the first wave, and together we have had no mortality of our employees, and all the employees have 100% recovered. Vaccine coverage has been 94%. And key takeaways are this, but the most important is to focus on teamwork. That is, together everyone achieves more. And ultimately, I would like to thank everyone for the patient hearing, and the journey still continues and we have a lot more to conquer. Thank you very much for your patient hearing.
Thank you, Mr. Ashish, for a wonderful talk. I think you have covered comprehensively the COVID protocols, and you have gone one step further in doing the noble work of distributing the food also, not also to the regular public, but also to the sadhu sants. So that's a role model for all of us to follow. Thanks. Can I talk? Amay?
Yes,
Can
sir.
we have the next speaker?
Yes, sir.
Sir, you have to stop share.
Yes.
Please stop your share. I now request Dr. Yogesh Shah, our past AIOS treasurer and senior ophthalmic surgeon from Mumbai, to talk on problems in insurance after achieving success in cashless practice.
Okay,
Please start sharing.
Yeah, but other screen is still active from the other side.
Sir, he stopped sharing now, sir. You can share screen.
Stop sharing, sir.
Sir, we welcome Dr. Tatyarao Lahane, Professor Tatyarao Lahane, Padma Shri, sir, for this session. He is there logged in just now. I think. Sir, welcome, sir. Sir,
Welcome, sir. Good
muted hai
evening.
tumhi, muted ahe, sir. Unmute kara.
Hello, can you see my screen?
Yes.
Before,
sir, this unmuted. So Kulkarni sir, I just heard there in the other session, Yogesh sir, Jagesh, I think the good going. Amay, I have seen Nana Sahib, I have seen Madhavrao, I have seen. So Bhatti sir is also there. So it is a good going. I think you have completed a few people and now going on to other. So please go ahead, Jagesh. Please go ahead.
Sir, sincere request to everybody that is contesting for the post of Vice President at AIOS. Everybody should fully support him. A
Yes.
sincere request.
Yes,
Dr.
sir.
Yogesh Bhai, chalu karo, sir.
Yeah, but
Please share your screen, sir.
I'm
Unable to share, sir.
Yeah, I'm unable to share it. Can you see the slide here?
No, sir. So the technical person.
No, Yogesh Bhai, you go to the share.
Yeah, I have gone to the share.
1 minute रुको. अभी क्या आ गया है शेयर के बाद?
ये screen आ रहा है.
Sir, open your presentation first and then share screen.
My
karo.
presentation is open. I'll
नहीं,
again
इसमें
open
then
it.
अगर स्क्रीन आ रहा है तो उसमें आपको 4-5
Sir,
ये दिखेंगे.
I will open the presentation
नहीं, उसमें
again.
आपको 4-5 आइटम दिखेंगे. उसमें आपका जहाँ प्रेजेंटेशन है उसको पहले सिलेक्ट करो and then शेयर करो.
Okay, I have opened my presentation.
Now share screen. So you'll see what Dr. Lahane sir has said.
Yeah, I know.
Share it.
I have to go to the Zoom meeting. I have opened and minimized it.
Don't minimize it. You keep it, and but okay, minimize, no problem. And then you share it.
Is it difficult? Then we'll tell the technical person to help you. In the meantime, we'll take the next presentation.
Take the next person, please.
Yeah, Amay?
Yeah. I would now like to invite Dr. Madhav Ambekar, Senior Ophthalmic Surgeon from Jalna, to talk on practice tips for beginners. Please share.
In the meantime, the technical person should contact Dr. Yogesh Shah. You send his presentation to the technical person. He can open it
I'll send it.
Yeah.
Good evening, everyone. Actually, today I had some issues with the sharing my screen. So effectively, I am right now showing my laptop through my iPhone.
No
because unfortunately, I am not able to share the laptop as of now.
Sir,
So
good evening, sir.
Good evening. Is it okay?
Yeah, it's coming.
Yeah, that's okay. Is it readable? Because
yeah,
right
readable.
Okay. First and foremost, I am thankful to BOA, Dr. Ragini, President Parikshit, and with a good theme of TPL for VP. So actually the process for the beginners has to start when he joins the post-graduation itself. And he has to decide whether he wants to go as a single or in a group. Then he has to decide for the place where he wants to start and whether he's interested into any super specialty. He has to decide all aspects into this. If he's going into single versus group, there are always advantages and disadvantages. As Kulkarni sir has always said, that group practice, I follow his words always, that the group practice is one of the best ways to cater your all interest in the life. So advantages and disadvantages on both are there. So I have to keep everything in the mind. This itself into it's very difficult. Always you have to keep looking into the like-minded people, and you can search in your own department, keep going for the conferences and meet various group of people or your colleagues who may be either 2-3 years, 4 years senior to you or junior to you. Because if you are in the 6th term, obviously you have a 2-year junior people also. And it is possible that once you are together, decide who goes for which kind of a specialty with their own interest. If you are into the single, then you need to go for the long-term fellowship, because then it is more difficult. Why? It comes in the future slides. Decide a fellowship of the interest, which doesn't need very heavy investment also, because like vitro-retinal setup sometimes needs so heavy investment that single-handed becomes very difficult. I know that the banks are willing for the advances, but it is you have to pay the dues always. And then you need to have a cross subsidy. And any system, either it can be single or a group, is not a foolproof system anytime. If a group, as it is said, that it is all-time best, but you can decide to have the various subspecialties and need to decide the place. Available resources, if you have got a reasonable funds available, go for the metro or the second line city. But if your funds are less, then you can always go at a taluka place. And happening taluka place can always be a very good, keep searching for the various places. And always remember to go out from your own town, try to search the place which is more happening. Small town and the second line cities, investment in the land and building may not be very skyrocketing. The settlement time is not very high, and a reasonable level of investment gives you excellent outcome. Small town always has its own advantages over the large towns, but outperforming in the metros is, I know that it is difficult, but then once you are into the metro, probably you will have various social aspects also coming into the field. But I always have felt that the second line cities are far better for the beginner. Doesn't matter, because metros are too saturated. Now what comes is the infrastructure. Decide what is the most mandatory infrastructure, what is required. If possible, explore the possibility of have few equipments or operating room facilities in the common, even if you have the separate operation, the OPD setups, or join as a partner in the single or a group in the multi-specialty hospital on a revenue sharing basis, which is much easier for all of us. Then comes is the partnership. Together we work, it will be a good partnership. If you are slightly still to have operation room sharing with some of your senior or junior, then the initial investment going very high will put you into a trap of advising unindicated laser PI or cataract at 6/9 vision also. If you want to be a lambi race ka ghoda, then you need to have a patience. You are running a marathon and not a sprinting for 100 or 200 meters of run. Do not expect to make a project free within a very ultra short time of say 2 or 3 years time, when the investments are in about say 2 to 3 crore rupees, because there are odd times occasions that the society at large registers that if you are suggesting the unindicated procedures, then they are registered by the society, because they would definitely in the current context go for the second or even the third opinion. And if you have advised, there is a tendency for people to advise cataract even at 6/9 or 6/12 vision. There are occasions that a lady who is say 75 plus having a 6/12 partial vision and doesn't need to go out anywhere in the field or doesn't need to read anything, 6/12 vision for her level can be reasonable. There can be a lot of controversy into this, but then the society doesn't need that kind of a very high precision in the current context, at least in the Indian situations. Now coming to the practice after fellowship, because in the current situations, most of the juniors are going for the fellowship or the super duper specialities. And always remember that you are the eye surgeon first and then the super specialist. And patient doesn't know that you are a VR surgeon or you are an oculoplastic surgeon and you are not supposed to prescribe the refractive errors, because there are occasions that patient would simply come for the refractive error correction, but then finally without making much of the issue that no, I don't give the refraction. I am only operating the oculoplasty. This is possible to have such kind of a RACI only if you are attached to an institution. But if you are into a single or in the group practice of your own, then obviously you also need to have such things done. And there is nothing like below dignity that refractive error correction is not my domain. Initially, you have to show your skill as an eye surgeon first, and then into your subspecialty, because patient needs to come to you first. I know one of the examples where one of the glaucoma consultants had said, "Sir, glaucoma ke patients to utne aate nahi hai," kind of a thing. So my cataract bhi nahi karta hu. I said, if you have done the cataract also, why don't you do the cataract? No, because I am a glaucoma consultant. So finally he started onto the cataract, and now he does almost everything into ophthalmology with with a lot of interest into the glaucoma. But this is most important to remain that even after the fellowship, there is nothing below dignity to have this thing done of refractive error correction. Then comes to the communication skill. It is the most important thing that assertive and the confident body language is mandatory, and control your tone on the very high temper situations also. And this applies to you as well as your staff, because you will register that the front desk, which needs the most coolest tempered person, sometimes is likely to lose the temper, and the people would start agitating over there. So it is mandatory to have a perfect communication skill. Quote the examples from their own profession or their business where the patient comes from, and give them the most correct judgment of the situation, even under the poor prognostic conditions. There is no great idea in keeping them, it is no good. So giving a perfect judgment is most mandatory. And you cannot make people fool for all the time, everyone. Because if you try to deceive everyone, it is realized another due course. Exponentially, initially, you may have a very exorbitantly high revenue generations. Unfortunately, if I quote, people may not like it, but in the current context, the society at large, if you speak as in the area where you are not known as a doctor, they would realize that there are areas where people have minted money along the remdesivir and admitting into the COVID wards and having repeated HRCT done. So patients
or the sir. You have 1 minute.
Yeah, fine. Patients or the relatives expect the doctors to give brief idea about the disease and do not count everything into the chair time. Each case at least lasts for at least for the initial few years. And technical counseling, the commercial counseling may be divided at 2 different levels also. And as a doctor, you need to primarily do that perfect technical counseling. Then social contacts are equally important. That in the current context, the negativity for the doctors and not mixing up into the society, but you try to attend few social groups like Rotary, Lions, rapport building with the other medical or the non-medical groups, and your behavior overall is noticed by the society. So you need to be modest and avoid controversial, unnecessarily post on the social media, which in the current context becomes the most mandatory, because right now there's a lot of issues going on in our area, at least this thing. So with this, I think, Amir, it's okay for you that 1 minute is over.
Yeah, thank you, sir.
That's
thank
fine.
you for summing up.
So
fantastic, Madhav bhai. Very nice.
Thanks a lot, sir.
Very important points, especially for the beginners. The way it is going on, the newcomers who are coming would like to start with a bang. But your tips are really going to help them in a long way. Nana Sahib is there. Would like to comment. Nana, he is one of the organizing secretaries, the main person for MOSCON at Nasik this time. Nana, your comments, please. You're muted. Nana, you're muted. Unmute, please.
Okay, sir. Am I audible, sir?
Hi, I can hear you.
Yes.
Okay. The communication skill is very important in managing the our practice, and counseling part is also very important. That's all, sir.
Okay, fine. Thank you. Now let's have Dr. Yogesh. I think is ready. He was
Yeah, I'm. Lana sir definitely guided me.
Okay.
Thank you, sir.
He is there. He's muted, but.
No, I'm not muted, sir.
Hey, you are
Okay.
there. We can hear you, sir. Yogesh
Now,
bhai. Go ahead. Put it on the slideshow.
Slideshow I'm putting on from beginning. Is it coming?
Yes, yes.
Yes, sir.
You are seeing the slide?
Yes, sir. Yogesh, we can hear you also, and we can see the slides also.
Okay. 1 minute, huh?
All the question and answers we'll take it later on.
Okay.
I think.
Put down. Next करो. जो आ रहा है उसमें next करते जाओ.
हाँ. Sir, वो white bag हाँ आया. Okay.
Yes, yes.
Yeah, thanks a lot, and sorry for the inconvenience caused because of the computer problem. To begin with, I'm very happy that our beloved Professor Dr. Lane is here in this particular presentation, because we all know that it was his great effort which made us achieve the great success in the cashless practice. At least in Bombay, I would say 96-97% of the people are happy with the cashless practice. And I'm sure in certain cities of Maharashtra also, the cashless practice is going on pretty well. With the ban on the cashless, largely we have sorted out our financial problems in medical practice. However, transferring these problems, just 1 minute, sir. Problems to the patient can at times affect our practice. Let us understand and avoid all these problems which have now started coming up in some people's practice. Is the slide moving?
Yes, sir.
Yeah, okay. Now, basically, we see that there is a policy holder, there is a service provider, insurance company, third party, and the ILDA, which is the central government agency. The basic problem, if we see, the policy holder is in agreement with the insurance company. The insurance company has assigned their third party agency to settle the bills. The service provider is not registered with the TPA. The service provider is registered with TPA, but not with the insurance company. And patient directly goes to the TPA. So there is some way, all of them are not connected together. Somebody is connected with one party, another party is connected with the third party, and so on. And that is why the basic loophole remains, that there is no direct agreement between parties. With this, the problems started coming up, and let us see what are the problems which we face. The ceiling is the first problem which has come up. If we look at the premium part of it, a man who is having insured 50,000 rupees is paying much less premium as compared to the man who has insured for 5 lakhs of rupees. Obviously so. But when it comes to payment, both of them get the same kind of payment. There is a cap on, for example, in the cataract surgery, everybody will get 24,000 rupees more or less. Some of the companies have changed this recently. We will come to that little later also. But this pinches to the patient that I am paying premium for 5 lakhs of rupees. I am only getting 25,000 rupees. And that eventually means that this patient will feel that I am not getting enough money. Let me go for a lower package. Let me go for the cheaper option in the cataract surgery. Post-COVID, obviously the financial restrictions have increased, and that is why again we have a more problem in this particular thing. In present scenario, as I said, the cap is approximately on the 24,000 rupees, and this is obviously not sufficient as far as the modern practice is concerned. In fact, at times our expenses go more than 24,000 rupees, the cost of the lens, cost of the consumable, cost of the phaco machine, which also at times need the consumable. There are some people who do give more than 24,000, but they have also found another alternative to cut the amount that is payable to the patient. They say that if the second eye surgery is done in the same year, in that case, the second eye will not get the same amount. Meaning they will say that multifocal IOL you have put up, okay, the first eye will get 40,000 rupees, but the second eye will only get 30,000 rupees. Totally, you will only get 65,000 or 70,000, something like that is always there in their policy. Now, this is what, at the time of purchasing the policy, neither the patient understands nor the agent explains it to them. And that is how they'll end up into trouble. And they say that I got in the first eye some amount, but in the second eye, I did not get the amount which I should be getting. There are certain policies which are called co-share policies, wherein the patient is going to pay 20% only and the 80% will be paid by the insurance company. However, unfortunately, quite a few people are not aware about such policies, and that kind of a policy is not taken. If that policy is taken, once again, the patient is likely to be little more benefited. But even in co-share, again, the second eye does not get the same amount at the first eye. So there are so many problems which the companies have indirectly put up, which we really do not understand. The next problem is ophthalmic practice. We are normally practicing in terms of a package, like cataract surgery for multifocal lens is X amount, or for a toric lens is X amount. Insurance company needs the breakup bill. They invariably insist on the breakup bill. And unfortunately, there is no guideline which has been put up that what should be the amount of each breakup. And when you put up that particular breakup and submit the bill, the insurance company says that this amount, let's say, if you have put up operation theater charge as 10,000, they say that this 10,000 is out of proportion and we will not be giving it to you. Similarly, the cost of the lens, the MRP is different. At what cost we have purchased is different. They would ask for a tax invoice, and once again, they might create up another problem. If our breakup is not matching with the tax, with the bill which we have paid, the hospital, what hospital has paid, if that is not there, then obviously the two things are not matching, and that might create a further problem. Machine cost, as we understand now, a lot of our phaco machines and the other machines which we use in the toric practice are not covered. You cannot say that I'm going to put up this charge as a machine charge. It has to go only in the OR charges. And in the OR charges, once again, that law applicable becomes that it is out of proportion. The second problem which sometimes come up is 1% of the sum insured can only be the stay charge. For a man who has got a 50,000 rupees sum insured, the stay charge will be only 500 rupees, which obviously is not the thing which in city like Bombay, they will say, how can you have only 500? Now, if I put up 10,000, 1,000 rupees as a stay charge, then straight away the company will say that you have taken up a package which is double the package than what you are allowed to. And hence, the 24,000 rupees or 25,000 will also come down to half the cost of 12,500 rupees only.
You have 1 minute, sir.
Sure, I'll sum it up. The problem of pre-existing disease is also there, and we have already said that we have been communicating with the insurance company and ILDA that there should have been a checkup prior to taking up the insurance for any people who is above X age, let's say 50 years or so, so that this pre-existing problem can come up. Retroactive date is another important thing. I think for the shortage of time, I'll skip that. Cosmetic surgery is something which is coming up. I was surprised that one of my patients having chalazion operation was also refused because they said it's a cosmetic surgery. Similarly, ptosis, often when it is covering the pupillary area, the light is not entering the eye. We are obviously correcting the ptosis not for the cosmetic purpose, but for the light to go through the eye. And that is again, they say they just read the word ptosis and say that it is a cosmetic surgery. LASIK is also once again covered by some of the insurance companies, some of them don't cover. When they cover LASIK, they say that the amount of the refractive error should be more than 8 diopter and so on and so forth. Anesthesia charges are again linked with the operation charges by some of the companies. And if you now collect the bill on behalf of the anesthetist and then pay the anesthetist, then the TDS and GST gets attracted, and that creates another problem for all of us. So in such scenarios, there are multiple things which we can still need to do about the insurance practice. Obviously, we need to get united, which is of vital importance. Propagate the ban on the cashless. Local body to represent the TPLI, formulating the guideline for protecting proactively. We should probably make a guideline and give it to them, submit it to them, so that that can get accepted and we can follow that particular guideline. Prepare the proper case summary and submit it along with the bill. so that they don't get the chance to raise the queries. Many individual problems may be there. Probably it is something which, due to the lack of the time, I'm not discussing. I thank you all for your kind attention.
Excellent, Dr. Yogesh Bhai. Very well covered. This is a burning topic for each and every person. Professor Lahane has done a good thing for BOA to ban cashless. So everybody is united. So all the bills which are to be reimbursed are done at full cost. That is the advantage all the BOA members are getting. I think the same role model we need to follow all over India. AIOS and MOS, I think we should take this up and see that all our doctors are benefited. What you said, teething problems for the patient also and at the individual practitioner level. So it will be a big boon if we have a standard protocol for the breakup charges, which everybody follows. Of course, for metros and mini metros, the surgeon rates are going to vary, but rest of this, I think we can try and match it up. So it's going to be a help in a long way for everybody. Thank you, Amay. I think we can take the next. Anybody would like to have some queries, we'll like to take at the end of the session. We are running short of time.
Yes, sir. Sure, sir.
I'll stop sharing my.
Sir, please stop sharing our screen.
Yeah, I've stopped.
There's slight change in the order of the speakers because Dr. Pankaj Shah needs to be in another hall.
Yes,
Taking his lecture first. So
instead of my lecture, I think I have allowed Pankaj to speak. So Pankaj.
Yeah, yes, I request Dr. Pankaj, who's a practicing cataract and refractive surgeon at Vivekanand Netralaya, Jalgaon, is also the treasurer of Maharashtra Ophthalmic Society right now. So a very busy man. I ask, he's going to talk on advantages of rural practice, rural India calling. Take it away, sir.
Yes, sir. Thank you. Is my slide visible?
Yeah.
Yes, sir. Am I audible also?
You're visible and audible, sir. Please go ahead.
Yeah. Thank you, Amay. Thank you, Jignesh sir, chairman, co-chairman, moderator, for giving me a chance. Warm regards to my guru, Dr. Anil Kulkarni sir, who has taught me, and I am what I am because of him. And this topic also, working in rural India, as because I was in Miraj and was always there in the camps, and this motivated me, and I am practicing at Jalgaon and Chopra, which is a rural place 60 kilometers from Jalgaon. So let's see what are the advantages of rural practice. So you want early fame and money, rural people are calling you. India lives in its villages. Healthcare services must begin where people are and where people problems arise. We have acquired the capability of placing satellite in orbit, but we have not been able to reach out to all our rural people. The dream of India as a strong nation will not be realized without self-reliant. Just a minute. It's visible, na?
Yeah, yeah, it's visible. Just
visible,
sir. On the slideshow.
Some problem.
Sir, it's not on slideshow.
Yeah, slideshow. That's what I said. Yeah.
Okay. India is still predominantly a rural country. 1.2 million people see the rural and urban population. Health force work in India, not enough here and too many there. So the health scenario in India is a matter of great concern. Only 30% of Indians have access to modern medicines. The difference in life expectancy, urban and rural, is at 12 years. Again, the national doctor-patient ratio in urban area is 1 in 1700 and 1 in 25,000 in rural area. Level of blindness is also in urban it's 6.5, whereas in rural it is 8.9%. So rural blindness is almost 1.5 times more, perhaps because there is no service as causes are similar. So why prevalence is more in rural area? Lies, least access, low priority, treatment of cost, fear of treatment, fear of surgery, God's will and ignorance. You see the causes of blindness, again cataract is the main, then refractive errors, glaucoma and posterior segment lesions and so on. Ophthalmic manpower in India is ophthalmic surgeon to population ratio is 1 in almost, which has to be in 1 in 50,000 is 1 in 1 lakh. 70% of surgeons are in private sector, 40% are absenteeism in government sector, and there are dual practice also. Again the same, see the population distribution and the distribution of ophthalmologists. So has the greatest number of blind people in the world. In slum and 80% live. Unfortunately, this number is increasing every day.
The problem is acute in rural India, particularly over the 60 years of age. And the backlog of cataract is huge and increasing. What are the key facts? Long distances of remote and backward areas prevent them from receiving treatment. Private doctors are beyond the reach of general masses. Most of the agencies working in this field are reluctant to reach out to the rural and slum population. Again, ignorance also prevails that blindness is the effect of old age and is not curable. So the truth is, while starting up the practice, manpower has an easy availability, infrastructure is easily available, there are no economic constraints, and early social acceptance in rural place. Why some doctors serve in rural areas is because of community affinities, geographical linkages, and family association. The advantages will be no waiting period, though less paying capacity, high volume makes it most cost effective. Nowadays, even rural people are earning more and paying capacity is comparable to urban people. And work recognition is in very short period. More percentage of people know you in short span of time. You have more respect as compared to urban people. And if anyone has a political ambition, you can get more such opportunities there. Drawbacks can be poor working and living arrangements, long estrangements from families, threats to personal security, no better housing, no better schools for children, no scope for training and skill development. Social response. Social taboos are still evident in the rural area. Many rumors and superstitions rule the poor population, which hinder their health care. Unreliable monsoon dependency agriculture leads to irregular and incomplete treatment. No awareness and unwillingness to pay for health makes private hospitals an uneconomic project. The challenges which are to be addressed is proper eye care awareness in the masses, setting up efficient eye care project. No challenge comes without opportunities. So we can create public awareness there, posters, banners. We can have a link between healthcare workers, school teachers, and community leaders, and have a long-term and sustainable awareness. These are the awareness and various things which we carry out in our area. So to carry an efficient eye care, advanced eye care institutions in small towns can help to deliver cost-effective eye care service to needy people at their doorsteps. This will also help to curtail the heavy load in metro cities and minimize cost. Even if you see from the desk of President AIS long back, he had beautifully pointed out that we seniors have to invest our wealth and value in the rural hospital, and youngsters' their sweat and equity staying in cities and working in villages is a smart solution for our shining youngsters. Now, is there a business in rural market? There is a business in rural market. If you go for a SWOT analysis, we see the strength, weakness, opportunities, and threats. SWOT analysis of rural India with corporate perspective and making a dent in rural India. 70% is rural, mostly depends on agriculture, largely illiterate, earn as low as $2 per day, live with minimum infrastructures, and language changes per few kilometers. But see the strength. Population is largely uncovered, contributes to half of the India's GDPs. Size of rural market is 3,000 crores. Rural India has seen growth in income due to rise in agricultural prices. Rise in expenditure is 9% since 2002. And there are many government initiatives like Bharat Nirman, Narega, and loan waivers have made rural India approachable and very marketable. The weakness will be low literacy, lack of infrastructure facilities, fake products in the market, no common language, sparsely located population, low earning per threshold, and traditional outlook of rural consumers. But we have opportunities. If you see, there are 41 million Kisan credit cards issued. Bharat Nirman and Pradhan Mantri Sadak Yojana has resulted in increased rural connectivity. 90% villages are electrified. Schemes like Rural Employment Guarantee Act and Loan Waiver have pumped the liquidity. Rural markets are ripe and fresh. A new brand can enter easily as competitor. Creating products for rural India is tricky. These are the threats which go only corporate with deep pockets can enter as a huge infrastructure is required. Tough rural terrain requires extra handling. To reach sparsely located population, a very scattered distribution network is required. Low availability of infrastructure facilities can cause loss of investment. Rural population is mostly illiterate. Communicating message to them is a real challenge. But the reefing benefits are, in 2001 and 2, LIC sold 55% of its policies in rural India. Of 2 million BSNL mobile connection, 50% are in town and villages. Hero Honda has 43% sales in rural India. Maruti Suzuki's rural sale increased from 3.5 to 10% in 1 year. You see the Hindustan Unilever, one of the initiatives in rural India, has more than 45% sale coming from rural India. Rediff Mail sign up 60% are from small towns. 50% transactions are from Rediff online shopping site. So these are various things. So 10 consumption data to blow your mind. 46% of the soft drink sales happen in rural areas. Rural India consists 49% of motorcycle sales. Cigarette sales is 59%. 53% is the FMCG sale. Talcum powder is used more than by 25% of rural India. Lipsticks are more used by rural women than the urban women. Has a large consuming class with 45% of middle class and 58% of total disposable income accounting for consumption. By 2010, rural India consumes 60% of goods produced in the country. So do not follow where the path may lead. Go where you can have a trail. You see a lady sarpanch making an impact on the Times of India. So now changing phase of rural India, we are at a turning point that has potential to bring prosperity to rural India and benefits of economic growth and development to rural India percolating slowly but steadily.
Please sum up, sir.
Thank you for thinking on the rural setup. The path is tortuous, but we have to join together to make it straight and easy for walk. So we have to strengthen the supply side of Health Mohan for this initiative and can be taken to increase the number as well as decrease the shortfall of manpower resources. The rich must live more simply, so the poor may simply live. Thank you.
Fantastic presentation, Pankaj.
Thank you, sir.
An eye-opening presentation of the rural India. The rural India is rich. They have the money. As Dr. Ambekar also said, you should go to the second line cities and the villages. There is a lot of money there also, and you serve the rural people. So fantastic presentation. Amay, I think instead of me, let Dr. Anil Kulkarni sir have the next presentation.
Sure, sir. I now invite Professor Dr. Anil Kulkarni from Miras for his talk on group practice experience of 25 years.
Sir is father of Amay Kulkarni. Everybody knows sir is a role model and a guru for everybody.
Thank you, Dr. Jignesh and all other colleagues. It's a nice way of getting the introduction. For the first time, I'm hearing it on this, that I'm a father of Amaya. And let's hope that I get this recognition henceforth also. And thanks a lot for your kind words.
Yes.
I just, I'm propagating this group practice since last 25 years. One of the simple reasons is that you really need to look this into seriously. See, I was the person who was in a medical college as professor, as a private practitioner, then as a managing trustee of a charitable hospital. So all hats were already worn. But then I realized that how much you can work singly, there is a limit. But if you join together, probably you would be doing it much better. Only thing you require is that rather than a capital I specialist, you have to really think that you have to adjust with others. Otherwise, what happens is you just want to excel individually, and that obviously compromises his quality of life. And then sometimes, as Amay will tell us, that most of the times you are not available when our children were growing up. Now we are actually trying to modify it by looking after our grandkids. Now, due to fear of being overtaken by our fellow surgeons, if he purchases a bigger car, we suddenly want to go for almost a chartered plane. Now, this is something where we are then treated as potential customers by corporate companies, obviously with their profit motive. And what happens? Your chartered accountants will tell you what is a debt trap. You usually sometimes have a low income, which is going to be a fact in this COVID period. You can be deep in debt, you may have a bad credit. And what advice you will receive is, okay, no, what you can get now is something like a more loans, and you must be getting those offers nowadays. Now, who loses? Not only an individual eye surgeon, but even a helpless patient, because they have limited resources to pay. The solution obviously is a group practice where you from individual go to a cohesive effect and the individual acclaim to a collective acclaim that can produce a brand value. So rather than remaining alone, let us join together. This will steer the infrastructure, reduce the cost of service. Multiple facilities can be under one roof, and individual members can acquire new technology. This not only improves quality of life, but you can even think of going on vacations once in a while, like Dr. Jignesh is going to organize every year. By the way, that was one of the fantastic trip ever had in our Europe trip by Dr. Jignesh.
Yeah, I think you enjoyed it thoroughly, sir.
Yeah, very good.
Luckily, because of COVID, we are not having for the last.
I'm sure next year you will plan that.
Yes, sir.
Now, this is something which we know the type of good practice where everybody joins together and dissolves their own practice. Now, this is no individual practice. This is like a Disha Eye Hospital near Kolkata and their branches. What we tried to do was that we asked the surgeons to continue their regular practice and joined hands for specific activity, like a laser center or ultrasonic clear or OT facilities. This was a private company, but it was controlled by clinicians. This was a Prathamesh Laser Center at Sangli. We started it in 1996. We were 27 eye surgeons who participated. There was no vitreoretinal surgeon because they were not available that time. It was a 45 lakhs project in 96, but the contribution, mind well, was only 50,000 rupees each. And then we formed a company, but with one industrialist to guide us. We did not have Pankaj Shah or Jignesh Taswala amongst us to guide us about the financial matters. So we took an industrialist. And why we did it? Because their treatment was by his own doctor. You don't have to refer the patients, and no further investment in diagnostic equipment because we can just concentrate on modernization of OT. The finances were giving us 15 to 20% on investment. So working partners were getting almost 40 to 60,000 per year, depending on how much work you are bringing to this center. Important thing is the patient charges remained unchanged for years together. The loan was fully repaid in about 5 years, and then I retired chairman after it became loan free. Then another 4 years later, we had one more idea. I'm really now going. Why I'm showing this is that I usually try to persuade people or rather dissuade people in going for a refractive surgery LASIK machine. But that time it was the in thing. So we went for excimer laser purchase. We were 20 eye surgeons. And then the directors had only 2 lakhs plus members included about 50,000 rupees. We were thinking about the individual surgeon who can treat his own patient. One thing we maintained was that no charges were paid for referring the patient. There was a strict quality control, but because of the group, we had a reduction in economic pressure. This required 7 years to become loan free. One of the reasons was that we had calculated that every member will bring one patient, but somehow it is not practical. And recurrent cost of gas refill and maintenance is really astronomical. After 7 years, when it became loan free, I then retired as chairman. The third type of group practice is when there is one senior surgeon and he has a major share. Others can join him. Like we had here 10 eye surgeons, again one industrialist. Sometimes I really feel that the doctors are fools because we never think about investment in the form of what returns are expected. But it's all right. We want to remain fools for the period for the satisfaction. Here, this practice was with 1 crore investment. We took a loan of 45 lakhs and individual members contributed between 1 to 5 lakhs. This is Amaya Lasers and Research Private Limited, which we started almost 20 years back. The one which we then went for as a group practice, another one, where surgeons continue their own regular practice, join hands for a new establishment, including a tertiary eye care center. What is the difference? It's a corporate hospital, but remember, this is controlled by clinicians and ophthalmologists alone. So we say that it is a corporate hospital with personal touch. And members will have their own consulting room outside, or they can have their consulting room in the premises of this Atharva Netralaya. So you are aware that initial investment minimum is around 50 lakhs or sometimes more, while this Atharva Netralaya members had an initial investment between 1 to 5 lakhs and had each and everything excepting an excimer laser machine for their disposal. Initial loss for 2 years, obviously expected, is a new business, and now it's becoming.
You have 1 minute, sir.
Yeah, sure. Now remember, we have 50 eye surgeons in Pune, including few are from outsides. More are obviously welcome. This is a project of 3 crores, but remember, it has got a sense of ownership for everybody. And I presume and insist that with ownership comes the responsibility and also a satisfaction of working with all equipments. So sharing and joining hands together is the need of the time. And basically, like I said, people used to get all surgical hands-on in our institutes. And then we're thinking about not having all the equipments when they went to metros. I think at least in one city, we have solved that problem. And let us hope others also try to share my views. Thank you for your patient listening.
Thank you, sir. As usual, a fantastic presentation. Go home message given by you is very important, especially the beginners. If they join, they don't compromise on the quality of surgery and the equipment. And of course, they have the infrastructure ready. So thank you very much. As usual, you have honored the time also. Dr. Nana Sahib, would you like to comment? He is also co-panelist. Rest of them, I don't see anybody. Nana, you unmute yourself, please.
I am very
Yes,
much.
sir.
I am there.
Hello.
Yeah, Nana, your comments on sir's this thing.
Sir,
Yogesh
sir has given very fantastic presentation of group practice. Even we in the Nashik are doing group practice in the form of Unity Leather Center, and it's working very well.
So we have one more center which has come up. Sir,
We are working since last 7 to 8 years.
Yeah, Yogesh bhai would like to speak, sir.
Yeah, Jignesh, I think it was a lovely presentation, and that is what was expected also.
As usual.
As usual, yes. Sir, just to share with you, this thing possibly has clicked very well as far as the refractive surgery is concerned. In fact, there are more than one such group practices only in city of Borivali, in the suburb of Borivali. There are 2 such centers. But as you rightly said, we have almost about, I think, 65 eye surgeons in Borivali. And these groups have 20 or 25 or 30 people. And there are some who are not in the group, but they are going there and operating, and they are all welcomed as well. So ultimately, the benefit which was going to the manufacturing companies, especially the excimer laser and other thing, where the cost of the machine equipment itself is so big. And as you presented in your presentation, that excimer laser break-even was 7 years. Within 7 years, the technology had changed twice.
Correct.
And that, adds onto the pressure. But as you rightly said, I think in future, individual practice people will not survive. Group practice has to come.
Yes.
Post-COVID, the need for the group practice, I think, is 10 times more than what it was in 2019.
Sure.
Especially in metros and mini metros where the infrastructure cost is more, I think buying equipment, costly equipment is going to be difficult. So group practice is the way. Professor Lahane is there, I think. Sir, would like to comment? Sir, unmute yourself.
No, basically what Kulkarni sir has said is very true. See what happens now, individual person who is going for the practice, it is very difficult to purchase the equipment and repay the loan. So I think group practice, because it is not required that for everything it should be a group practice.
Correct.
But few equipments which are, you can say, very costly equipments are there. For that there should be a group, and that group should I think have a group practice, so that any equipment like a laser, you can say, there are so many changes are happening, but laser is purchased and kept, and our 5-6 people together. So what happens, that loan get divided.
Correct.
So like that, I think so many things are there where we can go for the group practice, and that is, I think, it is required, that is a need of the day, we must go ahead for the group practice. And I think sir himself is advocating, and I am also advocating now, that whenever I am going anywhere for the inauguration, now in 1.5 years I have not gone, but I am advocating ki bhai, don't purchase the equipment of so much of the, you can say, costly. It should be a group practice and you can practice with him कि इनके पास ये है क्या. तो I think एक OCT लेना है, तो एक OCT एक आदमी के लिए जरूरी नहीं है, बट एक OCT लेके अगर 8-10 लोगों ने रखा तो वो sufficient है. तो ऐसा I think it should be like that. Madhav bol.
Yeah, sir, I have got one public-private partnership related idea which was in my mind since long time. So the infrastructure used at the government hospitals, like we as a private practitioners can visit to the government hospitals, and I have got the vision document ready, but unfortunately once it was ready, I discussed with Tope sir also here in Jalna. But then after that, the COVID suddenly started in last February, March. And so it is very much pending with me. Once this is over, I would have my presentation to you, sir.
I think this, we are also telling that in the government, there is so much of the infrastructure, so much of the equipment. We are using those equipment from morning 8 to 9 up to 2 p.m.
Yes.
Or maximum 3 p.m. After that, these equipment, that place is not used. And so if in the afternoon, evening time, we can give it to the people who are working in the medical colleges also, not PPP. So those people will practice. So what is happening now? We have got the people, but who are those? Those are, they feel that they can't practice. It means those people who are unable to practice, they don't want to practice. So like such people, it means those who are avoiding hard work. Such type of people are in the government medical colleges. We are unable to attract the good people in the government medical colleges unless and until we give them practice in the evening time. And that is also, I think everything is there. And if they practice here, I think that will attract the people. Secondly, we will have a good people like the Anil Kulkarni sir, or Vangikar sir, or Karandikar sir. These people were there. Because of that, I think that teacher community was respected. So nowadays the teachers are also not good. So there, see what happens. We should have some high-tech teachers. And we were knowing that time what is the ethics. Dr. R.B. Bhagwat was the medicine professor. Whatever he does, that was the ethics. It means for us, ideal was R.B. Bhagwat. Ideal was the that time, that was the ethics. So now what has happened? Now that ethics has gone. The such type of the stalwarts teachers are not attracted towards the job that may be in the private or that may be in the government. So now something should be done. What Madhav was saying is very true. I have spoken to the minister also, and I'm advocating that people who are around this hospital, they can also utilize our this one, whatever charges you want to do. If that machine you are not using and if he is using in the evening, then you charge him. But I think that is just remaining idle from 3 p.m. onward. So that should be utilized. As a policy, I have written to the government of Maharashtra that after I have written after 5 p.m. I have not written because the MCI may intervene and some problem may come. So I written from 5 to 10. That can be utilized for the people who are working here or for the people, those who want to join hand. And then the rate should be decided and contract should be made, and so that they will come and utilize. So I think, but this is the need of the hour. We will have to do it, and government will also come forward.
Sir,
so what
I'll
will
come out
happen
with the
because
vision
of that? Whenever you are going out, it is not required that you are purchasing some 5, 6, 7, 8 crore, and that is difficult. So I think idea is good.
Very nicely floated idea by Madhav. And I think what with Professor Lahane there, I think it's going to go into implementation very soon. As we are short of time, question and answers, I've just requested Amaya to put it on the chat box and the individual speakers can answer it. We are running short of time. We have 3 more speakers to go in. So Amaya, over to you now.
Yes, sir. Thank you, sir. I now request Dr. Prashant Bharatiya to go ahead with his talk. Please start sharing your screen, sir. Dr. Prashant Bharatiya is a cornea specialist. He's trained at RP Center and New Delhi and Melbourne, Australia. He's worked in various big setups and now has a standalone practice in Indore. He's now made a novel web portal for all eye specialists to use in whatever type of practice that they are in. So he's going to talk on Doc Setu, connecting doctors, need of the hour. Go
Excellent, sir. Welcome.
Thank you. Am I visible and audible?
Yeah.
You're visible and audible, sir. Please go ahead.
Right, I'll try to be quick. Good evening, everybody. And at the outset, I would like to thank Dr. Ragini Madam for giving me this opportunity to showcase DocSetu in this August forum. Now, I'm sorry, just one second. Now, machine dependence is the key in our branch. It begins from the very first evaluation in the OPD. And so it's very unlike other branches. My wife is a gynecologist. She just needs one stethoscope and I need so many things. So whenever you plan to start a eye hospital, which all the esteemed speakers were talking about, you need at least 10 pieces of medical equipment. And all these equipment need finances. It's not always possible for you to do a group practice or maybe rent it in all places. So the next best option could be using used equipment. And there are a lot of vendor websites which provide used medical equipment, which buy your medical equipment and then they resell to others. But there are problems with these vendors. The reliability factor is one. They have a lot of commissions, brokerage is there, and the pricing is so variable that you are really short of ideas. And it is also possible that some eye specialist friend of yours is selling and you don't know. So we need to connect all our ophthalmologists, or maybe all doctors actually, but at the moment let us connect all the ophthalmologists so that if any person in the end of this country can actually connect with somebody in the other end, and then if he has something to say sell, it can be showcased to everybody. So we have used this technology to bridge the gap between all the ophthalmologists. We are trying to do that at least. And this is one small attempt of ours, docsetu.com, which will try to bridge this gap. So what is this docsetu.com? It's actually a web portal. It's a website. We are trying to keep it only for AIOS members, where you can buy or sell used equipment among members only. There is going to be an industry connect platform which will come up where the providers or the companies can showcase their products, but again, they will not be allowed inside the site. So why docsetu.com when in this era of WhatsApp and Facebook apps where on the WhatsApp you can send message instantly, but then you cannot do a ready reckoning. That is, you cannot look back and see where somebody had posted a slit lamp 1 month ago, but then if you have not downloaded it, it just gets lost in the flood of all the messages. And so the website is easier to use in such cases, and it is more secure in such cases because you have ease of accessibility also here. Now with this COVID-19 downturn, which everybody of us has been discussing, there were a lot of wants which we had. I wanted to buy an OCT, but now I can't think of buying a new OCT. So I might think about getting a used one. So there are some don't wants. Many people have 2 OCTs or maybe 2 microscopes and it's just lying waste and they want to get rid of it and probably buy some other equipment. And at this moment, I can't come to Bombay or Mumbai to see to attend your conference if it was physical. So I can't see the equipment which are displayed by the various vendors. So that's the place where this docsetu.com comes. I want to disclaim that this is not a website by AIOS and it is being made by me only. It is not by AIOS. There's a clear-cut disclaimer on my website as soon as you enter on it. This is a no transaction site. There are no transactions. Membership is absolutely free. And it is non-monetized. Non-monetized means there is no, you cannot pay money to be listed on top. It is all logic-based, category-based, alphabetical, location-based. There are no transactions. It's a zero commission marketplace and the person actually deals with the other person directly. It is just a listing sort of thing where you can just see and browse. It's a very simple site. You have got a simple, it is as simple as your simple banking platform. You just have to log in. Once you press the login button, if you have not previously logged in, you'll be asked to sign up. You sign up with your AIOS membership number, your mobile number and email. The email has to be the registered email ID so that we can verify that you are the person. And once you sign up, then you can start posting your item for resale. There's a small button on the side, on the right hand side, where you can just click and enter into a form. Now this is best done on the mobile side. You have that button on the top. This is because you can click photographs and then you can upload directly. So once you click that, you get a form where you can fill in your details. You can upload your photographs. Once you press the upload button, you get an action button below that where you can use the camera of the mobile and you can directly upload it on the website. So it's very simple to upload. So once you have uploaded, the items can be seen. They are trying to make some categories. If you want to see all of them together, there is this button on the lower side where you can see all the items on sale immediately. And if in case if you don't see your item there which you want, you can put it on your wish list. So if somebody has this item and wants to sell it but has not listed it has not posted it, he can probably look into this wish list also. Again, this wish list is only available to members. The person who has logged in, like you can see my name is there on the site because I'm logged in, and that's where the wish list comes up. Otherwise, it's not available. It is not visible for general people. There is going to be this Industry Connect platform on this. It is coming soon, where you can browse products. You can see the various companies who is providing what, and you can actually get the contact details. So anybody who's starting up or wants to exchange an equipment, wants to buy a newer equipment, can actually go to this place and try to find out. It's going to be just a price discovery platform. It is not going to be a transaction platform, again, to be very clear. So there will be other features, a chat, and maybe some equipment specific forums can be created. It's a very secure site. We have got SSL certification, and we double check the email before we let anybody coming inside. So we have a privacy policy which is in sync with the IT Act of the Government of India. And I would sincerely request all of you to please visit the site, sign up and explore whatever practice you are, solo, group, corporate. It is going to be helpful. I'll need a lot of feedback. If you can contribute ideas, it will be very nice. And I must thank Professor Lahane sir once again and Dr. Ragini madam again to have allowed me to talk on DocSetu. Thank you very much, Amay.
Excellent idea, Dr. Prashant. A very good idea. In fact, the way you're going to connect, the name is also very apt, DocSetu. So you're going to connect all the doctors. It will be a website connecting all the doctors, and they need, suppose I want to sell something, it is there, and somebody wants to buy it. It's a good connect. So great idea. And it's how do you recover the cost on this the website and
Sir,
all?
at this, that's a very nice question, sir. At this moment of time, the data which is there in this site is very less. Okay. Once the data increases, and once we start placing these industry people, when they have a lot of equipment coming in, then we'll have to find out some way to keep a subscription model where it will be based upon how many equipment you want to list, and some whatever data they are using, they are going to use, that we will have to charge. That has to be clearly made. That policy has to be made. It is not yet ready because at this moment of time we have got enough data to play freely.
Great idea. I think you continue this. It's a very nice website.
Thank you. I'll need feedback from all people later on.
Sure.
Sure,
yeah,
sir.
Amen.
Yeah, I now request Dr. Taswala sir to start sharing his screen. Dr. Taswala is Vice President MOS. He is also the past president of Pune Ophthalmic Society. He is member Scientific Committee MOS, and he is also member Advisory Committee Pune Ophthalmic Society. Today he is talking on pearls for solo private practice. Please take it away, sir.
Yeah. At the outset, I would like to thank Professor Ragini, Professor Lahane, the team BOA and team MOS for giving me this August platform to speak on this subject of pearls for solo practice. I've added for beginners because usually this helps, all my points are going to help the beginners more than anybody else. So, Amay, just let me know at the 1 minute prior, you can give me an alert.
Sure, sir.
Okay. Question and answer. Now it says, I think Dr. Vinod Goyal is not there. We have the last talk of mine. So you can have the question and answers put in the panel of the chat box. I think people will answer it. Or we have a question answer session immediately after that for about 5 minutes, 5 to 10 minutes. So pearls for solo practice. My pearls is as like the 10 commandments, how a person who is just starting his practice or who is already in the practice should go about it. First is financial planning and budgeting. Paisa to lagta hai, paise bina kuch nahi hota hai. So once you have the money, then you search for an appropriate place. Then the instrumentation you need to put in, which are the instruments you need to initially invest. Once you have that to run the show, you require staff as a helping hand. Then once you have your setup done, you need to have a advertisement in a way, having a presence on the social platforms and also having attachments with the institute. To fine tune your initially, there are a lot of hiccups. So you should have an observership at your seniors or a teacher center. Tie up with a neutral center with diagnostic equipment and OT, as Dr. Anil Kulkarni sir had just said. Honing of the skills for newer technologies, techniques and modalities. And finally, we need to upgrade and upscale. Once you establish, you have to go further. So regarding financial planning, you need to work out the approximate cost of the infrastructure and instrumentation. If you are a general ophthalmologist, the cost input will be different. And as a sub-specialist or a super specialist will be different. Your costing will change depending on which scenario you choose. If you are going for an outright buying of the place and then installing all the instrumentation, it's a huge investment. Which is a no-no, is what I would recommend, because we have gone through it, and for the last 34 years I've been practicing this. I would not recommend, actually it is for a beginner. If you buy your own clinic and and buy just the basic equipment and rent out the advanced ones, it's a smart investment. For most of them, this is what is recommended. If you take a rental clinic and buy all the equipment and instrumentation, you save on infrastructure cost. But then you have to have, if you set up well, later on, the owner will jack up the rates and it's going to be a big problem later on. If you go for a rental clinic and buy basic equipment and take the advanced equipment on rent, you save on infrastructure and advanced equipment cost. How do you arrange the finances? Once you have the details of what the costing is, you have to prepare a project report. And the whichever bank is going to lend you requires a blueprint of how you're going to have your earnings over the next 5 years after taking care of your expenses. You have to also make the arrangement of your margin money, usually 15 to 25% bank, and the other NB, non-banking finances, usually give between 85 to 75% of the loan. You have to generate and pay at the time of the loan reimbursement. Some banks have now started nowadays to give 100% loan. Margin money comes from your savings, help or loan from your parents, relatives and friends. Always go for nationalized bank, as the rate of interest is lowest and there is no hidden charges. Once you take the loan, you have the moratorium. So you have a interest free, some period where you don't have to pay either any of the EMIs. But remember that during this period, the interest is building up. And going for a staggering payment. Staggering payment means if you have a lack of loan and your EMI is about 5,000, initially you can ask the bank to keep it as 3,500 and increase it every 3 months. Over a period of time, as your earnings grow up, you will be able to repay it better. Never take credit card loans, as interest is highest, almost 21 to 36%. And even if there is a 1 day late, you have to pay the full interest. Don't try to skip the EMI as interest starts building up. Initially, interest component is more, and as years pass by, the capital component increases. So try and chalk out your EMI or what you are going to pay, and that is how your loan should be taken. And the year period, some people give for 5 years, some for 7 years. Always take loan on a daily or a monthly reducing balance, as opposed to fixed rate. A fixed rate of 10%, your EMI will be on a lakh of loan, say about 7,000. On a daily reducing balance, it will be hardly 3,000, 3,500. So you save about 1,500 on an EMI. So go in for a monthly and always ask the bank which type of a loan are they giving. List, as I just said, take nationalized bank loans. I have given the list. All the 12 banks which are there, you can choose any one of them rather than going for the semi-nationalized or the private financing. Once you have the loans passed, you need to budget yourself. Day-to-day expenses of your clinic, EMI repayment, staff salaries, margin money for buying new equipment, mediclaim, life insurance and professional indemnity, which is very important. As MOS, we have started group indemnity and it is very cheap, much less than what your individual indemnity cost. Utility expenses, telephone, cell phone, MSCB, property tax, professional and biomedical waste. Housing loan in case you plan to buy a house also side by side. Your personal expenses, and of course you need to pay income tax. I would recommend all the beginners to pay income tax from the very first year, because you have to have a strong file for taking loans. So even if it is nil, you start building up your white for the margin money. Saving should be for FD, mutual funds, shares and gold. Every beginner should have some share as a saving, which should be helpful in later in life. Income generation, how you increase your income. At your center, of course, OPD consultation, operation, diagnostics and procedures. Then if you get attached to the institute, the same sources as above, plus the newer machines which you have, which you don't have at the clinic, the procedural charges and all you can charge there. You can have an optical shop, a contact lens and a low visual aid center attached to your clinic. Generating more surgeries at a discounted rate by conducting free diagnostic eye cams at your center once in a month, initially on a Sunday, a non-working day, so it doesn't affect your practice. Visiting peripheral rural areas by conducting outreach eye check programs in camp in rural once a week, fortnight or month, whatever is feasible, thereby having a surgical inflow from such camps to your main center. Conducting paid subspecialty training, suppose you are in oculoplastic, wet labs and tutorial classes for the general ophthalmologist at a nominal fee, so that also adds to your earnings. And articles in the newsprint, lectures in NGO, radios, TV public awareness programs for better outreach to a general public and facing and becoming a face in the crowd. This will help you indirectly as you are creating your own presence in the virtual and physical world. Searching for an appropriate place. For a beginners, what I would say is you need to first decide whether you're going for an ownership or rental, and then choose as per your budget the place. Points to be kept in mind is easily approachable by all modes of transport. Bus, rickshaw, gaadi, kahi asal, they should be able to come, so you have more flow. Easily accessible, usually ground or first floor unless lift availability, as many of our patients are in geriatric age group. And try and keep in close vicinity about a kilometer or two where you have a multi-speciality hospital with ICU, because all people we have an emergency, it should be immediately shifted to a close by multi-speciality hospital with an ICU. And of course enough parking space, so people come in. I have been facing this, sir तुम्हारे यहाँ parking की जगह ही नहीं है, आए कैसे? You have open another center. So such acute is the problem of parking. Which equipment and instrumentation to invest initially? If finance is a problem, have only the very basic equipment. Depends whether you are again a general ophthalmologist or subspecialties and your area of practice, whether you are in the urban metro or a mini metro, or you are in a taluka place or in one of the villages. But basics remain the same. In the OPD, you need to have a chair unit, the slit lamp, autoref, keratometer, direct, indirect ophthalmoscope, and a tonometer. The rest of the equipment, I would say, depending upon your subspecialty, you should have. Basic surgical instruments. In the OT, you have to have a stainless or a motorized chair unit, or a manual one will also do in case the finance is a problem. Phaco is the in thing nowadays, so have a Phaco machine. If you can't do it, stick to SICS initially, and once you gather funds, buy in a low-cost machine initially at a discounted rate as compared to the imported ones. The Indian ones are very good. They give very good after-sales service. The rest of the equipment and the instrumentation as per your subspecialty, the basics you can invest initially. OPD and OT equipment and instruments usually to be bought in conference by forming a group. If you have a group and buy it, that is what we did. When I bought my first direct in-depth ophthalmoscope, we were 10 people, so we paid almost 20% less. Staff recruitment, once you have this as a solo practitioner, minimum requirement is a front desk where you have a receptionist, an OT assistant, a maid or a ayah for maintaining cleanliness. For a front desk, you have to teach them for having, because that is the face of your clinic. So mock training session should be there for basic etiquettes and how to deal and handle patients with various temperament. Tip is to have a OT assistant specific for ophthalmic purpose. In case he is not there, you train him. Rest you can have unskilled workers. In semi-urban and urban and rural area, a single multitask assistant will also do. Presence on your social platform. Well, in today's world, if you are not there, you are not in the race. So Facebook, Twitter, Instagram, and WhatsApp, of course, we have, and have your own website where you put in what all you are specialized in. Blogging, write your blogs in between so people know how much worth you are. Also, all this will help you have a full virtual presence. Post on your Facebook on a regular way the latest events, the happenings of your center, updation of your skills, receiving due recognition, appreciation, awards by renowned societies in India and world over. You showcase your professional and personal talents on all platforms. Please don't post videos showing face of the patient without explicit consent of the patient. Best to avoid it. Institutional practice, if you have an attachment with the interaction and goodwill with fellow consultants, your cross-referrals increase and that helps in growing your earnings. Emergencies and casualty and house calls, again, that adds to it. Joining charity institute and honing, here you need to hone your skills and have a wider acceptance. You need to fine-tune and balance your center work with the institutional work. You can't keep doing all the charity work. You have to see that your center also works nicely. So have more footfalls in your clinic. Observership, best is to do a proper fellowship at a renowned institute in case you want to do a subspecialty practice. As a general ophthalmologist, initial phase for confidence and better result, do plan to attend and observe surgeries. If you have a teacher in your vicinity, do, otherwise a senior or a colleague whom you rate in high esteem. Physically attending gives you added advantage of the arrangement, placement of the equipment in the OT, functioning of the surgeon and the staff, handling of the instruments, foot pedal nuances, sitting arrangements, comfortable ergonomic posture, and much more. For surgical steps, of course, on YouTube, various different surgeons, you learn different steps and master it. Tie up with the neutral center with diagnostic equipment, as Dr. Anil Kulkarni sir also has said, to save on cost without compromising on quality. For beginners, I recommend to have a tie-up with well-equipped centers who allow you to do diagnostic center tests, procedures, and operations at a predetermined rate. So you save on huge investment which you would have otherwise done. You require less investment in space and equipment at your center. Also, you can join like-minded colleagues to have a neutral center, as sir said, and have your own shares and make a huge center. Have all the equipment, infrastructure, OT, and support staff at a fraction of the cost which you would have otherwise invested doing solo practice. It's a win-win situation. Honing of your skills for newer techniques and modalities. Majority of the surgical vendors are ready to allow you to use the newer machines as marketing strategies. So you get to hands-on and directly at no cost with your expert around to guide you at each step. Short observer course and hands-on to teach you newer techniques are available at a lot of tertiary centers all over the country. Choose one which suits you. Of course, our very own YouTube also helps in seeing newer techniques done by our colleagues, and you pick up many pearls, and which will be of very immense help to your day-to-day practice. Be part of the social group on WhatsApp. I have been in connection with a lot of PG groups, and where the teachers really put in very valuable tips for small little, intricate steps of cataract surgery and any other ophthalmic surgery. So you learn and clarify your doubts there. Of course, AIOS conducts a lot of TSTC, that is the SSTC and TSTC programs, and they are all being conducted by the experts. So you hone your skills. And finally, once you set your practice, you need to upgrade and upscale. So as you grow, being par with the best in your area, you have to decide a timeline to add on to your advanced equipment from time to time in a staggered manner. For having all the new machinery, you need extra space. So expansion of your center, either an add-on or a separate entity in the adjoining premises, for convenience of functioning, has to be done as and when fund and space is available. Proper training and know-how of operating newer machinery is also to be kept in mind before installation, usually done by the vendor themselves under supervision. Thank you very much for a patient listening. I have tried to keep it within the time, and we are open to questions now. If Dr. Vinod Goel is not there as the next speaker, Amey, can you just check before you?
Yeah, I just checked, sir. There are no questions as such on the social media sites, but I would like to say that it was a very, very comprehensive presentation, sir. I did not want to stop you at all because I'm the only beginner here right now. So fantastic presentation, very, very illuminating. And I do agree that we as doctors need, first and foremost, financial literacy. We are very well educated, but we are financially illiterate. As you just told me, I just heard something new called monthly reducing balance. I had no idea what that was. So I'll now search what that is. So
yes.
Amey, you have got a at-home mentor, you know, for us.
He's a big mentor. We follow him.
We follow him all time. We follow all time. And out of that,
it was a very, very comprehensive thing and fantastic presentations.
Yeah.
Can I ask a query, sir?
Now, sir.
Yeah, one of the query to Mr. Prashant Bhartiya. See, the point is there are other groups also who do equipment, sell and buy things.
Yes. Yes.
The problem is you are not sure what is the quality of that particular
right.
thing when you think about the price which needs to be accepted, right? So you'll have to introduce something addition to this, which will probably give a person who is like, supposing you have a true value car from Maruti and you know that they are charging slightly more, but then you are sure that they had checked it before it is sold. So if you can just add that kind of thing, probably it will be a much better initiative from your side.
Very good idea from Anil Kulkarni sir. I think you should have a quality control cell. In that you can have 2-3 doctors, senior doctor like Dr. Anil Kulkarni, and in your area who can really go through the details of what the equipment these people are selling, whether it's a colleague or the industrial people, and that is going to help us a long way. That we get quality instruments even if it is second hand.
Right, sir. I must thank you for this, and this did definitely come up when we started it. Many people who have actually sold and bought equipment on this platform, they did mention this particular point, that how do we do a quality check on the equipment which the other doctor is selling. So now this is an aspect which will have to be dealt with in more detail in the future, and this is on the anvil. I cannot take it up on a personal basis or on the website that we do something. We cannot physically check the equipment anyway. So the first sale which happened on the site was by the doctor who was practicing in near Calcutta, and the person who was selling was from Agra. So the person from Kolkata traveled down to Agra to get that machine, because that rate difference between the new OCT machine and the old OCT machine was terrific. So he was getting an OCT machine somewhere around 11 or 12 lakhs, and the original OCT machine was around 25 lakhs. So he went down personally, he checked the machine, although he is also not a biomedical engineer to cross-check everything. But he went down, he talked personally to the person, and when he was personally satisfied, he did pick up that machine. Now, this cannot be possible in small items. I agree that you cannot go to each place for small items. But then there will have to be a system where we as probably as AIOS members will probably have to employ a group of probably biomedical engineers who can help each other, help us all. Where if we have a breakdown, probably we can have a central helpline where the person can come and help us. And in a similar manner, if there is a second-hand equipment to be sold, they can dismantle and remantle between the places, and the middleman can be taken off. He can just be the technical person. You can directly deal with the doctor, but the technical person can be hired. So that part can be taken care of. Now everything cannot be done at one particular level. So we'll have to, that is on the mind, and that was number one. That will be coming up in the next phase when we are very sure about the basic security of this site.
What you can do, Prashant, Dr. Prashant, what you can do now is a biomedical engineer, instead of the doctor going all the way, you ask the doctor to, in between the two, they can share the cost of the biomedical engineer who checks and give it. So that will save, instead of now having 3-4 biomedical on the roll, because who's going to pay for that? So initially we do it that way, and then we have a small subscription from those who log in, say 100 rupees, 200 rupees. If you have 10,000 people, you have a lakh of rupees, and then you have the biomedical engineers with a specific predetermined rate for checking the local cost plus this.
There is going to be no money on this, sir.
No, I'm talking about later.
No, money for biomedical engineers. We'll have a list of biomedical engineers. You can contact the biomedical engineer. You can have we can have reviews of those biomedical engineers. But if we bring in money here, the whole concept of this connection will be gone. Money is required. I agree, money is required. You asked me this first question, and that is going to be answered soon. As we get the industry connect, we will have some subscription. We'll get the data for the. We'll get some money for the data which we will be using, and probably for 1 or 2 employees which we might have to employ. Maybe we can do that. But if we monetize this site and in the site, then the whole concept will be over.
Fully agree with you. Yes, Dr. Ambekar would like to say something.
No, that's what I'm saying, that disassembling the unit and reassembling it at the back home, carrying it back, it needs a biomedical engineer actually, because from Agra to Kolkata, carrying this is not that easy.
Yes, you're absolutely right, sir. That's what happened. But it was an OCT which he could pack in his car and go. But there are a lot of vendor sites which are biomedical engineers and are doing this thing. But at this moment of time, they are many, and we don't know all of them. So what we can do is we can also list them gradually. We can have a review of those people. Like if I have used a service of any XYZ biomedical engineer, I can write the review there that I had used this guy for this particular thing and he was okay or he was not okay or whatever. And this can be between us members only. That is where this Doc Setu comes in between, because it will not be open to others.
Quite right. We have now exceeded the time by almost 40 minutes.
No, sir, I'll just
We
make a
have
short,
Professor Lahane.
since Lahane sir is here.
Yeah.
सर मी तुम्हाला एक मेल पाठवतो. मी जे तयार केलेलं पेपर आहे त्याचं एक तुम्हाला मेल पाठवतो सर. ते तुम्ही वाचल्यानंतर मग आपण त्याच्यावरती जसं तुम्हाला वेळ मिळेल तसं डिस्कशन करता येईल आपल्याला.
पाठवा.
Yes sir.
Before we wind up, Professor Lahane, is there earnest request to all those who have logged in, all the August audience? I would request them to vote for Professor Lahane, who is contesting the AIO selection as a vice president. We would like to come up with thumping majority. That is an earnest request. Final comments by Professor Lahane before I conclude, and Amay gives the thanks. This thing.
No, sir is there.
Kulkarni sir.
You muted, sir.
Lahane sir, you are muted.
Kulkarni sir is there, so we'll ask Kulkarni sir to give the final comment.
Sir, Sangha sir.
No, sir, this was a very nice actually program. And whenever you have these inputs which are apart from the clinical skills, that really gives you an insight of what extra thing also has to be done apart from your routine practice. As I was telling, the Madhav has put in some very good suggestions, and then Taswala sir rightly has talked about the bank things as well as how to create and how to get these loans, and probably what sort of thing we should approach when we are starting the practice. So basically, these are something which it need not be for the beginners. Majority of the people were talking about that this is for beginners. I think if I get so much of information from there, then possibly I can't call myself as beginner. But then at the same time, this is a very important information. And once the presence of persons like Dr. Lahane amongst us probably gives us a slightly better level to all this discussion. So thank you for giving us this opportunity of participating, and thanks BOA and MOS, particularly Dr. Lahane sir and Dr. Ragini madam, for really doing a wonderful job of doing this. This is absolutely phenomenal. I had worked as a chairman scientific committee for MOS as well as the member for almost 6 years before, from 1994 to 2000, and I know how difficult it is to really get somebody and get their presentations which are quality presentations. So hats off to you, Lahane sir, and your team.
Thank you, sir.
As a chairman of this session, I am extremely grateful to Professor Lahane, Professor Ragini, Team MOS and Team BOA for allowing us to conduct this session. As the chairman and co-panelist on Dr. Nana Sahib Khare is also there. And fantastic lectures by all the speakers. It was an eye-opening session, I would say, as Dr. Anil Kulkarni sir has also said. And once more, a big thank you, Lahane sir. Your comments before which, I mean, after that,
thank you, Taswala sir, Anil Kulkarni sir. Thank you, everybody, those Nana Sahib also. I think it was a good session, and how the sir was saying, it is out of ophthalmology, but where we are not having much of the business sense. And I think this will have to be in future. That is very useful, and I think we must take some decisions at the government level, or we must take some decisions at our we can say association level, and we must see that our people are not under the so much of the pressure of the loan. So I think that is good, and I will see the draft of Ambekar, and I already drafted it to the government of Maharashtra, and it has already gone first to the finance, then JD, then law, and I think from all over they were asked so many questions, but I answered the questions. So I think we'll come across the PPP model within first hour this assembly. It means the cabinet. We are trying that this model should be passed in the cabinet, and once it is passed in the cabinet, that will be very useful for the doctors. So thank you very much for joining. Without you, I think it was not possible to such a wonderful conference. It was for near about 4 days, 800 faculty, and the reputation of near about 50 faculty. It means 850 faculty were there, and maximum attendance, and it is seen by more than 30,000 people. It is seen from the three and us today also. I think that was a wonderful conference, and conference is always successful when all the faculty they come and the people join on the name of faculty. And,
Sir, great efforts by you and Professor Ragini, team BOA and MOS. All the 4 Sundays, we really enjoyed it. And it was a rich scientific content. And of course, beyond ophthalmology also, today we had a fantastic session. One suggestion to you, sir, once you become the Vice President of EIOS, this model which Dr. Prashant has done, I think at EIOS level also we should do. Because all the EIOS members, at his individual level, he has got a fantastic idea. Why not do it at the pan-India level? It is going to really help everybody.
This Prashant model, I will take it to the all India level.
Yes,
sir. It is for iOS only. You can take it whenever you want. It is for them only.
No, I will do it.
Yes, absolutely, sir.
It's your brainchild, but it needs to be implemented at the pan-India level.
Yes, we will definitely implement.
Yes, over to you.
Yeah. So
bye, everyone.
In conclusion, I would like to thank Professor Dr. T.P. Lahane sir, Dr. Ragini ma'am, Dr. Preetam Sawant sir, Dr. Swapnesh Sawant for their untiring efforts, without which this mammoth task wouldn't have been possible over the last 1 month. I would like to thank Dr. Jignesh Taswala sir, our Vice President, for chairing this session, and Dr. Nana Saheb Khare for being the co-convener. I would like to thank all our panel speakers, Dr. Yogesh Shah sir, Dr. Madhav Ambekar sir, Dr. Prashant Bhartiya sir, Dr. Ashish Bajaj sir, and last but not the least, Dr. Anil Kulkarni sir, for being a part of this wonderful session, and hope to see you again in a physical BOA meeting very soon. Thank you.
And thank you to the technical team also. We are overshot by almost 45 minutes. They have been with us. Seamless presentation by all of them. Thank you very much, sir.
Thank you.
Thank you.
Thank you. Thank you. Thank you. Thank you. Thank you.